Hearty welcome to all of you. Before we begin this very lovely conference, let us invoke God's blessings by hearing the Ganesh Vandana.
Vakratunda Mahakaya Surya Koti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada.
So again, my team and I are really very, very excited and happy to welcome all of you, speakers, delegates, my team who worked with me, colleagues, and teachers to this very, very unique and vibrant conference, the 6th Annual Women and Diabetes Conference, Wodcon, where women matter, and that too in the midst of this very, very colorful festival of India, Holi. So you will see today all of us in sunshine yellow. And just like the sun which gives its rays to all, Wodcon is here to unravel the Pandora's box. And the Pandora's box contains all the differences in the pathophysiology, in the presentations, and also in the management of diabetes in women. Women, as we know, have a unique life cycle. If girls and boys in their young age become obese, it is a woman, it is a girl who gets the PCOS. And if this PCOS woman, she becomes pregnant, she may get gestational diabetes. And we know that gestational diabetes is a high risk factor for future diabetes and also cardiovascular disease. Not only that, even the offspring is susceptible or high risk for future diabetes as well. So we do not want to create a progeny of ill people. Another problem with women is that we are next seeing a huge epidemic of premature menopause. 1/3 of the life of the women will be spent in the reproductive age and 2/3 will be in the menopause. And menopause has its added problems which can complicate diabetes in women. And to add to that, autoimmune disease and depression, which is very, very common in women, are added risk factors. So if you can see, women have double the risk factors for atherosclerotic cardiovascular disease compared to men, and who have the traditional or the conventional risk factors which are common to both. And so we are going to see a rise in cardiovascular disease in women, and we have to arrest that. So we have esteemed speakers today who will unravel all this from the Pandora's box. And let me tell you that we have excellent speakers, and some of you are already here who are voices in national and international conference. They are all updated, and they will step by step bring out all these aspects of women in diabetes and update all of us with problems in women. Last 5 years, this conference was only for women, by women, and of women. This year, the doors are open to the men as well, because every healthcare practitioner must be aware and better understand the varied presentations of diabetes in women. Last year, we had advocacy session where we had invited the president of the RSSDI and the president of the Endocrine Society of India, basically asking for gender to be included in the guidelines. And let me tell you that it has created an awakening with like-minded associations. And today there are initiatives and collaborations that are going on in the research and study of diabetes in Indian women. So I won't take much of your time, but I definitely predict a very game-changing, informative, and meaningful deliberation today and tomorrow. And I'm sure you will be going home with a bag full of carry-home messages. Finally, I cannot end without saying a big thank you to my very debonair and dashing team, to all my mentors, to all my scientific advisors, and especially my backbone, Dr. Vijay Neglur, and to all of you delegates out there for adding the color and grace to Wodcon, where women matter. I now invite Dr. Vijay Neglur, who is the program director and also the convener for today. He's the chief advisor, and he has been with me since the last 5 years. This time I have brought him to the forefront to say a few words before we begin.
Thank you. Thank you, Benny, for your kind words. And good morning, everybody. There's a saying in Rigveda which says, Sangachadvam, Samvadadvam, Sammo Manasi Janatam, Deva Bhago Yatha Purve, Sanjanana Smanpate. What it means let us all come together. Let's all think together in the same direction and help our patients of diabetes to control their sugars well so that they live a long life. So that's the prayer to which we begin with. And once again, thanks for including men in the conference, which is meant by women and for women. Anyway, I thank you very much. I extend a warm welcome to all delegates for this 2-day exciting seminar. I thank all the speakers and the chairpersons for accepting our invitation and contributing generously for our meeting. I wish all of you the very best in this meeting and request you to enjoy the academic and the scientific feast for next 2 days. Thank you very much.
Thank you, sir. And I think without wasting much time, we will get on with the conference. Let's get started. For that, I invite Dr. Purvi Chawla to start the deliberations for the first session.
Thank you so much, ma'am. Good morning, everyone. This is the 6th year of this well-designed, elegant, and a different conference on women and diabetes, the brainchild of Dr. Benny Neglur, ma'am, joined by none other than Dr. Vijay Neglur, sir, who has been not only a stoic support, but a beacon of encouragement for all. The theme this year, as you know, is Unraveling the Pandora's Box. And for the same, we have a very an array of diverse faculty of national and international repute. Who's who of the world of diabetes, endocrinology, and medicine. So with this, on this auspicious note, seeking blessings from all you stalwarts, we further invite you all to a 2-day academic treat, and we have a very appetizing starter session to begin with. May I invite Shilpa Joshi ma'am, as well as Dr. Kavita Gupta, for kickstarting the first session of starters. Shilpa Joshi ma'am is Director of Mumbai Diet and Health Center, and Dr. Kavita Gupta is Director Nutritionist at Sunil's Diabetes Care and Research Center, Nagpur. Welcome, and please take over the dais.
Thank you so much, Purvi, for this kind words of introduction. Welcome everybody to the 6th Conference of Women and Diabetes. So to start the first session on starters, it's my proud privilege to welcome a dear friend, Cheryl Salis, who is a registered dietitian, certified diabetes educator, and a pump specialist. She has a 22 years experience and has a long list of achievements, but just to sort of summarize them, the latest ones we take. So she's the recipient of Sadhana Award of 2022 for excellence in field of nutrition and dietetics, And you all must have read her book, Diet in Diabetes Simplified. She is the author of that book. Kavita, would you like to take the next speaker? Welcome, Cheryl.
Yes, thank you. First of all, I would just like to thank Dr. Benny Neglur, ma'am, and Dr. Neglur, sir, for the opportunity. And for this, I would like to invite my second panelist. That's none other than Shiny Sundaran. I think her name says it all. And she is a shining, renowned sports consultant and a fitness nutritionist, and she's also involved in weight management. She's the consultant over there, and she has a level 2 anthropometrist from New Zealand, and she holds important posts in many of the organizations. And we all are aware of the wonderful live shows what she does, in Instagram and Facebook. So we welcome you, Shiny.
It's my proud privilege again to invite the next speaker, Miss Salome Benjamin, my teacher. So welcome, ma'am. She was HOD dietetics in TNMC and Nair Hospital from 1981 to 2015. She is chairperson of RD Board of Indian Dietetic Association, and she is the vice president of Association of Diabetes Educators. Welcome, ma'am. I don't think there is any dietitian in India who has not been her student.
Thank you, Shilpa. Good morning and to everybody.
Good morning, ma'am. And with that, I would like to invite a very senior name, Dr. Dharini Krishnan, ma'am, who is an inspiring, legendary name in the field of dietetics, a very senior consultant dietitian from Chennai. And she has a big list of, she has a YouTube channel named as Dharini Krishnan's Easy Diet. And I'm sure each one of you must have gone through and listened to her wonderful talk, which she is doing in regional languages as well. She's a genetic counselor, and she used to run a free clinic for hens. And with that, we invite you, ma'am.
Thank you, Kavita.
Cheryl, you can start the session.
Thank you so much, and a warm good morning to everybody. It's lovely to see everybody shining bright in yellow, and it's wonderful to be on this platform, especially in this conference, which is so dear to all of us. And without wasting any time, I'm going to start by setting a context, and then we have very eminent panelists with us. We're going to ask certain very relevant questions in the area of diabetes, pregnancy, nutrition. So I'm just going to share my screen. And thank you so much, Benny ma'am, and entire team of Wodcon for inviting us for this very delicious. I know there's so much of, changes that have been happening in the field, and therefore it's very important that all of us stay updated with the recent, one second, I'm sorry, actually. Can you see my screen?
No.
No, we can't.
Not yet.
No, Cheryl.
No. Is my screen visible?
Yes, ma'am.
Okay, great. So there's so much of advancement that is happening in the field of nutrition, and therefore it's very important that we stay updated. And it's not a one-size-fits-all approach anymore. First, we used to have a diabetic diet. It's, there was a lot of restrictions on food. So we used to have a big list of what not to eat and a very small list of what to eat. And people used to get dejected and not really follow a plan. And therefore, we really did not have follow-ups. And today times have changed and there's so much of confusion where we all healthcare professionals are constantly bombarded with messages or even in clinic asking us, should we follow this diet, for keeping my blood glucose under control, for weight loss? And there's so much of confusion which is all there. And yes, again, I don't think there's any person with diabetes who did not follow any ghar ka nuska. And they forget to tell their diabetologist or their dietitian they're on some kind of treatment. And they think that, maybe taking an Ayurvedic supplement will help them keep their sugars under control. And that leaves the person completely confused as to what should I do. And therefore, there is zero compliance as well as follow-up. But let's look at what are the guidelines. And if we review all the guidelines, whether it's the RSSDI, ESI guidelines 2020, the ADA 2022, and the ICMR NIN guidelines 2020. One is definitely that we are a carb-loving country, which is clearly shown by the START study. So we have to lower the carbs, look at quality of carbs. So improve the quality of carbs, reduce calories of weight loss is a goal, and reduce the intake of processed and simple carbs. And definitely in people with type 1 diabetes, we have to match insulin to the carb intake. When we're looking at gestational diabetes, we know that postprandial blood glucose levels is always a challenge. And there again, moderating the carbs to ensure that we're achieving good glycemic control. Definitely looking at improving the dietary fiber. And what are the recent guidelines say? 20 grams of fiber per 1,000 calories, which makes it 40 grams per every 2,000 calories. And we know again that 9 out of 10 people are deficient in their fiber intake because our diets are becoming more and more refined and processed. Now, while we are moderating carbs, we're improving the quantity of fiber. One macronutrient, which is always a concern in our country, is protein. And definitely we have to look at improving the protein content, improving the quality of protein, because we know it not only helps you achieve satiety, but also helps to blunt the post-glycemic blood glucose response. Now, when we are trying to give adequate calories and we are trying to, lower the carbs, then the fats. In fact, in the earlier days, fats were a villain and people used to actually go on fat-free diets. So today we know that healthy fats are good. And while we are moderating the carbs, we improve the dietary quality by improving the intake of good quality fats, reducing the saturated fat content, and taking as negligible as possible of trans fats. So this is a synopsis of what today's guidelines are. And again, increasing physical activity, which is always a challenge in our population. I love the plate method. So where we were talking about the pyramid, today we're talking about the plate method. Take a 9-inch plate, fill half your plate with non-starchy vegetables, 1/4 of your plate with cereals, millets, and starchy vegetables, and 1/4 of your plate with protein sources. Now, this is a very simple way for our people to understand and implement. The compliance is better. And by this, we're definitely going to achieve lowering the carbs, improving the quality of protein, because we're going to ensure we're taking a cereal pulse combination, as well as there is going to be dietary fiber in the diet. So this is very simple for us to explain as well as implement. Portion control with emphasis on nutrient quality and density is key. So we're talking about diet diversity. We're talking about nutrient quality and definitely reducing the quantity of certain, macronutrients, or increasing the quantity of certain macronutrients and achieving portion control. Now, today, there's a lot of buzz about diabetes remission. Even on social media or in the paper, we constantly get queries from clients, is there something like diabetes reversal? And today we have, we've seen that there is enough evidence and data to show that if the person loses, 15 kilos of weight, by following maybe a VLCD diet and then putting them on a maintenance diet, we're able to achieve remission. And that is where the role of meals replacement comes into play, which Shiny is going to deliberate on. So in summary, we're looking at a supervised, simple, sustainable, and affordable meal plan. And I think our Indian traditional foods, if you're able to tweak them and, they can become diabetes friendly by just improving the amount of protein, the amount of fiber, including healthy fats, and therefore making it lower glycemic index and lower glycemic load. And it's definitely not a one size fits all, because today you have so many different kinds of drugs. We're definitely seeing a high number of children with, not only childhood obesity, but even childhood type 2 diabetes. And today is the time of precision nutrition, where we're talking about personalized nutrition. So on that note, I'm going to now start with the panel discussion. And we have very eminent panelists with us, Shiny, Salome ma'am, and Dharini ma'am, who are going to discuss the various aspects of nutrition in different conditions. So thank you so much. So Shiny, my first question is to you. We see, today we definitely know that obesity is on the rise. We're definitely seeing more and more people with obesity. And when it comes to weight loss diets, meal replacements is definitely something that we all look at, introducing in our client's diet. So who are your candidates for meal replacement? That's the first thing. And when do you start them on meal replacements? And how long do you continue them on meal replacements?
Yeah. Good morning, everyone. Before I begin, thank you so much, Dr. Vijay Nagalur and Dr. Benny, ma'am. Thanks for having me here. And it's so good to meet all the other dietitians, my seniors, Shilpa, all of them. Okay. Are you able to hear me? Main thing about meal replacement.
Shiny, your voice. A lot of tracking.
People who get on a plan, any kind of nutritional plan. Are you able to hear now?
Yes, it's good. It's good.
Yeah. Okay. So the main thing about meal replacement is a lot of people approach a nutritionist for a plan, but then later what happens is the motivation and everything fizzles out and they drop out of the plan. There are times that we make a number of follow-up calls and then they really don't respond because they're feeling guilty that they're not able to implement it. Okay. And another factor is also the job scenario. Post-COVID, each one has had challenges and they're clinging on to their jobs and they don't want to, they're on pay cuts and a whole lot of challenges are there. And they travel quite a lot. And then so work becomes priority. And then following up with a meal plan with the correct timings, everything becomes a huge problem. So that is where meal replacements come. So who would I consider giving a meal replacement? Someone who is morbidly obese, someone who has a job where they travel quite a lot, or they could be stationed in their own city, own home, but then they have issues getting 3 proper meals on time. Another challenge also would be with the problem areas like mid-morning as well as evening, where the snacking habit is so high and they find it very, very difficult to control that. And the moment they end up snacking something, they feel very guilty. So the emotions that follow after consuming that kind of a food is another thing that they have to deal with. And also people who were considered for bariatric surgeries, but they want to give one last shot before they decide to take up bariatric surgery. So they would be ready to do anything by conservative management, by making lifestyle challenges or changes. And that is when the meal replacement comes in handy. So usually 2 meals are replaced using these meal replacements, and definitely for a period of around 3 months. And then seeing how they are able to make some changes and bringing them back to a normal diet. If it is someone who is 100 plus kgs and all that, then probably this might continue for 6 months. But for someone who is overweight, then probably just 2 meals for 3 months is what I would look at. And also before giving a meal replacement, educating the client about how important it is for them to understand that the normal diet and a balanced diet is what we are striving to achieve. But then to combat the food cravings, or rather the hunger pangs, or probably because of the job scenario, they travel quite a lot and there are gaps between meals, which actually deters them from being compliant. So that is why we are going to be using the meal replacement as communicated. And another factor is they should be individuals who drink adequate water. So unless I fix the water intake to the optimal, I wouldn't even consider giving them a meal replacement because of obvious reasons.
And I think meal replacements came very handy during COVID when they did not have their cooks at home and they were struggling. So that is when we saw that people, that came to their rescue actually. And like you said, I think, the snacks in our country is definitely a challenge, especially the evening snack. And that's where the carb load, the fat load all goes up.
Yeah. So and the worst thing is they might have the snack, but then after what happens is they feel so guilty. So they let go of their lunch and their dinner. Right. And then you don't want them to carry that guilt and spoil the rest of the day. So that's where the meal replacement is such a blessing.
True. And it's also nutritionally adequate. So, you're at least ensuring that you have all the macro as well as micronutrients. So that is, so thank you so much, Shiny. And my next question is now to Salome, ma'am. And Salome, ma'am, we see a lot of women today, especially when they conceive, they're already overweight. And we see a lot of people with PCOS. I think every second girl who comes to our clinic has PCOS, and that's an emerging problem. So what is your recommendation for a woman who's morbidly obese, BMI more than 30, with a history of PCOS? What would be your calorie recommendations for this woman? Because we see, either they eat too much, or sometimes they're so scared that they eat so little, and we see that they land up with nutritional ketosis. So what would your, recommendations be for this woman?
Thank you, Cheryl. At the onset, I must congratulate Dr. Benny and Dr. Neglu for this wonderful conference and the concept. And this good moderation by Cheryl, Shilpa, and Kavita. So thank you for your question. If I look at my experience of 45 plus years, it is different from case to case based. The blanket statement, I don't think I can give, say 30 calories, 25 calories, 20 calories. It depends on so many other factors like preconceptional weight, the weight gain trajectory, how a woman gains weight, and the duration of PCOS, and any other lifestyle factors, which is the main cause of the weight gain, and then the difficulty to conceive. So what happens in women is once they conceive, they are overjoyed. And maybe because they are PCOS and difficulty to conceive, even entire family's attention goes towards them. And that's why they want to feed every pregnant women or every pregnant girl, young girls. And we see that these age varies, especially when PCOS is concerned. It's not an early pregnancy we see. We see little later, 27 to 32 years. And this is the time where already your body has undergone a lot of metabolism, the bone loss and other things. So the target for weight gain for PCOS and obesity is nearly only 5 to 9 kgs. So if I calculate 5 to 9 kgs, and if I divide it trimester based, so first trimester, we don't need any weight gain. Whatever the gain is of placenta and the fetal weight is fine. So we don't need to increase any calories. But when we look at the second and third trimester, as per the guidelines, 350 to 450 calories. When we are targeting weight maintenance, also we are targeting the weight of the born child. In my experience, of course, I do the assessment in detail. What is the intake? What sort of lifestyle it is? What are the wrong food habits? And then put every component of macro, micronutrient in place and give sometimes 22, sometimes 25, and even when needed, 30 calories. But I don't think I have ever needed to give them 30 calories. Generally 22 to 25 calories per kg body weight. Present body weight is sufficient for their second trimester and the third trimester. Unless there are other complications and there is a poor intake and poor weight gain or the fetal weight gain, then we need to consider other factors. Its calories is not only one thing, there are so many other aspects. The other components which you in your introduction have very well established, the guidelines, the fiber, the type of fat, the saturated, the non-saturated, the ratio of too fat to saturated, and the MUFA, the role of MUFA. I think the entire world, the globally we know now what is it that is going to help us to maintain the correct weight and the right outcome of the pregnancy. And it's not only calories, we do look at other macro and micronutrients.
Thank you so much, ma'am. I think that was very, very well put. And this is exactly the message that we want to go, that yes, even if the person is obese, we still have to meet their nutritional needs, because sometimes we see that they're so careful. They eat little, they don't really gain the weight that is required to gain in pregnancy. And that definitely impacts the fetus as well. So definitely not going below 1600 to 1800 calories, because that is what the ADA guidelines also suggest. So thank you so much, ma'am. And now my question is to Dharini, ma'am. Again, with obesity and metabolic syndrome, we definitely are seeing a rise in people with dyslipidemia. So, high triglycerides, high LDL cholesterol, and low HDL cholesterol. This is what we see in most of the blood investigations done. So what are your recommendations for an individual with dyslipidemia?
Thanks, Cheryl. Thanks, Dr. Benny, Dr. Vijay, and team for giving me this opportunity. And hello to all the friends out there who recommended me. I just want to put this, like all of us know a lot about TG and HDL, which is there out in the population. And that is why I think we are the cardiac capital of the world. I want to put an acronym which says MOVEIT, MOVEIT. I will just explain the single lines and then explain in detail. M stands for move to complex carbohydrates. O stand with out of processed foods. And V is venture to the right oils. And E is engage in activity, which helps in HDL. And I is increase the right spices, but don't overdo it. And the T is take nuts. So to explain it further, coming to move to complex carbs, I think all of us know hand-pounded rice, but be careful that you're not, when you're washing it, it's going red, then it's not the true hand-pounded rice. Move to millets, but the unpolished ones like bajra or foxtail millet, not to the polished ones because they're equally bad. They may be a shade better than white rice, but they're equally bad. And a no to wheat, not to everybody, only to people who have issues, because it's becoming a fad to say no wheat, no wheat, no wheat. When somebody's so stressed and when they are pregnant and they want to eat their comfort food, if they have no problems with gluten, let's not say no wheat, no wheat, no wheat, right? Out with processed foods. Today, even an atta, idli or dokla or whatever it is comes home, which is made by somebody, and you have no idea what goes into it. So let's take that extra effort to make it ourselves, because I think that carries a long way, because if the soda is there, your sodium is up, your blood pressure could be in trouble. So let's watch out. So processed foods does not mean only packeted foods, but a whole list of things that today we think is normal to do, which may not be the right thing to do. Coming to venturing to right oils, India with global liberalization has so many oils that even a nutritionist sometimes is so confused what is good and what is bad. My message is always stick to tradition and what you love, because the foods you make, it takes about 2 generations to change the type of food you eat. That's why you see Indian foods all across the globe, right? The best goes to the globe and then we get ours, right? So coming to that, let's stick to tradition if possible. Where you are, you get it. If it's sesame oil or mustard oil or whatever it tastes best for your food, or coconut oil. So 10 ml of that and 5 ml of rice bran or any other oil you want to use. If you want to use 5 ml of ghee, the right type of ghee, it's not wrong. Again, let's not stress people, which creates more endogenous cholesterol than otherwise. Now, increase spices, don't overdo it. Just do as much as you would put garlic the way you do. Just because a particular science says that don't overdo it, it may create gastric issues for you. So watch out on that. And insulin to be titrated with meals. That's the other I, right? And tea, take nuts, of course, almonds, walnuts. But yeah, not that our nuts are not good, but of course, the science from almonds and walnuts is far better. And that's all I have to say about this.
Thank you so much, Dharini ma'am. I love this new thing. I think we'll all start using it. Move it. And as you rightly said, old is gold. And I think it's time for all of us, all healthcare professionals, to reinforce traditional eating habits, because there's so much of science and so much of nutrition in our own foods, which I think the new generation is almost forgetting. And I think it's time for us to reinforce. So thank you so much for that, Dharini ma'am. Salome ma'am, my next question question is to you, because we see so many people. I think vegan is now the new thing. Every time we have a new fad that is coming, and yes, vegan is a way of life. And if somebody wants to practice it, why not? But is it important or is it necessary for somebody to become vegan to control their diabetes or, to control their lipids? Because a lot of people, when their lipids are high, they completely go off non-veg. So what is your, take on whether, dietary cholesterol versus, its contribution to serum cholesterol levels? Should I completely stop eating meat, fish, egg, and poultry?
Thank you, Cheryl. There are a lot of controversies in this regarding dietary cholesterol and serum cholesterol. If you look at the guidelines, the meta-analysis, the ACC, the AHA, many of the studies say that there is no relation. The dietary cholesterol does not increase directly the serum cholesterol. First of all, the cholesterol is not neither soluble in blood or plasma. So it just cannot go into the blood. But these are the lipoproteins which we are worried about. And these lipoproteins which constitute the cholesterol, or it increase the cholesterol, the LDL cholesterol, that is important. So going vegan is one way of reducing, but if we see the physiology and the science, if we consume less cholesterol, there will be increased synthesis of endogenous cholesterol, which is otherwise also going to increase your serum cholesterol. So we need to balance it. If we consume less than 300 milligram of cholesterol in our day-to-day diet, whether it is vegan or whether it is lacto-ovo or whether it is with lean meat, it is still controllable that we can control our LDL cholesterol and thus help our whatever the cardiac health if we are worried about. So what I would say, I would blanketly not advise anybody to go vegan diet, because it has its own limitations and the deficiencies. We see the B12 and other things, and you get fed up of taking vegan at least without dairy. We know that there are more cardiac arrest and bypasses among the vegetarian people who are lacto-vegetarians. So it's the milk and the dairy fat which contributes. So it's the saturated fat which we are looking at, which is contributing. So ratio of polyunsaturated to saturated fat is very, very important in controlling LDL or in controlling overall cholesterol. And therefore, we need to look into, as you rightly said, our plate. What is it contains? There are, as Dharini ma'am says, that there are so many vegetable oils in India, and they are good for health. And we can use those oils with minimum of saturated fat. That's 1 teaspoon of ghee, that is your saturated fat, and see where your saturated fat comes from, a hidden fat. So that is what we need to see, the ratio of this. And now current guidelines says 10% of the total calories come from these polyunsaturated fat or saturated fat. In that, it is 6 plus 4. 6% is PFUFA and 4% is your saturated. Let me tell you, all the years of my clinical practice, I have followed that. All my girls, Shilpa and others, will agree that in spite of the guidelines of 10% and 15%, in our practice, we have not used that. We have used 6% or even less than PUFA and 4% of saturated fat, and remaining is MUFA, which is going to balance your entire lipid profile. So I don't think we should be strictly vegetarian. It depends. If it's a choice for a person, want to go vegetarian and go for it, I will have no objection, but we as a nutritionist or a professional must tell them what are the limitations of a vegan diet, how long one can do it, and what are the other supplements you will need when you are in a vegan diet, especially when there is a no dairy milk. But use of low fat dairy can also be recommended for maintaining your LDL cholesterol. And that is the culprit, the LDL cholesterol. The total cholesterol is nothing but the sum of LDL, SDL, and other triglycerides. And in Indian diet, the sugar and the carbohydrate is also the culprit. So as you already initiated the entire session with low carbs, so we need to go low carb, but not very low carbs. Sometimes we become too stringent. So it should be low carb. It should be good fiber, say 14 gram fiber for 1,000 calorie. It should also be maintaining your sugar, like say 10 gram per day. That's the minimum sugar. And that is how we can control the lipids. It's not one factor, the cholesterol or any particular one nutrient.
I think very well summarized, ma'am. I think this is so important. So as you rightly said, I think it's also very important to move more and sit less. People only focus on diet and don't really focus on activity. And like you rightly said, moderation is key. Anything extreme is short-lived and that is not going to give us sustained results. So thank you so much for that. Do we have time for one more question? I'll very quickly ask Dharini, ma'am, in less than 2 minutes, just one question is, in people with GDM, in women with GDM, how would we control? Because we know that 1 hour postprandial is also very important. So what would be your tips to, help manage that postprandial blood glucose level, especially with breakfast?
Yeah, thanks, Cheryl. It's Insta is the word. We have Insta influences like Shiny here. So I is increase the protein, no to processed foods. S is split the breakfast so that your sugars don't go up. T is take the sodium less and bring it down, cut your salt. And A is avoid fried foods. So here we are on Insta, do it fast, less sodium, more fiber, and there you are, less than 2 minutes. Over to you, Sharon.
Awesome. I think so. We've going back with 2 great acronyms that we will use for life now. So we have Move It and we have Insta. So thank you so much for that, ma'am. That was a very, very quick reply and very, very impactful reply. So thank you so much. We've had great fun this morning, discussing very, very important topics on nutrition and women. So thank you so much once again, Benny, ma'am, for this opportunity, and to the entire Wodcon team. And looking forward to the next 2 days of great deliberations by wonderful speakers. So thank you so much and see you at Desert tomorrow. Yeah, over to you, Dr. Purvi.
Great, thank you so much. It was really a very appetizing and a sizzling starter session. And with that, to keep the time on, we move on to the next session, which is mother care. We have 3 dynamic and very dedicated faculty tackling topics in the arena of pregnancy and motherhood. Inviting Dr. Alka Gandhi, who is a physician diabetologist from the city of Mumbai. And I will be chairing this session. Unfortunately, Dr. Prema ma'am has not been able to join us today due to something emergent. Dr. Alka Gandhi, please start the session.
Thank you, Purvi. Thank you, Benny ma'am, and good morning, everyone. So let us start this conference with a big bang again. And we have a very interesting topic, whether to use metformin or no in pregnancy. And we have a very prominent speaker, Dr. Gagan Priya. She is a very well-known endocrinologist from Fortis and Ivy Hospitals, Mohali. She has various awards like Scope Certified World Obesity Federation and IGEM Award for Best Reviewer in 2021 as well as 2018, and MMS Ahuja Award also. And she has a co-editor of various publications like Lipicrinology or Glucocrinology and Hypothyroid Disorders. She has over 65 publications and 25 book chapters. Founder member of FLAME. So I welcome Dr. Gagan Priya.
Thank you. Thanks, Dr. Alka, and sincere thanks to Dr. Benny for inviting me to this, very august gathering. It's really wonderful to see women coming together. So the topic for today would be to use or not to use metformin in pregnancy. This is one of the most debated topics when it comes to reproductive endocrinology, and there are extreme positions on both sides of the table. So some say completely forbidding it in pregnancy, and some say you can use it at first line. So we'll try and review the evidence and see where we stand. What are the common clinical scenarios in which you might be using considering the use of metformin in pregnancy, a woman could have pre-gestational type 2 diabetes and already be on metformin, and the question is whether to continue or not. Then it could be considered as a therapeutic option in women with gestational diabetes, and it can also be used in polycystic ovary syndrome. The use in this scenario would be in women who are undergoing ovulation induction and later on to reduce the risk of complications. Now, as far as therapeutic dose is concerned, in pregnancy, we don't really know the therapeutic dose. We're just extrapolating from non-pregnant trials, and the doses used are 500 to 2,500 milligrams per day. We don't have data above that dose. Now, what is the problem here with metformin is it has a very significant transplacental passage, and we'll talk about it as we go along. Now, coming to pregnancy, when you look at studies in women who were undergoing ovulation induction, large meta-analyses have shown that there is an improvement in live birth rates. There is an improvement in clinical pregnancy rates and ovulation rates. So that seems to be beneficial in favor of the mother. Now, there is no clear evidence that it decreases miscarriages, and when combined with clomiphene citrate, the clinical pregnancy rates were higher than using clomiphene citrate alone. That's how it gained momentum. But the most significant benefit one can see with metformin that has been, established into very large meta-analysis, the Cochrane meta-analysis, which we know is the standard of, conducting a meta-analysis, and the JAMA meta-analysis, both showed that there was a very significant reduction in the incidence of ovarian hyperstimulation syndrome. So OHSS does come down. The effect on miscarriage was uncertain, insignificant in one study, significant in another. Now, does it reduce pregnancy losses, GDM, pregnancy-induced hypertension preterm? Again, several meta-analyses have looked at this question, and we have had mixed results. The question was, will continued use of metformin during pregnancy reduce the risk of all of these problems? The PregMet study is one study which looked at this question. It was a well-conducted randomized trial. The first study had 250 odd patients, and then the second follow-up study had around 480 patients. So another set of patients were recruited for the second study. And in these patients, metformin was continued from the first trimester to delivery. There was no effect on preeclampsia, PIH, or GDM, but there was a significant reduction in late miscarriages and preterm deliveries. So in nutshell, in women with PCOS, what does it offer? In women who are undergoing IVF or ICSI, it improves live birth rates and clinical pregnancy rates, reduces OHSS, but not miscarriages. So in early pregnancy, early miscarriages are not reduced. In PCOS women, when it is continued till term, it offers the benefit of reducing late miscarriages and preterm births, but there is no decrease in the risk of other complications. There were some studies that showed that PIH may be reduced, but not preeclampsia. So now coming to the quintessential question, that is role in gestational diabetes and overt type 2 diabetes. This was the subject of our invited review in Drugs and Context. And in fact, we reviewed the literature till 2018 in a great detail to come up with this review paper. And I would suggest you can go and read it for greater detail. But what we found was, let's first ask the question, does it have the same glycemic efficacy as insulin? I mean, why are we considering replacing insulin? The rationale is, of course, there that it reduces insulin resistance. So it's useful in GDM, it's useful in type 2 diabetes. And very early papers from South Africa by the group of Dr. Coetzee and all, they recommended that they found good results with metformin. Subsequently, several observational studies and small randomized trials did come up, but the real momentum was gained with the publication of this trial from Australia and New Zealand, that is the MIG trial in 2008, which was published in NEJM. So 750 odd women randomized to metformin versus insulin. They found the glycemic control was good, but 46% patients required supplemental insulin. Fine. Less maternal weight gain was there. There was high patient acceptability. In fact, 77% patients said that in a subsequent pregnancy, they would want metformin. And several other RCTs came up with these same results. So looking at all of these trials, we asked the question, which GDM women are likely to, be okay with metformin alone, which are likely to require supplemental insulin. So this was the list of factors we found which predicted the need for supplemental insulin. All of these trials, these are the reference numbers from our paper. Higher fasting glucose of above 105, early onset of GDM before 22 weeks of pregnancy, past history of a GDM pregnancy, older age of diagnosis above 35 years of age, higher baseline A1Cs of more than 6.1 and elevated BMI of more than 30. So these were the women who were not going to get controlled on metformin alone and would require supplemental insulin. What were the beneficial effects on maternal outcomes? There was less maternal weight gain, less risk of PIH, maternal hypoglycemia was less, and of course the obvious benefit, you would need less intensive monitoring and lower cost of therapy. Some studies, including the MIG study, did report an increase in preterm delivery, but this was not shown in other trials. And if you go back to the PCOS PregMed study, actually preterm delivery had reduced. Two meta-analyses of GDM studies actually also reported that preterm delivery was not increased. There was actually a trend towards reduction in preterm delivery. So far, beneficial. Now, looking at fetal outcomes, again, there have been several meta-analyses. I'll not enlist them. There are about 17, 18 meta-analysis studies conducted. There are some beneficial effects. The mean birth weight is lower by almost 200 grams. Incidence of macrosomia and large for gestational age babies is lower. Neonatal hypoglycemia risk is reduced, and the NICU admission risk is reduced. Again, the question, preterm delivery, prematurity, that query hangs because some studies showed it, others did not. So far, so good. Next question we asked was, what about women with type 2 diabetes? One thing upfront, I will say that metformin alone is unlikely to be sufficient throughout pregnancy in women who have overt diabetes. So the question really is whether or not we continue metformin along with insulin, and in patients who are already on insulin, whether we add metformin. Now, unfortunately, there are very, very few studies here, observational trials in very small RCTs, and one Cochrane meta-analysis that looked at 3 good quality randomized trials found that what are the potential benefits of adding metformin onto insulin here? Reduction in insulin dose, less maternal weight gain, less maternal and neonatal hypoglycemia, and in terms of macrosomia, in this group, there was no difference. But more recently, we have another large randomized trial, the MITI trial that was published in the Lancet in 2020. Again, metformin was added to a woman with pregnancy and overt diabetes onto insulin, 500 odd women. There was no difference in the primary composite of fetal outcomes, but in maternal outcomes, you can see the glycemic control was better. Insulin dose was substantially lower, 1.1 unit per kg per day versus 1.5 unit per kg per day without metformin. There was less weight gain and less risk of cesarean section deliveries. In terms of fetal outcomes, birth weight was lower again by the same 200 gram margin we've been seeing in previous trials. Macrosomia was lower and adiposity measures were reduced. So, to summarize where we stand in GDM and overt diabetes, it has modest glycemic efficacy. Some women may require supplemental insulin. And yes, we have some indicators of who these women are. It has favorable maternal outcomes. For short-term fetal outcomes, it seems generally favorable, but there is concern about preterm delivery and smaller babies. But now the next question is of safety. So the question really is, why all this colavary? Why this colavary? So the concern is that metformin freely crosses the placenta, and it is, metformin is a small hydrophilic molecule which needs organic transporters to be passing across the placental membrane. And unfortunately for us, those organic cation transporters are expressed in the placenta. They are not expressed in early part of pregnancy, but as pregnancy advances, the expression of OCT3 tends to increase towards the end of pregnancy. And what researchers have found that fetal cord blood concentration can be at least half of maternal concentration, or even as high as maternal concentration. So as pregnancy advances, the fetal exposure is going to increase. It's possibly not a concern in early pregnancy, but in later pregnancy, it does become a concern. Then comes, okay, fine, it crosses the placenta, but does it do any harm to the fetus? Because for the maternal metabolism, it's generally favorable. So why are we worried? Because of its mechanism of action. It causes cellular energy depletion, as I'll talk about later. It affects 1-carbon metabolism and inhibits protein synthesis. So it has the potential to affect organogenesis and epigenetic programming. Now, this is what we know about metformin's mechanism of action. It is transported into the cell and it inhibits the complex 1 of the electron transport chain of mitochondria. And if we go back to our biochemistry classes, this is what is involved in the generation of ATP, the cellular energy formulation. So this leads to a decrease in ATP production, increase in ATP ratio, and activation of AMP kinase. So one, it is a cellular energy depleter. And while some of the effects are beneficial, such as a reduction in gluconeogenesis, impaired glycolysis, increased fatty acid oxidation, it also interferes with the TCA cycle. It interferes with mTOR signaling, which is involved in protein synthesis. It does reduce, oxidative stress and endothelial dysfunction. Again, positive effects, but we'll focus on these two subsequently. Now, by reduction in, inhibition of the TCA cycle, it reduces the substrates available for histone phosphorylation, acetylation, and histone methylation. So it really has the potential to impact the programming of the epigenome, and all of these processes are involved in the programming of the DNA makeup. In addition, it has anti-folate effects in the B12 pathway and the folate pathway. It causes a sort of methylfolate trap, thus again reducing the substrates required for the synthesis of essential nucleic acids, again having a potential for the affecting the epigenetic programming. B12 deficiency is another important point of concern. Almost 30% people who are using higher doses of metformin, they can have B12 deficiency because of reduced absorption. So the first question with safety comes, is metformin teratogenic? Now, there are lack of transporters, fortunately, in early embryonic tissue, and no teratogenic effect has been seen at very, very high doses of metformin also in these studies. And if you look at the human data also with PCOS women, where it is used right from the point of conception, no increased risk of congenital malformations has been reported. In fact, one meta-analysis showed that the malformation rate was 1.7% in metformin group against 7.2% in the control group. Next question is, would the epigenetic programming be beneficial for the offspring or detrimental for the offspring? Again, when you look at animal models, you're getting stories on all sides of the table. So some researchers have found that it actually reduces insulin resistance and hyperglycemia in the offspring. Others have reported the opposite. So we don't really get much information from there. What about its effect on reproductive outcomes? One study reported that it reduces the testicular volume, reduces Sertoli cell number, but when Rowe et al. Looked at human data, they found no effect. So there have been several long-term follow-up studies now available of metformin exposure during pregnancy. So children who were exposed in utero during pregnancy have been followed from a period of 1 to almost 9 years, and these the trial. So this was the MIG trial. Rowe et al. First came up. Then we also have PCOS pregnancies, Rowe et al. Showing data of 7 to 9 years. I'll not read the table in detail, but let's come to what we found in these studies. What was found was that at 1 to 2 years or up to 4 years, the children who they initially had birth, their body weight was less by around 200 grams, but they seem to show a catch-up growth in the first 1 to 2 years after birth, such that they had higher body weight compared to the control group children, that is the ones who were exposed to insulin or placebo, with a standard mean difference of around 0.26. So they are heavier in early childhood. There is no difference in height. There is actually no statistical difference in BMI Z-scores, but there's a trend towards higher BMI. Then there are individual studies such as the MIG trial, MIG-TOFU follow-up, which showed that the mid-arm circumference is, bigger, waist circumference is higher, waist to height ratio is higher, biceps can fold, and arm fat was high, but total body fat was similar. One small study also showed that they had higher fasting glucose ferritin, but lower LDL cholesterol. We don't really know, how much significance to give to this follow-up of only 12 children. And another study showed that the mean scores for androgen levels in girls were higher at 5 to 10 years. But the problem with all of these long-term follow-up studies is that the percentage of children who have been followed up over long term is significantly low. Only about 30 to 40% of children who were enrolled in the initial study have been able to follow up over a period of 7 to 9 years. So we don't really, we can't really give a conclusive answer from this take. Now, looking at decreased nutrient uptake in epigenetic programming, this was a hypothesis, and I'm still saying this is a hypothesis. We can't, clearly say this is the truth or reality or science. Metformin does have an impact on mitochondrial energy processing. It impairs one carbon metabolism. It reduces P12, also sort of creates a methylfolate trap. So all of these at birth may manifest as, smaller babies, but when they just like similar to, DOHAD, that is a developmental origin of health in adult diseases, it can increase the risk of future cardiometabolic diseases. But this is a question far, far from resolved right now. So safety considerations, going back to summarizing what we've talked about, established maternal safety, no concerns short term, may be beneficial for the fetus in some aspects, but concerns about long-term effects on offspring health remain unresolved. The last 2 minutes, I'll take this question of, in the light of all of this evidence, where do we position metformin now? So looking at guidelines, FDA says it is category B drug, which basically, honestly, to me, doesn't mean much because insulin is a category B drug. Acetaminophen is a category B drug. What does it mean is that animal studies have shown no point of concern, but we don't have adequate human data. But to say that is unfair because we do have a lot of studies and we need somebody to sit and come with form guidelines. Looking at the ADA position statement, ADA recommends its use only for ovulation induction in PCOS and to be continued till end of first trimester. And this is a position they've changed now. 2017, they said once pregnancy is there, just stop metformin. It considers metformin as a second-line drug to insulin, only to be used with caution. Fair enough. ACOG also comes with a similar guideline that it's a reasonable second choice for women who refuse or cannot take insulin, but it's necessary to inform about the risk of prematurity and tell the mother that it crosses the placenta and we don't have long-term safety data. But on the other hand, if you look at WHO, Society of Maternal Fetal Medicine, FIGO, and the Endocrine Society guidelines, they're kind of projecting it as a possible first-line alternative to insulin. Again, this is something we need to question. So in a nutshell, where do I think, what stand would I take? One, metformin should be only used if the patient refuses or cannot take insulin, and there are real concerns in taking insulin. And there also, we should look at certain factors. If the fasting plasma glucose is below 110 or actually even go below 105, there's poor compliance or refusal to use insulin, and there's lack of skills and resources for diabetes self-management. In GDM, you can consider it. When a woman has type 2 diabetes as an add-on to insulin, you may want to consider it if there is high insulin dose requirement and excess maternal weight gain. But bottom line, counsel the patient clearly that it does cross the placenta and we do not know how the long-term effects will pan out. But there are some absolute indications where you should put your foot down and say, no, metformin for you, you have to take insulin and only insulin. Diagnosis of diabetes in early gestation. These women are not likely to respond to metformin in the first place. And why then, start experimenting? Those who have elevated BMI above 30, gastrointestinal intolerance to metformin or previous drug reaction, renal or hepatic dysfunction. Again, in oral antidiabetics would be an absolute no. Metabolic status, significant hyperglycemia, ketosis or ketonuria, again, an absolute no there. If there is a high-risk pregnancy, like a history of major congenital anomaly in previous pregnancy, hydramnios, maternal or fetal distress, again, insulin is the only answer. So with that, I'll conclude here, and the house is open back to questions. Thank you.
Thank you, ma'am. Thank you for the wonderful session. Ma'am, we have time for 1 or 2 questions.
No, just now we don't have time. I think you carry on with the next. Yeah.
Okay. Yeah. Dr. Purvi, I want to introduce the next speaker.
Absolutely. So that was a brilliant deliberation on metformin use in pregnancy. And with that, it's my pleasure and pride to introduce Dr. Meena Chabra, who's a senior visiting consultant and diabetologist at Sir Gangaram Hospital, New Delhi. Amongst all the important positions held, ma'am has been chairman of RSSDI Delhi Chapter 2021 and has achieved several awards. Importantly, RSSDI Award for Excellence in Diabetes Care 2019, the B.D. Kumar Oration Award 2019 for Excellence in the Field of Cardiology and whatnot. Without further ado, I have the pleasure of getting Dr. Meena Chabra ma'am on stage for this deliberation on assisted pregnancy in diabetes management from pre-procedure to full term. Ma'am, you'll have to unmute.
We got a notification to unmute, yes, sir.
Yeah. Thank you, Dr. Benny, for giving me this opportunity, and thank you, Purvi, for the kind introduction. So I have a difficult job, but Dr. Gagan's made my job easier. And at the outset, I would like to tell you that I'm not going to dwell on metformin. So I'm going to talk about management of pregnancy. And 1 minute, let me just share my slides first. Share screen. You can't see. I can't see. फुल स्क्रीन कर दो. कैसे करना? कहाँ से? दिख नहीं रहा.
Yes, sir, your screen is visible.
Yeah. My topic is assisted pregnancy in diabetes, management from pre-procedure to full term. So this is a very interesting topic. So my slides are not second. Yeah. First, what is an assisted pregnancy? So assisted reproductive technology includes medical procedures used to address infertility. So even ovulation induction, if it's been used, is a part of an assisted pregnancy. And also assisted reproductive technology includes all fertility treatments in which eggs or embryos are handled. So ART involves surgically removing eggs from a woman's ovaries, combining them with the sperm in the lab and transferring the embryo to the women. Intrauterine insemination, also known as artificial insemination, is inserting sperm in the womb via a thin plastic tube. So why are we talking about diabetes and fertility? Because diabetic women are associated with a lower rate of fertility. The reasons could be obesity. They may have PCOS. They may have micro and macrovascular complications of diabetes. There may be autoimmunity. And many women with diabetes, both type 1 and type 2, may need assisted reproduction technologies. So today my job is to talk about the management of diabetes when these technologies are taking place. So first step is that if you have a type 1 or a type 2 diabetic patient, who is planning assisted pregnancy and is following up with the infertility specialist, you have to offer a structured education program, such as the dose adjustment for normal eating, DFNE-DAFN program for type 1 diabetes. You have to offer diabetes education and self-management for ongoing and newly diagnosed type 2 diabetes as soon as possible. So here you may have a type 2 diabetic woman who developed diabetes at the age of, say, 19 or 20. She got married at the age of 25, has been struggling to get pregnant, and at 32 now, am I audible?
Yes, ma'am, you are audible.
Okay, because my electricity just, so I think I'm on, right. I'm so sorry that the electricity just went off. And so I'm on probably on the generator. I'm sorry. So this patient who is now following up with the infertility specialist needs preconception care. So you may have a woman who was type 2 or type 1, but if she has pre-existing diabetes, you can expect that she will have progressively increasing insulin resistance. And also because of the diabetogenic stress of the placental hormones, she is expected to have worsening of glycemia. And we know that worsening of glycemia can lead to maternal and fetal consequences. Of course, increased insulin requirement during pregnancies, particularly as the pregnancy advances. There may be worsening of certain complications, particularly worsening of nephropathy and retinopathy and autonomic neuropathy. She may have nocturnal hypoglycemia. You have to always keep your eyes open for diabetic ketoacidosis, and we will not discuss the fetal complications as of now. So diabetes in pregnancy is associated with risks to the woman. For example, higher rates of miscarriage, preeclampsia, and preterm labor, and to the developing fetus, higher rates of congenital malformations, macrosomia, birth injury, and perinatal mortality. Now, there are additional risks with the technologies that we are using. That is, the assisted reproductive technology has additional risks of multiple gestations, prematurity, low birth weight, small for gestational age, and birth defects. So our job becomes even tougher. As a diabetes doctor, the job is tougher because preconception information for women with pre-existing diabetes who are going for ART is very important. Right from adolescence, when you have diagnosed a patient with type 2 diabetes, you have to advise the women about the importance of avoiding an unplanned pregnancy. Now, this holds true for both type 1 and type 2 diabetes. You have to inform the women and their families how diabetes can affect their pregnancy and how the pregnancy can affect diabetes. So you have prepared your type 2 and type 1 diabetic patient to be very aware that she will need very special care during pregnancy. Now, unfortunately, if she has problems of infertility and needs ART, preconception care is even more important. Now, how do you go about it? You have to offer and advise the women who are planning to become pregnant by ART before the embryo retrieval. Because remember, before she goes for the embryo retrieval by the ultrasound, with ultrasound, the HbA1c should be less than 6.1. Because congenital malformations are more if the blood sugar is not controlled before the ova is picked up during the embryo retrieval. So this is one important message to our audience, that you don't have to start controlling diabetes once the embryo has been transferred, but you have to start controlling diabetes, bring down the HbA1c to 6.1 or lower, and then embryo retrieval should be done. And after embryo retrieval and the embryo transfer, throughout the pregnancy, you have to maintain good glycemic control and continue it to avoid miscarriages and, of course, to avoid congenital malformation. So this is the message. Of course, case care, assessment and review of your patient, dilated eye examination should definitely be done before pregnancy, or at least I do it even before embryo retrieval. Ova is retrieved, I do that before that so that I'm prepared. Then patients should be monitored every trimester and at least for 1 year postpartum, as indicated by the degree of retinopathy in case she has and as recommended by the eye care provider. Similarly, renal assessment, you must do the albumin creatinine ratio before you send the patient for ART. Advise women with diabetes who are planning to become pregnant via ART to start taking folic acid. And of course, they will continue until 12 weeks of gestation to reduce the risk of having a baby with a neural tube defect. You must instruct her to buy a blood glucose meter. You must prepare her for self-monitored blood glucose several times, because if she's pregnant, she must be ready to test. And people who go for ARTs are very, very, they listen to us because it's a very precious pregnancy. Ketone testing strips, particularly for type 1 diabetic women. We do a monthly HbA1c till the retrieval of the egg and embryo transfer happens. And the frequency of appointments with the diabetologist should increase once she's planning an assisted pregnancy. Now, this is very important. Women with pre-existing diabetes who are planning to become pregnant with ART should keep their HbA1c concentrations below 6.1% if this is safely achievable. Reassure women that any reduction in HbA1c is likely to reduce the risk of congenital malformations. But you have to also tell them that there is still a small risk of congenital malformations. And if it's above 10%, there is no way you will advise her to go for ART. Again, I repeat, eggs from the ovaries also to be retrieved only when the HbA1c is below 6.1%. Now, how do you achieve this? I stop all drugs except metformin. So we stop SGLT2, DP4, GLP-1s, put the patient on insulin, control her blood sugars, continue metformin to address insulin resistance, and routinely assess her glycemic control. We set individualized target. Blood glucose concentrations before and during assisted pregnancies are again very important. You have to take into account the risk of hypoglycemia. Frequent monitoring is the answer. Sometimes we put the patient on continuous glucose monitoring systems. And because now that we have the flash glucose monitors, the Libres and the Libre Pros, our jobs have become easier. You have to involve the patient, and you can involve the patient in self-management of insulin doses. Now, we know that pre-pregnant value is different from post-pregnant blood sugar value. And once the embryo has been transferred, from embryo transfer, we want the blood sugar fasting to be less than 95, 1 hour to be less than 140, and 2 hours to be less than 120. These goals after ART are similar to the goals of any other women, type 2 diabetic women who has conceived naturally or she has conceived after ART. So these glycemic goals remain the same. Then what about medications? Gagan has talked in detail, but in our infertility center, in Gangaram Hospital, we continue with metformin because most of our type 2 diabetic patients who have become pregnant after ART are already on metformin. So we continue metformin and it depends on the obstetrician. Sometimes they may stop, but usually we continue through term. And it may be used, we use it because the patient is already on metformin, but I stop other drugs. I add regular insulin before meals. Usually we do it to a type 2 diabetic patient before she goes for egg retrieval and embryo transfer. But some of them may be very well controlled on only metformin. Then we continue them on metformin. Once the embryo transfer happens, after 2 weeks, the beta HCG is checked and the pregnancy is confirmed. And 2 weeks after that, when the first ultrasound is done and a live pregnancy is found, now we put the patient on insulin. So we will start with boluses before meals. And if the fasting is not in target, then we also add the basal insulin. So basal insulin, of course, is used to control fasting. We give boluses before every meal. And of course, we can split the breakfast if we are not able to control the 1 hour post breakfast or 1 hour post lunch or 1 hour post dinner with boluses. I do have patients whom we put on pumps during pregnancy, particularly patients who have precious pregnancies after ART. Age is more than 35, have been trying ART for a while and have not been successful. And if they are, then the pregnancy is very, very precious and we don't want to lose it. So we do put such patients on pumps. So good glycemic control is a must. And we do use a lot of CGMS However, if cost is a constraint or if the patient is not able to afford a Libre or a Libre Pro sensor, then we do use a lot of self-monitoring of blood glucose. We do sugars really a lot of times, fasting. Maybe 1 week we do 1 hour post-breakfast, 1 hour post-lunch, 1 hour post-dinner. And next week, then we shift to fasting 2 hours after breakfast, lunch, and dinner. And we manage sugars very, very well. So these are very important things that we have to emphasize, that self-monitoring of blood glucose is important, along with sensors if possible. You could do it. Then we must check the fasting 1 hour and 2 hour. Dietary advice and the role of the nutritionist is very, very important. Of course, we put her on a structured exercise program and monitor sugars before and after unusual exercise, because we don't want her to go into hypoglycemia. So, of course, if patient is hypertensive along with having type 2 diabetes, we discontinue and continue angiotensin-converting enzyme inhibitors. We discontinue statins before pregnancy or as soon as pregnancy is confirmed. Now, what about management of emergencies and complications during pregnancy? We must instruct the patient who are on insulin about hypoglycemia. If the patient has hypoglycemic unawareness, particularly in the first trimester, then it's important that you tell them to buy glucagon and keep it, or you ask them to buy sugar bolts. Sugar tablets are available, dextrose tablets, or a concentrated glucose solution. Glucose can be kept at home. Then if the patient, it's a type 1 patient whom you've been, type 1 diabetic patient who's on basal bolus insulin and has become pregnant after ART, you must exclude ketoacidosis as a matter of urgency, because sometimes you may, in the first trimester, if the woman is vomiting and has nausea, you may mistake it as the nausea of pregnancy and morning sickness, and while she may be going into ketoacidosis. So she must buy the ketone sticks and must be checking ketone if she's unwell or has any other unusual symptoms like vomiting or abdominal pain. So, of course, retinal and renal assessment should be offered to women who are planning assisted reproductive technology and going ahead with it. And you must check for diabetic retinopathy, because this may worsen during pregnancy. Also diabetic nephropathy, because that is associated with adverse pregnancy outcomes such as intrauterine growth retardation, preeclampsia, and preterm birth, and we should be aware. So another important aspect is that pregnant women with diabetes, you must be in touch with a joint diabetes and antenatal clinic. So this is again my message to our audience, that only the obstetrician or the gynecologist cannot handle the blood sugars in an assisted pregnancy, and a nutritionist should be on board, and the diabetologist or endocrinologist should be on board. Glycemic control should be assessed every 1 to 2 weeks. Antenatal appointments should especially cover care for women with diabetes, in addition to the care normally provided to a healthy pregnant woman. So a healthy pregnant woman, even after ART, needs less care than a type 2 or a type 1 diabetic woman who has gone ahead with ART and is now, you have to take her to term. So you have to prioritize women with diabetes for ultrasounds. You must do a 4-chamber view of the fetal heart and outflow tract at 18 to 20 weeks. This is very important because congenital malformations are very common. So we must do the ultrasounds in time, must motivate the patient that a 4-chamber view of the fetal heart and outflow tracts is very important. We must, we may expect a preterm labor in women with diabetes. Of course, sometimes the obstetrician may give antenatal steroids for fetal lung maturation. These are not contraindicated, but then you have to administer additional insulin because the patient is on insulin, may need, because steroids once started, the sugars may suddenly become very high. So you may need additional boluses in the evening. So apart from pre-breakfast, pre-lunch, and pre-dinner bolus, if the steroid dose is given in the morning after breakfast, you may need an extra bolus at 6 p.m. in the evening. So you have to remember this. Tocolysis is not contraindicated, but it is not to be used. But beta mimetics are not to be used for women with diabetes. So timing and mode of birth. Offer an anesthetic assessment in the 3rd trimester to all patients who have diabetes, whether type 1 or type 2, and have become pregnant after ART. particularly patients with obesity, autonomic neuropathy, nephropathy. If GA is being used for the birth, in our hospital, the anesthetist monitor blood glucose every 30 minutes, right from induction of GA until after the baby is born and the woman is fully conscious. Of course, you can offer an elective birth after full term. So even an ART pregnancy can be taken to full term, 38 weeks. Inform the women who have a macrosomic fetus after ultrasound about the risks and the benefits of vaginal birth. If possible, induction of labor. You can also talk about the advantages of a cesarean section. Most people agree for a cesarean section because it's a very precious pregnancy after ART. During labor and birth, you can monitor capillary blood glucose hourly during labor and birth if it's a natural delivery to maintain a concentration between 70 to 126. And if the concentration cannot be maintained in this range, then of course we use intravenous dextrose and insulin infusion. And we have infusion pumps and we do use them during labor. And in women with type 1 diabetes, we do use insulin infusion. We start right from the beginning once a labor starts naturally, or if we have induced labor, or if there's a cesarean section, of course, the anesthetist takes over. And so newborn baby, I think, advise women to give birth in hospitals. This is very important because the neonatal resuscitation should be available 24 hours. Feed babies as soon as possible after birth within 30 minutes. And then 2 to 3 hours until feeding maintains a pre-feed blood glucose concentration of at least 2 millimoles per liter. And we should keep checking the neonate's glucose 2 to 4 hours after birth. This is very important. If the concentration is below 2 millimoles or 36 milligram% on 2 consecutive readings, despite maximal support for feeding, or if there are abnormal clinical signs, or if the baby is not feeding orally effectively, then you can start tube feeding or intravenous glucose should be given. So if the baby presents with hypoglycemia, such as abnormal muscle tone or level of consciousness or seizures or apnea, we should start treatment with intravenous dextrose as soon as possible. Of course, we've just said that you have to do an echocardiography for babies now who show clinical signs of congenital heart disease or cardiomyopathy. Probably you could have picked it up during the scans, but if you have and the pregnancy has continued, you can now do the echocardiography. Then postnatal management of diabetes. If it is pre-existing diabetes, you can reduce the dose of insulin and the patient can go back on oral drugs. Normally, I don't give any other drug, no DP4, no SGLT2, no GLP-1s, oral or injectables, if the patient is nursing the baby. But some of our endocrinologists continue metformin postnatally if after 3 months, if she stops feeding the baby. So we can resume or continue the use of metformin and even glibenclamide immediately after birth. If the patient doesn't like to continue on insulin, there are women who are very involved in the management of the baby and do not like to continue basal bolus insulin and frequent monitoring. There, you can give metformin to these patients even if they are breastfeeding. So the offer lifestyle advice now, because the ART has happened, they have a healthy baby, talk to them about weight control, diet and exercise. Of course, if the patient is not breastfeeding, you can start DP4 or SGLT2 or injectable or oral GLP-1s. You should screen for micro and macrovascular complications. You can restart statins if indicated, restart ACRB, switch from the drugs that you had given in pregnancy to ACRB if they are indicated. And contraception advice, even if pregnancy was assisted, even if this pregnancy was assisted, contraceptive advice should be given. So you must empower the women. This is my last slide. And preconception care should be encouraged in all women going for ART. And you must prepare the woman before before even retrieval of the egg and embryo transfer. These are nice guidelines. We don't have guidelines from India. And so this was my last slide. And we must prepare the woman and give her additional time, ask her to take additional efforts to manage diabetes before the ART, of course, during the first, second, third trimester, and even postnatally. Thank you.
Thank you, ma'am. Yeah, continue. Thank you for the wonderful talk, ma'am. So as we know now, infertility is increasing and therefore ART is becoming very important, especially in type 2 diabetic patients. So I'm sure this is going to give a good insight to all our delegates. And now we have our next talk. So we have with us Dr. Rutul Goglani. He's a fellow in diabetes from Liverpool, UK, MD diabetologist practicing at Ahmedabad. He's certified in diabetology from RSSDI and postgraduate diploma in diabetes complications and technology. He's a member RSSDI, EASD, ADA, and SPAD with special interest in diabetes and infertility, GDM, and type 1 diabetes. So I welcome Dr. Rutul, and his topic is going to be GDM. So post GDM, the risk of diabetes and coronary artery calcification.
Thank you very much, Dr. Alka Gandhi, for wonderful introduction. And thank you, everyone, the beautiful ladies here, for inviting me. Perhaps I am the first speaker in Wodcon. It's been 5 years. This is the 6th year, and I'm the first man who is speaking in Wodcon, I guess. Is it true?
Yes, yes.
Yeah. Yeah, so thank you very much, Beni Neglur ma'am and Purvi Chawla ma'am, Dr. Shefali and Dr. Ami Sangvi for having me here. So should I share my screen? Hope it's visible.
Yeah.
Yeah. Great. So my topic is GDM, risk of future diabetes and coronary artery calcification. It is really a wonderful topic and it is very close to my heart. Nowadays, how the DIPSI is promoting everything like awareness of GDM everywhere. The base of this thing is mainly NCDs and metabolic disorders which we need to reduce. And the base of this thing is a coronary artery calcification and future risk of diabetes, definitely. So again, congratulations to everyone and a woman power team of Wodcon 2022. So Indians are definitely at high risk of every kind of metabolic disorder if we see. And this slide says that rate of gestational diabetes is also among them. And in Asian Indian women, it is almost more than 2 times higher of risk of gestational diabetes when we compare to counterpart of non-Hispanic white women. So hyperglycemia in pregnancy, if we see, according to IDF 2017, it says that Southeast Asia region has the highest prevalence of hyperglycemia in pregnancy during age of 20 to 50 years of women. So 1 in 6 live births occur to women with some form of hyperglycemia, and it accounts around 84% of which are due to gestational diabetes. So overall, all hyperglycemia in pregnancy has 84% of GDM. So what is our concern? Why we are worried about this thing? Because GDM is ultimately some form of compromised beta cell function, or we could say beta cell dysfunction. So GDM represents detection of chronic beta cell dysfunction, and this GDM is a stage in the evolution of type 2 diabetes. So ultimately, the chances of those GDM mothers becoming type 2 diabetic is very high in the future and in very short span of after a delivery of the baby. So lifetime risk of type 2 diabetes increase in women with gestational diabetes. Up to 50% of gestational diabetes women develop impaired glucose tolerance within 5 to 10 years of pregnancy. So what ADA says that women with GDM have 10-fold increased risk of, so it is 10-fold increased risk of development of type 2 diabetes than women with no GDM. So the absolute risk increases linearly through a woman in lifestyle. So 20% at 10 years, 30% at 20 years, 40% at 30 years, and 50% at 40 years, but at 60% at 50 years after the delivery. So gestational diabetes induces placental genes for chronic stress and inflammatory pathway. So ultimately, we give by gestational diabetes, a woman has inflammatory environment in her body, and ultimately it starts the cycle which almost causes all the metabolic problems. So as a natural interference between mother and fetus, the placenta is obligatory target of such environmental changes of inflammation. GDM elicits major changes in this expression profile of placental genes with prominent increase in markers and mediators of inflammation. This upregulation of inflammatory markers like interleukins, leptins, or TNF-alpha receptors, and then downstream molecular adapters indicated an activation of pathway recruiting stress activation protein, and ultimately it causes chronic stress and inflammation in the mother GDM mothers. So GDM may play a crucial role in the increase in prevalence of diabetes and obesity, which ultimately leads to cardiometabolic disorder, and it is the first step where women has starting of cardiometabolic disorders. So women with GDM are at higher risk of premature cardiovascular disease at very early stage due to gestational diabetes alone. So women with history of GDM have higher prevalence of metabolic syndrome and increased risk of cardiovascular diseases. So if we see down the line 10 years, women with GDM have more non-invasive cardio-diagnostic procedures, simple cardiovascular events, and total cardiovascular hospitalization after adjusting for age, ethnicity, comorbidities such as preeclampsia and obesity. So down the line 10 years, in comparison to non-gestational diabetic women, there are very high chance of women with GDM has to be hospitalized due to cardiovascular disease and different diagnostic procedures of cardiovascular diseases. So in 2016, there was a publication which was published in PubMed that said that gestational diabetes mellitus has very high risk of cardiovascular disease, and this shows that genetic, epigenetic factors, lifestyle, inflammation, hypertensive disorders with endothelial dysfunction, type 2 diabetes, cardiovascular disease, obesity, metabolic syndrome, dyslipidemia, this all stuff along with gestational diabetes and insulin resistance leads to higher risk of cardiovascular diseases. In 2001, there was an abstract which says that increased prevalence of significant coronary artery calcification. So before 20 years, it was established that there is some degree of coronary artery calcification in patients with diabetes and pregnancy. But in 2021, February 2021, there was a paper or the study named Cardia, which was published, and it says that gestational diabetes is tied to artery damage years after pregnancy. So women who has gestational diabetes during pregnancy are at high risk for what's known as coronary artery calcification and plaque that accumulates in arteries and restricts blood flow to heart muscles, and more than a decade after they deliver their babies. So this Cardia study ultimately said that women without previous gestational diabetes showed increase in the risk of coronary artery calcification associated with worsening glucose tolerance. So the patient non-gestational diabetes has also increased in risk of coronary artery calcification if they develop diabetes. But the women who had gestational diabetes and they develop type 2 diabetes in future, then they have 2 times higher risk of coronary artery calcification in future or midlife. So midlife atherosclerotic cardiovascular risk among women with previous gestational diabetes is not diminished by attaining normoglycemia in future. So this is cardiac study which says that in normoglycemic patient or pre-diabetic patient, even they had gestational diabetes, then they have very high risk of coronary artery calcification, and proportion is very high in normoglycemia even. So what are the clinical implications of this coronary artery calcification? Sustained normoglycemia among women with previous gestational diabetes may not diminish future atherosclerotic cardiovascular disease risk in women during midlife. So even the patient had gestational diabetes, and if we try to keep normoglycemia, it is not going to change the fate of cardiovascular disease in gestational diabetic women. So a history of gestational diabetes may entail underlying vascular changes and adversely affect development of cardiovascular disease through pathways such as insulin resistance, impaired insulin secretion that promote atherogenic plaques independent of dysglycemia. These findings add to mounting evidence that enhanced cardiovascular risk factors screening among women with a history of gestational diabetes is needed to better risk stratify women for early atherosclerotic cardiovascular disease prevention. So in clinical implication, if the patient with GDM comes to you after delivery, then definitely we should screen after 2 to 3 years of the delivery for all kind of cardiovascular disease. And if we see any kind of signs and symptoms, then definitely we should not be hesitated for even invasive diagnostic procedures as well. So what Dr. Professor V. Seshia says, that women with history of GDM are at higher risk of future diabetes and cardiovascular disease, predominantly type 2 diabetes, as their children. So there are very high chance in offspring at their younger age, they get diabetes as well. And if that offspring is a female child, then definitely the chances of gestational diabetes is also very high in those female kids. So transgenerational transmission occurs in those females. So female gender is definitely the key of diabetes prevention. If baby is low birth weight or high birth weight, large for gestational age birth weight, then the chances of elevated risk of obesity, diabetes, hypertension, and cardiovascular disease in those offspring is very high. So ultimately, it leads to intergenerational transmission of those risks. And this maternal health is linked to NCD epidemic. What David Barker says, it has conceptualized that body's susceptibility to lifestyle disease was programmed intrauterine. So whatever the environment we give to baby, it will reflect after a few years in after the delivery in those baby. So it is definitely a vicious cycle. Obesity leads to hyperglycemia in pregnancy. This leads to obesity in future generation, and those obese children are again prone to diabetes. And so the womb is the first place from where legacy starts and continues. So it depends on us what legacy we want to pass. So with this, I would be again thankful to Wodcon organizers and especially Dr. Benny Neglur ma'am. And if you think about it, pregnant women are really technically bodybuilders. With this, I will conclude. And if we have any question, I would like to address them. Thank you.
Thank you, Dr. Rutul. for the wonderful presentation. And yes, definitely. So the current pregnancy, if we manage well, we are saving next, and I would say next 2 generations from further complications. So as you rightly said, like the water hypothesis or the DOHAT study, which is now in vogue since last 5 years, and we have really understood the importance of controlling glucose well, especially when the lady is pregnant, and that is what we want to achieve. Yeah, could be any questions you want to ask?
I think I'll invite Dr. Benny, ma'am, who's the anchor for the session, to ask one question, ma'am, if we have just a couple of minutes before we go on to the next smashing session.
Okay, I think this was an excellent session. All the 3 speakers have deliberated excellently, and the clarity in your take-home messages. About the calcification, I would just urge that after gestational diabetes, say after 3 to 4 years, kindly assess the women for coronary artery calcium or for the biomarkers for their future risk factors. And we know that the coronary artery calcium should be 0. If it is more than 0, that means they already have to start statins and lifestyle and things like that. Another big controversy, I would just ask Dr. Gagan Priya. Metformin has always been a controversy, and it's still there even today. And we know the Indian guidelines already dictate that after 20 weeks, you can give metformin. And all the gynecologists start metformin pretty early, although the standard of care is insulin. And on one hand, they say you can give metformin, and then metformin has all the limitations. And in PCOS, we give it in the first trimester and stop it at the end of the first trimester. So, it's kind of contradictory, they say. These gynecologists say it's contradictory when it's given in first trimester, and then why start late? So what is your answer to that, Dr. Gagan?
And also, also take up whether in assisted pregnancy, because most assisted pregnancies, women are already on metformin.
Yes.
So they don't stop.
So,
the embryo transfer happens. So
the issue with metformin is about its fetal transfer. And for fetal transfer, it requires the organic cation transporters. Now, what studies have shown in early embryos, the expression of these OCTs is not really there. And the expression increases as gestation progresses. So it's in the 2nd and 3rd trimester that the transplacental passage becomes a very big issue. Now, studies have clearly shown at the point of conception and in early pregnancy, there is no increased risk of congenital malformations. And that is why in the PCOS studies, you're getting some clear benefits there. In fact, ovulation induction, the assisted reproduction, you've said, the biggest benefit comes in reduction of OHSS and multiple pregnancies. I mean, that's a real problem with ovulation induction protocols. The higher we are going, trying to induce more and more follicles, the OHSS risk actually goes up. There is also a reduction in late, miscarriages and preterm deliveries that studies have shown. The PregMed study was a beautifully conducted study which showed that. Now, the problem is in later half of pregnancy when transplacental passage becomes important. And I showed the mechanistic, that it causes a state of cellular energy depletion and fetal growth restriction. So what we're seeing at birth is smaller babies. We think they are healthier, but what if it's the same scenario that happens with undernutrition, that you're getting smaller babies, they catch up a lot of, there's a catch-up growth, and by 1 to 2 years, they're actually heavier than the babies who are exposed to metformin in pregnancy, to insulin in pregnancy. So that's the issue that needs real resolution. And I think guidelines now are taking a cautious approach that it should not be offered as first line. It should be offered only as second line when women refuse to take insulin. But also remember that in women who have overt hyperglycemia, metformin is not going to be enough. And I am not, I'm a very strong antagonist of glyburide for that matter. So I think insulin, we should convince people to take insulin. Glyburide has, metformin has some beneficial things behind it, but glyburide tends to have a lot of negatives with it.
Dr. Meena, you just said that it can be also given in assisted pregnancy, and they also
always
do that.
given. Yeah, ma'am, and it's difficult. And our obstetricians say that if we lose the precious pregnancy, the patient gets very annoyed. So I don't know whether it's patient-driven, study-driven, but in my hospital, metformin seems to continue pre-embryo transfer. I mean, and after embryo transfer.
So most obstetric guidelines are clearly saying you should continue it till the end of first trimester. The question is till the end of first trimester or till delivery. So there, the consensus as of now lies in till the end of first trimester. It is pretty safe. It is the later half where we have problems of fetal growth restriction.
Right. I think we are now going beyond time. I request Dr. Purvi Chawla to carry on with the next session. Thank you so much, Dr. Gagan, Dr. Rutul, and Dr. Meena, and all the chairpersons here. It has been a wonderful time.
Absolutely, I echo your thoughts, Dr. Ma'am. Fantastic deliberations. We have tons of questions, but we will have to take them offline. With that, we end this session and thank once again Dr. Gagan Priya, Dr. Meena Chabra ma'am, and Dr. Rutul Goklani, and my co-chair Dr. Alka Gandhi as well for this session. And we move on. Dr. Meena ma'am, please stay back for the frontline session that you are chairing. So we move on to the frontline session. We invite Dr. Meena Chabra, ma'am, again to chair, as well as Dr. Shubhashri Patil, who is a diabetologist physician from the city of Mumbai, and Dr. Anuj Maheshwari, sir, who will also be speaking in this session. Dr. Meena Chabra, ma'am, all yours.
Yeah, thank you.
Before you come in, Meena, there is a slight change in the schedule. Dr. Anuj Maheshwari wants to go a little early because of his some commitment. So what we'll have is, first we'll have Anuj to speak, then maybe Sanjay, then Bansi, and Bansi again. So this is how we can take the schedule. Is it okay with you?
Yes. Yes.
Thank you. So welcome to this program, and it's my proud privilege to introduce Dr. Anuj Maheshwari, because it is customary to introduce, otherwise he needs no introduction. He is the professor and head in medicine at the BBD University, Lucknow. He is a DNB teacher and guide, recipient of several awards, notable among those being recipient of the Health Icon Award 2017 as well as 2019, recipient of Marvelous Personality of the Year 2017 by the Governor of UP. And I think the stage is all yours, Dr. Anuj Maheshwari. Kindly proceed with your presentation.
Thank you, Dr. Meena Chabra. Thank you, Dr. Vijay Nagalur and Dr. Benny Nagalur, for considering my request to make this talk a little preponed. I can understand the difficulties what arising in doing so, but I'm grateful. So I'm just sharing my screen here, and thanks to Dr. Bansi also, who agreed to change his talk with me, and thanks a lot everyone who has cooperated me here. So I shall be talking about the straight talk, hypertension in women with diabetes. It's really very nice topic and quite close to heart topic for me and many more diabetologists who work here for the hypertension and diabetes together, because it gives us a very important information about the women when we are going to treat hypertension and diabetes together. So let's talk first and let's understand, do we have reasons of gender discrimination in metabolic diseases and hypertension? There are three types of the discrimination. One discrimination, what socially we do, like in our families, like in our society, like we maybe economical, females are comparatively lesser paid than men. There can be some delay in the treatment part of the females also, maybe in the family, maybe in the society. Sometimes their problems are not taken well up to the appropriate consideration. And apart from that, a lot of behavioral and environmental factors works there. Environmental factors also works in females more easily and more aggressively as compared to the male. For example, obesity, for example, other factors, metabolic diseases, epigenetic modifiers like obesity, like changing eating habits, like
alcohol, smoking, all these are more dangerous when they are with some women instead of men. So these epigenetic modifiers, which are changing the course of the metabolic diseases, are more dangerous and more aggressive in women. As far as the sex hormone, they always tell a different story, which is absolutely different from the men. Like sex hormones, mostly they are the steroidogenic hormone. They have got sex-specific gene expression also. And apart from lot of comorbidities are there, which takes women to the mortality easily as compared to the men. And these sex hormones, which are changing their pattern of release from one day to the last day of the month, from puberty to the menopause in the age, it's really very much different, which makes it every time different challenges for the women to treat their metabolic diseases. When we talk about the genes, there are certain things which are regulated by genes like renin-angiotensin system, adrenergic system, and when we talk about the nitric oxide and oxidative stress, nitric oxide reduces that stress, and these sometimes are lesser there. As you've seen, some estrogen-related problems, all these are governed by the genes in the women. But apart from that, there are the two important things like environment and the sex steroid. Sex steroid, which is a symbolic of the femaleness, like estradiol, testosterone, estrogen-androgen ratio, all these are causing hypertension in one way or another way when they are disturbed. All the environmental factors, what we talk about the male, like age, increasing age is obviously causing the hypertension, that is essential hypertension. Increasing BMI induces the hypertension. Insulin level, insulin resistance, that induces the hypertension, oxidative stress, and cholesterol. All these environmental factors are more detrimental in the females as compared to the male. So when we ask this question, do we have enough reasons of gender variability in blood pressure? Of course, it is there. As much as the variability in the females, none of the species and none of the race is having that kind of the variability what we see when we try to see the life course of the women. How does it happen? Hormonal changes occurring throughout lifetime of women, like at puberty, menarche, pregnancy, and menopause. Changes in the level of the estrogen-androgen ratio, which induces the endothelial dysfunction since from the very beginning in the scarcity of the nitric oxide, or we can say the factors which stop the oxidative stress. We see not only the rising oxidative stress, but also rising level of the endothelin, which causes the renal vasoconstriction leading to the hypertension. On the other hand, the BMI increasing the sympathetic activation, causing more renin release and more angiotensin 2, and again, together with oxidative stress, it causes again renal vasoconstriction. So this is the two-way pathway which is going on in women, which induces the hypertension. Women's physiology varies every day of its menstrual cycle. This picture may be little for the fun, but in the true sense, we see that every day for the women is different as far as the hormonal physiology is concerned. From the first day to the last day of the menstrual cycle, we see the different level of the various hormones and different levels of the effect on these hormones on the day-to-day activity of the women. That may be the mood, that may be the sleeplessness, that may be insomnia, and a lot of other things may be there. So when comes to the heart disease, men and women are not really equal. Women are different, and they need gender-specific cardiovascular treatment as compared to the men. We always think that cardiovascular disease is still largely considered a men's problem, with breast cancer commonly perceived as the greater issue for the women. But CVD is the top killer for the women in Europe, resulting in 51% of the death compared to 3% caused by the breast cancer. So still the cardiovascular disease is more or bigger killer in women as compared to the men. as far as the India is concerned, 3 in 5 women in India are at high risk of the cardiovascular disease as early as 35 years of the age, accounts for 15% of global burden of the heart disease. So India in itself constitutes a big chunk of female cardiovascular disease towards the world population. Inter-Heart study has given us this idea that cardiovascular risk factors, hypertension, diabetes, high alcohol intake, and low physical activity carry more strong relationship in women than in men, consequently raising the risk of MI in women. As far as the LDL cholesterol level is concerned, it is rising, and rising LDL cholesterol were related to the cardiovascular disease in both men and women, but low HDL cholesterol and increased triglyceride have been shown to be more strongly related to the cardiovascular disease in women than in men, with a 70% higher risk in women compared to a 30% risk in the men. This lipid research clinical prevalence study has shown that low HDL cholesterol and high triglycerides are the independent predictors of the cardiovascular disease mortality in women, and they are the more powerful determinants of the coronary artery disease risk in women than total cholesterol and LDL cholesterol. When we talk about the increasing BMI, it impacts more in women for cardiovascular disease, hypertension, and type 2 diabetes. Here we can see clearly in this picture where you can see that as far as the increasing BMI is there, we can see that very sharp rise in the occurrence of type 2 diabetes in the women, followed by the hypertension and coronary artery disease. Let's talk about the pregnancy-induced hypertension. We know that hormones play a very important role whenever the pregnancy-induced hypertension is there. But apart from that, cholesterol, triglyceride, lipoprotein in normal pregnancy attributed to the pregnancy hormones, human chorionic gonadotrophic hormones, and beta-estradiol, insulin, and progesterone. All these constitutes a pregnancy-related hypertension. So women with lower HDL-C, HDL cholesterol, and higher triglyceride before conception have higher chance of the preeclampsia and gestational diabetes. And of course, those who develop hypertension during pregnancy, they have got a higher chance of developing hypertension in future. When we look over the lipid levels on the basis of their age and gender, we see that in women, the LDL cholesterol is changing as per the phase of the life. Till the puberty, it is little lesser than the men. Then men always have the more LDL cholesterol, and till the reproductive life of the women goes on, their LDL cholesterol remains lesser than men. But after the menopause, it crosses the men and remains there till the end of life. They always remain on the higher risk. And as far as the during the reproductive period is concerned, now so many diversions has come up, like irregular lifestyle, smoking, alcohol, which has caused the increased LDL cholesterol in women also. HDL cholesterol, you can see the very straightforward pattern always remains after the puberty in the female. HDL cholesterol higher than men, and probably it is the protecting factors from the cardiovascular disease in women, which is said and very greatly highlighted in many of the studies. This is the outcome of our own study, what we have done in the M study and presented on the World Forum of the Indian International Society of Hypertension. Systolic hypertension comes earlier in women while aging. Diabetes disproportionately increases the coronary heart disease mortality in women with angina. The loss of nocturnal dipping in women is more common. As you all know that nocturnal dipping is an essential factor for the maintenance of the normal blood pressure and keeping a person away from the cardiovascular disease. And once this nocturnal dipping is lost, chances of getting early morning MI, early morning stroke becomes more stronger. Poor nocturnal dipping or non-dipping of the blood pressure during night time is observed more commonly in hypertensive women as compared to men. Identification of the specific hemodynamic mechanisms associated with non-dipping could potentially influence the choice of antihypertensive treatment regimen for non-dipper hypertensive patient. For postmenopausal women, the presence of coronary artery disease and advancing age are accompanied by blunted nighttime blood pressure dipping, which may increase the risk of adverse cardiovascular events Lifestyle changes that increase daytime physical activity and improve nighttime sleep quality may help improving the cardiovascular risk by enhancing nighttime BP dipping. Cardiovascular disease mortality, women comparing with the men. You can see it here in this graph. The mortality is higher in women as compared to the men. Estrogen is a potent vasodilator. Interruption of the estrogen in postmenopausal hypertension has been seen, and it gives an idea that estrogen relax vascular smooth muscle by increasing nitric oxide level and decreasing the vasoconstriction by acting as a calcium antagonist. So once the estrogen is not there, then this vasodilatation is lost in the postmenopausal women. Hormone replacement therapy has also seen to be playing an important role in postmenopausal hypertension. There has been some study which says that use of unopposed estrogen as hormone replacement therapy is associated with significantly higher HDL cholesterol and HDL2 and lower LDL cholesterol as compared with premenopausal women. However, combination HRT appears to negate the increase in HDL seen with estrogen monotherapy. So it is not very much clear whether it is protecting from cardiovascular adverse outcomes or not. In hypertensive women, discontinuation of combined oral contraceptive pills sometimes improves the blood pressure control because all they are the steroidogenic pills. The presence of poorly controlled hypertension is associated with approximately 3-fold increased risk of the MI and ischemic stroke, while the risk of hemorrhagic stroke rises 15-fold. In women with multiple cardiovascular risk factors, the use of progesterone-only contraceptive pill may be more appropriate. Estrogen conferred cardiovascular protection in premenopausal women, but losing to the modern lifestyle and rising insulin resistance because of the multiple reasons. This insulin resistance is not only arising due to the diabetes, type 2 diabetes, but also the obesity, lack of physical activity, diet, high carbohydrate diet. All these are playing, especially the late night sleeping pattern, also playing an important role in losing this estrogen conferred protection towards cardiovascular disease. Since birth to throughout childhood, cholesterol levels are same in both the boys and girls. Boys have a lesser size of the LDL, which tends to rise in both males and females after 20 years of the age, but do so more rapidly in men. Boys have a smaller HDL, which reduces in size with advancing age. Rapidly changing lifestyle takes away the natural advantage or natural boon what has been given to the women because of their reproductive phenomena, and it was the gift from the nature as they were taking the reproductive responsibilities on them to keep them away from the heart disease. But this change in the lifestyle, aggressively smoking, alcohol, and food habits, late night awakening, all these are changing the scenario. So adult, according to the events risk factors, this Preminger heart study had shown if the multiple risk factors are there, like if a person is having diabetes, cigarette smoking, atrial fibrillation, CVD, all these are there. As much as the risk factors, the women are posing the higher risk than men. When the risk factors are lesser, we can see that men are having the higher risk of the cardiovascular disease, but almost with the higher risk factors, more number of the risk factors are causing them more dangerous outcome. Take-home message is that higher percentage of the women than men have high BP after 65 years. Worldwide prevalence of hypertension is predicted to increase by 9% in men and 13% in women between 2000 and 2025. Largest group of the women at risk of CVD are aged 35 to 44, including 69% of the housewives and 67% of the working professionals. This has been the outcome of our own study. A 5-year follow-up study showed that women were 8 times more likely than men to experience a composite endpoint of the death, acute myocardial infarction, unstable angina, coronary intervention, heart failure, cerebral ischemic stroke, or transient ischemic attack of peripheral artery disease. data over 6 to 8 years from the Nurses Health Study and Health Professional Follow-up Study show that relative risk of the coronary heart disease individuals with metabolic syndrome compared with those without the metabolic syndrome was higher in women than in men. So finally, men are from Mars and women are from Venus. The proverb seems to be true when we talk about the hypertension, diabetes, and together they are taking the women towards the cardiovascular and outcome, and women are on the higher and bigger risk as compared to the men, but still are less attended as compared to their male counterpart. Thank you very much for your kind listening.
Dr. Shubhashri, thank you, sir. That was a fantastic talk, very comprehensive in the short time.
So, taking it forward, I would like to introduce Dr. Sanjay Agrawal for the next session. It is truly a pleasure and privilege to be introducing Sir. He is a very prominent and popular face in the field of diabetology. He is head of Department of Diabetes and Medicine in Ruby Hall Clinic and also attached to Jahangir Hospital. He is director of Angel Clinic. He has many awards and recognitions and many publications to his credit. He is also a faculty at various national and international conferences. Today, he is going to take us through a very interesting topic of what comes first in women, SGLT2 inhibitors or GLP-1I. Over to you, sir.
Thank you very much, Dr. Patil. Let me try and share my screen first. And then let me curse Vijay for giving me this topic.
I know that you can do justice for such subject.
So that's why. Let me first at least get my screen up there before I start screaming at you. 1 minute. I don't know how to do that. Give me a second. I'm putting it from my lap, from my iPad. So give me a second. I don't know how I can do that. Okay.
Who doesn't need
I can start doing it. Wait.
This country and out of this country. So Dr. Bansi Sabu is the Chief Diabetologist and Chairman, Diabetes Care Hormone Clinic, Ahmedabad. He is the past president and I think one of the most dynamic president of the RSSDI has been said that Dr. Bansi Sabu has remained president of the ARO at present. He is the honorary secretary of the Diabetes India right now, managing editor of the Sariko's International Textbook of the Diabetes. He has launched a project of the Diabetes Free India 2030, which has been acknowledged by the President of the India, Dr. Shri Pranab Mukherjee ji, founder of the NGO Diabetes Care India and India Street Registry Project. Bansi is not there. I think I have seen Bansi just a few minutes before.
He wanted Sanjay to speak ahead of him. He wanted to speak Sanjay ahead of him. Never mind, you already introduced him. I think, Sanjay, are you ready?
Just one thing I thought I figured out. Just let me see if I can do it.
My God.
Should we call Bansi?
Yes,
Yeah,
I think he's just joining in.
Yeah, okay, we'll just join him.
Just keep him on standby in case I can't do it, okay?
I think...
I don't want to waste your time.
I think in that case, since we have Dr. Maheshwari sir with us, we can
just ask a question to him. Yes.
Yes. If you take the question, that will be.
Dr. Maheshwari, can you just tell us why the differences between men and women, so far the treatment of hypertension is concerned, how men behave differently than women when a specific drug therapy is concerned?
Dr. Negalur, this is the very advanced stage of the research when we make the treatments are being available to the men and women equally good. Right now, we are facing the situation, majority of the women are remained undetected or underdetected, and they are not getting the treatment for their hypertension and even for the metabolic diseases also. So as far as the drug.
Are you able to see my screen?
Yes, Sanjay.
So as far as the drug-to-drug comparison is concerned, it is not very commonly seen, but it has been seen that whatever the good response is coming from the RAS inhibitors, it is coming from the women better as compared to the men, because RAS inhibitors always play a bigger role in causation of the hypertension as far as the women is concerned. So we can talk later after this Dr. Sanjay Agrawal's presentation also, because Sanjay Agrawal is ready for that. So let's, I think somebody is introducing Dr. Sanjay Agrawal. Or should
I've been introduced already.
I have been introduced, don't worry.
Yes, Sanjay, the stage is yours.
Thank you very much. And thank you very much for inviting me to speak over here. So as first things first, of course, when I started to prepare this topic yesterday, my first response was to curse Vijay to give me this twisted topic. But then I said, intelligent man that he is, he should have a reason why he's given me this topic. And I don't doubt that in any kind of a way. So anyway, I sat down with a glass of wine and I said, let me see what I can find, which is gender-specific information related to SGLT2 inhibitors or GLP-1 in women. All along, I thought there was really very little data and very little really kind of gender-specific information related to this. But then when I got down to it, it got really very interesting. And I know now why Vijay really gave me this topic. So let me just try and bring out some highlights as to where we are coming from when we talk about SGLT2 inhibitors and GLP-1 in women. So we all are familiar that, you know, when you talk about type 2 diabetes as a whole and the risk for cardiovascular complications, we know that there is a 53% increase in unstable angina when patients have diabetes, 54% increase in the risk of myocardial infarction, 56% increase in the risk for heart failure, 72% increase in the risk for stroke, and 28% risk for peripheral arterial disease. But what is important in Indians is it never comes alone. We know that this triumvirate is actually most often than not seen in majority of our patients. And if you have one, the other one is just round the corner. So whenever we address diabetes, we obviously tend to also look at
We can't hear, sir. Kushal, can you check?
Yes, maybe he's facing.
Pregnancy, which antihypertensive drugs are safe in pregnancy. So they get that message very clear.
Yes. For the pregnancy-induced hypertension, usually we should not prefer RAS inhibitors. this message should always be very clear.
Right.
If any lady is taking a statin before pregnancy, she should stop that. Statins and RAS inhibitors should be a big no during the pregnancy. Although most of the people know that alpha methyl dopa can be a very good drug, but its availability is not so well nowadays. So that's why many people remains in jeopardy what to use in pregnancy and what not to use in pregnancy. I would like to say that calcium channel blockers and beta blockers are safer drugs for the pregnancy-induced hypertension, and we can go with these drugs till the end of the pregnancy if this pregnancy-induced hypertension is there. But always remember, keep on doing the lifestyle management if you are treating pregnancy-induced hypertension. Even if not treating, still we all Indians are having the high risk for all metabolic diseases. We all are having higher insulin resistance. So we should always be more careful. And we all know that pregnancy is the stage when insulin resistance is seen, which is a thing when it is considered normal. So obviously, if insulin resistance is higher before entering into the pregnancy, it will cause its impact during the pregnancy when it is already welcome and it is required for the formation of another child or another life in the womb. So we should always be more careful for all these things.
Thank you so much, Dr. Anuj, and we'll proceed with the session.
And since I can see Bansi here, I think he can start his session. And not only will speak on the excess of diabetes care, we will also talk about research and registry of diabetes together. So I think we will hand over to Bansi to have this deliberation. And if Sanjay Agrawal is again back on the line, we can get him again at the end of Dr. Bansi's talk. Is it okay, Purvi?
Absolutely, sir.
Bansi, the stage is yours. I know you're the face of diabetes in India. Not only India, I think abroad, all over the world, people know you as the most dynamic, I should say dynamite or dynamic person in diabetes in India and of course all over the world. And you have really created a lot of awareness of diabetes by making a lot of teaching sessions. I know Diabetes Bite, the Purvi does that very intelligently. And of course, the lot of educational activities, getting all people together on one platform. Very great heroic job. I think you are the one person who has really contributed so much for the education. So it's your session, and you already been introduced by Dr. Anuj Maheshwari extensively. I request you to share your presentation on this particular platform.
So first of all, thanks Dr. Vijay Neglur for very kind words. So I'm really obliged, and thank you Dr. Beni and Dr. Vijay for inviting me. Thank you, Anuj. Sorry, I could not hear you fully. And then I was thinking that Sanjay will be there. So we will have a discussion. If Sanjay is there, then I can have the first talk of Dr. Vasant Kumar, which Dr. Beni and Dr. Vijay asked me yesterday. That is, Dr. Vasant Kumar is busy and engaged somewhere, so he will not be able to give the talk. But if he is not there, then I will start my original talk and then that talk, because that talk requires Dr. Sanjay to be there. As it's a discussion, it's an RSSGI research and registry, what's our plan? And I was thinking if he is there around, then we can have discussion for that. So if he is not there, I think connectivity issue is there. So Purvi can call him. And before that, I can start my first talk, which has been given by Dr. Vijay and Dr. Beni to me. So once again, thank you for inviting me and asking me to give this talk. So I think I am audible and my slides are visible. Am I?
Yes, sir.
Right, sir. So I'm just doing it. Anyone can tell me from the event side, RX events, how to remove that?
Yes, sir, we can see it.
No, but I think there's, on top, it is always written something. So how to remove it? No problem. Okay. So the topic given to me is access to diabetes care in India and changes over the horizon. And as we know that time is less and I have to give 2 talks, and we would like to discuss also some of the points of RSSGI registry and RSSGI research, what we are planning to do. So with this, I start with my first talk. We know that diabetes is a global epidemic. out of control, and currently it is unstoppable. This is very important. 4 in 5 adults with diabetes, they live in low and middle income countries. So I mean, India and China, and if I just take Indonesia, Bangladesh, Pakistan, these are the developing countries. Out of them, whatever the number of patients which are there, almost 75%, 2/3 of them, they live in these countries. And 64% patients who are diabetes, actually, they are living in Asia only. No disease has impacted human life stronger than diabetes. And it's a global threat. No socio-economic or a national boundaries. Half of people with diabetes are undiagnosed. The costs are greater than any other disease. We may think that diabetes is not very costly, but that's not true. And it is more problematic in rural area, particularly when I'm talking of India, is a low income or middle income countries, and complications are increasing even in younger age. And that is what we are seeing in our country. The rule of half exactly work in our country. We have half of our patients who are not diagnosed. So whatever the number of patients which we are seeing, actually similar number of patients who are not diagnosed with diabetes. Those who are diagnosed, again, half of them are not receiving the care. Either they are not having access to the care, that is what the topic is given to me, or they can't afford, or they are going in alternative therapy, or they are not taking it regularly. They may take it for some days and then they again stop it. Those who are taking the medication, again, the targets as far as glucose is concerned, it is half of them are achieving. But outcome is further reduced. I mean, it is 6.25. That is what ABC, that A1C, blood pressure, cholesterol, all three are to be controlled, and that too for a longer period of time. Then and then we can have some desired outcome in these patients. So that rule of half exactly working in our country, in all other developing countries also. Why it is so? Because in our country, the non-communicable disease such as diabetes, we were discussing about the hypertension before it, even coronary artery disease, obesity, they have not received enough medical attention. And that's true. As the communicable diseases in our country like tuberculosis or AIDS, and now it is COVID, which is so much so that, you know, the attention from the government side, from the medical school side, from the doctor side, everybody is talking about the communicable diseases. Therefore, the allocation of financial resources towards these non-communicable disease is much less when compared with those which is allocated to infectious disease. So if you go and see the internal medicine department, everybody is working to treat and cure the patients of infections, and hardly anyone is bothered to deal with diabetes or hypertension. There is a wide disparity in the healthcare facility, which is available in a rural or urban areas. Again, that's again a big challenge, that healthcare facility which is available in rural area is not geared up to take care of non-communicable disease. Hence, long-term prognosis of diabetes is affected due to lack of adequate facility. That is in government sector. If I ask in the private sector, what is the problem? Yes, in private sector, there are good facilities which are available in some of tertiary care center, but again, patient has to pay. It is from their own pocket they have to pay. When uniformly good quality care is accessible to all, the disease outcome is at least not predetermined by the individual's socio-economic standing. And the prevailing poverty, ignorance, illiteracy, and a poor health consciousness further adds to the problems. I mean, the patients who can afford, they can still go to the better center, but then again, their education, their ignorance, their health literacy, all are the factors which are very, very important, other than the economy, other than the rural and urban areas of taking care of diabetes patients. We also have some distinctive feature of type 2 diabetes in our country. We are getting diabetes even at the lower BMI, with a higher waist circumference, with the more central obesity. We see more visceral fat, more insulin resistance, and a very typical phenotype, which we are seeing even if you see the clusters which were identified by Anjana and Dr. V. Mohan group. They had identified one unique, which is severe insulin resistance along with insulin deficiency, which was not there in the patients who were in the Sweden. So the type 2 diabetes cluster, which had formed in western part of the world, from the western part in compared to India, we found in India we have higher insulin resistance and early beta cell failure also. We are also genetically more predisposed to develop diabetes. We have more urbanization, and simultaneously the economic prosperity further increase the incidence of diabetes with decreased physical activity and a lot of nutrient abundance which was available to us. With high intake of refined cereals, we are taking more of carbohydrates and a low intake of fiber, fruit, vegetables, and protein. Our patients are in a young age with lower BMI, with higher prevalence of coronary artery disease, and we have more of microvascular complication too. But even after all these things, our awareness level in our country is very poor. We have high prevalence of undiagnosed diabetes, and we have unaffordability of care for many patients of our country. And at the same time, the trained medical and paramedical personnel, particularly to deal with a non-communicable disease like diabetes, which is also very low. So number of persons who are dealing with these disease is also very low in our country. So these are some of the unique problems which are associated with diabetes care in our country. And one more very important thing is appropriate monitoring and follow-up of the patient is lacking. And that I will be also talking about the registry, that we don't have the systematic electronic medical records also. And that is also one of the very important reasons why we are not able to appropriately monitor our patients. We don't have the follow-up system of our patients. We don't know when they are developing complications, how we can primarily or secondary prevent these complications also. We understand that there is a lot of issue of cost or financial burden, but other than that, we had come out with our own Indian guidelines, but still there is a non-adherence to the recommended guidelines. Since last 5 years, we are working very hard that our Indian guidelines, the RSSDI guidelines, should reach to the rural level. And in last 2 years, because of the COVID, online program which we have done across the country, district coordinators were educated across the country. 750 RSSDI had created a district coordinator, and we are teaching, educating them the RSSDI guidelines. So the basic guideline of treating diabetes, which we are improving even in our rural area also, but still it is very much non-adherent when we see the patients who are coming from other clinicians or primary care physicians or from the rural area. Actually, they are just writing whatever they want to write, but they are not adherent to the recommended guidelines. So the regular follow-up of what is to be done, that is also very, very important from our country. So there is a low awareness in spite of high prevalence. And this multiple times I put this slide, and this is one very important slide why I want to do it. Even in the newspaper, in press also, we are writing that even our urban patients might be staying in Mumbai and Ahmedabad, that 53% they believe that eating Karela or Methi can cure diabetes, which is not true. So I mean, I'm not talking of other aspect of the diabetes awareness in our country, and that's what we have created a Defeat Diabetes campaign in our country, that 53% of the people, they still believe that by eating something Karela or Methi that can cure the diabetes. That sort of awareness is there even in the urban people, and those who are literate and those who are taking care of diabetes, they are taking medication from the best of the best doctors in India also. Now, this is very important slide, and I will have 3 slides continuously, and that, you know, the access to the care, which is Dr. Neglur is asking, that we have in last 15-20 years, so many newer medications had come to our country. Even whatever the medicines which is available in the world was available in our country. We were also having the best data which was available. Even we may not have done, but we clinical research, we were there, and even we were the part of some of the cardiovascular outcome data also, because these were the multinational trials. But still, number of medications which increased so many. Still, if you see in 2007, this data shows that people with type 2 diabetes, only 19.7% of the patients were controlled. I'm not showing the data of 1999. I'm not showing the data of 1990, but this is the data of 2007. Let me show you the data of 2014 also. The similar number is also, even after 8 years, 70% of diabetes patients in India have HbA1c of 7. So, I mean, even after 7 years, you can see from 7 to 14, there is no improvement as such diabetes control is concerned in our country. This is an only data from ICMR INDIAB data, which is national data, one of the biggest epidemiological study conducted by Dr. B. Mohan as a principal investigator, supported by ICMR. And this is one more data from which is recently published in 2020. And again, they are talking that patients who are controlled are only 22.5. So I mean, still 77.5% of our patients are not controlled. So I tried to show you three conjugated the data from 2007, 14, and 2020. Even after so many medication, even after so many clinical trial which was published, even after so many guidelines which had come, still the care for diabetic patients who should get good control of diabetes, which is not improved. Still, we are seeing that more than 70-75% of our patients are not achieving even a A1C to get control, which is less than 7, which is recommended by Indian guidelines as well as by many guidelines across the world. Why it is so? I think probably this is still one of the most important reasons. We have a clinical inertia. Even this paper is long back published in 2005, but I can still see after 15 years or 20 years, still we have a lot of clinical inertia. Our clinicians, they are not aggressive enough to achieve the tighter glycemic control when patient comes. Even at the time of diagnosis, when it goes to the primary care physician, when it is, even after a few years, the patients, most of the time patient sugar remains between 7.5 to 8.5. They don't achieve the target A1C of around 6.5 or 7. So I mean, if you try to achieve a target of 6.5, I'm sure many of your patients will achieve A1C of around 6.8 or 7.1. So I mean, that sort of around 7, we are not moving. We are moving around 8 A1C, and that's the reason for our uncontrolled diabetes. Whether you use combination, whether you use insulin, whether you use multiple combination, but still this is the fact, and this is fact is from the diagnosis to 10 or 15 years, and this is one of the most important reasons why patients are developing diabetes complications in our country. And otherwise also they are getting diabetes in their 30-40 and in 50-55 because of their uncontrolled diabetes. Many of our patients, they develop micro and macrovascular complications. So this lack of awareness is not new. I mean, since years, which we are seeing the data from India, even from the data of Cure, which is published from Dr. V. Mohan, that our patients are not understanding, they are unaware about the diabetes condition, whether that can lead to complication. They don't know about that. It can lead to even heart attack, even it can lead to kidney failure or a foot problem. So the awareness about the diabetes and its complication is very, very low, and that is not improved even after 20 years with so many data, so much of awareness program which has been done in our country is still, I think, one of the important reasons. So one side, we have the low awareness from the patient or the general public point of view. At the same time, we have a major challenge from our doctors, primary care physicians, who are not aggressively controlling our diabetes. And third, our government is also not taking care of NCD. They are considered it's a second or third. They may treat the complication, but still the infection disease is a major problem in our country, and that they try to deal with it only. So no medical schools, no medical students are taught about the diabetes or similar type of problem in medical school itself. This is very interesting paper Dr. Anuj Mishra had written in Lancet that there are some areas to focus to improve the management of diabetes in India. And one, he talked about the earlier diagnosis. I mean, this is what he talked, that we should try to have a campaign across the country for a early diagnosis, because 50% of our patients are not diagnosed. They diagnose with the complication itself, and then they should be provided at least basic treatment. And for basic treatment, we have to educate the healthcare professionals, primary care physicians across the country. So we have taken a campaign across the country. This was in 2018, in 19 and 20 and 21 as a president-elect and president of RSSDI. We have taken a campaign national level that let us try to do an early diagnosis and early treatment for these patients. Some simple intervention which can be done, like a smoking cessation and something like a regular exercise, upgrading the skills of physicians. That is what we are trying to do it. Specific solutions may be also required for some of the socio-cultural issues, and regularly updating our national guideline. And that is also, we are following international guidelines, and we are also trying to come out with our national guidelines, and that is also we are regularly updating too. Everybody talks, whenever we talk about this, that cost of treatment is very high. I also talked in last few slides that cost is a major challenge in our country. We know that diabetes is a costly disease, patient has to pay from their pocket, and diabetes is a costly disease. But very interesting statement which is done by IDF, International Diabetic Federation, and they had put in IDF Atlas that treating diabetes is not expensive. not treating it properly is very expensive. So this is something which is a very important statement, which I think we should write, all of us outside our clinic and also in the media, everywhere we should talk about that. Treating diabetes is not expensive. It is not treating it properly. I mean, somebody is getting the medication, but still is not achieving the target control. That becomes more expensive. It is the complications, which is because of an uncontrolled diabetes over a period of diabetes, uncontrolled diabetes, the person is going to develop a lot of complication. That becomes very expensive. I think that we should try to increase the awareness about that. So now my talk is about making diabetes more accessible. Could we really change in last 20 years or 25 years or 30 years? I will be talking about the diabetes research and RSSDA in last 50 years, what we could have done, but can we make it more accessible? In India, we know that it is here somewhere. Can you believe that we have a poor ratio of doctors in compared to in Pakistan? When I had seen this slide, it was to me also very much surprised, but it was published in BMJ Open in 2017. So forget about some of the developed country like Germany or USA or even Brazil, which is also a developing country, but in compared to Brazil, China and Pakistan, we are less. And government doctors in India is very, very less. I mean, still whatever we have the doctors, which is private primarily, we don't have the government doctors, and this is low doctor population ratio. And then I will show you the diabetes care and health facility, public health facility in India. And this is not improved. These are the paper which I am talking of last 2-3 years or 4-5 years, which is published. We are not talking of something which is before 25 years. So still the scenario for improving diabetes care in public health facility is very, very poor, because there is no clinical records. They are not maintained. The onus is on patients to keep their own clinical records. The facility for blood glucose measurement is available in some of the primary care sector. Yes, it is available, but A1C is not done. So the primary health care center, the A1C is not done. We have just asked some of the patients before some time. Dr. Vasant Kumar was talking that, will you believe that in India still there are a lot of patients who had never done A1C in their lifetime? I mean, sorry, in last 15-20 years, there is not a single A1C report is being done, and patient is developing straight with the complication. Lifestyle modification support, it means we don't have the dietitian, we don't have the educators, we don't have these facilities which are available in the government hospital or the only in some of the private few tertiary care centers have these facilities. The bicarbonates and sulfonylurea is the only available. Still, we run diabetes clinic in civil hospital. I mean, there's a government hospital, one of the biggest medical college in our country, 250 seats. We were also the part of, when we were studying, it was Dr. O.P. Gupta had started this diabetes department, but still in that department, metformin, sulfonylurea and insulin, only 3 things are available, and insulin is not available regularly or routinely, and again it is only premix insulin. Even statin is not available and can be given to the patients, and they don't have any patients' clinical records which are maintained by them. There is one Dr. Jayaprasad Tripathi who had published this paper, who talked that 42 physicians who were interviewed and poor follow-up, patient overload, lack of specialized training were the major barriers that emerged from the interview responses. Then they were saying that a lot of patients are there. Already 200 patients have to be seen, and how they can maintain the data, how they can give them a treatment. That was the problem in the public sector. Patient had to visit tertiary facility for drugs and routine follow-up. So sometimes the patient from PSC, these things can be done at PSC by giving them HbA1c, some basic medication, or by training these PSC care doctor. They had to visit the tertiary care hospital, which have medical college where more doctors are there for a routine follow-up. So what will happen? The tertiary care facility will also get congested, where the patients can be treated even at a primary level center. So the tertiary care center has to see more than 300 patients, and they are also not maintaining everything which they should do as a tertiary care center. There is no formal referral system, and most of the doctors in primary care facility did not receive any specialized training. Forget about the diabetes, about any non-communicable disease, and that's what they have lack of patients follow-up. But over a period of time, we all understood that diabetes is not a disease of one system only. It's not a system of only decreased insulin secretion. It is a multiple pathophysiological defects which are responsible for diabetes. And I think if I just say that the doctors who are trained or who are educated through this online CME, or those who are coming to the conferences, maybe 10,000, 20,000 physicians who are regularly engaged now in this program or these online diabetes education program, at least they all could understand one very simple thing: a diabetes is not a simple of an insulin secretion which is getting decreased and they have insulin resistance. So now they started treating diabetes with multiple oral anti-diabetic agents, because they now understand that it is not just sulfonylurea and metformin which is sufficient to treat the diabetic patient. So this is at least one thing which has changed in last 20-25 years. As I am practicing since last 1997, so 25 years, and I can see how the prescriptions from the rural area or from primary care physician is also changing in last 25 years. So type 2 diabetes management is a multifactorial management. Some of the doctors who are really taking keen interest in diabetes education, they are now talking of lifestyle and smoking control. They are talking about glycemic control. They talk about the obesity also. That is also a very important part of it. Blood pressure control, lipids level are to be controlled, and even when antiplatelets are to be given. So those doctors who are in private and those who are wants to know more about diabetes, at least they could understand that it's a multiple pathophysiological defects are there, and we have to treat diabetes not just a glucose centric. We have to treat multiple other problems also, like body weight, blood pressure, and lipid levels too. This is one trial which I always talk, that it is the multifactorial management of type 2 diabetes can decrease the micro and macrovascular complication both. And this is what is 1002 trial. A very fantastic, with the 7.8 years of a treatment with 21 years of follow-up, had shown that it can decrease the microvascular and macrovascular complication and increase the survival, and there is a decrease in mortality also. So diabetes can be controlled, and with other factors, if we control simultaneously, probably you are improving the care and improving the survival for the diabetic patients also. So that's very important message which our primary care physician should know. Our current understanding of managing diabetes is changed completely. Now we talk more about the cardiovascular outcome data. We talk about after 2015, it is not only the glucocentric approach, it is not only the ABC approach, only blood pressure, cholesterol, smoking cessation, or the weight reduction which is important, but at the same time, the medication which we are using, they should also give the primary and secondary prevention of cardiovascular complication in a diabetic patient. Where 2/3 of our diabetic patients, they die because of that. So the two major changes which had happened, one is the CV outcome trial data had shown how we practice the diabetes. Now, how we deal with diabetes is not just giving them any anti-diabetic agent. We have to give a medication which will decrease the cardiovascular mortality and cardiovascular complication. And second, one more thing which had come, sorry, that one more slide which was there, that is talking about the continuous glucose monitoring. In last 5 years, we also understood the glycemic variability also equally important. It's just not the glucose control is important, not just A1C, it is the glycemic variability also to be controlled, and we want less and less glycemic variability. This is RSSDI ESI guideline, a therapeutic circle, a unique circle which has been provided by RSSDI guideline, which is talking about ABCDEFGH approach, which is A for the patient, what is the A1C, what is the body weight, what is the CKD status, duration of diabetes, established cardiovascular disease, financing condition of the patient, general glycemic load of the patient, and hypo risk of the patient. On that basis, you decide the therapy when you are dealing with diabetes. And this is the Indian guidelines, and across the country, multiple talks we do on these Indian guidelines, these RSSDA guidelines, on a unique therapeutic circle. So this is very important for all our clinicians. But now we are moving from the way before 100 years, a very personalized treatment was there. A doctor used to see a patient and then he used to decide. And then we had come to the patient-centered care. That is what the patient is there, and we have to deal with the patients and pharmacy and the patient education and telehealth and everything comes around him, and we want to have the best treatment. Then came the team approach. It is not only the patient-centered care, but different specialists in diabetes field particularly, they all should take care. And if they all can be in a one center, then a tertiary care center where educators, mental health experts, pharmacists, dietitian, educator, doctors, assistant doctor, everybody has to do it. And then we came with the guidelines and protocol base. I mean, the guideline was talking that how patient is to be treated, whether the patient require this drug or that drug, whether they need as per their cardiac status, as per their CKD status, guidelines and protocols came. And then the very precise treatment had come because of our continuous glucose monitoring with the diagnosis of the patient by genomics, like we are getting now the patients who is actually a MODY patients, not a type 1 diabetic patients, not type 2 diabetic patient. So you will treat the patient with a specific drug to achieve a tight control. That is what the precise medicine, not just everything or whatever the guideline had written. You just don't put all these medication from the same. And then we were having, then we came with the artificial intelligence. Now with the help of data, with AI, even without the doctor also, we can have some of the information and treating these diabetic patients or the creating protocol for these patients with artificial intelligence again. And now we are coming back with the personalized medicine. So again, with artificial intelligence, with personalized precision medicine, with guidelines, with team approach, with patient-centered care, again, we are coming to the very much personalized medicine to treat the diabetic patients with that. This is one thing which we have done, started in our clinic, in our city. We have with us Dharmender, Dhruvi, Sanjeev. This is published in Journal of Clinical Diabetology, and there's a blue index health score. So each and every patient who is coming to our clinic, we try to understand what is his A1C, what is his blood pressure, what is his cholesterol, what is his diet, what is his exercise, whether his follow-up is regularly or not, what about his general health, what about his habits, whether he is having infection control, vaccinated or not vaccinated, and what about the medication which he is taking, what is happening to him as far as any medication side effect. So this is very easy way of approaching these patients with a very personalized way of treating these patients, and all these things are taken care by the diabetic educator. They don't need even the doctors to see. Before they come to the doctor, we can understand that whether his A1C may be good control, his cholesterol may be good control, his blood pressure may be good control, but he's not adherent with the diet. So the doctor will spend maximum time for the diet only, to educate him about the diet. Suppose he's doing diet very good, but he's not doing exercise. Then also the doctor will know that this is the red area where he has to talk about the exercise. Suppose some patient might be doing everything good, but he is not doing follow-up. He is not doing follow-up regularly, neither with his primary care physician or with his doctor. Suppose he is doing everything good, but his general health is not good. He is having malignancy. What's the point of now achieving a very tight glycemic control for that patient? And that's what important point which also we must understand. If he is not vaccinated, if he is having some side effects of the medication, he might be achieving the best control out of it, but patient is not comfortable because he is getting a lot of side effects. So this is one very simple blue index health score which we have created just to educate our patient and to be taken care by our educator before they approach to the doctor's clinic also. So this is what a very simple blue index which we have created. So the type 2 diabetic patients, even whatever best we are doing, still we are winning the battle but losing the war. That means that we are trying the best of the best medication. We are trying to decrease the cardiovascular mortality. We are trying to achieve a tighter glycemic control. We know that by achieving tighter glycemic control, we can reduce the complication also, but still it is not happening in real world. Still 2/3 of our diabetic patients are not achieving the good control. And this is even after improving so much access for our diabetic patient, still our patients are not achieving a tighter glycemic control. And that's what in next decade we have to work hard that access may be improved, but access for diabetes care, it means more doctors are to be trained and more awareness are to be created for improving diabetes care in our patients. With this, I once again thank you, Dr. Neglur sir, for inviting me, Dr. Neglur and Dr. Benny Neglur both, and thank you for giving me this opportunity. Thank you.
Thank you, Dr. Bansi, for that excellent talk. Dr. Bansi, do you agree that too many medicines has led to confusion also, because now there are too many permutation combinations? So more medicines has led to greater confusion. And
but Meena, I think it is required also. We know there is a multiple pathophysiological defects which are responsible. So if I suppose somebody come and ask me that what is the role of now the alpha glucosidase inhibitor, or role of suppose glitazone, which has not been prescribed by many of our American colleagues, or somebody from Europe, somebody say that what is the role of now sulfonylurea? After 2-3 drugs, you can start them with the insulin only. So I think there is a role for each and every molecule which is available. And those molecules which are not very important, I don't think we are putting them in guidelines. Like hydroxychloroquine also decreases the A1C. So we are not creating or increasing the confusion. If you see our RSSDI guideline also, very particularly we have written that even the saroglitazar and hydroxychloroquine, which had shown there is a glucose lowering effect, but probably they don't have the role or a place in managing diabetes. And we are not increasing the confusion for our primary care physician. We are also restricting or the number of molecules which are really useful, and they will be useful for some stage of diabetes in our patients.
Sanjay is back. Sanjay, are you ready with your presentation?
I have sent it to the RX people so they can project it.
Yeah, if they can do it, I think we can take your talk. Is it Abu?
I am fine.
Yeah.
I'll be more than happy to listen, Sanjay.
Yeah.
I must.
I apologize for the bad connection.
But Sanjay, I want you to be there because we are talking for 5 minutes, the RSSDI registry and RSSDI research.
Yeah, after 5 minutes, we'll have a discussion on that. So Sanjay, stay back after your talk.
Oh, yes. No problem.
Sanjay is the most important person. Even in Bhagavad Gita, it says Sanjay.
Oh my God.
So whatever Sanjay says, people used to listen. The Dhritarashtra used to listen to what used to happen in Kurukshetra war field, because Sanjay has a very important role to play in Mahabharata of diabetes as well. So Sanjay, your time.
Everybody listens in India also. The Sanjay Agrawal.
Yes.
Bansi, kuch galti ho gayi to bata do.
Sanjay, what sir is saying is that you are a warmonger.
Yeah.
Project my slides before these guys go totally tandem.
I know. You advise Putin also about stopping the war.
All right. Thank you so much for projecting. I apologize. I'm not going to waste too much of time. Somebody will have to just... can I take control of the screen remotely? Okay.
Yes, sir. Just I give
How
it
do I
to
do
you.
that?
You got a notification to accept that control.
I can't get it. Anyway, what you do is I'll just say next. Forget it.
Yeah,
Let's not waste time. Okay. So I think, wait, don't go forward. Wait. What are you doing?
Fast forward is doing.
Go back. Okay, here you are. All right. Thank you so much. And I apologize for having missed out earlier and delaying the whole proceedings, but I'm not going to waste too much time. And as I said earlier, that essentially, we're talking about the use of GLP-1RA and SGLT2 inhibitors in women. And I would like to start my lecture with the premise that basically the data on such a thing is very sparse and not really very robust. But the overall benefits of both these molecules is clearly outlined, and it's really not very, very gender specific. So I think with this, having said this, the RSSDI also sort of recognized the role of managing diabetes a little differently in women, and we came out with our own initiative and a publication that has been projected out here. But let's look at what really matters when we treat diabetes in women and the use of these molecules. So may I have the next slide, please? Thank you. So what I would start really is the risk higher in women? Next slide. Clearly, that the risk for cardiovascular complications is higher in type 2 diabetes, whether it's men or women. And we know that the risk for unstable angina, myocardial infarction, heart failure, stroke, and peripheral arterial disease all increase variably all the way from 53% to 72%, and the risk for peripheral arterial disease increases by 28%. Next slide. But what is important is that when you have patients with diabetes, you never have it alone. You always end up that at some point of time during the course of diabetes, the patient has associated obesity, hypertension, and you end up sort of looking at this triumvirate to see that, we are not only managing glycemic control, but you're also doing some weight regulation and hypertension control, because these are present more often than not in almost about 80% of our patients with diabetes. So whatever treatment that we look at, we need to ensure that we are addressing the glycemic control, we are enforcing a weight control, and we are obviously having a beneficial effect on the blood pressure of the patient. Next slide. So 8 out of 10 persons in India have at least one feature of this phenotype. And obviously, as I just mentioned to you, that the overall treatment requires a comprehensive treatment of all these three problems that come together. Next slide. But the gender differences are really very little when it comes to incidences of diabetes. They're more or less similar in men and women till the reproductive period of the women. But due to hormonal changes, the risk of development of diabetes increases in the postmenopausal women. And that's because of some reasons, that there is a reduction in the insulin sensitivity, there is an increase in the visceral fat, there is an increase in the waist circumference, obviously androgen profile increases, and there is a reduction in the adiponectin. So obviously postmenopausal women have a little different way to address, because we have to look at all these factors in the women. Next slide. But what really predisposes women for an increased risk for cardiovascular diseases is a host of factors that tend to occur during the life cycle of the women: the hypertensive disorders during pregnancy, gestational diabetes, hormonal changes which happen postmenopausally, polycystic ovarian syndrome, use of OCs, premature menopause, and hormone replacement therapy. And we know that coronary artery disease causes death in the female gender more than any other pathology, and the mortality rate for coronary artery disease is higher in women than in men. Next slide. But in the typical phenotype, the Indian phenotype, there are multiple risks involved. We know that we have a lowered BMI, but for the lower BMI, we have more abdominal fat, more insulin resistance, high level of C-reactive protein, lower level of adiponectin, high level of leptin and triglycerides, and there is an increased susceptibility to type 2 diabetes and coronary artery disease. And we have a characteristic dyslipidemia of low level of HDL and high level of LDL. So whatever we do, we need to sort of avoid the risk. And next slide, I'll just come to that. That we have seen that every 5% weight increase is associated with a 33% increase in the diabetes prevalence. And now we come where women are concerned. A 1.5-fold BMI increase is associated with a 90-fold increase in diabetes incidence in women, and a 40-fold increase in diabetes incidence in men. So clearly you can see the disparity over here, and ectopic fat makes a big difference. Next slide. But the evolving role of SGLT2 inhibitors in Indian phenotype has come about, and we are seeing now that there is a more expanded role of SGLT2 inhibitors beyond just glycemic lowering. And if you look at the challenges that I just mentioned earlier, for the high abdominal adiposity and visceral fat at any given BMI, SGLT2 inhibitors reduce the body weight, and they cause more reduction in the visceral fat mass as compared to the subcutaneous fat. We have a high waist circumference and a waist hip ratio, and SGLT2 inhibitors tend to reduce the waist circumference. We have a low level of adipokine and a high plasma leptin, which increases the concentrations of triglycerides. And we know that SGLT2 inhibitors reduce both the triglycerides and leptin. We have a low rate of glucose disposal, and SGLT2 inhibitors increase the rate of glucose disposal. We have impaired insulin secretion and increased insulin resistance, and SGLT2 inhibitors improve beta cell function and reduce the insulin resistance. Now, you extrapolate that in terms of gender specificity, and we know that most of the Indian women would have a lot of these features which are characteristic of them. And clearly that SGLT2 inhibitors have a clearly a high role to play when it comes to women in our country who have diabetes. So we are looking at the possibility that why can't we use SGLT2 inhibitors in all our prescriptions, given the fact that it has such wide, improvements beyond glycemic lowering? So whether it comes to cardiovascular risk, cardiovascular events, renal risk, obesity, and of course, when it comes to fat mass reduction and all the problems associated with it. Next slide. So I'm really going to look at some of the guideline approach that we've got today and what should be a logical approach. Next slide. Next slide, please. Yes. If you look at the ADA algorithm that was put out this year, we have a clear defined role for the SGLT2 inhibitors and GLP-1 analogs. And we know that after lifestyle and metformin, the expanded role has now come to see that, okay, does the patient have ASCVD risk, heart failure, or CKD? And irrespective of the baseline A1C, the recommendations for GLP-1 analog and SGLT2 inhibitors have clearly been outlined as an overall that we know that various CVOTs have said the benefits of GLP-1 in patients with the ASCVD risk, whereas when it comes to heart failure and chronic kidney disease, we know that SGLT2 inhibitors have an expanded role. But even if you look at patients who have obesity or a weight gain, the role of SGLT2 inhibitors and GLP-1 analogs have a higher hierarchy because we know that these two molecules have the greatest weight benefits. And when it comes to patients who have an increased risk for hypoglycemia, again, these two have a high sort of hierarchy, the higher role to play. So we see now that when we treat our patients with diabetes, we always have at the back of our mind that can we use a GLP-1 analog or an SGLT2 inhibitors in this particular patient who sits opposite us. Next slide. This has been validated by various societies. So if you look at even the ACE algorithm, the ESC algorithm, and more or less they're on the same lines. But what I really mentioned to you earlier about the association of weight with diabetes, and we know that as weight increases, the incidence of diabetes also increases. So when you look at the use of these molecules in terms of weight loss, we know that there is a clear benefit, but they do have different mechanisms of action. So when it comes to SGLT2 inhibitors, the weight loss comes through calorie loss due to increased renal glucose excretion. And when it comes to GLP-1, there is an inhibition of the gastric emptying. There is a decreased calorie ingestion due to increased satiety, and there is, of course, the effect on the acid secretion. So more or less, these two molecules can be combined for the beneficial effect on the weight control. Next slide. There are certain sex-specific effects of GLP-1 analogs, and in some of the trials, it's been shown that females show greater weight loss and more GI side effects. Now, if you look at all the GLP-1 RAs, whether it's exenatide, liraglutide, albiglutide, lixisenatide, dulaglutide, or semaglutide, it has more prominent weight loss in females. It has similar reduction of cardiovascular risk factors between sexes. It has similar reduction in A1C levels between sexes in the majority of the studies. There is a similar risk for hypoglycemia between sexes, but there is a more prominent GI adverse events in women. Next slide. We don't really have to talk too much about the benefits of SGLT2 inhibitors, which is not really gender specific. And if you look at all the trials, we know that the SGLT2 inhibitors have equal benefits, although there are subtle changes between the two sexes, as I talked about in the next few slides. But we cannot dispute the fact, the effect of SGLT2 inhibitors in acute heart failure, chronic heart failure, congestive heart failure, CKD, or type 2 diabetes. We know that all the effects are clearly benefited with the use of SGLT2 inhibitors. Next slide. But 5 key benefits in the Indian phenotype have been highlighted: that it has a fast duration of action, it has good glucose lowering, the effect on weight loss and BP reduction is excellent, and what is important, it caused the weight loss through 2/3 reduction in the fat loss, and it has, of course, an insulin-dependent mechanism of action, so there is a low chances of hypoglycemia, and nobody can dispute the proven cardiovascular, renal, and other pleiotropic benefits that SGLT2 inhibitors. So today we really have to justify that why should we not use SGLT2 inhibitors in all our patients with diabetes. Next slide. We're going to really highlight some of the cardiovascular benefits. Next slide. So this was a good paper which looked at the population-based cohort study, which assessed sex disparities and the cardiovascular risk. And if you look at the primary MACE, adjusted and unadjusted, myocardial infarction, again, adjusted and unadjusted, and the risk for stroke, you can clearly see the risk is higher in women as compared to men. And we know that what this paper really talked about is that women with type 2 have less well-controlled A1Cs, lipid levels, and blood pressures as compared to the male counterparts. Next slide. And this was also sort of talked about by Avdesh in his paper, which was published last year, that when you look at the gender differences in cardiovascular risk, women have less well-controlled A1C, lipids, and blood pressure, and received less intervention as compared to men. And we have, of course, through various studies, the guidelines have promoted the benefits of SGLT2 inhibitors and GLP-1 RAs. But what is not very clear is, does the benefit extend equally to the women who are underrepresented in these trials? Next slide. If you look at the effectiveness of cardiovascular outcomes when they were compared against sulfonylurea, and they looked at, of course, the SGLT2 inhibitors, the GLP-1 RAs, and the DPP-4 inhibitors, you can see here that the effectiveness of GLP-1 was much stronger in women as compared to men against sulfonylurea. And when you look at SGLT2 inhibitors, again, the benefit was more in women as compared to men when compared against sulfonylurea. Next slide. This was, again, as pointed out by Avdesh in a study, a meta-analysis of 3 CVOTs, and they looked at the effect on SGLT2 inhibitors, MACE outcomes in women versus men, and they showed that there was a significant reduction in MACE in men, but not as much in women. And this study consists of almost 65% of male cohort and 35% in the female cohort. Although none of these studies, when they looked at gender specificity, did not have any p-value significance, but there was a clear benefit in, a tendency to benefit in men as compared to women. But what about the GLP-1 analogs? Next slide. And if you look at the same sort of MACE outcomes in women with GLP-1 versus men who received GLP-1 analog, they showed that there was a significant reduction in MACE outcomes in both sexes. So although the trials did not really achieve clear significant benefit in terms of p-value, but there was a tendency to improvement in both the sexes when it comes to the use of GLP-1 analogs for MACE outcomes. Next slide. And if you look at the various studies that have been done, and if you see the representation of women in these studies, so although the overall benefits of these studies, when you look at the primary endpoints, cardiovascular death, and the secondary endpoints were clearly towards benefit, and this was clinically significant. In EMPA-REG, the women represented about 28.5%. In Canvas study, women represented about 35.8%. In the Declared study, the women represented about 37.4%. And in the SCORE trial, there were 44.9% of the trial population which were women. So clearly you can see that although the overall benefits were there, but this was not really gender specific, and both the genders really benefited from the use of SGLT2 inhibitors. And I don't want to get into the specificities of all the endpoints, but if you look at all the overall endpoints, there was a benefit in both the sexes, including the women, and they were adequately represented in these trials. Next slide. If you look at the GLP-1 RA trials, in the LEADER trial, the women comprised of about 35.7% of the population. In the REWIND study, 46% of the women were part of the total trial population. And in the SUSTAIN 6, there were about 36.8% of the total population which was studied. And you can see here, the benefit extended in all the population that was studied. And this was really not gender specific in any kind of a way. Next slide. And this was also true that women benefited from the trials for reduced ejection, chronic heart failure for reduced ejection fraction, as well as for acute heart failures. Next slide. Yes, we're going to talk a little away, and we're talking about the role of PCOS-related cardiometabolic risk. And we know that the risk actually stems from the heightened insulin resistance, increased incidences of type 2 diabetes, presence of hypertension, obesity, dyslipidemia, Natal, and metabolic syndrome. And use of SGLT2 inhibitors have shown clearly that it improves the beta cell function. It inhibits the glucose and the SGLT, it inhibits the glucose and sodium reabsorption and promotes glucose urine excretion. It decreases the gluconeogenesis and enhances the lipolysis, reducing the fat liver mass, as well as it decreases the blood glucose levels, as well as lowers the blood pressure. And it improves the insulin sensitivity, so improves the peripheral glucose uptake, and it reduces the visceral adipose tissue, promoting weight loss. So clearly, SGLT2 inhibitors in patients with PCOS also has a reduction in the cardiometabolic risk. Next slide. So there are certain cautions that really come with the use of these drugs, and I want to talk to you quickly about them. Next slide. I want to say that SGLT2 inhibitors have an increased bone fracture risk, and this stems, of course, from the effect of sustained release of parathyroid hormone, which controls calcium level in the blood, and increase in the FGF23, which is associated with bone disease. And ultimately, all this increases urinary phosphate and lowers the 1,25-dihydroxyvitamin D, which increases the risk of bone fracture. Now, US FDA added a warning in September 2015 about the reduction in bone density and increased fracture risk with the use of canagliflozin. And this was dose-dependent declines in the bone mineral density. So we need to, obviously, in postmenopausal women who have an increased risk of osteoporosis, we should be very careful in using SGLT2 inhibitors in this set of population. Next slide. This was also validated in the Canvas trial, which showed an increase, almost 26% increase in the risk of fractures. And this was more for the postmenopausal women. Next slide. What about genital mycotic infections? And women reported a higher infection rates than men. And this was seen across all the trials of SGLT2 inhibitors. So obviously, we should be advocating a heightened sort of, awareness about risk for genitourinary infections when you treat patients, particularly women, and you have to teach them personal hygienes and the risk for infections and how to recognize them. And if they do develop increased risk of infections, then we should stop them, treat them, and then restart them. But importance is that you have to talk to them about hygiene standards when you use SGLT2 inhibitors. Next slide. This was also seen in the studies where they showed in the dapagliflozin study that whether you use 5 milligram or 10 milligram, the risk for infections were more with women as compared to men. And if you look at the next slide, the risk was as much with the canagliflozin study. Next slide, please. Yes, this was a canagliflozin study, which also showed an increased risk for genital mycotic infections for women as compared to men. Next slide. So I'm not going to end up my talk with some key takeaway points in summary. Next slide. I want to ask myself this question: should GLP-1 RA be the first choice in women? And if you look at the pharmacokinetics of exenatide and liraglutide, when you combine it with metformin, there are better therapeutic results in women as compared to men. But if you look at liraglutide studies, the changes in body weight, which are linked to female gender and baseline BMI, are higher with the female sex. What about the cardiovascular outcome trials that have shown that GLP-1 RA has significant protective effect for cardiovascular events, which is true for both the sexes? And a meta-analysis shows that GLP-1 RA decreases major adverse cardiovascular events in both the sexes as compared to placebo. Next slide. If you look at the glycemic control is better in men as when treated with exenatide, but liraglutide effects on glycemic control is better in women. And I really don't know the reason why. I haven't been able to find a good reason for this. But other studies have shown that women have a higher rate for gastrointestinal adverse effects, but GLP-1 RA-induced gastroesophageal reflux is similar. It has a similar rate in men and women. Next slide. What about when you look at tolerance when compared against SU, and we know that GLP-1, DPP-4, and SGLT2s are better tolerated in women when compared with SUs when severe non-fatal adverse reactions are considered. And the importance is that the use of contraception is recommended in fertile women when treated with GLP-1 RA. Next slide. What about SGLT2 inhibitors? From the dapagliflozin studies, we have seen that better responses are seen in women with major adverse cardiovascular event reduction as compared to men. And others show similar protection in men and women when vascular risk and death, amputation, fracture, genital infection, and urinary tract infections are considered. And another meta-analysis showed that there is a trend towards greater reduction in major ASCVD outcomes in women as compared to men. Next slide. What about CVOTs performed with GLP-1, RAs, DPP-4, and SGLT2s? They've not been able to really provide a very rigorous comparison. And we know that there is an increased risk of genital infection with SGLT2 inhibitors, and canagliflozin can affect bone resorption and fracture risk. So as far as possible, you should use it with great caution in postmenopausal women. Next slide. I just want to end up my talk with this last slide. And this is really not a gender-specific slide, where we see the effects, comparative effects, and where are you going to use them? Because we know that we need to individualize. We need to look at all our patients and the overall sense, and we need to choose our therapies very wisely. So when you're using cardiovascular patients, when you're using GLP-1 RA or SGLT2 inhibitors for various indications, when it comes to cardiovascular events, both are protective. When it comes to blood pressure reduction, both are protective. When you look at patients for volume depletion, you have to be careful using SGLT2 inhibitors because it causes a lot of osmotic diuresis. So there is a word of caution there, but safe to use with GLP-1 analogs. Fracture risk is protective when it comes to GLP-1 analog, but you have to use it with caution when you use SGLT2 inhibitors. When it comes to heart rate changes, it is neutral with SGLT2 inhibitors, but used with caution GLP-1 RA. Heart failures, clearly SGLT2 inhibitors are protective, but the GLP-1 RAs are safe. When it comes to pancreatic disease, although GLP-1 RA has been said safe, I would not really agree too much there. You have to be very cautious when patients with at risk for pancreatitis or those who've had a pancreatitis. So you have to be very cautious and avoid using GLP-1 RAs in these patients or at a risk for pancreatic CAs. SGLT2 inhibitors are neutral. Genitourinary infections, GLP-1 RAs are neutral but used with cautions. And when it comes to amputation risk, you have to be very careful when you use SGLT2 inhibitors. So can I have the next slide? I think that's my last slide. So thank you very much. And I would like to thank Benny and Vijay and the whole team of Wodcon for inviting me today on this topic. Although I had to really use a lot of my innovative sense to see that, and I, of course, throughout their entire preparation, curse Vijay for giving me this topic. But at the end, I think I learned a lot from this preparation. So thank you very much for making this happen. Thank you so much.
Thank you so much, Dr. Sanjay, for the creatively handling that topic so well. With that, we invite Dr. Banshi Sabu sir for the very coveted talk on RSSDI research and registry.
We can make this little short so that in the interest of time, we are running behind by 15 minutes. So,
it will not take more than 10 minutes.
Yes, Dr. Banshi and Dr. Agrawal. Yeah.
Yes, we have Dr. Agrawal, who is RSSDA secretary. We have Dr. H.P. Chandalia sir is also there, I think.
Yes, he's there. Yes.
Can you see the slide?
Yes.
Yes. So first of all, again, thanks Dr. Neglur sir and Dr. Benny Neglur for giving me an opportunity. Dr. Vasant Kumar is not available, so I am just giving his talk. RSSDA research and registry, which you are asking. This is what the research from RSSDA. The 50 years of RSSDA, which was founded by Dr. M.S. Ahuja in All India Institute of Medical Science. And this year we are going to have the celebration of 50 year also, again at AMS in month of August. And the idea was to promote research in field of diabetes. That is what he thought of before 50 years. At that point of time, even number of diabetic patients in our country were not so high. It is significantly increased in last 30 years only. The research is promoted by RSSDI. We are having our own journal. This year, we are going to introduce one more. We have grants, which has been distributed from RSSDI also since last almost 15 years. We are regularly giving grants for those who are applying for it. We do annual meeting where young researchers, they present their work, and every year now we are getting more than 200 posters or papers which are asked for, and they are young researchers from all across the country. We do the dedicated symposia on MMS Ahuja and Dr. B.B. Tripathi. There are top diabetes researchers are getting recognized on the platform of RSSDI, and every year one young diabetes researcher award is also been introduced since last 10 years, and research is our focus. But still, we need to do much more, and that is what I'm going to talk that this year we are going to have a research retreat and a new meeting which is introduced after 50 years of RSSDI, and that's meeting is dedicated for diabetes research. This year, it is planned in month of May on 28th and 29th May. It is in physical format, but it will be also having some virtual part of it. Primarily, it is attracting all researchers who have done their original work. So we are requesting all those researchers, diabetes physicians across the country who have published their work in last 3 years, and they can present their work in this research retreat meeting. They need to present their work, and they also have to discuss the scope for collaboration. So whatever the work which they have done, still they want more work on the similar thing. They want more collaboration from the different doctors or many other associations. They can collaborate also. Many new research ideas and projects which we are going to discuss during this meeting. And it will be a new era in the field of diabetes research, which will get inaugurated under banner of RSSDA. There are multiple workshops which we are going to do, and it will be of hybrid meeting, which we are going to do on these 2 days, 28th and 29th May. The registry is a patient registry. It's an organized system that uses observational study method to collect the uniform data to evaluate specific outcome for a population defined by a particular disease, condition, or exposure, and that serves one or more predetermined scientific, clinical, or policy purpose, and that is what we call registry. There are advantages. A patient registry can be a powerful tool, observe the course of disease, to understand variation in treatment and outcomes, to examine factors that influence prognosis and quality of life, to describe care patients, including appropriateness of care, disparities in delivery of care, to assess the effectiveness, to monitor safety and harm, and to measure the quality of care. So these are the so many advantages, and that's what RSSDA is also looking for, some of the registry from our country. It is actually electronic medical records, but there are a lot of advantages which we all know, but there are problems in our country that people are not managing or maintaining their electronic medical records. And that's one of the major challenges, that why we are not able to have a registry. Even Dr. Sanjay is trying since last 2 years to have a uniformity in electronic health record software, and to create that uniformity across the country to the healthcare provider, to all RSSDA members. If we can have, then probably we will have the registry in much better way in compared to what we are planning just now. The adoption of electronic medical records, if I see the data from even US in 2016, the number of patients who were in registry, I mean in the electronic medical records, only 5% from our country. So 5% of our physicians or the doctors who are actually maintaining the electronic health records. This is older data of 2016, maybe in 6 years, slightly more increase maybe there. But there are challenges even in US also. So it's not like that Indian doctors are not maintaining the electronic health records. The similar type of situation was there before 10 years in US population also. So it's not like that. This is an NEGM paper which is published in 2009. In US also, the similar type of thing was there in 2009. So maybe in 2022, whatever the data which we are having, whatever type of electronic medical records we have, in another decade, which is going to improve. The big challenge, which we know that the little standardization across the clinic. So in India, the diabetes clinics are not standardized, or the primary care physicians or the general practitioner who are practicing also diabetes, that standardization is not there. The details of diabetes management records are not there, or not managed, or not maintained. The regular follow-up of these patients are not also there in our country. So the responsibility of a healthcare professional, I always say that, yes, taking utmost care of the patient, that is number one. One should do it. But publishing your knowledge and experience for the better tomorrow, that's also very, very important duty or a responsibility of a healthcare professional, and then to educate others. So the three things one must do. One, they should take care of the patient, they should educate others, and very important, they should publish their knowledge or experience for the better tomorrow. And that everyone cannot do it. They should do it by at least providing their data, by keeping the electronic medical records properly. This health data which they are having, they can publish at least real world data, and that is going to help for the better tomorrow. Registry are not there in our country. That's not true, because there are few successful registry which has been done. ICMR cancer registry running since several decades. So it is very, very successful registry. Even from 2006, ICMR young diabetes registry is also there. I am one of the part of it. And this is the CKD registry, which is also very successfully running in our country, from which Dr. Sanjay had taken some of the inputs. And we are also trying to create our own registry also. Hemophilia registry is one of the more successful registry from India government, which is also successfully running across the country. So RSSDI is also creating a platform to participate in the registry. We are planning to have type 1 diabetes registry, which is already almost rolled out in our country. Hypoglycemia registry for that, and hyperglycemia and pregnancy. These are the three major things which we are thinking from RSSDI platform. Why we want to do it? To continue to improve the patient care and clinical outcome worldwide by collecting reliable and real-world clinical data. Build on the success of RSSDI to initiate long-term, large-scale global registry. Collect reliable data using a standardized, user-friendly electronic form. Provide a platform to allow participating physicians to retrieve and analyze their own patient data and for benchmarking. This is what our primary purpose, that they can retrieve their own data and they can analyze their own patient data and they can have a benchmarking also. Why India needs a type 1 registry? We thought of, let us start with a type 1 registry. The one of the problem is we have limited data for type 1 from our country, from prevalence point of view. Even whatever the data which is there, it's conflicting. Many patients, but no proper records. This IDF shown that we are probably IDF Atlas has shown that we are having highest number of type 1, more than even US also, type 1 diabetic patients in our country below the age of 15. Limited publications. Even we have so many number of type 1 diabetic patients, still the data publications from our country is very less. We don't have national consensus guideline for type 1 diabetic patients, and that is what we are doing this year, that we are going to have a guideline for type 1 diabetic patients too. So registry can remove the discrepancy between different data, because in India, the data which is been shown 97,000, 18,000 per 100, 18,000 children, they may have diabetes incidence, which was published in 2013. Even the patients who are there, how many of them are dying in young age, how many of them are developing complication, nothing we can have. So unless we have registry for type 1, probably these data will come for our country. Registry will improve the standard of care also. The good clinical practice on one hand and medical errors on other hands can be analyzed. The healthcare professionals, including pediatrician, can be evaluated, therefore their care will improve. The overall objective is to reduce morbidity and mortality while maximizing the cost effectiveness of diabetes care is important for developed country as well as for developing countries too. So with this, we are going to have registry from our country. We are going to have more research from RSSDI, how to help more research in our country. That is our plan. And I would like to have the comment from Dr. Sanjay Agrawal, what is he has planned. Already whatever we had planned in last 2 years, which I have discussed, but this is our plan for in coming 5 years, more diabetes research and more registry from diabetes in field of diabetes from RSSDI will be rolled out in our country. Thank you. Once again, thank you very much.
Thank you, Bansi. I think it's been an excellent summary of what we actually thought in the last 2.5 years. What we've really realized is there is a huge paucity of data on the Indian population, and we need to build this data up. And we know that whatever we outline, whether it's in the guidelines or, whatever policies that we want to do, we need to have a population-specific data. And that's where we have actually started, avenues to see how we can collect them. The second is research remains the ethos of our society. And we need to encourage people to, get into research. So while we've got excellent researchers all over the country, we need to cultivate young minds to get into research and promote research at all levels in every part of the country. So at state levels, we have, of course, encouraged state bodies to see that they can give us small grants to, people who are interested in research. We want to encourage students also during the formative years to take up research. And of course, the larger grants, we are rolling it out from the central body, multi-centric and single centers related studies. So we have, of course, now Bansi's become the research chairman. And we've got a very good vetting process to see that all proposals that come to us, we look at them from the merit of the proposal and see that we can give them grants. We are proud to say that we've been rolling out grants to the tune of about 2.5 to 3 crores a year from the body to see that we can encourage research. And we are willing to do more for that. And even state bodies have been extending grants. So, I don't think there is anything that prevents anybody from taking up research. We want to encourage that. At the same time, we are trying to see how we can have our own population-specific data collection. This is through various means. And we are trying to prepare the diabetes grid of India, where we can plug in data from all sources so that on a backbone, we can, have all this data talking to each other. And just as a cancer grid society is maintained by the Tata Memorial, we're trying to see that we can develop the diabetes grid of the country, where all, research, all data that comes from any sources can be put on a single framework, and, anybody can harness data out of it for their own purposes. One thing that we're also trying to do in terms of promotion of research, and Bansi may have missed out in speaking that out, we are trying to put up a sort of a competition where we're going to invite proposals all across the country, and each one of you can write a proposal in about 300 words, 500, we'll decide that. And there'll be a submission platform for this research to be put up. Now, we will have a committee which will look at all these research and pick up 20 best proposals. And of the 20 best proposals, we're going to select 6 of them, which will have the opportunity to work with the top researchers of the country. The grants for this proposal are going to come from the body. So you don't have to really look for grants. We are going to give the grants, but each of the 6 proposals will get opportunity to work with 6 top researchers of the country. And the other 14 will be groomed by the next level of researchers to cultivate into a higher standard so that they can reapply next year along with other people. So we want to see that everybody gets opportunities to work with top level researchers and, cultivate habits which will be sort of, which we can sort of have a kind of a research ecosystem which will develop at all levels. So this is something that we are looking to introduce in our research retreat program. And we will give all the funding for the 6 top researchers, and that, we will see what best we can do. So they will work with them for a prospective study for 1 year or 2 years, which will be totally funded by us. And we want to see that people take maximum benefit. We'll be announcing this very shortly. So I think I don't take up too much of time. I know we're running behind time, but as Bansi pointed out, and as I've just said, we want to see that RSSDI goes almost to international standards. We want to see our data is upgraded. We want to see that we feature in all the top world research that happens, and we have adequate representation of our population everywhere. And to do that, we have to take the benefits of all these initiatives, mentoring, and be part of this entire ecosystem. So thank you very much.
Great job.
Thank you, Dr. Neglur, sir. I just want, if Dr. H.B. Chandalia is there, he can have also comment. He's the patron of RSSDI. And we have with us Dr. Makkad also, President-elect for RSSDI. If he wants to make the comment for RSSDI activity related to research and what we are doing for registry. just for a few minutes.
Bansi, I'm very much enthused to hear what you're doing, and it's really wonderful. The stimulation of research that you have in your mind is unique, because this was our main objective, and we were always worried that our research is not picking up. So I'm very happy that you're doing that. My only problem about the electronic medical records, please, if you can develop a very good software and distribute it to everyone, but it has to be a very good software to incorporate all features, all aspects of diabetes records. So that would help tremendously. I looked at many softwares and was disappointed. So I think that will be, if you can focus on that, it will help us quite a lot. Except for very deep appreciation, I don't want to take any more time.
So we have already developed the electronic medical record of our own RSSDI, which I'll share with you. We have looked at it. We're just trying to see how it can be implemented, but the EMR of RSSDI is already ready, sir.
And during research retreat meeting, we are going to have a workshop only related to these electronic health records. Yes, Dr. Makkar, you want to make any comment, and then we end the session, close the session.
I think all has been said by, very much in detail by Sanjay, and I'm really excited to see how the research is going to shape up when it is supported by full scale by RSSDI. I'm quite hopeful that we are going to do a very good job with, promoting research in India in diabetes.
Go to Dr. Neglur, sir, for your final comments.
Thank you. Thank you very much for the great insight and the great work you are doing. We wish you all the great success and hope we really create a good base for research so that we can be part of the community who can project our activities to the world. Thank you. Back to the...
And to say the last word, I think Wodcon will also be there with you to do gender-related research.
We look forward to it.
Thank you. That's a great thing. Purvi, back to you.
After that great deliberation, we move on, and we were just in awe of all the speakers in the last session. In the frontline session, Dr. Banshi Sabu sir, Dr. Sanjay Agrawal, Dr. Anuj Maheshwari sir, excellent deliberations. And we move on to the masters. And may I welcome Dr. Manoj Chawla, consultant diabetologist and director at Leena Diabetes Care and Mumbai Diabetes Research Center, Mumbai. Dr. Sanjay Agrawal, sir, director, Asian Clinic Diabetes Care and National Secretary of RSSDI. And Dr. Shefali Karkhanis, founder, co-director of Karkhanis Super Specialty Hospital, Thane, and also the scientific co-chairperson for this Wodcon conference. Without much ado, may I hand over the session to the able chairs.
Hi, Shefali, do I take it ahead?
Yes, sir. Yes.
So, because I was also confused with the order changing here of the talks, I believe Dr. Neglur sir will be delivering the next talk.
Yes.
Right.
Yes.
And well, it's very difficult to introduce the one of the persons involved in doing the conference himself. Dr. Neglur, of course, is the co-founder and medical director at Dr. Neglur's Diabetes and Thyroid Specialized Center at Thane. He's an honorary associate professor of medicine since the last 20 years at Rajiv Gandhi Medical College and Shivaji Hospital, Kalwa, and currently one of the leading teachers in PHFI, and everyone here who knows him can vouch him for his teaching skills and how people look forward and are eager to learn every aspect of medicine from him. On the advisory board of various companies, and he's earned the title Syndrome Man and the Gentle Giant in Diabetes. It gives me great pleasure to welcome Professor Dr. Neglur, who will be speaking to us on hepatogenous diabetes. Is it time to separate it from type 2 diabetes? Dr. Neglur, sir.
Thank you, Manoj, for your kind words of introduction. Thank you, Wodcon, for this great opportunity to speak and discuss about the hepatogenous diabetes. Is it time to separate it from type 2 diabetes? We know liver has many functions. It does synthesize and store amino acids, proteins, vitamins. It has important functional detoxification, blood circulation, filtration, bile drainage, and most important is a blood regulation of glucose. And we know it's the metabolic hub. which regulates the energy to the skeletal muscle and the adipose tissue. And to do this, it requires multiple nutrients, hormonal and neuronal signals, which ultimately regulate this very tightly. And any disorder in that is the one which results into accumulation of fat in the liver and eventually brings about liver function, which is affected. And that's why Roy Taylor said that before the diagnosis of type 2 diabetes, there's a long silent scream from the liver. So liver forms the most important organ so far as the glycemia is concerned. So physiology of homeostasis begins with the blood coming to the liver from the portal system, carrying with that glucose, other nutrients, insulin, and incretins, all of them get into the liver. So liver does the job of doing glycogen synthesis, inhibiting gluconeogenesis, and de novo lipogenesis. It allows the intake of glucose into the adipose tissue. It's very important to understand that glucose has a function to produce glycerol in the fat tissue. And when the fatty acids come in, it forms the backbone of the triglyceride. So that's the reason why glucose gets into the adipose tissue, and also glucose is necessary for the skeletal muscle, and the glycogen is also stored in the skeletal muscle. In the fasting state, it is in the other way, the exactly reverse of that. There is a glycogenolysis, there is a gluconeogenesis, and of course, even the fat synthesis also goes down, and the lipolysis occurs, and there is increased amount of fat getting into the muscle for the purpose of energy. At the molecular level, what you see here is that as the insulin comes here on the liver, it stimulates the SMILE transcription factor, which again inhibits the G6-phase and PepCK enzyme, and that brings about reduction of hepatic gluconeogenesis. And in the fasting state, it's a glucagon, which is a 7-pass receptor, also called serpentine receptor, which stimulates PGC1 alpha, which inhibits the SMILE protein or a SMILE transcription factor, which brings about stimulation of GPase and PepCK and brings about release of glucose. So very, very tightly regulated at the molecular level how the liver functions to regulate the blood glucose. What happens in the normal patient is that when the glucose when the insulin sits on the receptor, it initiates the PI3K and AKT pathway, which brings about reduction of glucose production or hepatic gluconeogenesis. But what happens in patients who have excess amount of fat in the liver, either because of excess consumption of fat or because of the de novo synthesis of fat by the liver or decreased beta oxidation, there's accumulation of diacylglycerol. The same thing also happens in patients who have got hepatitis C virus infection. They have an increased de novo lipogenesis, decreased beta oxidation, and that stops this PI3K pathway, AKT pathway, and initiates PKC pathway, which brings about increased gluconeogenesis by the liver, which actually is supposed to inhibit the gluconeogenesis. In patients with the context to the liver disease, what actually happens, we can see here that the insulin sensitivity definitely goes down. In patients who have got the NAFLD, either a non-diabetic with lean or obese, you can see here that the excess production of insulin secretion, that's because the liver doesn't pick up that insulin because of the poor liver function. And that's why there's a hypersecretion of the insulin in the peripheral circulation, which also could be contributing to the peripheral insulin resistance these patients have. And therefore, there's eventually a beta cell failure. And you can see here in the green line, there's a beta cell failure, and the glucose starts getting elevated in the blood sugar. So that's exactly predominantly the point in the liver. The liver doesn't pick up the glucose. This is the publication of Diabetes Care 2018, which looked at the meta-analysis of 16 patients, 16 studies, which says that the patients who have the fatty liver disease have a risk of developing diabetes almost to 2.5-fold, which again is a cause for the cardiovascular disease. And the NAFLD itself has got 64% increased risk of a cardiovascular disease, not forgetting the risk of hepatocellular carcinoma as well. So therefore, the type 2 diabetes and fatty liver disease is a bidirectional association. There's an association of fatty liver disease into developing type 2 diabetes and also developing a cardiovascular disease and hepatocellular failure. This is the publication from the Lancet, which looks at the food intake, which has changed because of the unhealthy lifestyle, where you large consumption of glucose, fructose, and sat fat, which ultimately results in visceral obesity and insulin resistance in the muscle, and under the background of the PNL-PA3 genetic background, and because of the dysbiosis from the guts, where we have the pathogen-associated molecular protein and damage-associated molecular protein, which brings about high influx of fat into the liver, which is more than 10%, which is responsible for the insulin resistance and the new onset diabetes. So therefore, the story begins with the liver because of the large accumulation of the fat in liver. Not forgetting that the infections also as a cause of dysbiosis, which brings about the changes in the protein in the receptors, the receptors and toll-like receptors in the intestine, which increases the permeability of the intestine and therefore resulting into the bacterial overgrowth, which brings about the insulin resistance, which also causes cardiovascular disease, type 2 diabetes, and also increases the appetite and blocks the satiation in these patients. So the microbiota in the intestine also has a contribution in a great way for the infectious disease. Taking all this into account, Roy Taylor was the first man who said that the twin cycle hypothesis, in which he said that the positive calorie balance, which causes increased amount of liver fat, and that liver fat increased VLDL in the blood, also increases the lipid in the internal milieu of especially the islet of Langerhans and produces the lipotoxicity, which also affects the function of the beta cell and therefore increases the plasma glucose with the reduction of the insulin production by the beta cell. So therefore, the positive calorie balance with increased amount of lipids and lipotoxicity causes diabetes as well. So we know that the insulin resistance is the key factor which brings about hyperinsulinemia and hyperglycemia. The hyperinsulinemia itself increases the steroid regulator element binding protein, which affects the liver, and also the carbohydrate related element binding protein, all of them under the influence of the genes which I mentioned earlier, like PNL-PA3, and the environmental factors, the dietary factors, brings about fatty liver and the NASH and the cirrhosis. So hepatogenous diabetes, which is actually a disease seen in patients of chronic liver disease to a tune of 80 to 85%, without history of standard risk factors of diabetes, namely the high BMI, family history of diabetes, and dyslipidemia. They have a normal fasting blood sugar, and A1C is also normal in almost 25% of the patients. That's why to diagnose hepatogenous diabetes, you need to resort to do oral glucose tolerance test. The evidence of retinopathy and cardiovascular disease is far less in patients of hepatogenous diabetes because the liver itself produces a lot of clotting factors. And because the clotting factors are less, so therefore the hypercoagulable state is also less in patients who have got compromised liver function, and therefore they have a decreased evidence of cardiovascular disease. Likely in the liver disease, the causes are the hepatitis C virus, alcohol-induced liver disease, and of course the cryptogenic etiology, which can cause the involvement of liver. It worsens with the parallel of the liver disease. As the liver gets worsened, the diabetes also gets worsened, and reverses once you transplant these patients with liver transplant. And this is also associated with the liver complications, namely encephalopathy, variceal bleeding, spontaneous bacterial peritonitis, and hepatorenal syndrome. So therefore, this is a very peculiar entity, and one needs to distinguish from the standard garden variety of a type 2 diabetes. This is the tabular form of showing the differences which I mentioned earlier, that usually it's a cirrhosis which is the cause, and we need to have oral glucose tolerance test to diagnose this. The risk of metformin-associated lactic acidosis is pretty high in hepatogenous compared to type 2 diabetes. Hypoglycemia is also pretty high. The liver transplant can reverse the hepatitis diabetes, and there's no traditional risk factor, which I mentioned already. So liver fat in the liver is bad, and that actually is the reason which causes high fats in the blood, namely triglyceride-free fatty acids, and reduces increases the ALT, and ultimately results into hypertension because of endothelial dysfunction and the heart disease because of cardiac lipotoxicity and energy dysfunction. So therefore, the fat in the liver disease is a core of the non-communicable disease like type 2 diabetes, the future cardiovascular disease, hypertension, atherosclerotic diseases, the NAFLD and cirrhosis, and of course the CKD, PCOS, sleep apnea, osteoporosis, name it, and there are many. So the genesis of the disease begins with the fat in the liver. Very simple test, very cheap test, which was used in the healthcare insurance program from Korea, looking at 142,000 patients, just estimating the SGPT or ALT. And it's very interesting to remember that the differences in the levels in men and women, men is below 30, women is 19. Remember, this is very important. And the high levels of ALT or SGPT has a risk of diabetes of 5 to 20-fold. And what is very interesting is when the levels are crossed beyond 30, you can see the risk of mortality of the liver mortality is pretty high, almost 9.5 to 59%, and all-cause mortality also 70% increased. So the main targets for the treatment of diabetes we have, of course, is the pancreas and skeletal muscle. We have the adipose tissue to reduce adiposity and lipotoxicity. Gut, of course, the incretin hormones are very important. And the idea is to protect the kidney, heart, endothelial, and of course, the brain and the eye. The liver is often forgotten and not included because people do not pay attention to the liver, though the establishment of the hepatic insulin resistance is responsible for the fasting hyperglycemia and contributes to glucose intolerance, and therefore the high prevalence of NASH, to the tune of NASH or NAFLD, to the tune of 70% in patients of diabetes. So we have this hepatic effect of treatment we have, and then we have a drug specific for the liver. We have the drug like FXR agonist, we have GKRP inhibitors, we have MPCs and glucagon receptor agonists. There are many of them. The time doesn't permit me to go in details, but suffice to say that GLP receptor agonists and GIP and GLP are the one which increase the insulin secretion, and it is the SGLT2 which brings about decreased insulin secretion. Lifestyle which we advise most of our patients for type 2 diabetes is the hypocaloric diet and the physical activity, which is the idea is to improve the insulin sensitivity. But in patients of liver disease, it is difficult because most of the patients are malnourished and they have ascites and edema, which hamper the physical activity in these patients. So it is not possible to advise that. There's a lot of thought about using metformin in patients with the cirrhosis or the liver disease, how safe it is. So this was the data which looked at from 2000-2010, where the 250 patients were given metformin after the cirrhosis was developed. And you can see 57% reduction in the risk of all-cause mortality with all stages of cirrhosis. You can see here that the survival benefit with metformin, with those who continue, with those who discontinue, you see the survival benefit again with the patients who have got cirrhosis, and those who have advanced liver, poor liver function, advanced the child criteria of B and C, even them you see the benefit. So therefore, the metformin is not intrinsically hepatotoxic. Hence, withholding metformin with the abnormal ALT, AST, or routinely measuring transmission is not supported. The sulfonylureas, of course, are good drugs to treat patients of type 2 diabetes. But here, because the beta cell damage occurs in patients who have alcohol-induced liver disease, and therefore they may not respond to sulfonylureas. There's a risk of hypoglycemia. It's very important because the decreased hepatic uptake of insulin, because of decreased clearance, and decreased hepatic gluconeogenesis. We must be careful of using sulfonylureas in these patients. TZDs, of course, no hypo. They improve the histology in the liver. They decrease hepatic fat, ballooning, and necroinflammation. But the concern is the retention of fluid and the weight gain. AGIs, of course, are good drug. They reduce the carbohydrate absorption. They decrease the PPH, reduce ammonia, which is very important, welcome need of the hour in patients of liver disease, increase the GI motility, and therefore sometimes they increase transaminases. And there are cases reported of hepatitis, especially with voglibose, and cholestasis with voglibose are reported, though quite rare. The SGLT2 inhibitors, of course, are the new kids on the block, and they also have a special role to play in the patients of cirrhosis of liver when they're given this drug. This is the mechanistic study which looked at the SGLT2 inhibitors in the management of ascites, the added benefit in reducing the hepatic and renal fibrosis, and therefore this was published recently in 2018. And we know that these functions, which again is published in Hepatology last year, shows that it improves the inflammatory infiltrates, the accumulation of triglycerides, and tunnel-positive apoptotic cells are decreased when you use the SGLT2 inhibitor. So these drugs have been well tolerated. They're very effective in these patients who have the impaired liver function, and they can be safely used. In fact, they benefit the patient's histology of the liver as well. The GLP receptor agonists have got the profound effect on the weight loss. And these are the trials which looked at the weight loss in SUSTAIN 3, SUSTAIN 7, and SUSTAIN 10. You see there's a weight loss which is quite significant. What's also seen is the pentraxin 3, which is again inflammatory marker in patients of NAFLD, which is reduced quite significantly by GLP receptor agonists. So these are the drugs. The preliminary data suggests that these incretins are beneficial in the chronic liver disease, especially NAFLD, but they're still in the process of learning. We have to still learn. The Indian molecule saroglitazar, this is the evidence-4 trial, which looked at the 104 patients of NAFLD, and it showed the benefit in terms of reduction of the ALT. It showed the absolute change in the liver fat content, and also the percent of liver fat reduction by 10%, and in patient with liver fat reduction by 30%. So it showed across the board the benefit in reduction. There are phase 3 trial in US in looking at this benefit of saroglitazar in patients who have compromised liver function. We all think that the insulin is a very safe molecule. And lo and behold, this study looked at is insulin preferred treatment for persons with type 2 diabetes and liver cirrhosis. This is the publication which has come in late 2021. And here it has 2,447 patients, insulin users, versus 4,000 non-users. This is the prospective. This is the real-world analysis, and it from the Taiwan registry. And what you see here, very interestingly, that if you look at the cumulative effect on the people between users of insulin and non-users, the non-users are benefited compared to users of insulin. Same is true for patients who have the hepatic fibrosis, and also look at the MACE. There's a quite bit of reduction even the MACE event itself. So this study shows that the effect of patients using insulin is quite harmful and increase the risk of death and liver-related complications and the cardiovascular event and hypoglycemia. We probably don't know the answer why this happens. It could be that insulin itself is a strong stimulus for adrenergic system and also produces endothelin-1, which is a strong vasoconstrictor. And that could be one of the reasons what these people believe that the insulin could have produced this kind of disaster in patients who have the cirrhosis and with diabetes, and therefore the management is difficult. So the approach is today is again weight loss, the risk factors to be treated, the liver-directed like vitamin E. Of course, there's no role much in the patients who have diabetes. And other approaches like statins and metformin, as I mentioned earlier. So should we modify our guidelines? Because we know that we have the guidelines which looks at the benefit of the heart and the cardiovascular disease and the kidney disease. Do we also look at the liver as well? Yes, it's important. It's time now we have to look at this guideline as well. Because 12.1 million, that is 17% of type 2 diabetes in India, have liver fibrosis and increased related liver disease due to cardiovascular comorbid conditions and mortality. Coexisting type 2 diabetes and AFLD, the risk is developed in developing cirrhosis and HCC is pretty high. Type 2 diabetes is strongly associated with cardiovascular disease, and the presence of NAFLD worsens it further. So therefore, we need to have a guideline which also looks into the liver and its associated problems in patients of diabetes. And we need to prioritize their treatment as well, either using the SGLT2, GLP receptor agonist, TZDs, and not forgetting metformin. So the key points that I would like to drive are the hepatitis diabetes develops in cirrhotic individuals as a consequence of the loss of liver function. Recent evidence suggests that liver dysfunction per se exerts detrimental effect on the beta cells, independently of the degree of glucose tolerance. Liver is a major site of drug metabolism, therefore increased risk of hepatotoxicity, which has to keep in mind. Increased of hypoglycemia and lactic acidosis. You have to keep very careful about insulin, sulfonylurea, metformin. Hepatitis diabetes usually represents with the normal fasting and A1C. Therefore, we require to do OGTT in these patients to make a diagnosis. And differentiation between classical and HT is important, both from the pathognostic and prognostic and the therapeutic point of view. With that, I come to the end of my presentation. Thank you very much for the patient listening. And I stop sharing my presentation. Over to the organizers.
Thank you. Thank you, Dr. Neglur, for that presentation on NAFLD. We know that every time there would be a topic which requires understanding of the basic sciences and pathophysiology, there is no better person than yourself. One quick question, Dr. Neglur. Would NAFLD be the cause or consequence of diabetes?
Yeah, as I told you, the presentation of the 6th meta-analysis, which showed that the NAFLD itself has a high risk of developing diabetes to the tune of almost 2.5-fold. So therefore, the risk of diabetes development is the origin begins in the liver. So therefore, I feel that NAFLD is the cause for diabetes rather than diabetes is the cause for NAFLD.
Thank you. And one other quick question, if allowed. You think going ahead with precision medicine coming in, people would evaluate that in an individual, what is the cause of their diabetes? Is it the kidney which is contributing? Is it the liver or something else? And then decide the therapy for that person.
Yes, always the precision medicine will be always useful, and you need to find out the real cause. That means the treatment of etiology is important. But I feel we tend to neglect the liver as one of the important organ. And as I mentioned earlier, it's the most important metabolically active organ, and it is the energy distribution, which is the most important function of the liver. And if that is taken care of, I think probably the management of diabetes becomes simple.
Thank you.
Thank you very much, sir. As usual, a wonderful lecture, right from biology, physiology, pathology to evidence-based medicine.
Thank you.
Thank you very much for that. It's a privilege and an honor to invite the next speaker, Dr. H.P. Chandalia, sir. Sir has been a teacher and mentor to many diabetologists all across the country. He is a director, endocrinologist, endocrinology, diabetes and metabolism at Jaslok Hospital and Denmark. He's been the past president and patron of RSSDI, has held many faculty positions, has had more than 75 articles and 20 authorships to his name. He's been an editor for many journals, including RSSDI textbook of diabetes. Over to you, sir. I welcome you to Wodcon.
Thank you. Thank you very much for inviting me, Wodcon, especially Dr. Dharini Krishnan. I'll start my talk on the nutrition in critically ill, and especially the critically ill diabetics. So let me start sharing the screen. Yeah, I'll share the screen. Okay.
So click here. Please.
Again came to the Share, do that.
While the slides are being shared, let me just say a word about Dr. Chandalia. He's our teacher, he's our mentor. Both Dr. Neglur and myself were in his ward, and it was he who started diabetology in Grand Medical College, and we have been one of his first students, and he has brought diabetology into the forefront. And what we are today, a lot of contribution has come from you, sir. Thank you very much.
Thank you very much, Benny and Vijay and all the conference organizers. So can I have the next slide? Will you be? Yeah, okay. So this is the outline of my talk. I'm going to discuss a little bit about stress, hyperglycemia, and diabetes, and a little bit resemblance between starvation and diabetes, and go to the main subject, that is enteral and parenteral nutrition in critically ill, specific references to diabetics. Next slide. Okay, so a little bit about stress, hyperglycemia, and diabetics that you see in critical care. They are not necessarily the permanent type 2 diabetics, but there are some who develop hyperglycemia quite severe in the critical care setting. And so there are known diabetics which are hospitalized, and additionally undiagnosed also. Sometimes diabetes is diagnosed during critical illness. And then there are those who develop stress, hyperglycemia, and sometimes steroid-induced, diabetes, which always in the background of probably some genetic predisposition. Next slide. Now, so these are the groups of people you see. You also see some impaired glucose tolerance of pre-diabetes going into diabetes there. And remember that pancreatitis patients will also have hyperglycemia. Whether they will persist with diabetes later on recovery is to be on follow-up, but at the time of the critical care stay, you have to look after their diabetes. So these are a variety of groups you're going to see. Next slide. And of course, hospitalized diabetic patients, the common diagnosis that diabetics you see in critical care setting is those with vascular events like a myocardial infarction or stroke. And then of course, those with infections, which mainly foot, the gallbladder, respiratory infection, and urinary urosepsis. These are the people who end up diabetics in critical care setting, and those who have surgery and trauma, and those with pancreatitis. So these are the group of people you're going to see in this setting, which we have to consider. Next slide. Okay, this is about stress hyperglycemia, how the sugar goes up during stress, and this was something we applied a glycosylated hemoglobin test at that time and published early in Lancet. There's also increase in glycation. So there has always been a debate whether stress hyperglycemia should be treated. So we discussed this in this particular paper that yes, it results in increased glycation and has to be treated. Next slide. So again, hospitalized patients, known, unknown, and all those we discussed. Next slide. Go quickly. Yep. Okay. Now looking in the reverse fashion, more than 25% of critically ill will show hyperglycemia. So in critical care, it's not a question of no diabetes. Sugar is high, that's which you start treating them. And of course, a large number of patients receiving total parenteral nutrition will show, a large number will show hyperglycemia until you modulate your what the feeds you are giving in the parenteral nutrition. Next slide. So very, very commonly seen situation in the critical care setting. Next slide, please. Yes. Next slide. Yeah. Now remember that diabetes and starvation resemble each other to a great extent. Like insulin resistance occurs in both. Only the sugar doesn't go high in starvation. In fact, can go a little low. Ketogenesis is there. Mild acidosis is there. Even the starvation, and dehydration also is there in both of them. So by this we understand that you cannot starve a diabetic for a long time. It will accentuate all the pathophysiological things you see in uncontrolled diabetic. Therefore, I think starving a diabetic even for surgery for more than about 6 or 8 hours is not right. And there are studies showing giving glucose and water 2 hours before surgery to a diabetic and coming out with much better post-operative outcomes. So this is very important not to start. That's why probably diabetics are operated first thing in the morning. They have a priority in the timing slot for any surgery or procedure. Next slide. Now, the effect of hyperglycemia, I don't want to go into details of that. This is what we all learn in diabetology all the time. The vascular changes, the inflammatory molecule, all those are there. So next slide, please. Yes. Next one. Yeah. So hyperglycemia will impact the outcomes in all kind of diabetics that you see. And there is a clear relationship to the admission, blood glucose, and outcome in intensive care. Next slide. And this is seen here as the entry blood glucose level goes high, the outcomes are worsened. So I think blood sugar, if it is markedly raised, sometimes can predict the mortality risk in a person in the critical care setting. Next slide. Now we go to enteral and parenteral nutrition, and we see the importance of nutrition and how exactly to plan nutrition in this situation. Next slide. Yes. So, of course, the optimal nutrition is very important for restoring the immune function or maintaining the immune function at the normal level, and of course, reducing morbidity, mortality, duration of hospitalization, and duration of intensive care unit stay, and as well as the days on ventilator. So these are some of the parameters we use when we study outcome measures. You know, we measure the outcomes in any given in a critically ill person. These are the parameters we use. Next slide. Now, enteral nutrition, you see, the support can result itself into hyperglycemia in many people in the critically ill, and insulin requirements in the diabetic will increase substantially in many of them, but not necessarily. So those with hepatic and renal problem will have to be extremely careful while treating the hyperglycemia there. And of course, remember that whenever sugars go very high, you always think of cutting down on the carbohydrates when you're giving enteral feed, and even in the glucose concentration in your total parenteral nutrition. And one more strategy that you can use there, and which is recommended in the critical setting in the enteral nutrition, is that you cut down the amount of carbohydrate by about 15 to 20% and give the fat in the full amount that is recommended at the 30% or even slightly raised to 40%. So this is one strategy being employed when hyperglycemia is entirely uncontrollable in this situation with the enteral feeding or even parenteral feeding. The glucose concentration has to be lowered, and you see in the enteral some fat feeds of the good kind of fats, probably olive oil put in the Ray's tube itself can give good calories in a very small volume and does not increase osmolarity. Remember, fats don't increase osmolarity of the feed in the stomach, and therefore they are kinder to the stomach when we give enteral feeding in this way. Next slide. Total calories, there are phases in critical illness where a person is hypercatabolic initially, coming with fever or whatever, shock, septicemia. Then they start recovering, and then, of course, you see, you have to also make sure how many non-protein calories you are giving. In the hypercatabolic phase, earlier on, the large amount of calories were advised. I remember 30, 40 years ago, intensivists and my surgeons who were doing a lot of pancreatic surgery and this type of thing where parenteral nutrition was required. You see, they will advise me that the calories must be 2,500 or something like that, which of course are very unphysiological. I always thought that way. And slowly the papers started coming that you don't have to go that high in the hypercatabolic phase. You only go high by about 5 more calories than you usually do per kilogram of body weight. So in the recovery phase, we'll see what calories you use, and also we have to see that non-protein calories and the protein calories, some balance is maintained. Next slide. The carbohydrates are required in some sense, mind you. Totally carbohydrate free will increase ketogenesis. So this is not recommended. And diabetic, even if you hyperglycemic carbohydrates is there, type of carbohydrates we are going to discuss. And of course, you see lowering carbohydrate and increasing fat to about 10%, lowering here and 10% increasing in fat is advisable in many situations with uncontrolled hyperglycemia. Next slide. Now, the glucose, fat, and protein ratio is very much like what your diabetic diet will prescribe. So, frankly, we are coming very close to physiology, even in the critical care setting. Staying close to physiology always ultimately proves to be correct, like that feeding very heavily in the hypercatabolic physiological, because those calories could not be utilized and they cause additional what we call metabolic stress. Non-utilizable calories will produce metabolic stress. See, so I think the only difference will be carbohydrates are slightly lower compared to non-diabetics by about 10% of calories. See, and the ratio with those who are very uncontrolled, I told you, you see carbohydrates are further lower and fat instead of 20 sometimes can be taken to 30. From 30 can be taken to 40 and protein is about 20%. Of course, out of these, which kind of fat you should increase or give there is MUFA, omega-3 or the medium chain triglycerides. When there are intestinal problem, medium chain triglycerides are highly beneficial because they directly absorb with the lymphatic system. Omega-3 will be beneficial in reducing oxidative stress, and MUFA will also be advisable. So these are three desirable types. Given situation, you choose those carefully, and type of fat that is available in the feed is not a problem, but available in the parenteral nutrition is often derived. You see, mostly you see the MUFA rich and sometimes with omega-3 added. And of course, the separate medium chain triglyceride feeds available as well. See, so advantages of increasing fat calories, I already showed you. Remember that when you reduce carbohydrate, the respiratory quotient falls. And therefore, it is a bit easier to wean the patients who are on ventilator. You see, it's a bit easier to wean when you slightly reduce carbohydrates and increase the fat again. So this is a good advantage again of this strategy. And I often recommend this in people where there is a weaning difficulty. Next slide. Now, this I already told you that 2-hour pre-op feed is very important. There are several papers on that, and I think we should start giving water and maybe IV glucose if the anesthetic is disturbed by oral, but they are all absorbed within 2 hours. Really, water and glucose can be absorbed even by enteral route, you know, within 2 hours. But however, IV glucose is required, mind you. So sometimes people try to solve the problem by only giving saline. It is not physiological because it starts the patient and starts ketogenesis. For fast recovering, protein balance is required. Protein balance is very much required because many of these people, protein requirements are higher in many of them, large majority. Even in obese people who are wasting away very rapidly in the intensive care setting, the proteins given will be good amount. Next slide. So metabolic control, of course, has to be there of glucose, but that is not my topic, so I'll pass on very rapidly. Next slide. See, next slide, please. Next slide. Okay. So we know that we give IV, infusion of insulin. Next slide. And this is, of course, the gold standard, which all of you learned. Now, next slide, please. Yeah. So you really give a small bolus and then set up an infusion, which is, I think, I won't go into details of that. But this is very essential in critical care setting while you're treating a diabetic. Next slide. And you learn to master this. Of course, most of our diabetologists have done that. See, and insulin infusion, of course, helps tremendously in the outcomes. Next slide. Okay. Now Nutri-Score is a very interesting place where you try to judge that initiating nutrition and adequate nutrition, how it will help the person. And higher the score, it means nutrition management or support is required very badly. Anything. So this goes maximum up to 9, but anywhere about 3 or 4, you should seriously consider enteral and if required parenteral, and subtypes both combined also is a very important strategy employed, which I'll show you later on. Next slide, please. Yes. Now, disease-specific feeding formulas are there, like renal disease, sometimes low protein will be given, and potassium low phosphorus will be there in renal disease, those formula which are available. You see, in hepatic disease, increase the branch chain amino acid, B, C, A is very important, and reduce the aromatic like phenylalanine, tryptophan, tyrosine. In diabetics, you may reduce carbohydrate, increase fat, And you may use very specific carbohydrates like oligosaccharides, fructose, cornstarch, and fiber in the enteral feed. And in pulmonary disease, also you can reduce glucose infusion in order to lower the respiratory quotient. And the ARDC, you see, they tried a little higher fat diet has been used in the acute respiratory distress syndrome. Next slide. Yes. Now, enteral nutrition, what can be contraindications? Obviously, here, intestinal problem and hemodynamic instability. With that, frankly, you can wait for about a day or two to start nutrition. Sometimes we felt you must start nutrition immediately, but they've shown that hemodynamic instability do not initiate. It is not necessary to run for starting enteral fluid or parenteral fluid. For probably 24, 48 hours, that to stabilize the patient. You see, then these are relative contraindications like short bowel syndrome. And on the next slide, please. Okay, so should we give complete enteral feed that is full calorie like 1500? The resting energy expenditure REE, you see, is something like 25 calories per kilo of ideal body weight. In obese people, you use ideal body weight. However, would you really use that? Not necessarily so. You see, if you want to maintain the trophic function of the gut, that means you want to prevent the structural integrity, you want to prevent deterioration of structural integrity of the bowel. When people are fasting, you know, there is transmigration of the bacteria and there is hepatic dysfunction starts. So for that, about 500 to 1,000 calories are enough. These are called trophic calories. Sometimes we used to give amino acid mixtures when there was no feed going on, total parenteral nutrition, but probably a small amount of feed enterally will serve the purpose of maintaining the gut integrity. And of course, the outcomes there have been measured. Next slide. The complications of enteral feeding are very obvious, you see, and refeeding syndrome, of course, is obvious, like what you do in the people who are starved and then you start feeding, what problems you get. High gastric volume, if it's raised there before you give the next feed more than 500 ml, you are a bit careful, but many studies show that it may not be a very important issue and you can continue to give the enteral feed. Next slide. So both way it is possible. Causes of diarrhea are very important because many of them start diarrhea and the causes here are antibiotics and the H2 receptor antagonists and the drugs like what you see, osmotically active drugs and laxatives. And of course, gastrointestinal dysfunction, especially colonization of the small bowel with bacteria, and that will set up bad diarrhea, and that may continue even after the patient recovers for quite some time. Next slide. Okay. So again, causes of diarrhea in critically ill patient, again, some more causes there. And altered gastrointestinal flora is extremely important. And Clostridium diarrhea is also not infrequently seen in critical care settings, so that needs to be diagnosed and treated. Next slide. Contamination of enteral feed is possible. Therefore, do not get whole day's feed, or if you get them from the kitchen, they have to be properly refrigerated. Otherwise, people get infection. And of course, these are constipation of obvious causes. Next slide. Very rapidly. Parenteral nutrition. You again see the energy need and protein need, electrolyte abnormalities, and how much fluid requirement. Because many of these people may have fluid overload as well, and then you'll have to give a little more concentrated feed or be happy with administration of 500 to 1,000 calories. Next slide. And these are the recommendations, the calories and recovery phase, slightly more calories, about 5 calories per kilogram more obese people, half of their actual body weight. Half the calories and what to recommend for actual body weight or ideal body weight will be similar. You see, or 22 to 25 calories per kilogram of body weight. See, next slide. I go over very rapidly over some points. So these are the protein recommendation. Nowhere more than 2 grams per kg of ideal body weight. Very rarely 2.5 in burns and highly catabolic people. Otherwise, frankly, most of the time proteins recommended are 1.2 to 2 grams in most of the people. Next slide. So parenteral fluid composition, sometimes we give amino acids separately, not really required. No benefits have been shown. Lipids can be from soya bean, from olive oil or fish oil, sometimes mixture of those. Next slide. And I gave you some situations where you use one or the other. Micronutrients, if the enteral feed is more than 1500 calories, the deficiency of micronutrients is less likely to arise. However, you should replace all the routine micronutrients. And remember, vitamin K replacement does not occur in parenteral nutrition. So you'll have to look after vitamin K very well. Next slide. And prebiotic and probiotics, you see, may be used in order to maintain the gut flora. The disturbance there is very bad in people coming out of ICU care for months. They have the bacterial overgrowth diarrhea. So these are some of the pre and probiotic we use. Next slide. So I think with those, I think supplements hardly required, actually not practiced. And I must tell you that the studies in these areas are always on very small number, not very well controlled, not adequately powered, and therefore quite often very dubious results emerge in this critical care setting. And therefore, I think staying very close to physiology is probably what makes maximum sense. Next slide. See, remember that enteral nutrition sometimes can be initiated, you know, and partly enteral and partly parenteral can be initiated between, even parenteral can be initiated between 5 to 8 days. It is reasonably good. Instead of starting on day 1 parenteral nutrition, you should try enteral, and if it is inadequate, you can supplement or replace with parenteral. Between 5 and 8 days, the outcomes don't change. So you don't have to run for it on day 1. Next slide. I think I got only 2-3 slides more, so please bear with me. You see, and supplemental parenteral nutrition is given with enteral to make it complete. And day 5 to 8 is correct time to start. So don't worry that you have delayed introduction of parenteral nutrition, and starting early, there is no clear difference in the outcomes. Next slide. So I think the parenteral nutrition complications are very well known locally and in catheter related. Main thing is hypertriglyceridemia is very important. In diabetics, triglycerides are often high to start with, and then they go to 1,000, 1,500 triglycerides, which is dangerous. Then the fat infusion has to be removed. Even the triglycerides are very high. Wait for some hours, 2 hours, 3 hours, and see triglycerides come down to a level of below 400. Then only you reinstitute infusion of lipids. So this is a very common problem seen, besides many others listed here. Next slide. Okay, and of course these are very well understood complications. So I'll leave it there. Next slide. Okay, and I think enteral versus parenteral, I would not go on betting. Frankly, enteral can be as good as parenteral, and parenteral can be as safe as enteral, provided you take the very precautions like putting the central catheter properly, preventing infection. Then I think parenteral also, you don't have to hesitate in instituting that. So they are very close to each other in the appropriate situations. Next slide. Okay. So this is a summary. Hyperglycemia is common in critical illness, needs to be controlled optimally. Optimal nutrition is very, very important in critically ill. Both enteral and parenteral nutrition initiated at the right time, singly or in combination, improve outcomes. Next slide. And remember that macro and micronutrient content, volume, and electrolyte contents delivered have been to be planned properly. And the studies in this area are not yet very strong evidence-based for you to really opt for some odd questions that are raised, supplement questions, etc., that are raised cannot be answered very well at the moment. So thank you very much for your patient hearing.
Thank you very much, sir. That was indeed a beautiful overview of how to treat our ICU patients. In interest of time, may I request Dr. Purvi to take over?
Thank you. Indeed, a masterclass that we just experienced, hepatogenous diabetes, and as well as the ICU management or enteral nutrition management. We move on to the very, very important session. And before that, let me thank Professor H.B. Chandalia, sir, as well as Dr. Vijay Neglu, sir, and our chairs, Dr. Manoj Chawla and Dr. Shefali Karkhanis as well, for wonderfully conducting that session. Now we move on to a very important session that is expected to have a profound impact on a variety of metabolic disorders. And we have masters of the field for the same. And for that session, may I invite Dr. Lotika Purohit, who is a diabetologist and a EPM IITB consultant as well. She's from South Mumbai. We have Dr. Kirti Samudra, a physician diabetologist, and Dr. Tejas Shah, who is diabetologist and director of EVA Diabetes Care Center, Mumbai. Without much ado, may I request you to start with the first talk.
Thank you very much, Purvi, for the introduction, and thank you to Dr. Benny ma'am for the invitation. So now we are moving on to another session, which will be weight matters. So good afternoon. We will now be moving on to an interesting session called Weight Matters. Am I audible? So,
yes.
Yeah. So to start the session, we have with us Dr. Neeta Deshpande. She's a professor of medicine and a diabetologist and obesity consultant, has been a pioneer in diabetes reversal work. She has several awards and fellowships to her credit. Today, she will be speaking to us on attenuating the biological drive for weight regain following weight loss. With this, I invite Dr. Neeta.
A very good afternoon to all of you. At the outset, I would like to thank my dear friends Benny and Vijay for inviting me to speak at this prestigious conference. I also congratulate the entire team, and actually I'm a part of the team for getting this together and having such important topics. So let me start by sharing my screen. So the topic under discussion is attenuating the biologic drive for weight regain after weight loss. We haven't yet found the holy grail for this, but we have to go with what we know, the physiology and how to beat that physiology after weight loss, which actually drives weight regain. So that my talk will be in two parts. The first part will be about the basic physiology of what actually happens after you lose weight and what are the physiological changes that happen which actually drive you to gain weight once again. And then after that, I will delve into the management aspects of what we could possibly do to attenuate this particular weight regain, which we are all worried about, because the treatment of obesity is basically not just weight loss, but maintaining that weight loss. So we all know that it is very, very challenging. These are so many different studies telling you the same thing, that the weight loss happens beautifully, but what happens afterwards is the problem. That weight regain happens regardless of the therapies that are used, the kind of diet, so many changes. And you can see that this is exemplified in the very famous Look Ahead trial. So you can see here that at the end of 4 years, some people have gained all the weight. So it's not easy to maintain the lost weight. And this time and again, different studies, different modalities, we have seen how all of this happens. So the question is, why does it happen? So this is a very nice slide telling you about weight loss that happens. But after you have attained some kind of or some degree of weight loss, if you have to prevent weight regain, treatment is required. If you look at this dotted line on top, there is gradual weight increase with no treatment at all in an obese patient. But after the weight has been lost, if there is no treatment, you go back to the same spot. However, with some kind of treatment, you may be able to achieve weight maintenance to a large degree. And this is exemplified in this particular slide. So the physiological responses to weight loss need to be examined. That is, what is the root of the problem? So this is a slide which tells you that after a very low calorie diet for about 10 weeks, in which time you have lost good bit of weight, all of you have seen this, all of you might have experienced it with your patients. But afterwards, what happens is this, that the weight slowly creeps back up again, as you can see over here. And why is this? This is because after you have lost weight, after that initial weight loss phase, what happens is there is hunger and a desire to eat. And this increases exponentially. And you can see here that this is the hunger that goes up. The desire to eat also goes up quite a bit. And the reasons for this are very, very physiological. There are physiological responses to weight loss, as you can see here. And you can see here that ghrelin, the hunger hormone, increases, whereas the satiety hormones like PYY, amylin, and CCK start to drop. So it's not like your patient has lost motivation or your patient is no more adherent to his lifestyle or his exercise. It is physiological to a large extent. And these are the hormones that do this problem, create this problem in the patient. As also you can see that GIP and PP increase and GLP-1 and insulin fall. And all these are physiological responses to weight loss. Changes in leptin levels also occur with dieting. When one goes on a diet, as the BMI drops, the leptin levels also, they are positively associated with BMI. That is one part, that is hormones. What happens to energy expenditure? So we've seen what happens with hunger and the desire to eat on one side. On the other side, let's see what happens when weight reduces with respect to energy expenditure. So this is initial weight, okay, and this is 10% gain. This is return to initial weight. This is 10% weight loss, and this is 20% weight loss. And you can see here that the energy expenditure, which was very high when you gain weight, that starts to go down after you have lost 10 and 20% weight loss. So if your hunger increases, your desire to eat increases, and your energy expenditure goes down exponentially, this is a recipe for weight regain. And this is what happens. So this is, to put it in a nutshell, after 10% weight gain, you can see here that the energy expenditure increases, but you can see these green dotted lines after 10 and 20% weight loss respectively. And you can see here that the energy expenditure just continues to fall. So it is a double whammy where you start to eat more and expend less. So obviously you're going to regain weight. So the body size, the weight changes, and energy expenditure are encapsulated very nicely over here. You can see that a normal or a lean person, when he starts to reduce weight, his energy expenditure goes down. And the same happens with an obese individual also. As weight increases, the energy expenditure increases, and vice versa. When there is physiological weight loss, then again the same thing happens. But when there is non-physiological weight loss, that is leading to the weight reduced state, it goes down exponentially and quite fast. When there is overfeeding, the energy expenditure goes up, whether it's in a normal or an obese individual. But when there is calorie restriction, which is typically what we do in the weight loss period, you can see here that it doesn't follow this line, but it comes down much faster. The energy expenditure comes down much faster. So this was in a nutshell about energy intake and energy expenditure after weight loss and how things go against an individual who's trying to maintain weight. Apart from this, you have the role of the central nervous system as well. So this is the third dimension that I'm talking about. So you have energy intake on one side, energy expenditure on the other. You know that these are all the things that are involved in it. But apart from that, you have the hedonic inputs like increased palatability or pleasure and a reward system. So all of these things are going to act against a person who's trying to lose weight or who has lost weight. So what can we do for these individual things? So for energy expenditure, obviously, you have to go for lifestyle modification, increase physical activity, reduce the dietary cues, and reduce the exposure. Whereas for hedonic inputs, you might have to go for pharmacotherapy, and I'm going to get into that just a little later. So the pharmacotherapy is the one that can reduce hunger, increase satiety, And I told you that both of these things are problematic in a person who has lost weight because the hormones are against them. And preoccupation with food, that is the desire to eat, even this can be reduced by pharmacotherapy. So in general, just caloric restriction and increased exercise. This, I'm just putting this across to you as an introduction. So continued caloric restriction and continued exercise may not really be the only thing that can maintain weight, because there is a limit to how much you can limit your calories. There is a limit to how much you can increase your exercise. If the hormones are going against you, perhaps there is a need to put those hormones back in place so that weight maintenance can occur. And this is very, very important. And I'm going to go into that in just a while. So let me put all of this together. So this is a person who is obese, who has done caloric restriction or diet and has lost weight. After he or she loses weight, leptin is reduced, the satiety hormones are reduced, and energy expenditure is also reduced. So all of these together are going to conserve energy, which means to say that you will expend less energy even if you exercise, and your hunger is going to go up. And this is what causes the weight regain. So this is the encapsulation of what I have told you so far. So if you have to counter this, what will you do? So this is a slide which tells you that if you do only caloric restriction, which is a counter physiological weight loss, then there is going to be physiological compensation. The weight loss is short term. Ultimately, it's all going to come back, as you can see here, because there is increased appetite drive and reduced thermogenesis during the maintenance phase. So if you had to do only caloric restriction, this would probably be the fate of maximum number of your patients. Whereas if you do a physiological weight loss, which means that there is lifestyle change, which of course includes caloric restriction and exercise, but added to that, if you were to consider effective medication, surgery, then perhaps this will not go back up here, and this could be the holy grail for your maintenance in the long term. So that initial weight loss continues or merges very effectively into the long-term weight loss, so that the body is not allowed to defend its own fat mass, which it had earlier on. So let's come now to some of the methods with which you can attenuate as much as possible the biological drive to weight regain. So you could do a targeted physiological approach, and the goal would be to restore the energy balance, reduce intake, which means you have to reduce appetite, you have to reduce craving, the desire to eat, increase the satiety, and or that means you could try both these methods, increase the energy expenditure. And we've had various resources to actually come to this conclusion. People have looked at monogenic obesity, type 2 diabetes, and individuals with obesity also. And with this, they have been able to formulate that this or pharmacotherapy or maybe surgery could be the answer to attenuating the biological drive for weight regain. So this is a study which shows you that weight loss maintenance can be achieved with exercise, liraglutide, or both. So this was the trial design. Initially, there was a weight loss period where they gave a very low calorie diet, and then they were randomized to placebo only, exercise only, liraglutide, or exercise with liraglutide. And at the end of 52 weeks, it was stopped and there was no intervention, and the follow-up was done at 104 weeks. So this was the study design. And what you find here in this study is that very well that it is exercise with liraglutide that has the best weight maintenance as compared to all the other three groups. What does this tell us? This tells us that if you want to prevent weight regain, you would have to intervene with the help of treatment. You cannot continue to rely on just diet and exercise. You can see here that everyone lost weight here, and look at the placebo group. They gained this much of weight. If it is only exercise, well, it is better, a little better than the placebo, but again, there is weight regain. And if it is only liraglutide, it is better, but the best bet would be to combine that pharmacotherapy with exercise. So this is what this particular study tells us. Now we are all talking about semaglutide. This is the step 4 trial where all of them were initially, all the obese patients were initially given semaglutide. Weight was lost. And then after that weight loss period, people were randomized to continue with the semaglutide or be on placebo. That means they were taken off the semaglutide. And in this randomized period, they looked at the weight maintenance as to what happened. And what you can see here is a beautiful depiction of these divergent lines that you can see. So this is weight loss with semaglutide. If you continued semaglutide, you continue to lose weight and maintain it, whereas if you switch to placebo, you did not. Your weight started to creep back up again. What does this tell you? This tells you that during the weight maintenance period, you will need help in terms of combating the physiological forces which make you regain weight in the form of pharmacotherapy. Last slide, I showed you liraglutide, and here I'm showing you semaglutide. So this is the importance of adjuvant therapy, especially so in the weight maintenance period, to make it more successful. Then you could modulate nutrient intake. We don't have amylin analogs here yet, but this is one way that you can do it. I showed you about liraglutide and semaglutide. How do they do it? These are drugs that affect the neurohormonal axis or the gut-brain axis. So you can see here that GLP-1 or glucagon co-agonist, these are the ways in which they improve the weight loss maintenance, or GLP-1 GIP co-agonist, or a triagonist. So body weight is improved, and all of this energy expenditure, the desire to eat, all of these things go down, the satiety increases, and this is how it helps us to prevent weight regain. So this is the experience of anti-obesity medication of different people, that they don't like the taste of it, less likely to eat sweets. So the hedonic inputs that come to the brain, the pleasure, the reward, even that is taken care of. And my brain is so different. I'm able to notice real hunger for the first time. That means mindless eating is also taken care of. So there is a change in the craving, which is exactly what we want. And there is improved adherence to lifestyle by counteracting the physiological drive for regain. That's the topic under discussion for me today. That is, how do you counteract this biological drive for regain? So this is what you do. You could use anti-obesity medication, smaller portions, decreased interest in food and drink, better choices, more mindful. This is exactly what we want in the weight maintenance period. Next comes the Roux-en-Y gastric bypass that causes changes that are opposite to caloric restriction. So this is another thing. Now, if you ask me, do you want to do this for every patient? Do you want to give drugs to every patient? Do you want to do surgery for every patient? The answer would obviously be not. I would say, at least from my experience, that most patients who have a body mass index of 27, 28, achieve good bit of weight loss, come closer to their ideal body weight. These are the patients who would probably not need external help for weight maintenance other than reinforcement, good follow-up of their weight loss with a good obesity team. They would probably be able to manage with lifestyle changes alone, maybe a little intensified lifestyle changes. But it has also been seen that lack of follow-up is going to make these patients relapse. So if they are not morbidly obese, or if they are just obese, below 27 or below 30, they would probably not need all these things. But once they have crossed the threshold of a BMI of 30 or an increased fat mass, weight regain is rather a rule than an exception. And that is the time that you might have to counsel your patients that your weight maintenance phase is going to be far more difficult than your weight loss phase, and you may need help, and you may need adjuvant therapy in the form of at least anti-obesity medication. So it may not be for all, but these are the different modalities. I have not delved into the depths of the kinds of diet that will help in attenuating this physiological weight gain, because there is not enough evidence for that. So higher protein intake, maintenance of muscle mass, these are things, and exercise, these are things that might help to attenuate the biological drive, but there is not enough evidence for that. There is evidence in the form of pharmacotherapy and there is evidence in the form of bariatric surgery, and that's why I have chosen to mention these two in greater detail than the kind of macronutrient composition that one should have to build muscle mass, etc. So you can see here that caloric restriction works very differently from that of, say, a gastric bypass surgery. Here you can see that there is energy expenditure is reduced when you do caloric restriction, whereas it is increased after bypass surgery. The appetite increases, the hunger increases, and the satiety reduces, like I have shown you in all the slides with respect to ghrelin, CCK, etc. Reward-based eating is increased, whereas all these three are exactly the opposite after a gastric bypass surgery. And that's why when you have morbid obesity or severe obesity, it would probably be a good idea to add surgery to lifestyle modification. Then stress responses, and mainly it is the gut peptides, as you can see here. You can see here that ghrelin increases, I've shown you a slide, whereas it reduces in case of a gastric bypass. And the satiety hormones are reduced after caloric restriction, whereas they increase after Roux-en-Y gastric bypass. So suffice it to say here that there are modalities with which you can beat physiology, and one should make use of them in cases where you think that weight maintenance is going to be a problem, because weight regain and weight maintenance are things which ought to be done in a case after weight loss. Otherwise, it is of no use at all, because it just ultimately ends up being yo-yo dieting, the patient getting more depressed and having lot of comorbidities because of the yo-yo dieting. Because you should remember that every time that a patient gains weight and every time that a patient loses weight, that person is going to lose both fat and muscle. But when weight gain happens, it is 100% fat. So the next time that the patient is starting out for weight loss, he is going to be compromised already with a higher fat to protein ratio. So weight gain is always all 100% fat. So please remember that yo-yo dieting should be avoided at all costs. And that is the reason that this topic has been taken up, how to avoid weight regain and how to maintain weight. So to summarize, caloric restriction leads to the weight reduced state, which reflects physiology that is designed to restore the lost fat and muscle. So there is no reduction in target or fat mass set point. So that doesn't come down. It increases the appetitive drives like the hedonic drive, the satiety, and the increased hunger. And there is decreased energy expenditure or thermogenesis, what we call, because of metabolic adaptation. Therefore, effective long-term treatment of obesity requires avoidance of the weight-reduced state, which means that you have to combat physiology. So you need preferential loss of fat rather than muscle. I said that there could be dietary changes that you could do while you're losing weight so that you maintain muscle mass. And there should be absence of counter-regulatory responses such as decreased appetitive drives or increased preserved energy expenditure. And how do you do that? You do that probably by metabolic surgery, with medication, and certain other lifestyle therapies. So I shall end my talk here with just giving this tip that weight maintenance is as important as weight loss. And one must do regular follow-up, just like you do in diabetes, to make sure that the patient is not regaining weight. And if so, there should be changes instituted immediately so that the patient does not relapse. Thank you all very much.
Can I ask a question, Lutika?
Yes, ma'am.
Anita, that was an excellent presentation, and so beautifully you have taken us through the physiology. Now we see many diabetic patients who are on liraglutide from the beginning. I mean, from day one, we have already started them. They also lose weight, but in spite of pharmacotherapy, they regain their weight. And also we want to know, when do you start treatment after weight loss? Which is the dividing time? Which is the time you start pharmacotherapy? Is it from the beginning or is it after they lose weight? And another thing is, what is the role of meal replacement in weight loss?
Yeah. Thank you very much, Benny, for that question. The first question that you asked about is about the timing of pharmacotherapy. Ideally speaking, in an ideal world, if a patient can afford and if a patient is willing, if the BMI is more than 30, I would say that pharmacotherapy should be from day one. And then that has to continue. I know it's difficult and patients may not accept it, but that would be ideal. But supposing that doesn't happen, because we don't live in an ideal world, once weight loss has happened with a good lifestyle modification, etc., during the follow-up, if you find that the weight is creeping back up despite the patient's best efforts, I think that should be the time to start pharmacotherapy in a small way, at least, after explaining everything to the patient. But as I said, in an ideal world, it's best to start it right from the beginning. That would be very, very physiological. The second question that you've asked is about meal replacements. Well, meal replacements are a great way to initiate weight loss and to achieve weight loss. Of course, it's not a permanent solution, but it has many effects in the sense that it is scientific. You can reproduce it. It is calculable. It also makes sure that the patient gets the proper nutrition. And behaviorally, the patient begins to realize that they can manage to get by with much less than they were actually consuming, because with regular food, under-reporting and over-reporting of calories is very, very common, because portion sizes are not the same in India and it's not easy to quantify. So with meal replacements, you can actually quantify it and do it. So that is very much possible. So meal replacements for the right patient at the right time and for the right period can be a boon. So judicious use of meal replacements in the right setting can do a lot of good for weight loss.
Thank you.
Thank you. Thank you, Neeta, for an excellent talk. And what I liked about it is that that you stressed about weight maintenance, which is as important as weight loss. It's something that we need to, have regular follow-up with and see to it that the weight doesn't get regained. With this, I would like to hand over to my co-chairperson to introduce our next speaker, Dr. Rucha Mehta, who also has
Thank you, Dr. Benny, for giving me this opportunity. And I'm privileged and honored to introduce Dr. Rucha Mehta. She is a consultant endocrinologist and diabetologist at EDMO Clinic, Ahmedabad, Apollo Hospital, Ahmedabad. She's a chair of Research Ethics Committee and even panel of expert group of diabetes and obesity of joint RSSDI and ESI clinical practice guidelines. She was HOD in Endocrine Department, Global Hospitals, Mumbai, Director of Research, Western University, California, Clinical Faculty, Director of Diabetes Clinic, PA Hospital, San Antonio. Clinical and research interest areas are pre-diabetes, obesity, metabolism. She did her MBBS at St. GS Medical College at KMA Hospital, Mumbai, and she's did her MD in endocrinology and diabetology at University of Texas Health Sciences Center at San Antonio, USA. She'll be talking mainly now. Dr. Neeta Deshpande spoke about weight maintenance, and we have been told about how much weight gain should be there in pregnancy, ideal weight gain, which now doesn't hold true anymore, because most of our ladies who are pregnant either are pre-diabetic or PCOS or obesity. So exactly, actually, how should they maintain the weight, how much they should gain? And post-delivery, we see all our obese ladies patient, now they say that after delivery, they have gained the weight. So what should be the right weight gain, or how they should lose the weight? This is an important topic which Dr. Rucha Mehta will address to. Welcome, Dr. Rucha Mehta.
Thank you so much for the kind introduction, and thank you again to Dr. Benny Negalur for this wonderful symposium. I've been a part of it now for the past 6 years, and it's wonderful. It always coincides with the Women's Day festivities. So it's really great to be here. And in the interest of time, I'll just go ahead and get started. And thank you for that kind introduction. So the topic given to me today was, as we've said, is talking about gestational weight gain. How much and how do we lose it? So that's what I'll try to focus on. And I've tried to keep it a bit practical so that we can, you just had a lot of scientific discussions. You've seen some data. A lot of it does overlap, as you will realize. But what I'm going to try to do is keep this as practical as possible. Next slide. So I have divided the topic into 4 main factors. Is the pre-pregnancy BMI, which is linked to PCOS and other reasons where the pregnant woman might gain weight. And what we can really focus on is that time period, gestational or intra-pregnancy weight gain, and how does this impact our outcomes? Because that's what we are trying to make sure we have a successful pregnancy for the mother and the child. So how will you manage this? Now, what we know from the United States data, and this is taken from the National Center website, that the proportion of females who are in the age group of 20 to 39 years with obesity is as high as 40%. And I'll show you in the next slide how this is increasing in India. Prevalence even by race. So even in the US data, if you look at non-Hispanic Asian females, 17.2%. And severe obesity, wherein the BMI is more than 40 kilogram per meter square, is almost 9 to 10%. So these are astounding numbers. What we know from our ICMR data, the reason we worry about this, as rightfully pointed out by the chairperson, is that women are starting to take over men in terms of generalized obesity. So whether you go north, south, east, or west, as you can see, it does not seem to matter. The number of women, this is from a 2015 survey, and a huge amount of patients, people were looked at. You can see almost 30 to 40%, depending on which part of the country you're looking at. And also when we start looking at abdominal obesity, which is the main thing that we worry about, that this is also increasing as high as 44.5% in Chandigarh. So why are we talking about this today? Gestational weight gain above the IOM Institute of Medicine target ranges is where all of this began. In 1997, as early as, I would say as late as that, studies were done looking at, was there any correlation to pregnancy outcomes and gestational weight gain or pre-pregnancy weight? And that's when the guidelines came out for the first time, which were then revised in 2009, that if you don't have the appropriate weight, you can have long-term effects on the mother and the offspring, and of course, in the short term on the pregnancy. And hence, appropriately, this session is labeled as Weight Matters. No talk would be complete without talking about the Life Cycle Project Maternal Obesity and Childhood Outcome Study Group, because they had the largest meta-analysis. They looked at several patients, and I just want to put a word also on underweight, because back in the day, we used to worry about underweight. As you can see that inappropriate weight, so being underweight, about 8,000 patients looked at, also leads to a risk of any adverse outcome, preeclampsia, small size for gestational age, you can see over here. You also have an increased rate of Caesarean delivery. So even being underweight can lead to adverse outcomes. Now, even in the normal weight, but look at normal weight versus overweight. The minute you start becoming overweight and even obese, these risks start to increase. And this is the absolute percentage of adverse outcomes. So the common complications we worry about, of course, with increased maternal weight gain is preeclampsia, gestational diabetes, a large size for gestational age, and intra-obstetric complications. So I'll break it down further more for you so it's a little bit clear. So here's again looking at pre-pregnancy BMI category in primiparas. So when the first time you become pregnant, and even then if your weight is on the higher side, if you're overweight, you can see that the chances of having complications are higher. If you're obese, these chances are even higher, especially emergency C-sections, and a large for gestational age baby goes from low to very high categories. Now, what about in certain special groups? Because nowadays we are seeing older women, we are seeing shorter women still, we see women who are smoking. And all of this, especially smoking, confers quite a high risk on all of these complications. And therefore, look at this small for gestational age, especially if you're smoking, there's a high risk to the fetus. So this is something, these are the things we can work upon besides just dietary interventions, because they may be very tough in the pregnant woman who feels hungry all the time. Now, why is this happening? As I mentioned to you, why do we worry about maternal obesity? Why do we worry about gestational weight gain? We know that both of these can lead to what is known as in utero overnutrition at the level of the fetus. We also know, of course, at the level of the mother, the biggest risk, obesity, is the highest risk for insulin resistance and subsequent maternal diabetes, what we call as gestational diabetes mellitus. Now, what we also know that all of this in utero overnutrition causes genetic or epigenetic changes in certain genes as early as week 6 to week 8. And you can see this happening at the level of the PPAR alpha, the APCA1, the MEST. All of this can confer an increased risk of obesity, diabetes, and cardiovascular disease in the offspring and lead to intergenerational effects and a long-term risk of non-communicable disease. So this is not to say that it's just the mother who's at risk, but we are also putting the baby at risk. And therefore, you could use this as your hook, as your factor, telling the mom, because, every mother really does care about the child, even the child in utero. And you can say that before you get pregnant, it's important to lose weight. Now, firstly, let's understand what is normal weight gain. So components of normal gestational weight gain, generally speaking, about 10 to 12 kilograms, slightly variable. The fetus could weigh anywhere from 3 to 3.5 to sometimes 4 kilograms. The placenta is about a little bit over 0.5 kilogram. I've got the breakdown for amniotic fluid, maternal tissue buildup, increase in blood volumes, increase in maternal fat store, and increase in the extravascular fluid volume. All of this will contribute to at least a 10 to 12 kilograms in weight gain. So this would be normal weight gain for most of our pregnancies. Now, if there is increased gestational weight gain, our own Dr. Vishwanathan has put forward these, what I have been talking to you about, but just to break it down a bit further, is that how does this affect the mother? So we can think about antepartum outcomes, so maternal discomfort, so hyperemesis, abnormal glucose metabolism. They may present to you with pre-existing high blood pressure, cholesterol, linked diseases such as gallstones, and also what you heard today about fatty liver earlier in Dr. Vijay Negaloor's lecture. Intrapartum outcomes. The mother with an increased weight gain is at high risk for premature rupture of membranes, preterm labor, post-dated pregnancies. Also, at the time of labor, she will have a difficult labor because the length of labor might vary. She might need some instrumentations. She might be at risk for lacerations. If the baby is large, there might be a shoulder dystocia because you've just induced gestational diabetes by not controlling the weight, which we all know is the most common risk factor for a large for gestational age baby. And subsequently, in the postpartum period, she may fail to lactate. She may have intermediate and long-term weight retention. In the long term, this could lead to postpartum diabetes or maintenance or pursuit of the gestational diabetes, and also she could have premenopausal breast cancer. So there are a lot of things that can happen. Now, here is also the obstetric complication in this particular study based on the maternal BMI. So you can see in the control group versus the obese and the morbidly obese, the chances of gestational hypertension and preeclampsia are almost doubled. The chance of gestational diabetes also increases. Premature rupture of membranes goes from 1.7 to 2.1, so not much difference there. Preterm deliveries, certainly. Fetal growth restriction. Large for gestational age baby, that seems to be the most common. So these are all the complications that can happen as your BMI starts to increase. Now, what about the infants of the mother who are overweight? Again, Dr. Vishwanath's group has looked at this data, and what do we find is that birth outcomes such as preterm birth, which leads to its own complications such as need for NICUs, low birth weight babies, large for gestational age, and a poor APGAR score. Postnatal outcomes, they might need perinatal mortality, neonatal hypoglycemia, neonatal distress, hyperbilirubinemias, hospitalizations, and other morbidities, and long-term impact on the chance of developing NCDs, as I showed you earlier. With this in mind, in 1997, when the task force looked at all of this data, they came out with certain weight gain guidelines. So if you have an underweight patient, you're allowed to make them gain more weight, or if you have a normal weight patient. However, as you start getting into higher BMIs, there is no recommendation to lose weight during pregnancy, mind you, and I will repeat this again at the end. However, we do try to control the amount of weight that they would put on. For example, in the overweight, in the underweight individual, maybe we allow them to gain about 12.5 to 18 kilograms total weight. In the normal weight person, we might allow them anywhere from 11.5 to 16 kilograms. The overweight person with a BMI less than 30 but higher than 25, roughly between 7 to 12. And in your obese patient, you want to keep that weight gain as close as possible to the physiological weight gain I showed you. So roughly about 9 to 10 kilograms. I always feel shoot for this. We're going to probably gain more because the data that I'm not showing right now, I just decided to hide some slides, is that in spite of all of this, most of the obese women gained more weight than was recommended to them across the board in all the studies. Now, what if the woman is carrying twins? Of course, we have to allow them something more. Now, remember, the baby weighs 3.5 kilograms, but in a twin pregnancy, the weights may not be equal. In a normal weight person, that weight gain can be allowed about 17 to 25 kilograms. In an overweight person, about 14 to 23 kilograms. In an obese person, about 11 to 20 kilograms only. So again, these things are to be kept in mind. What about the special populations I just showed you? So in the short stature, really no modification. They may be at risk for cesarean sections. In a younger age, again, no modification. When do you worry about this? As I said, is you just have to make sure if they are smoking, you ask them to quit smoking. In the primi-paras, you need to make sure they understand what is the importance of diet and exercise. We can also now break this down by the rate of weight gain per trimester, because it's also important to understand when does most of this weight gain happen. So total weight gain, I already explained to you. The first trimester, generally speaking, the female should not gain any more than 2 to 3 kilograms if they are overweight, and if they're underweight, maybe 4 to 5 kilograms. But generally speaking, in the first trimester, there should not be a whole lot of weight as the baby has not yet started to grow, neither the placenta. It's the second trimester when you will start seeing the weight starts to go up by per week. And in the underweight patient, you might try to monitor this at half kilogram per week. In the normal weight and the overweight patient, you can see it drops off from 0.4 to just 250 grams or 0.2 kilograms per week. This is higher in the last trimester, anywhere from 1 kilogram in the underweight patient to 0.5 kilogram in the overweight patient. So it's important also to keep in mind and kind of check on their diet, see what they're doing. Every time they come into you, maybe a diet recall needs to be filled in. So I will now make a segue into how will we manage these patients. Counseling becomes the mainstay of therapy. Nutrition and physical activity is what, of course, you're going to counsel them about. I cannot stress the importance that you need to catch them before they get pregnant. Approximately 4 to 5% of the United States women are underweight and almost 8 to 10% or higher in India. These are the women who should be encouraged to reach a normal weight before pregnancy. So I don't want to miss this. We have to look into eating disorders in the younger population. Everybody wants to look good. They're not eating right. So here is a nice meta-analysis that I found that talks about the exact topic we have today. How do you attenuate pregnancy weight gain and what works and why? So Dr. Walker and her colleagues, what they did in this particular study is they looked at about 60 trials. The trials were subcategorized according to if they had a dietary intervention, a physical activity intervention, a lifestyle, which is a combination of physical activity and diet, using e-health. And that has become the norm since the last 2 years of COVID. So I thought it was important to include this. And other interventions that was targeting unwanted pregnancies, adolescents, drug-based interventions using metformin and GLP-1 analogs, and other interventions which could not be classified. What was the outcome measure? The outcome was to look at the pregnancy weight gain, of course. So now I'm just showing you some of the data from this. So just follow me along. So we have broken them down into physical activity, lifestyle, and e-health. And there was a gestational weight gain measured at about 12 to 24 weeks. So in the second trimester and the third trimester. What you find over here, a good number of participants. And if you look at this, overall measurement in the diet group alone, if you will see, they lost about 3.27 kilograms with a statistically significant p-value. The physical activity group over here in the second trimester, they seem to lose about 1 kilogram, and this value was significant. However, not as significant in the first trimester. In combining both, as you can see, it did not seem to, there was in this particular, in the second trimester, and overall it does make an impact. Using eHealth, the p-value was not statistically significant, but there was a weight loss of about 1 kilogram. Now, let's also look over here at a regression analysis. I'm just going to move so I can see the slides. Yeah. So this is looking at diet, physical activity, and again, lifestyle, and based on the trimesters, based on the intensity of exercise. So I'll focus on this part over here. As you can see, 1 to 4 hours, not much change in the diet group or the physical activity group. More than 4 to 8 hours is where you sort of start getting into some amount of weight loss. But again, the p-value is not statistically significant. If they exercise more than 8 times, so even if they're doing shorter bursts of activity, that seemed to work actually much better. So it's more important to keep on moving. The intensity does not matter. Frequency is what seemed to matter, as is also seen in the bottom panel. And again, diet, of course, is important, but the p-values were not highly statistically significant. So this is an interesting intervention. What I would take away from this, that diet is certainly most important. Keep on moving. Even though we are just simply measuring gestational weight gain, there'll be many benefits at the cardiovascular outcome levels also. So now let's go on to see. Sorry, I'm just not able to. Yeah, here we go. So what sort of, how can you make this easier for yourself and for the patient? So I just sort of put forth a dietary questionnaire that you could have it ready when they first come into you. And then when they come in the second time, all we do in our clinic is have them fill out a dietary recall. Because you really do need to know your patients. Are they eating 3 meals a day, 4 meals a day? Do they have any food allergies? Are they using a special diet? Do you avoid any food or eating patterns for religious reasons? How do you cook your food? Do you pre-cook a week ahead? So many things that you need to know. Have they been exercising before? So I think all of this data collection, as I mentioned, I'm going to have some practical points while they are waiting to be seen. This is something we need to be doing for them. You could also have a briefer dietary questionnaire. So when they come in, you're ready, because now you need to advise them before they get pregnant, how much weight loss. So from Dr. Schumer's study, what we know is that a 10% reduction in pre-pregnancy BMI, not kilograms, would reduce the risk of gestational diabetes, preeclampsia, preterm birth, large for gestational age, and stillbirth, right, about 10%. Now, if you want to further improve the outcomes in terms of chances of cesarean birth, shoulder dystorcias, you're looking for a 20 to 30% reduction. So this is something you can easily advise your patients. You need to calculate these numbers for them. You have to be able to explain to them macronutrients. So I just think we'll talk about that a little bit because there are guidelines. It's very easy, though it looks complicated. I will just bring you to carbohydrates. As you can see across the board, it doesn't matter which age group you're looking at. What you want to do is give them about 45 to 65% of the calories, mainly as carbohydrates. So that's totally, something that is in keeping with our food patterns. 20 to 30%, 10 to 30% is going to be protein. And so you have a grams over there also. Fiber is important. If they can't take fiber in the form of vegetables, flax seeds, nuts, you can add in isabgol or something, and that should be fine. So it's all good. And total fat. So fat is not to be missed in the term of good fats. You must avoid saturated fats. And so we try to give them maybe olive oil, nuts, flaxseed, again, whatever is possible for your patients, some of the oils that you can recommend to them as well. Now, if you have a dietitian working with you, since you will try to control the food intake. Now, when you have your obese patient, you are not going to get them to lose weight. But what we find very often when we do the dietary detail questionnaire, they are sometimes eating way above because they have not realized they're eating 4,000 to 5,000 calories a day, sometimes averagely about 3,000 to 3,500 calories. When we ask them to take carbohydrates about less than 200 grams a day, we find that they were already consuming 250 grams of carbs. So the simplest approach is reducing their meal portions by 20%. So for example, at lunch, if they were having 3 to 4 chapatis, rice, dal, and vegetable, we'll ask them to cut out 2 of the chapatis and cut out half the portion of rice. or switch to a better quality of the rice. So it's not, white rice, maybe it's unpolished or brown rice or even dalia for that matter. So they are getting a better quality of carbohydrate. And when we cut down the roti, we ask them to increase vegetable, which is going to give them a lot of fiber. They could also start their meal by eating a plate of salad like kheera, kakdi, tomatoes, cucumber. So very simple ways of cutting down the carbs, but so that they don't feel hungry and they are not nutritionally deprived is where we need to get to. What's important is vegetables. Vegetables are very important for them. Dark green vegetables, if they're available, all the colors. Beans are great sources of fiber and protein for your patients. Starchy vegetables we try to limit in the case of our patients, especially if they already have pre-diabetes before we go into the pregnancy journey. Fruits, we allow them about 1 to 2 per day, but no fruit juices, please. Grains, dairy, all of this must be given in a balanced amount. If your patient is a meat eater or if they like to eat eggs, you don't need to restrict them. There is always the concern about mercury levels in fish and where the sources are. So if they're not comfortable, then they can certainly avoid that. Nuts, seeds, and soy products are other ways that you can work with your patients. And therefore, if you can come up with your dietitian, the diet plan needs to be customized and trimester-wise. Remember, they should not be gaining too much weight in the first trimester, but still making sure they're getting all of the macronutrients. We must, however, never forget these micronutrients in our pregnant and lactating women. And if necessary, most of the times we end up supplementing them with vitamins, the prenatal vitamins, also omega-3 capsules, which nowadays most of the gynecologists will give your patients, folic acid supplementation. If there's a past pregnant history of neural tube defects, we have to give even more. So these are small handouts we have in our clinic as to healthy pregnancy, as to what they can do. Eat small meal, fresh fruits, vegetables, probiotics is another important thing. We also give out, trimester-wise friendly diet charts with multiple options. So for example, breakfast could be dalia, it could be milk with curd, or it could be eggs, some paneer. Lunch could be a regular, as I said, medium-sized rotis, 3, but we didn't give them rice. And we might give them at dinner time. So these are the ways you can kind of cut down the diet plans. Because what's important is you also start to get them to exercise. What is recommended is a low impact aerobic exercise. The easiest is to walk. If they are able to, some amount of strength exercise or toning, simply using light dumbbells or resistance bands or pelvic floor muscle training exercises. So not to exceed really about 45 minutes a day, 30 to 40 minutes a day, if they can, and if they're allowed to do that. Very often in our patients will use heart rate monitoring bands. Most of them do have some form of heart rate with a Fitbit or an Apple Watch. Now, these are some of the contraindications to aerobic exercise during pregnancy. If they have any heart or lung disease, cervical insufficiencies, multiple gestations, history of bleeding, all of this, of course, needs to be kept in mind. Safest activity is walking, yoga. If they are able to tolerate some Pilates-based modified exercising, some pelvic floor training, but avoid hot yoga, avoid hot Pilates, avoid anything such as horseback riding, anything that is going to cause trouble. Just a quick word about bariatric surgery. I very often get asked the question that after bariatric surgery, when can I get pregnant? Because we use it, and I've not spoken about metformin and other agents because Dr. Neeta already spoke about it, so I happily took those slides off. So we can definitely, what we can do is bariatric surgery is increasingly common. We always say the woman needs to avoid conception at least for 1 to 1.5 years, if not longer, because they are still actively losing weight. They may not be able to eat enough for themselves and the growing child. So this is something to be kept in mind, that it's not a quick fix. Now, we have learned way back that eating alone will not keep well. We must also take exercise, and we must take it every day. So if they can't get on a treadmill or outside, they can walk every time 10 minutes after each meal or something. Just a few takeaway messages. Preconception counseling is key for both the underweight and overweight patient. Please take a detailed history so as not to miss any risk factors. Cessation of smoking. There is no guideline to lose weight during an ongoing pregnancy. Focus is to make sure they do not gain too much weight as per recommendation. There's no data to support weight loss during pregnancy. The simplest things are avoid processed food, sugary and fat diets, and eat balanced meals, sleep and stress reduction, and quit smoking, of course. So what you really need is a whole bunch of people working together and you need a good metabolic program along with your gynecologist. And with this, I'll just stop right over here and hand it back to Dr. Kirti.
Thank you, Richa, for excellent deliberation. And as you said, there are no guidelines for weight loss during pregnancy. Maybe we'll require those later on, because now obese girls getting pregnant. So what to do for them, and post delivery also, how they should be losing weight and maintaining weight. Thank you so much. I hand over to Tejas.
Thank you very much. Again, excellent sessions, and hearty congratulations to the entire team, Dr. Beni and the entire team of Wodcon. Fantastic going on. For our next talk, we have the talk is on navigating through the possibility of progression or through the progression of reversal of diabetes. We have none other than Dr. Brij Makkar here. Dr. Makkar has been a well-known figure all over India in the field of diabetes. He's a Director for Diabetes and Obesity Center, New Delhi. He's been the Honorary Secretary for RSSDI from 2017.
Tejas, you can skip this, I think.
No problem, sir. The course director for Cleveland Clinic and well known to all of us. Over to you, Dr. Makkar.
Welcome, sir.
Thank you, Dr. Tejas, and thank you, Dr. Vijay, Dr. Beni, for this great opportunity to give me this opportunity to speak on this very prestigious meeting. So I am going to speak on the remission of diabetes. Shall I share my presentation?
Yes.
Sure.
Okay. Can you see my slides?
Yes, sir.
Yes, sir.
Great. And I hope I am audible comfortably.
Yes.
I am not in India right now. I am in San Francisco, and there is some issue here with the signals. So I would, please bear with me if there are some issues, and just let me know if you stop hearing sound or the presentation doesn't move. But hopefully this should go well. So I would be speaking on navigating through the possibility of remission of type 2 diabetes. I don't have any disclosures for this presentation. I would take you through briefly about the definition of remission, what is the link between obesity and type 2 diabetes, and how does obesity lead to insulin resistance and beta cell dysfunction, and how is acute caloric restriction instrumental in leading to remission or reversal of diabetes. One thing, remission and reversal, I will be speaking, using this term synonymously, so that I will not be differentiating between two things. So first thing, what is definition of remission? So remission is defined as partial remission once you have the hyperglycemia below the diagnostic thresholds of diabetes. That means if fasting levels come to less than 126 and postprandial less than 200 and A1C less than 6.5, lasting for at least 1 year without giving any active pharmacotherapy or ongoing procedures. And it is defined as complete remission once you get the glucose levels below the cutoffs for hyperglycemia. That means below in the normal range, the fasting of less than 100 and postprandial less than 140 or A1C less than 5.7, again without any pharmacotherapy or ongoing procedure. And prolonged remission is defined when the remission is lasting for more than 5 years. Now let us see what is the link between obesity and type 2 diabetes. So we know obesity is one of the key drivers for development of type 2 diabetes, and almost 90% of type 2 diabetes individuals are either overweight or obese. And if you look at the data from various countries, as there is increase in prevalence of obesity, there is a parallel rise in the prevalence of diabetes, which is been reported from United States, from Australia. And if you look data from ICMR INDIAB study, you will see that the 5 states, Punjab, Tamil Nadu, Sikkim, Delhi, and Chandigarh, have the highest prevalence of diabetes. Now, interestingly, 4 of these states also have the highest prevalence of obesity and highest prevalence of abdominal adiposity. And there are numerous studies which have shown that obesity and type 2 diabetes have a strong association, and whenever there is a increase in BMI over a population, it can predict a change in the prevalence of diabetes also. So whenever there is rise in prevalence of obesity, there is a rise in prevalence of type 2 diabetes. We also know that type 2 diabetes is defined by two hallmark features: presence of insulin resistance and a compromised islet cell function, predominantly beta cell dysfunction. And we know from UKpedia study very clearly that this beta cell function goes on progressively declining during the course of disease. Now, how does obesity lead to this development of insulin resistance and beta cell dysfunction? So I am not going to go into the details of various studies. I'm just trying to build up the concept here. So there is a unified field theory which is proposed to explain this, and there is a possibility that both obesity and type 2 diabetes share a common underlying defect, which favors on one hand the progression development of insulin resistance, and on the other hand there is a uh, development of beta cell decompensation. The proposed hypothesis is that once there is a exposure of various cells to sustained nutrient excess, which is more than the requirement of the cells, there is impaired inflammatory signaling, increase in ER stress, increased production of free radicals, which leads to mitochondrial dysfunction and activation of serine threonine kinase pathways or AKT pathways. This pathway is very important in activating the FOXO mechanisms also. So once there is mitochondrial dysfunction, this actually sets a cascade of reactions which leads to developments of insulin resistance and beta cell dysfunction on one hand, and activation of FOXO on the other hand. Now, just to take you through the normal functioning of mitochondria. Mitochondria are basically the powerhouse of cell involved in metabolism of glucose as well as fatty acids. So there is glucose oxidation and lipid oxidation, and this happens depending on the physiological or nutritional circumstances, depending on what is available. And depending on the normal availability of whether there is excess of glucose like in the postprandial phase, or you have less glucose and more free fatty acids during the fasting phase, mitochondria can switch between glucose oxidation or lipid oxidation, and this is called metabolic flexibility of mitochondria, and this is the normal state of mitochondrial metabolism. What happens is, once there is obesity, there is chronic nutrient excess and there is increased supply of both glucose and free fatty acids entering the mitochondria, and they compete for the mitochondrial electron transport chain, leading to a gridlock and leading to the loss of discretion at the level of mitochondria to choose between the fuels. And this is a state of metabolic inflexibility. And this plays a key role in development of these metabolic abnormalities. So once there is obesity, there is increased storage of fat in the adipose tissue, leading to increased lipolysis and increased release of adipocytokines. On one hand, leading to insulin resistance. On the other hand, there is increased free fatty acids leading to lipotoxicity at level of pancreas and liver. Also, there is increased lipid storage in liver, leading to increased fatty glucose production. So overall, there is a situation of glucolipotoxicity, worsening pancreas function, leading to decreased insulin and setting a vicious cycle. So once there is increased excess nutrients, there is on one side development of insulin resistance, and on the other side you have a progressive beta cell dysfunction. And reduced insulin secretion worsens this nutrient excess problem by increasing further the glucose in the circulation and free fatty acids, leading to glucolipotoxicity. So there is a vicious cycle setup which leads to progressive increase in the inflammation, increased free radical production, and worsening of both insulin resistance and beta cell dysfunction. If this hypothesis is correct, then caloric restriction should be able to reverse these core defects. So let us see, how does caloric restriction lead to diabetes reversal? Now, we know that if you look at the natural history of diabetes, we know that it is a progressive disease which can be controlled but not cured because of the understanding of the mechanisms of insulin resistance and beta cell dysfunction. But if you look at the data from various diabetes prevention studies, all studies showed that even modest weight loss can lead to dramatic reduction in the risk of developing type 2 diabetes. And the first hint that type 2 diabetes is possibly fully reversible came from the bariatric surgery. And almost 30 years back, the Poris et al. Showed that once you have bariatric surgery, almost 90% of the people, the glucose levels normalized even before the weight loss was achieved, and they remained free of diabetes as long as 10 years. So normalization of glucose in type 2 diabetes occurred even before the significant weight loss, and this occurred within a week or so after the bariatric surgery. Now, this led to the belief that bariatric surgery possibly led to some changes in the incretin hormones, but at the same time overlooked the major fact that there was a severe decrease in the caloric intake which followed bariatric surgery, and which may be instrumental in leading to these changes. So, acute massive reduction in the caloric intake possibly led to the sudden reversal of traffic of fat in the fat stores, leading to major change in intracellular concentration of fat metabolites, or a shift towards the positive direction. So, if you look at the changes in the fat stores during hypocaloric conditions, the fat is first mobilized from the ectopic sites and then from the visceral sites. So if this hypothesis is correct, and if the rapid change in metabolism following the bariatric surgery is due to restriction of the caloric intake resulting from bariatric surgery, then defects of both insulin secretion and hepatic insulin sensitivity should be correctable by change in diet alone. And this was tested in the counterpoint study, which aimed to look at whether both beta cell failure and insulin resistance can be reversed by dietary restriction by providing a restricted caloric diet. And this study actually was a small group of patients, but very interesting study. 11 subjects given only 600 kilocalories diet for 8 weeks. And they were assessed for the changes in beta cell function, liver and muscle insulin sensitivity, and the liver and pancreatic fat at first 1 week after initiating the calorie restricted diet, 4 weeks after the diet, and 8 weeks after the diet. And as you see, the weight loss at first week was only about 4 kg, but at the end of 8 weeks was about 15 kg. The average body weight was about 100 kg, so there was about 15% weight loss at 8 weeks. But the glucose normalized at the end of first week only. And if you look at the insulin secretion, this improved within 1 week and improved, completely by the end of 8 weeks. And this improvement in insulin secretion was, exactly matched by the decrease in the pancreatic fat content. And this was documented on the MRI images that there was severe or profound mobilization of fat out of pancreas as well as liver. The study concluded that the abnormalities underlying the type 2 diabetes are reversible by reducing the dietary energy intake alone. And this also was the basis of the direct trial where Roy Taylor, studied whether we can achieve remission of diabetes by providing acute caloric restriction. So this study involved 149 patients with type 2 diabetes with the BMI in the range of 27 to 45, and they were given a dietary replacement of their replacement diets were of about 825 to 850 calories given for 3 months, 3 to 4 months, and then this was followed by a stepped reintroduction of normal meals. And a remission of diabetes was defined as a A1C level of less than 6.5% after at least 2 months of all anti-diabetic medications were stopped from baseline to 12 months. And as I mentioned, the average weight in this study was also about 100 kg, and the co-primary endpoints were achievement of 15 kg or more of weight loss. So at the end of 1 year, there were 24% of the people achieved a weight loss of more than 15 kg, and 46% people achieved remission of diabetes at the end of 1 year. And if you look at the people who had lost more than 15 kg weight, this group achieved a remission in 86% of the patients, and those who lost more than 10% body weight had a remission in 57% of the cases. So studies showed that at 12 months, almost half the participants achieved remission to a non-diabetic state and were on off for all the anti-diabetic drugs. And studies showed remission of type 2 diabetes is a practical option which can be tried. So it is now certain that disease process can be halted by restoration of normal carbohydrate and fat metabolism, and type 2 diabetes can be understood as a potentially reversible metabolic state which is caused by the chronic nutrient excess. And there is enough evidence showing that insulin sensitivity is related to the hepatic triglyceride levels, and this is one of the main reasons which leads to abnormalities of metabolism. And if you decongest hepatic and pancreatic triglycerides, you can lead to remission of diabetes. The chronic exposure of beta cell to increased triglyceride levels actually leads to decreased capacity of beta cells to respond to increased glucose levels. But the beta cells have a capacity to store excess fat within the beta cells, and once there is excess fat in the beta cells, they do not produce excess ATP whenever it is required, because they already have a nutrient excess. So the whole metabolism gets deranged at the level of beta cell. So Roy Taylor proposed twin cycle hypothesis. I'm sure you have all seen that excess calorie leads to increased deposition of fat in liver, thereby leading to hepatic glucose resistance, insulin resistance leading to increased hepatic glucose output, leading to hyperglycemia. Once there is hyperglycemia, there is increased requirement for basal insulin secretion, and this basal insulin secretion further promotes liver fat deposition. On the other hand, increased spillage of fat leads to beta cell toxicity, lipotoxicity, leading to decreased insulin in response to food, further contributing to hyperglycemia. Now, this is the same graphical representation of twin cycle hypothesis. Now, once you replace the caloric excess by the isocaloric balanced diet after the weight loss has been achieved, you normalize this liver cycle, which is driving the hyperglycemia, as well as the pancreatic cycle. Now, if you look at this slide, this is basically I picked up from Domenico Achilles' presentation at Banting Oration time 2017 or 18. He proposed that you have to focus on both function and mass of beta cells, and as the metabolic abnormality sets in, these cells move towards a normally differentiated beta cells to de-differentiation. What happens is a normal cell with normal metabolic state is performing normal function, but once there is exposure to excessive nutrients, there is activation of FOXO and setting up of metabolic inflexibility at the level of mitochondria. And if the nutrient excess is sustained, then these cells, beta cells, start losing their lineage, endocrine lineage, and start de-differentiating towards alpha cell lineage or the null cells. And this was documented in the experiments, that chronic nutrient excess leads to de-differentiation of beta cells. And in the same ADA meeting, Roy Taylor showed that there were a group of responders who had complete recovery of beta cell functional capacity within 12 months, and they responded, while the non-responders did not have recovery of the beta cell function. And he proposed that if there is metabolic stress, this healthy beta cell moves towards a less specialized or leads to loss of specialized function of insulin secretion in beta cells. And if this metabolic stress is sustained for a long period, this can lead to development of null cells from the dedifferentiation of beta cell. So as long as the metabolic stress can be removed before the null cell stage is achieved, there is chance of remission of diabetes. But if the chronic stress is prolonged and the beta cell dedifferentiation has moved to null cell stage, possibly it will become irreversible. So to sum up this presentation, type 2 diabetes is caused by nutrient excess leading to fat accumulation in liver and pancreas beyond a trigger point, and this trigger point is dependent on individual sensitivity to fat excess in different individuals. And this leads to both insulin resistance and beta cell dysfunction. And acute caloric restriction helps in lowering the liver and pancreatic fat and may reverse the disease. And I've shown you the mechanisms involved in this remission of diabetes. Thank you so much. With this, I conclude my presentation. I hope I've finished well in time.
Yes, very much in time. You have a time for question, or because we are running behind the schedule almost by 50 minutes. So before we conclude, I just want to ask one question, Dr. Makkar. This weight loss which Royal achieved was essentially in obese patient. And we could get the loss of to 20 kilograms.
Yes.
When the dedifferentiation of the beta cells getting into alpha cell. How about people who are normal weight?
So this group also, if you look at the Western standards, this group also included patients who had overweight and obesity. The range of BMI was 27 to 45. So this included the overweight patients also. Now, when we say normal weight, then possibly we are talking about diabetes patients who apparently have normal weight, but they have the what is called metabolically obese normal weight phenotype. And Neeta is also there, I think, in the panel, and we had discussion about this earlier also. So even these individuals, if you put them on caloric restriction, there is significant improvement in their diabetic status, and we have seen remission of diabetes happening with much smaller weight loss in these individuals as compared to what you're looking at 15%. So maybe 5 to 7% weight loss changes the whole story in these individuals.
Okay, that's great. Back to Purvi. Anything else? Tejas?
Is there a comment from Dr. Rucha or Dr. Neeta?
Neeta?
Yeah, I completely agree with what Dr. Makkar said. I've had patients who have done the reversal program with us with a body mass index of 23, but with high fat percentage. And these patients have gone down all the way to 21 BMI, lost the liver fat and reversed their diabetes. And a couple of these patients put back the weight on, came back to 22, 23, their diabetes came back. So Roy Taylor talks of a concept of a personal threshold for BMI for these outliers. So most people, the fat in the liver and the BMI matches, but there are outliers where it doesn't match. And for these outliers, losing weight, even in the face of a normal BMI, helps them reverse diabetes.
So the bottom line is to restrict carb. How much lowest amount of carb we can give? 50, 75?
No, actually, Roy Taylor did not restrict carbs.
No restriction. So, it is the total overall caloric restriction that you have to look at.
It doesn't matter from what source the calories you get.
No, it is a balanced kind of thing.
Balanced,
usually
but you have to.
Yeah.
So more important thing is that you should always make sure that you are giving adequate protein. So that they don't end up in negative nitrogen balance.
Yeah, and the muscle mass
calories,
also is not
source of calories is not very significant.
Yes, I think that was a very interesting discussion on obesity. I think I hand over back to Tejas and Shefali to carry forward.
Thank you so much, sir. Indeed, it was a wonderful discussion on obesity. And I thank all the speakers as well as the chair for this wonderful insights. We now move on to the next session. It's complicated, and I invite the chair for the session, Dr. Neeta Deshpande. She is a professor, a consultant diabetologist, and consultant at Belgaum Diabetes Center. Dr. Anuj Mehta, who's a consultant diabetologist at Kasturba Health Society, and as well as a visiting faculty at SMBT College of Women. Dr. Ayan De, who's a consultant nephrologist at BD Hinduja Hospital from Mumbai, and he's a gold medalist in DNB nephrology. I welcome you all, and I hand over the session to you.
Yes, thank you very much, Shefali. And I think I would like to really introduce the first speaker myself, because he's a good friend, good speaker, very nice orator. And Dr. Rajiv Kovil is going to talk to us on a very important topic, and that is guideline-based therapy of heart failure in diabetes. So Rajiv is medical director and consultant diabetologist at Dr. Kovil's Diabetes Care Center. And he has several feathers in his cap. He's invited faculty to diabetes fellowship program at the D.Y. Patil Medical College, and he's a founder, member, and secretary of the UDF, speaker at various forums, and has been principal investigator and has multiple articles published in international and national journals. So we're going to listen to Rajiv now speak about guideline-based therapy in heart failure in diabetes. Over to Rajiv.
Hello, colleagues across India. At the outset, let me thank Dr. Benny Neglur and the entire team of Wodcon for having me here. And my job today is to speak on a very hot topic in the last 5 to 7 years about heart failure and guideline-directed medical therapy towards heart failure. And our understanding of heart failure has gone up tremendously over the last 7 to 8 years. And we from metabolic physicians and diabetologists have become cardiodiabetologists because of the emergence and the prevalence of heart failure, which earlier used to be missed or misdiagnosed as bronchitis. Now, if you look at the risk of cardiovascular disease in terms of atherosclerotic cardiovascular disease and patients with heart failure, the CV risk among patients with heart failure is much higher. As you can see, that there's a lot more morbidity and adverse cardiovascular events or outcomes coming out of heart failure, which could be hospitalization due to heart failure, which could be sudden cardiac death, and so many others which actually come out of heart failure, and the risk seems to be much higher as compared to atherosclerotic cardiovascular disease. If you look at this UK Biobank, which is a prospective study and got published a year back, it looks as that South Asian ancestry is an inherent risk factor for heart failure. So just being from this part of the world puts you at very high risk for heart failure as well as coronary artery disease. I remember a friend of mine from the UK telling us that in their cardiovascular OPD, the Asians come for the heart and the Caucasians come for peripheral vascular disease. So that's such a clear divide when it comes to complications related to the vascular system. Now, when we look at heart failure, I believe there needs to be a proper definition in place. The definition in place is symptoms and or signs of heart failure, which is caused by structural and or functional cardiac abnormalities and is also corroborated by at least one of the following: elevated natriuretic peptide levels or objective evidence of cardiogenic pulmonary or systemic congestion. When we look at the universal definition and classification of heart failure, which just got, I would say, slightly tweaked last year, this was the ACC definition and classification of heart failure 2013, which was stage A, stage B, stage C, and stage D. We got a new nomenclature saying that stage A is at risk for heart failure, stage B is pre-heart failure, stage C is heart failure, and stage D is advanced heart failure. So when we talk about stage A, these are patients with diabetes, heart disease, hypertension, but they do not have any structural biomarker or genetic marker for heart disease, but they have risk factors for heart disease. Pre-heart failure are patients with all these, but they have one of these following features. Maybe a functional cardiac abnormality. They may have a diastolic dysfunction. They may have a biomarker like a pro-BNP, which is high. Or they may have a structural heart disease like probably an LVH on an ECG or an echo. Stage C heart failure are patients who are symptomatic. Our NYHA classification for heart failure is basically at stage C heart failure. Our whole idea or our whole mission and vision should be that we prevent patients from stage A and stage B to going into stage C, and obviously into stage D, which is an advanced heart failure with recurrent hospitalization, and patient may require therapy beyond guideline directed medical therapy. So most of us see patients in stage C. Our efforts should be to identify the risk factors for heart failure or pre-heart failure or stage A at risk for heart failure, prevent them from progressing into an event like heart failure. Now we all know that how diabetic cardiomyopathy and metabolic imbalance occurs early. We are not able to make a switch between glucose and NEFA. That causes a problem in the cardiac myocytes and the cardiac function. And finally, you may land up with 4 stages of cardiomyopathy, which starts with diastolic dysfunction. You may have systolic and diastolic dysfunction, coronary vascular disease, cardiac damage, and frank heart failure due to a long-standing insult. This meta-analysis, which got published almost 4 years back, tells us that almost 50% of patients with type 2 diabetes have some form of LV diastolic dysfunction. So many of us come across these reports on echo which says diastolic dysfunction, and we just sweep it under the carpet without realizing that these are patients who have a structural issue. They are patients in stage B heart failure or at risk heart failure or pre-heart failure, and these guys will progress to stage C. At least 2 in every 3 asymptomatic patients with type 2 diabetes have either a cardiac structural or functional abnormality on echo. And that is what we see, that you may have a diastolic dysfunction, systolic dysfunction, some kind of a structural abnormality in our 2 out of 3 patients. Now, when we look at this wonderful classification, which again looked at the ejection fraction, and earlier we were used to HFpEF and HFrEF. Now you also have a heart failure with mildly reduced ejection fraction and heart failure with improved ejection fraction. Lot of doctors across the globe believe that probably there are patients who are HFpEF or this HFmEF, that is between 40 to 50, are patients who have recovered from HFrEF. There are a lot of schools of thought, but if you divide patients based on their ejection fraction, if it's less than 40%, it's called as heart failure with reduced ejection fraction. 41 to 49 is called as mildly reduced ejection fraction. More than 50 is considered as preserved ejection fraction. Heart failure with improved ejection fraction is heart failure with baseline LVF less than 40% with more than 10-point increase and a second measurement more than 40%. So there are new definitions where that mildly reduced has now been re-terminology into heart failure with improved ejection fraction. So patients with HFrEF who have improved may be called as HFrEF with improved ejection fraction. If you look at the clinical profiles of patients with HFpEF and HFrEF, HFrEF patients are younger, HFpEF are older, some female preponderance in HFpEF. Otherwise, majority of them have similar kind of risk factors with HFpEF having atrial fibrillations and probably chronic lung disease. Importantly, if you look at data, nearly 1 in 4 people age 60 plus may have previously unknown heart failure, and that is very, very dangerous. If you look at the latest data from the Impulse study, what it shows is that almost We always knew that there is a 50% mortality with heart failure hospitalization at the end of 5 years, which is worse than many of the cancers of the world. But what is very surprising is that almost 25 to 30% have rehospitalization in the 90 days following a hospitalization, and the death rate in 2 to 3 months is 10%. So any hospitalization due to heart failure has an increased mortality after that. And if you look at it, nearly 1 out of 4 people aged more than 60 with type 2 diabetes may have previously unknown heart failure. Majority may be HFpEF, though HFrEF, and fatigue, pedal edema, nocturnal cough, any disordered breathing. One should raise our eyebrows about heart failure. Now, what are the mechanisms through which SGLT2 have cardioprotective effects in people with heart failure? Increased natriuresis, increased diuresis, glycosuria. It reduces intraglomerular pressure. It improves metabolic efficiencies, improves oxygen supply, reduces oxidative stress, has some action on the endothelial function. Arterial stiffness also it reduces. Overall, it helps in patients with heart failure. If you look at EMPAS and its effect across the cardiovascular continuum, I believe 2015 or 16 is the ESD when the EMPA-REX study came out, which was like a fairy tale, and we all raised our eyebrows and started clapping when we realized that we have an anti-diabetic drug which can reduce cardiovascular death, one of the most hardest endpoint in any outcome study, following which we have a lot of data which suggests that it can be used in patients with reduced ejection fraction, right from DAPA-HF to Emperor reduced, and then also Emperor preserved, where you can use it in patients with preserved ejection fraction, both with patients with diabetes and without diabetes. You also have data from the chronic kidney disease, which suggests that it can help in prevention of progression of chronic kidney disease and also have emergent risk reductions in the heart. You have mechanistic studies like the EMBRACE, which tells us that it works probably by reducing the pulmonary artery diastolic pressure. You have fantastic RCTs done in an acute setting like the EMPAS, which just came out 10 days back, which looks at empagliflozin in acute LV dysfunction, again showing almost a 36% difference in outcome. Thus, you have a study which you have a molecule which has withstood the test of time, and the robustness of evidence that it has gathered over the last 4 to 5 years clearly tells us that it will make a meaningful difference in heart failure benefits in patients across the cardiovascular risk continuum. If you look at the European Society of Cardiology recommendations on risk factors, patients with diabetes mellitus, it comes up right up there with healthy lifestyle and an SGLT2 inhibitor. If you look at the algorithm for ADA standards of care, patients with ASCVD or indicators of high risk or heart failure or CKD, directly the choice is SGLT2 with proven benefits, where obviously you will have empagliflozin coming right up there. Wherever we want to minimize hypoglycemia, minimize weight gain, we must look at SGLT2 inhibitors as such. If you look at the ADA standard of care guidance, the efficacy of SGLT2 inhibitors is intermediate, it's insulinotropic, there is weight loss, fantastic cardiovascular benefit in ASCVD and heart failure, progression of diabetic kidney disease in both with patients with diabetes and non-diabetes, a very small risk of euglycemic ketosis, very, very low risk of bone fractures with CANA. Genitourinary infections can be reduced by combining with the DPP4 inhibitor. So all these are there, and we need to be careful in some of the indications when we use it. If you look at the ESC ad hoc task force committees recommendation on SGLT2, as you can see, individuals with heart failure with reduced ejection fraction with or without type 2 diabetes. It reduces the risk of death and hospitalization for heart failure. In individuals with diabetes recently diagnosed for heart failure, the risk of CV death or hospitalization of heart failure is reduced by sotagliflozin. Type 2 diabetes with high risk CV risk in individuals with diabetes and high CV risk, it reduces MACE, it reduces cardiovascular death, it reduces kidney progression in individuals with CKD with both diabetes and proteinuric diabetic kidney disease. It reduces the progression to ESCD. in individuals with proteinuric CKD with or without diabetes, the risk of kidney disease is reduced by dapagliflozin. In individuals with diabetes and CKD, the risk of CV death or hospitalization for heart failure reduced by Cana, Dapa, and sotagliflozin. If you look at the 2021 update to the ACC expert consensus decision making, these are the 4 pillars of first-line therapy in HFrEF, and probably we need to make sure we are able to up-titrate therapy based on a lot of clinical scenarios and based on large randomized trials for HFrEF, ARNI, SGLT2, evidence-based beta blockers, and MRAs are the first-line medications for all the population. If you look at clinical scenarios and patient profile, patients with reduced BP and increased heart rate, you look at giving an SGLT2 or an MRA. Patients with reduced BP and reduced heart rate could be an SGLT2 plus MRA. Patients with normal BP and reduced heart rate, you can use an SGLT2 with others. But if you look at whatever clinical scenario, especially AFib also, you have right now data suggesting that AFib also goes down, especially from Emperor reduced post-hoc analysis. So SGLT2s needs to be given in whatever clinical scenario, and you would have benefit, and that is the kind of robustness of evidence you have. If you look at the 2021 update to the 2017 expert consensus meeting, indications for use of an SGLT2 is in HFrEF with or without diabetes, NYHA, that is stage 3 with class 2 to class 4, and could be administered with background medications. Contraindications, obviously type 1, DKA, is hypersensitivity, lactation, and on dialysis. Caution could be in pregnancy, patients with peripheral vascular disease, ketoacidosis, patients who have sepsis, acute kidney injury, or necrotizing soft tissue infections around. In summary, I would say that why one should use SGLT2 inhibition, because it's got proven benefit across the spectrum of heart failure risk, early onset of CV risk reduction, lesser safety concern than a synergistic effects with other CV therapy. How does it work? There's a salutary effects on pathological pathways, volume and pressure offloading, beneficial effects via the renal cardiac axis, and improved cellular metabolism. When to use it as a foundation in HFrEF, first line in patients with ASCVD and type 2 diabetes, at hospital discharge and comorbid CKD eGFR is more than 20. Sick day rule, acute, avoid use in acute conditions, hypoxemic states, avoid use in type 1, counsel for good perineal hygiene, and monitor risk for genital tract infections.
Thank you very much, Dr. Rajiv.
We do have time, but this is a recorded talk, and so we go on to the next speaker, Shifali.
Yes, ma'am. Dr. Ayande, I would kindly request you to introduce the next speaker, please.
So thank you so much for having me, Dr. Dharini Krishnan ma'am and the Wodcon team. For a nephrologist to be in a conference, it's a privilege and an honor, and I'm doing a tough job of representing all the nephrologists. Over the last 3 to 5 years, as we discussed right now, there has been a watershed moment with so many landmark trials coming in the management of diabetes and kidney disease. And so very appropriately, this has been kept in the program, which will deal with the early recognition, assessment, and management of stage 1 to stage 3 CKD, chronic kidney disease. To give this talk, I would like to invite Dr. Jayant Panda, a very illustrious CV, a professor and head, PG Department of Medicine, SCB Medical College at Cuttack. He was a national president of CCDSI. He's the chairman of the API Odisha State Branch and member of Indian Medical Association. And with more than 70 national and international publications, I'm sure we are all in for a treat. So without further ado, we'll continue with the presentation.
Thank you, Dr. Ann, for that introduction.
Welcome, sir. Welcome.
Actually, I'm thankful to Team Women and Diabetes Conference because during this holy time, it's a nice opportunity to interact. And it's the time that women are leading the world. So I congratulate Dr. Benny Negalur and Dr. Bija Negalur and the whole team of Wodcon for this opportunity. And the next 20 minutes, I'll try to put some interesting facts on the early diabetic kidney disease, that is stages 1 to 3. My slides visible?
Yes, sir. Yes, sir.
Yeah. That's great. So first, thank you, Benny ma'am. Thank you, Bijay sir. And thanks the team Wodcon. I'll be touching upon the burden of the DKD and natural history and diagnosis, and why we need a good glycemic control, and by only controlling blood sugar, blood pressure, cholesterol, and the different parameters like weight, which usually focus how this diabetic kidney disease can be delayed and people can be protected, we'll see. And finally, the prevention and management quickly. An interesting fact which many of us must not be knowing, that women are more vulnerable to have diabetic kidney disease than male. 1 in 4 women you see with type 2 diabetes has a estimated GFR of less than 60, that is around 26%, whereas 1 in 5 men you see have the same GFR, the incidence is 21% only. So it's very relevant that in Women Diabetes Conference we take this topic. And you all already know that in this existing diabetes registry of India, published by Dr. Raj Purkar and the Nadiad group, the diabetic kidney disease is the major contributor for the CKD in India. That's almost 1/3. And then other causes come after that. And if you see the National Health and Nutrition Examination Survey, significant percentage of patients with diabetes also have CKD. Though 60% have no markers, 30% have the albumin creatinine ratio more than the 30 milligram per gram, and around 20% have estimated GFR of less than 60 ml, and 10% have both the urinary albumin creatinine ratio more than 30 and the GGFR less than 60. It's a very interesting chart which directly shows you the relationship of the estimated GFR and the urine protein excretion along with duration of diabetes. When the diabetes duration increases right from the pre-diabetes stage to the incipient diabetic kidney disease to overt diabetic kidney disease, and finally the end-stage renal disease, we'll see the progression of the microvascular complication. And there, this we take as early stages, the stage 1 in the pre-diabetes stage, stage 2 in the incipient, stage 3 in the overt, and up to the 60 ml estimated GFR, we see the GFR steadily decreases over the course of diabetes, and the protein excretion in the urine steadily increases, with highest in the end-stage renal disease and lowest GFR corresponding patient requiring a renal replacement therapy. So the most important, the natural history of diabetic kidney disease, the glomerular hyperfiltration, progressive albuminuria, declining GFR, and end-stage renal disease are the stages which all of us have read. And the most important fact comes, the metabolic changes associated with diabetes lead to glomerular hypertrophy and glomerulosclerosis, and the tumorointestinal inflammation and the fibrosis of diabetic kidney disease, which we want to check in the due course. So this is roughly shows the pathophysiology, which affecting tubules, the endothelial cells and the podocytes with different pathophysiology leads to the atrophy, and the most targeted is the nephron population and the fibrosis and the sclerosis, which all of you know. And where initially, before the onset of the diabetes, everything is normal. The nephron number, the nephron size, the single nephron glomerular filtration rate, the total GFR and the kidney size all becomes abnormal, and the nephropenia takes place, the remnant nephron hypertrophy takes place, the increased single nephron glomerular filtration rate takes place, and increase of normal total GFR and normal or kidney size takes place. So here the most interesting thing comes, the intensive glucose control we have seen in the different trials like ACCORD, ADVANCE, Kumamoto, UKPDS, VADT, that the intensive control favors the microvascular complication. So diabetic kidney disease is favored by intensive control, and all the risk ratio shifts towards the intensive control. And reduced risk of progressive kidney disease with intensive glycemic control, if you'll see, may it be albuminuria, may it be twofold increase in plasma creatinine, or risk of plasma urea doubling, that all reduces with the intensive control in UKPDS with a 10-year risk reduction. Very interesting data. When you have a standard management, you have the cumulative end-stage renal disease very high, and when you have a intensive glucose control, the incidence is as low as 65%. So it reduces the risk of end-stage renal disease in the patients of type 2 diabetes when you go for the intensive control. And the all-cause mortality in patients with diabetes, if it's stratified by baseline eGFR, if you'll see, the probability of death when the estimated GFR is less than 29 is the highest, whereas the probability comes down with high GFR, and the lowest probability of death is with estimated GFR more than 90. So this is very interesting data from the Southeast Diabetes Mortality Study, which tells when you preserve renal function, we prolong the life. And you see the multifactorial intervention, the blood pressure, glucose, lipids, that halves the macroalbuminuria. The incidence of macroalbuminuria in standard and intensive group, if you compare, it's almost half in the intensive group. And the blood pressure, the glucose, the lipids, the weight, everything is targeted here. So the potentially modifiable factors like alcohol, hyperglycemia, hyperlipidemia, hypertension, obesity, physical activity, and social network at baseline, all has to be focused, which can be modified. And other non-modifiable factors like age, the family history, the level of formal education, male sex in type 1 versus type 2 diabetes, they contribute also to the onset or the decading. So let us see very interesting data, the laboratory evaluation and also the different drugs and their action for the decay prevention. Routinely, we go for 24-hour urinary collection, the creatinine measurement and the estimated GFR calculation, the renal biopsy, the spot check urine collection, that's the milligram of albumin per gram of creatinine, and the time, which is a 4-hour over the night, the urine collection, the microgram of albumin per minute. And this, we see the measurements, the diagnostic results, and other considerations are not going detailed in the interest of time. But one thing is very typical. If you have a estimated GFR more than 60, you can target a low A1C, and patient can have a better quality of life.
If you have a estimated GFR less than 60, then the HbA1c has to be little higher, that is 7 to 8.5%. And Dr. Rajput and others in this Indian study of insulin therapy in chronic kidney disease have given this interesting correlation. And the different world authorities like American Association of Clinical Endocrinology gives a target of 6.5% in the management of hyperglycemia in DKD. The KDIGO guideline, the National Kidney Foundation Kidney Disease Outcome Guideline, targets 7%. ADA has divided 6.5 and 8. And if it's a long-standing diabetes, older age, micro and macrovascular complications and limited life expectancy, you can target less than 8. And if it's shorter duration with younger age, absence of complication and a longer life expectancy, you can target even less than 6.5. So the intensive glycemic control initiated during early diabetes can prevent DKD. That's a conclusion from the presentation so far. Let us come to the treatment. And the treatment is automatically done when the associated risk factors are controlled. So we targeted glycemic control, blood pressure control, the rash control, the proteinuria control, and the cholesterol control. And next of my presentation will base on this. Before I go to the control, I tell the prospective molecules, the conventional pathophysiology, and the novel medical treatment of the diabetic kidney disease where they are tried. We know the hyperglycemia and the different contributing factors, the regional hemodynamic changes, ischemia and inflammation, and here the most important is the overactive rash, and here comes the markers, the IGF, the TGF, the VEGF, and they are targeted by the atrasentan. And the glomerular hypertrophy and the glomerular sclerosis is targeted by the ruvoxistaurin, the sulodexide, and the baricitinib, the JAK inhibitor. The decrease in nitric oxide, the reactive oxygen species, they are modulated by the bardoxolone methyl and the peridoxamine. The tubulointestinal fibrosis by pirfenidone and the PTF, whereas the reactive oxygen species in the overactive rash along with TGF beta and angiotensin 2 aldosterone are controlled by the finerenone, and the vitamin D, the mesangial cell expansion by the PTF, whereas the glucose lowering drugs take care of the hyperglycemia. So this in nutshell tells the different noble molecules, but few of them have come into the clinical practice. The different trials, landmark trials in DKD management are there. The first is the collaborative trial using the captopril, the IDNT trial using irbesartan, the renal trial using losartan, the EMPA-REG using empagliflozin, the CANVAS, the Cadence, the LEADER, the REWIND, which have used the canagliflozin and liraglutide and dulaglutide. They show very interesting fact, which will be summarizing in following slides. The anti-hyperglycemic treatment and the option in patients of type 2 diabetes with CKD. When you choose drugs like a DPP-4 inhibitor, a GLP-1 agonist, or metformin, the mechanism of action, you know what benefits you get in a patient of DKD. The DPP-4 has a clear benefit of decreasing albuminuria at 24 weeks in a retrospective study, and also the RCTs are there to corroborate the action. The GLP-1 is proven in the later trial, showing decreased rate of DKD as a secondary outcome. And the metformin, we know, the improves the glucose controlling and impairs the vitamin B12 absorption in the UK prospective diabetes study, which we have discussed. The SGLT2 inhibitor, all of you know about the reduced risk of the cardiovascular complications. And this drug also has 65% in this trial, the EMPA-REG outcome, 65% people had CKD, which results shows the decreased progression of renal disease and decreased need for the renal replacement therapy. And the thiazolidine, the pioglitazone, which increase the insulin sensitive insulin sensitivity and decrease the gluconeogenesis, reduce the urinary albumin excretion. So these are the group of drugs which are beneficiary if we use for the glycemic control, also contribute towards protection of the renal function. And I'll tell you the drugs when to cap and when to modify the dose. The anti-hyperglycemic treatment, if you're using these groups in patients of type 2 diabetes with CKD or DKD, the metformin is contraindicated if the estimated GFR is less than 30. We have to use with caution in the mild to moderate renal insufficiency. The sulfonylurea increase the risk of hypoglycemia that all of us are careful about. Meglitinide used with caution in elderly and the renal and hepatic impairment. The glitazones used with caution as they tend to increase the fluid retention and associated with congestive heart failure. Alpha glucosidase inhibitors not recommended in severe renal impairment, and exenatide injectable, the use with caution in severe renal or the GI disease. So the different drugs like biguanides, we have to be careful and not start between 30 to 45 eGFR, and it's contraindicated when GFR is less than 30. We use many combination of metformin, and we don't know when the patient slips to this category where the patient has come to below 30 GFR. So we have to be very careful when it reaches 45, and better not to use in those patients where it can do more harm than good. The SGLT2 inhibitor, the criteria are different for different molecules. Empagliflozin are to be avoided or discontinued if it is less than 45 eGFR. Canagliflozin are to be avoided if it's less than 30, and dose adjustment between 30 to 59. DAPA contraindicated less than 30, and it's not started between 30 to 45. The first generation sulfonylureas like acetohexamide and dolazamide are not in use now, and second generation like glyburide, glimepiride, glipizide, and glyclazide. The glyburide, we have to be careful about the hypoglycemic effects, and we have to avoid use. The glimepiride cautiously when it's less than 15. Glipizide and glyclazide are the drugs which don't require dose adjustment. The alpha glucosidase inhibitor is contraindicated in less than 30 GFR. So GLP-1 receptor agonist, the exenatide, lixisenatide, liraglutide, semaglutide, and dulaglutide. Lira, sema, and dula, they don't need any adjustment, whereas exenatide and lixisenatide are contraindicated in GFR 30 and 15. Thiaglitazone, I have already told you, there is no dose adjustment, and the meglitinide cautiously if it is less than 15. DPP-4 we have to lower in most of the molecules, Zita, Vilda, Saxa, and Aloe. Lina doesn't require any adjustment, and insulin, the dose adjustment based on the patient response, and long-acting insulin has to be given carefully. So when you're trying glucose control in a CKD, it's a balancing act between the hypoglycemia and off-target effects and desire to lower the blood glucose with a targeted A1C. And the role of insulin resistance in developing hypertension and diabetic glomerular nephropathy is also debated, and enhancing insulin sensitivity of the podocyte is an attractive approach in the treatment of the commonest cause of renal failure in the world. And you have to remember, insulin infusion in healthy human causes moderate and transient microalbuminuria. So these are the fields of controversy we can explore. Then I come to the blood pressure goals in the patient with renal disease. The usual target we keep 140/90. The systolic 130/135 can be done without side effects, and blood pressure 130/80 or less. Diabetic kidney disease and proteinuria are present. You have to consider the tighter controls if the patient is younger and more stable. For elderly, I think 130/80 is a good target. Different authorities like JNCA, the ACCHA, and ADA give different targets, but 130/80 is a good target for this. Patients of diabetes and patients with CKD stage 3 beyond, and special populations like people more than 65 years and the multimorbidity patient with the different risk are to be carefully monitored. The selected antihypertensive agents in DKD are many, and you know about the ACE inhibitors, the aldosterone antagonists, the ARBs, and they have different actions. You have to be careful about hyperkalemia and pregnancy. ACE inhibitors are contraindicated, and different creatinine clearance, you have to be careful. So the lipid management is another important parameter to prevent the DKD, and rosuvastatin, if you're using in GFR less than 30, it should not be given at a dose of higher than 10. Only 10 can be given. Ezetimibe has no doses adjustment and need in patients who require extra reduction. And if GFR falls to less than 30 ml, the atorvastatin and fluvastatin are the preferred, not rosuvastatin. When greater lowering of the LDL is needed, the ezetimibe can be added, and the dose adjustment is not required, and the bile acid sequestrants are helpful in some patients, although they may rise the triglyceride level. So the different statins, and most of them, the doses are mentioned, and most of them, they don't require dose adjustment, are Lova, Fluva, Aturva, and then Simba, Prava, etc. So in normal to mild and mild to moderate, they don't require dose adjustment. In less than 30, or in patients coming to stage 2 and stage 1, we need to adjust the dose. Finally, I'll tell you the key recommendation of diabetic kidney disease. The hyperglycemia, the hypoglycemia management targeting A1C less than 7, if not limited by hypoglycemia episodes. So overall, you can keep a target of A1C 7. Dyslipidemia management per standard guideline for patients with diabetes. We have already discussed the dietary counseling for those who are overweight or obese, including a referral to intensive behavioral counseling intervention or the weight management programs are important. Reducing the salt intake to less than 2 grams of sodium, corresponding to 5 grams of sodium chloride per day, is adequate. Smoking cessation counseling and treatment, if applicable, according to the potentially nephrotoxic insult whenever possible. The nephrology referral if GFR is less than 30 ml and an alternate cause of kidney disease is suspected. We have to send the patient for super specialty consultation. And the key recommendation when blood pressure is there, we have to target the blood pressure 130/80. I have already told you, adding these medications in a stepwise fashion. Initially, we go for ACE inhibitors, ARB as the first line agents. Then we have to consider the diuretics and or calcium channel blockers as the second and third line if BP goal is not achieved, and spironolactone still if it is not achieved and GFR is more than 30 ml, and if still high, we have to send the patient to nephrologist and assess the renal function. If the urinary albumin creatinine ratio is more than 30 without hypertension, to consider the ACE inhibitor and ARB, not limited by the side effects, and increasing level of albuminuria over time, declining GFR, the presence of retinopathy, hyperlipidemia, and hyperuricemia, the family history of hypertension, macrovascular disease, or DKD, to consider for SGLT2 inhibitor. If urinary albumin creatinine ratio is more than 300 and GFR is more than 30 ml per minute. So when DKD with urinary albumin creatinine more than 30 with hypertension, we have to manage hypertension. We have to up-titrate the ACE inhibitor and ARB with a maximum dosage of 80 milligram of lisinopril, equivalent to 200 milligram of losartan, to achieve maximum albuminuria reduction as tolerated by BP and side effects. SGLT2 inhibitor in addition to ACE inhibitor, if it's more than 300 milligram per gram and GFR is more than 30, and spironolactone in addition to the maximum tolerated dose if it again remains more than 300 and GFR more than 30. So the final recommendation, the individuals with type 2 diabetes should be screened for albuminuria at the time of diagnosis and annually thereafter. In adults with diabetes, the metformin should be used as a first-line therapy for glucose management because of its associated A1C reduction, decreased risk of renal failure, and decreased mortality. The GLP-1 receptor agonist or SGL2 inhibitor should be considered as second-line therapy for patients with DKD to reduce progression of DKD. Patients with hypertension, diabetes should be treated with a ACE inhibitor or ARB to reduce the rate of progression of DKD. And patient with DKD should eat a protein-restricted diet. And for women of reproductive age with diabetes, the ACE inhibitor or ARB therapy should be initiated only after discussion with potentially teratogenic effect. So with this, I end my presentation giving you the message. If you are very vigilant controlling the blood glucose, blood pressure, lipids, weight, and associated factors, right from the diagnosis of the patient, you can delay the onset of diabetic kidney disease, and you should be vigilant doing a screening every year. And earliest you detect from the stage of pre-diabetes to incipient DKD, you can intervene adequately and delay a end-stage renal disease where the patient is moribund to undergo dialysis or the renal replacement therapy. I thank again the team Wodcon for the opportunity, and I end my talk inviting the questions. Thank you all.
Shefali.
Thank you very much, sir, for such a wonderful session. It was really an absolute overall overview of what a diabetic kidney can go through and how we can prevent the fallacies that a kidney will probably endure. Dr. Anushri, if you could introduce the next speaker, please.
Thank you, Team Wodcon, for having me here. We've had a wonderful session. And to give the next talk, I would like to invite Dr. Lotika Purohit, who is the Director at Diabetes Care Center in Kolaba, Mumbai. She's also a visiting diabetologist at Sir JJ Group of Hospitals and Grand Government Medical College. She's a partner with Sugar Doctor Medicare. She's the treasurer of RSSDI Maharashtra chapter. And she's the president-elect of Rotary Club of Bombay Midtown. She's going to talk on the 3G story of diabetic complications: gene, gender, and epigenome. Ma'am, I would hand it over to you.
Thank you so much, Anushri. Can somebody enable my screen sharing?
Yes, you can share your screen.
At the outset, I would like to thank Dr. Beni Neglur, the force behind Wodcon. She's really worked very hard and has been, getting us all together every year to celebrate the diabetes and women. And in normal courses, we would be all in a room together in like a sea of yellow. And it would have been so much fun, but this also is a good experience. Thank you also to Dr. Vijay Neglur for being the silent worker behind the scenes and working with tirelessly with the ma'am to create such a wonderful show. Of course, I would also like to thank my friends who are part of the organizing committee and for putting up such a wonderful show. I know that there would have been a lot of work gone behind the scenes. So with this, I would like to start my talk. It's a little different. 3G, the story of diabetes complications. Gene,
I'm sorry
gender,
to interrupt you.
So
Yes,
3G story of diabetes complications: gene, gender, and epigenome. So we all know that genes are what provide the instructions for making proteins within the cell. If a gene has a change or a mutation, then the protein may not function properly. And these genetic mutations cause diabetes, which affect the proteins that play a role in the ability of the body to either produce insulin or in the ability of the insulin to lower blood glucose. Most people typically, of course, have two genes. Now, what are the genes which could cause type 2 diabetes? The most common gene which would be CAPPN10, which has been the first gene which was identified, and this encodes the enzymes and degrades the proteins. Besides that, there is the TCF7L2. This is the protein coding gene that has the strongest link to type 2 diabetes across the racial groups. We also have the GLUT2, which is the gene encoded for glucose transporter, which regulates the entry of glucose into pancreatic beta cells. We also have the PPAR-G, which regulates the fat cells. Now, most of the type 1 and type 2 diabetes are polygenetic. But however, we have some rare forms of diabetes which result from mutations or changes in a single gene, and these are called monogenic diabetes. It affects about 1 to 4% of the population. It could be inherited from either of the parents. Usually it is autosomal denomination, and it, however, sometimes could even occur spontaneously. Now, this reduces the body's ability to produce insulin. Neonatal diabetes and maturity onset of diabetes of the young are two main forms of monogenic diabetes. Now, when do we need to check if there is a patient who develops diabetes within the first 6 months of age? We need to do the genetic testing. If it is in a young child or an adult with a strong family history and who do not have the typical features of type 1 or type 2 diabetes, that is the presence of diabetes-related autoantibodies, obesity, and other metabolic features. In these, we need to go into genetic testing. Now, heritability of diabetes complication. The role of genetic factors has been shaping susceptibility to diabetes complication for many years. And some familiar studies have clearly indicated that there is a susceptibility to diabetic nephropathy, which has a familial basis. And usually we know that a lot of times we see patients who come to us with nephropathy. When we ask them, they will say that, even their fathers, uncles, or somebody else in the family has also had diabetic nephropathy. There is also a threefold increase in the risk of diabetic nephropathy as compared to the siblings of normoalbuminuric subjects. Now, about 30% of the variance of urinary albumin excretion rate is also considered as a quantitative trait. Cardiovascular complications, 40 to 50% of the variance in coronary calcium and carotid intima medial thickness, which are the two indices of the extent of atherosclerosis, can also be attributed to familial factors in people with diabetes. Besides that, there's about 25 to 50% heritability in diabetic retinopathy. Now, more studies were done with the candidate genes. In this, there is a division into two categories: genes which are placed in the pathway that can mediate the production of cellular toxins in response to excess glucose, or those genes placed in the pathways involving the tissue-specific organ damage which is induced by these toxins. The candidate genes which are involved in the glucose-induced pathway, the most robust finding in this category concerns the genetic coding for aldose reductase, which is an enzyme that has catalyzed the reduction of carbonyl-containing compounds into their respective alcohols. Aldose reductase is also a key regulator of the polyol pathways through which excess glucose is converted into sorbitol and fructose in the insulin-dependent tissues. The accumulation of these metabolites, especially the sorbitol, has been shown to induce complex biochemical changes contributing to the development of diabetes complications. The candidate gene testing for tissue-specific alterations, the VEGF gene stands out among all the other candidates that have been investigated for their contribution to diabetic retinopathy. VEGF is a growth factor that specifically acts on the endothelial cells, increasing the vascular permeability and inducing angiogenesis. High VEGF levels can be found in the vitreous of individuals with proliferative diabetic retinopathy, and intraocular injection of anti-VEGF drugs do show the retinal vessel proliferation. Now we come to gender. There usually is the change when there is a comparison of the main sex dimorphisms in body composition, in metabolic homeostasis in human, that is a pre-metabolic, pre-menopausal woman who is compared with an age-matched man. As you can see that in the men, there is an increased skeletal muscle mass, increase in the visceral adiposity, ectopic fat, NEFA oxidation at rest, as well as there's an increase in glucose oxidation during exercise and an increased fasting plasma glucose. In the female predominant metabolic traits, there is an increase in the fat mass, subcutaneous tissue, insulin sensitivity, NEFA storage at rest, increased oxidation during exercise, and an increase in the 2-hour post-prandial plasma glucose. There is a lifelong impact and interaction between the sex and gender in the development of outcomes of type 2 diabetes, as we can see the social conditions as well as the biological factors which work in. There is a difference in the prevalence of prediabetes, diabetes, and overweight in men and women, as can be seen over here. Now, when we view the physiological as well as the pathological differences in the metabolism and energy homeostasis, the physiological sex differences I have already discussed earlier mainly, and the pathological differences would be increase in the fasting blood sugar, increase in the diabetes incidence. The men would have diabetes at an earlier age. There would be a higher chance of them being overweight, and fatty liver would be increased, but there would be a reduction in the depression and androgen hormone, increase in erectile dysfunction, and an increase in neuropathy and diabetic foot. In women, on the other hand, there is an increase in the IGT, reduction in diabetes incidence, but diabetes does occur at a higher BMI. There is increase in obesity incidence. Metabolic health is, they're metabolically healthy obese. There could be some increase in the fatty liver. However, in women, there is an increase in the depression, increase in androgens, and polycystic ovary, and cardiovascular disease. When we compare the differences in the fat distribution, as we can see in this MR image taken at L4-5 in a healthy male or female at approximately the same age and BMI, we see that the visceral adipose tissue is more in men, as well as the liver fat is more in comparison. Now, we know that the abdominal visceral adipose tissue is more strongly associated with insulin resistance in women than in men, which suggests a stronger link between excessive visceral adipose tissue and diabetes in women than in men. This also shows the tissue-specific action of estrogen on the energy balance and the metabolic regulation. In a rodent model, we see that with estrogen, there is a reduction in the body weight and adiposity, increase in the insulin sensitivity, increase in the glucose tolerance, and prevention of diet-induced obesity, steatosis, and diabetes. Now we come to the epigenome. The epigenetics of obesity. Obesity is associated with differential DNA methylation and an increase in the epigenetic variability. As we can see in this figure, we can see the altered gene expression and increase in the epigenetic variants. Type 2 diabetes is also associated with differential DNA methylation. In this figure, we can see the various tissues and genes with the observed alteration in the DNA methylation in subjects with type 2 diabetes. Then some of these genes also show differential gene expression and have been shown to functionally affect diabetes-related phenotypes, such as insulin secretion. The DNA methylation of the genes is indicated in blood, has been associated with the future risk of type 2 diabetes in prospective cohorts. The different diets and nutrients are also associated with differential DNA methylation. In this figure, we can see the comparison when in response to human diet intervention like overfeeding either with PFAS or saturated fatty acids for 7 weeks or 5 days of high fat overfeeding or 36-hour fasting. The the human pancreatic cells are cultured with palmitate or glucose versus control for 48 hours. And some of these genes also show differential expression, and the diet and nutrients further affect the metabolism and the clinical phenotype. Now, how does the environment affect 3 generations? We know that at the time of conception, the environment influences the parents, which includes the spermatozoa as well as the in utero environment. And eventually, there's a possibility to affect both the fetus as well as its reproductive cells. However, the evidence is limited and still more work needs to be done in this area. The interaction between environment, epigenome, and obesity and type 2 diabetes. We have several genetic and non-genetic factors which contribute to the development of obesity and type 2 diabetes. The same factors like exercise, genetic predisposition, diet, intrauterine environment, and aging also do influence the human epigenome. And this may contribute to the disease and interact with and respond to various physiological conditions of heterogeneous disease. This is a model of the epigenetic regulation of the gene expression associated with diabetes complications. Hyperglycemia leads to a loss of repressive modifications that normally maintain regulated control of gene expression while activating histone modifications, which may be increased, thus leading to relaxation or opening of the chromatin structure around the key pathological gene, resulting in increased transcription. The metabolic memory and the epigenetic memory for diabetes complication. Hyperglycemia and AGEs activate multiple signals, transduction pathways, including oxidative stress, which regulate the transcription factors and epigenetic factors such as histone methyltransferase. Now, the DNA methylation at promoters of inflammation and extracellular matrix. This persistence of epigenetic markers at target gene regions may be one of the mechanisms for metabolic memory, which is implicated in the continued development of vascular and renal complications despite the good glucose control. Signaling of the epigenetic networks mediating the pathogenesis of diabetes complication and metabolic memory. Diabetes and its consequent metabolic disorder can upregulate several growth factors and lipids that can act via their receptors and other mechanisms to trigger multiple signaling pathways, transcripting factors, and crosstalk the epigenetic network. These events also cause chromatin remodeling and change in the transcriptional regulation of key pathological genes in the cells from target tissues, which are relevant to various complications of diabetes. The chromatin structure and the transcriptase regulation. Chromatin is made up of nucleosome subunits, which consists of an octamer of histones wrapped by chromosomal DNA. The epigenetic mechanism in diabetic nephropathy, there is a signal transduction events downstream of high glucose and AGEs and the growth factors, which alter the expression recruitment of epigenetic factors that mediate or remove histone PTMs and DNA methylation, which leads to chromatin remodeling. The epigenetic mechanism of gene regulation in vascular inflammatory complications and atherosclerosis, retinopathy, and metabolic memory. This is a diagram which shows the role of the multiple epigenetic mechanisms, including those mediated by RNA and INC RNA, which is associated with the regulation of genes involved in the vascular inflammatory complications. These epigenetic mechanisms increase the expression of NF-kB regulated inflammatory genes and inhibit the expression of protective antioxidant genes, leading to the development of vascular complications such as atherosclerosis and diabetic retinopathy. To conclude, we have increasing evidence to show that besides the well-described biochemical mechanism, epigenetic mechanisms might also participate by fine-tuning gene expression to modulate the etiology of diabetes complications. Persistence of epigenetic modifications triggered by diabetic stimuli could be one of the key mechanisms underlying metabolic memory. The involvement of many epigenetic factors and the mechanism involved in the regulation of modification by upstream signal transduction pathways remain unknown. This is a rapidly expanding and dynamic field, and it is likely that the other epigenetic factors related to diabetes complications will be soon uncovered. Epigenomics may also aid in determining the functional role of complications associated with genetic variants, and it would be worthwhile to assess whether lifestyle modifications such as exercise, healthy diets can also reduce the diabetes complication by altering the epigenetic marks. With this, I come to the end of my talk. Thank you for a patient hearing.
Thank you very much, Dr. Lotika Purohit. If there are any questions, otherwise we can move ahead to the next session.
There are no questions.
Okay. I think for shortage of time, can we move on to the next session because we are 1 hour late?
Okay, sorry.
Thank you so much, Dr. Rajiv Kovil, Dr. Jayant Panda, and Dr. Lotika. And I also thank the chairpersons, Dr. Neeta Deshpande, Anuj Mehta, and Dr. Ayan Dey. Dr. Shefali, shall we move on to the next session?
Thank you very much, everyone, for joining us today. We now move on to the next session, which is offbeat, and I would like to invite the chair for the session. Dr. Lily Rodrigues is a consultant diabetologist and director of Suraksha Diabetic Center in Hyderabad. She is the chair-elect of RSSDI Telangana chapter and have many accolades to her name. Dr. Ami Sanghvi is a consultant diabetologist and director of Sanghvi Eye Care and Diabetes Care Center in Mumbai. And she's, of course, a scientific co-chair for Wodcon as well. I also invite Dr. Pratiksha Patil. She's a diabetologist and the director of Pratham Specialty Clinic at Andheri, Mumbai. I welcome you all.
A very good evening to everyone, and directly moving on to our session on offbeat. It's my privilege to invite a close friend of mine who is also part of the core committee, Dr. Shefali Karkhanis, who will be talking on evolving evidence with newer gliptins, focus on evogliptin. Dr. Shefali is a founder and co-director at Karkhane Super Speciality Hospital, Thane, has been a member of the organizing committee for women and diabetes since 5 years and CID since 2014, has numerous papers and poster presentations to her credit. She's been a speaker and faculty on various national conferences. I invite Dr. Shefali Karkhanis to take over.
Thank you so much, Dr. Ami, for the kind words. I would like to share my screen now. I really thank everyone for being a part of Wodcon, and I'm privileged to kickstart this offbeat session with talking about a newer DPP-4 inhibitor on the block, that is evogliptin. Yeah. So evogliptin is a piperazine derivative, which is a selective, potent, and reversible inhibitor of DPP-4 enzyme. It has been extensively studied for its efficacy as well as safety. The recommended dosage is 5 milligrams OD, and it's available in various countries, including South Korea, Azerbaijan, Russia, Bolivia, and of course, India. So we know this is a DPP-4 enzyme binding site where S1 and S2 isomers are fundamental to produce DPP-4 inhibition. Additionally, binding to the isomers S2 extensive and S1 prime, S2 prime helps in more inhibition of the DPP-4 enzyme. So if you evaluate all the available gliptins in the market today, the vildagliptin and saxagliptin bind to the S1 and S2 isomers, while linagliptin and allogliptin bind to the S1 prime, S2 prime isomers in addition to the basic binding site, while sitagliptin, teneligliptin, and evogliptin non-covalently bind to the S2 extensive as well. A little bit about pharmacokinetics of evogliptin, because this is where the molecule differs. On administration of the molecule, the plasma peak concentration is reached by about 3 to 5.5 hours. After administration of the dose, there is a DPP-4 inhibition which is observed. 80% of DPP-4 inhibition is achieved in less than an hour after administration, and the terminal half-life is fairly long, of about 32.5 to 39.8 hours. The molecule reaches a steady state concentration within 3 days, but the accumulation index is very low. So it is only 1.38 to 1.5. And although evogliptin is metabolized primarily by the CYP3A4, it is not an inducer of cytochrome P450, and hence the drug-to-drug interactions are very minimal. The renal clearance is only a fraction, and hence no change in the dosage is required when we are treating patients who are renally impaired with evogliptin. A little bit about pharmacodynamics. We've already seen that it achieves 80% DPP-4 inhibition within the first hour, but this lasts for over 24 hours, and this is the beauty of the molecule. Thereby, the postprandial GLP-1 levels increase by about 1.5 to 2.4 fold and reduces the PPG levels by about 20 to 35%. And this is where the evogliptin as a molecule scores over. This was a bridging study which was done in the Brazilian population to evaluate and validate the dose regime of evogliptin. The patients were randomized to either evogliptin 2.5 milligrams, 5 milligrams, or 10 milligrams against sitagliptin 100 milligrams for a period of 12 weeks. There was a good reduction sought of about 1.3% in HbA1c as compared to sitagliptin. So this made it very clear that 5 milligrams of evogliptin was safe, it was well tolerated. The adverse effects were similar to that of the class as a molecule, and that is how we came to the doses of 5 milligrams OD. The Evergreen study presented at ADA compared evogliptin versus an active comparator, linagliptin. The patients were, there was a run-in period of about 2 weeks, and then the patients were randomized one-on-one, either to evogliptin or to linagliptin. The patients underwent a CGMS before being randomized, and after that, again, after a period of 12 weeks, the patients again underwent a CGM. Since this was an open label study, the patients were then put on evogliptin 5 milligrams for another 12 weeks, following which they underwent a CGM again. And this is what was shown. So if you see, the fall in HbA1c is very similar in both the arms, evogliptin as well as linagliptin, whether you consider it as 12 weeks or you consider it at 24 weeks. So this proves non-inferiority of evogliptin against linagliptin. If you talk about glycemic variability, as CGMS was performed at every stage, the average glucose already was reduced by week 12, and this was there was improvement in the MAGE even by week 24. So this proved that the evogliptin not only reduced the HbA1c but also improved the time in range that the patient spent in 24 hours. So to note in this particular study was 80% of the patients achieved an HbA1c of less than 7% in the target population, and 48% of the patients achieved an HbA1c of less than 6.5%. Now we have to realize that this was only a 24-week study, so it's not a huge duration, but the amount of patients who achieved improvement in the glycemic variability as measured by MAGE and ST was also fantastic. So this proves that evogliptin is not only safe, but it is also a very effective anti-diabetic agent, non-inferior to linagliptin. What about the renal data? So this is a renal impairment study, which was done as a single dose, open label parallel group study, where the patients had mild to severe renal dysfunction. The eGFR was calculated up to 15. And the GMR of Cmax and AU class was calculated, and they found that dose adjustment was not required when giving evogliptin in patients with all stages of renal dysfunction, except for end-stage renal disease requiring dialysis because they were not tested. So it is found to be safe to be given in all cases of renal dysfunction. Even in the case of mild to moderate hepatic impairment, this dosage, although the exposure curve slightly increased, but there was no adverse effects, or there was no question about the safety and efficacy of the molecule, and hence no dose adjustment is required when you're giving evogliptin in patients with mild to moderate hepatic impairment as well. Vijay sir, Dr. Neglur sir spoke beautifully on NAFLD, which is now one of the most gripping disorders of the world. And this particular study was done in South Korea. This was a 24-week double-blind, active-controlled, randomized parallel phase 4 clinical trial, where 80% of the study participants had moderate to severe fatty liver as assessed by ultrasound at baseline. Now, during the event of the study, the hepatic fat content was assessed using the MRI-PDFF. Now, MRI-PDFF, we know, produces very accurate results. It's like a quantitative image biomark for liver fat. And the hepatic fat content was reduced by use of evogliptin for 24 weeks by about 1.69%. So this is a good reduction in the hepatic fat content. The absolute liver fat content also reduced from 16.15% to 14.38%. There was also a reduction in the visceral fat as well as a subcutaneous fat, with improvement in the end treatment of AST and ALT levels as well. We know that it's finally an anti-diabetic agent, so it reduces the glucose levels, it improves the HbA1c, reduces the fasting. But this evogliptin also had a beneficial effect or a positive effect on triglycerides, LDL-C, and the free fatty acid levels after 24 weeks of treatment. Not only that, insulin resistance, as assessed by HOMA-IR, also showed a tendency towards decrease. So here we have a molecule which is not only safe, but it also shows a trend whereby we might improve the status of NAFLD patients and who have type 2 diabetes. Here we talk about the cardiovascular risk assessment. This is a nationwide population-based cohort study done in South Korea. Almost to the tune of 140,000 patients were involved in this particular study. All of these patients were having type 2 diabetes. They were uncontrolled on metformin and lifestyle modifications. And then they were randomized to either the use of glimepiride, DPP-4 inhibitors, or SGLT2 inhibitors. Almost 28,700 patients were on glimepiride. Almost 1 lakh patients were on DPP-4 inhibitors, of which 3,000 patients were on evogliptin, and 10,700 patients were on SGLT2 inhibitors. The conclusion of this particular study showed that evogliptin, in fact, was associated with reduced risk of CVD as well as cerebrovascular events when compared to the glimepiride users. A null association was found with myocardial infarction and heart failure and TIA, but this particular study was to prove the cardiovascular safety of evogliptin, which has been established fairly well. We also have evogliptin with metformin combination at our disposal. And what is the clinical evidence? These are all the studies which I'll touch upon briefly. This is an international study in Korean population, which studied the efficacy and safety of adding evogliptin or sitagliptin in metformin treated patients. Metformin was of 1000 milligrams was used in this particular study. 24-week randomized control trial with a label extension of about 52 weeks was done. And the mean change in HbA1c was almost similar in both the arms, proving that evogliptin is non-inferior to sitagliptin. This is another study, Evolution India, with Indian patients. Again, vis-a-vis sitagliptin, evogliptin showed a similar reduction in HbA1c, thereby proving the non-inferiority on the baseline metformin therapy. The multinational global study again evaluated the change in HbA1c from baseline to week 24 by, this was a Russian and a Korean combined study, and in both the populations, sitagliptin as well as evogliptin showed a similar reduction in HbA1c in addition to metformin. So this completely proves that sitagliptin and evogliptin both are at par. Both of them are non-inferior to each other, and this proves the efficacy of the molecule as well. The safety of evogliptin was analyzed using data from 6 studies, where the forest graph shows that the rate of adverse events did not statistically change in patients who were receiving evogliptin as compared to the controls. In fact, there were no reports of any pancreatitis from any of the study participants in all the 6 studies. The data from 5 studies were analyzed to evaluate the risk of hypoglycemia. Now we know that patients receiving hypoglycemia, the forest graph is showing that the patients who have received hypoglycemia did not have any increased risk of symptomatic or asymptomatic hypoglycemia, and thus it's proved to be very safe. The latest Indian data is what we are all looking forward to, and this is what was presented. This is a real-world experience, a retrospective observational study for the use of evogliptin in type 2 diabetic patients, which was presented at RSSDI 2020. And the aim of the study was to assess the effectiveness and the safety of evogliptin, either alone or in combination with other oral hypoglycemic agents. Remember, in this particular study, the patients ranged from patients being drug naive to on 1 drug, on 2 drugs, on triple drug therapy of AHAs, AD. And this also showed a good reduction in HbA1c. By week 12, there was about 0.9% reduction in HbA1c. By week 24, this was about 1.45% reduction in HbA1c from baseline, with reduction in fasting as well as PP blood glucose values. This is another study which was presented at RSSDI 2020. And this used CGM to monitor how evogliptin affects a patient in the real world. So the patients were put on CGM for 15 days prior to adding evogliptin. And then again, after adding evogliptin, the patients were put on CGM for the next 14 days. This is what was seen. There was a significant reduction in the mean blood glucose levels after adding of evogliptin, and there was significant improvement in the percentage of time which was spent in the target range by the patients. Now remember, this is done immediately, so there is no span of time which is wasted. But evogliptin thus was found to be very effective in patients who were given who were added evogliptin in patients who were uncontrolled on other oral antidiabetic medications. This is a paper which was presented at ADA 2021. Again, an Indian data. Efficacy and safety of evogliptin plus metformin when added to insulin therapy in elderly patients with type 2 diabetes. The beauty of this study was it was not only that the patients were older, more than 65 years of age, but these patients were also on insulin. When they were put on evogliptin with metformin combination, the HbA1c reduction achieved was to the tune of 1.2%. Moreover, there was a reduction in the body weight after 6 months. There was a reduction in the requirement of insulin after 6 months, and the time spent in target range was increased. Most patients, almost 22% of the patients, achieved an HbA1c control of the target levels. And most importantly, what we always fear in senior citizens is the hypoglycemic events or hypoglycemic unawareness, and which leads to fall, etc. But there was no significant hypoglycemic events on addition of evogliptin with metformin to insulin therapy. This is another study which was published in Journal of Endocrine Society in 2021, where evogliptin was added as a third line therapy for patients who were uncontrolled on metformin and glimepiride, and then the criteria were assessed. Again, after 6 months, there was a good 1% drop in HbA1c with changes in the fasting and PPBS levels as well. The total cholesterol and triglyceride levels also significantly improved. There was no severe hypoglycemia in any of the patients. This is an active post-marketing surveillance of FDC evogliptin 5 milligrams with metformin hydrochloride 1000 milligrams film-coated bilayer tablet. And it was conducted in 6 centers across India with 300 patients who were involved in the study. The duration was 24 weeks, but more importantly, the duration of diabetes was about 4.3 years. So these were not newly diagnosed diabetes. In spite of that, there was a good 1% reduction in HbA1c, which was found at the end of 6 months. Thus, thereby, proving the efficacy of the molecule. The changes in the fasting and PP levels were also seen, and thus FDC of evogliptin with metformin. It is a wonderful modality to reduce the glycemic parameters, including the fasting PP and HbA1c levels, because it was safe, it was well tolerated, it's an OD preparation, so there is convenience. To summarize, evogliptin is truly a once-a-day gliptin with the longest half-life of about 32.5 to 39.8 hours. There is definite established renal, hepatic, as well as cardiovascular safety. There is no need to change the dosage in cases of renal impairment or mild to moderate hepatic impairment. As per the Evergreen study, we've seen that against an active comparator like linagliptin, it is showing similar kind of HbA1c reduction. 3 head-to-head trials against sitagliptin, including Indian Evolution study, has proven evogliptin to be non-inferior to sitagliptin. The combination dose of evogliptin with metformin FDC proves to be a better compliance with a convenient dose administration. It's a strong OD dosage, and it can be used along with insulin, along with other OHAs, along in senior patients, in drug-naive patients, in patients who are on multiple therapies, etc. And this is the ease of convenience. This is good safety. It has a good safety data, and it is efficacious as well. So all in all, I think this is a very good molecule for us to be using in our day-to-day practice. Thank you very much.
Thank you, Dr. Shefali, for the wonderful deliberation on evogliptin. We immediately move on to the next talk. I invite the other chairperson to introduce Dr. Dharini Krishnan.
Yeah, I take great pleasure and pride to introduce Dr. Unni, who is not a stranger to any of us in our country and abroad as well. And he's now heading the Department of Endocrinology and as a CEO of Chellaram Diabetes Institute, Pune, and leading Diabetes Institute in India, and an IDF certified center for education and excellence in diabetes care. Dr. Unni is also a game changer, not only the topic for today, but he's a game changer of this institute as far as I know. He has brought up this institute to the global repute, and we congratulate him for that. And Dr. Unni has so many accolades to his credit, and I don't want to go through all of them. And I straight away hand over the mic to Dr. Dharini Krishnan.
Thank you. Thank you, Dr. Rodriguez, for that kind introduction. I'd like to thank Dr. Benny Naglur and Dr. Vijay Naglur for the kind invitation. I'm just going to share my screen in a moment. May I ask if my slides are visible and if I'm audible?
Yes.
Sorry. So thank you, lovely to be here. And I'm going to talk about tirzepatide, the dual GLP-GIP agonist. Now, this is the agenda for my talk today. The first part is titled GIP or GLP-1 or both. And second is, what is this most important SERPA study and what are the implications for the future? Well, I've been an investigator in the injectable semaglutide and oral semaglutide study, but I must confess I don't have any experience with tirzepatide. So largely what I'm saying is my understanding of the literature. But it's important to note that just like we have the enteroendocrine cells, we also have the pancreatic endocrine cells. The enteroendocrine cells produce K cells, which primarily produce GIP. The L cells in the intestine produce GLP. And we all know that the islets of Langerhans contain alpha cells, which produce glucagon. Now, the interesting thing is glucagon, GIP, and GLP are all the three derived from a very, very similar structure. And it is the pattern of enzymes that determine which is predominant. And therefore, in the human body, the way each of these three peptides act on the receptor ultimately determines the clinical phenotype. So gastric inhibitory polypeptide, or as it is now called glucose-dependent insulinotropic polypeptide, GIP and GLP-1 are incretin hormones secreted from the intestine. And on ingestion of glucose and nutrients, they act on the pancreas and they exert their effects by binding to specific receptors, the GIP receptor and the GLP-1 receptor, and these receptors belong to the G protein coupled category. And one of the important stimulators of release of these hormones in the intestine is food. And once the receptor is bound, it activates and increases the level of intracellular cyclic AMP in beta cells. And this is very important to remember, that it increases the level of intracellular cyclic AMP, because that is how the efficacy of these peptides is determined. So it's also important to note that while both GIP and GLP have effects on various tissues, primarily within the pancreas, GIP and GLP promote beta cell proliferation, inhibit beta cell apoptosis, expand pancreatic beta cell mass, and at the same time, there is one effect which is paradoxical. It is that GIP increases postprandial glucagon, whereas GLP-1 suppresses it. In adipose tissues, it is important to remember that GIP, but not GLP-1, facilitates fat deposition. Both GIP and GLP-1 act on the brain, and therefore the secretion also has effects differential on type 2 diabetes and normal people, healthy people, I mean. So let's look at GLP-1 versus GIP. You can see both increase insulin, both increase tissue glucose uptake, both increase glycogen, and both reduce hepatic glucose output. Where they differ is that GIP increases glucagon. That's a critically important difference. And the second is GLP-1, of course, we know reduces glucagon. And the second is GLP-1 reduces liver fat, whereas GIP-1 paradoxically might increase fat deposition. So in the yellow color arrows, we talk about GLP-1, and the white color arrows, we talk about GIP. It is extremely clear here that GLP-1 decreases calorie intake, whereas GIP also decreases it. GLP has effects on gastric emptying, whereas GIP has no such effect. Both GLP and GIP increase the post-meal bone remodeling. And very interestingly, both reduce triglycerides, but GLP-1 reduces it by reducing chylomicron production, while GIP reduces it by increasing triglyceride uptake and storage. So how is GIP different? During hypoglycemia, you want hypoglycemia to be corrected. So during hypoglycemia, GIP increases glucagon. During hyperglycemia, GIP increases insulin. So GIP has a glucose stabilizing effect in that matter. And most importantly, on the brain, it augments GLP-1 action. So that is why GIP-GLP-1 combination may be useful. So GLP-1, we know, regulates blood glucose by several mechanisms. It stimulates increased insulin, suppresses glucagon. But GIP stimulates increased insulin release, but also stimulates glucagon release during hypoglycemia. So that is the concept of tirzepatide. And let me talk about tirzepatide when I go to the all-important, so-called all-important SURPASS study. So tirzepatide, I'll come to the structure in a moment. But as I said, the function of GLP-1 and GIP are best studied by looking at the cyclic AMP activation. And here you will see that cyclic AMP activation, you can see both GIP and GLP acting together, very similar. Here you look at GIP, here you look at tirzepatide. And here again you look at GLP, and here you look at tirzepatide. Now one look at this panel shows you that these two lines seem to converge, whereas these two lines seem to differ. In other words, though tirzepatide is a GLP-1 and GIP agonist, tirzepatide is a dual GLP-1 and GIP agonist, its action seems to favor an imbalance towards a preference towards GIP-1-like action. Similarly, you will see that this is effect on differentiated adipocytes. And again, you see that these squares are for GLP-1, and you can see that in differentiated adipocytes, GIP and tirzepatide stimulate cyclic AMP. So again, it shows a slight preference towards GIP-1, a slight partiality. And you will see that in the endocrine pancreatic beta cells, you will see that both tirzepatide, which is LY3298176, and GLP-1 GIP have a very similar action. So tirzepatide is a dual GLP-1 GIP co-agonist, but it seems to have, at least in some tissues, an imbalance towards stimulating GIP-1 rather than GLP-1. So tirzepatide, friends, is a dual glucose-dependent insulinotropic polypeptide, that is GIP-GLP-1 receptor agonist. The structure is primarily based on GIP agonism, and the structure is therefore primarily based on GIP, and it includes a C20 fatty diacid moiety. The half-life of tirzepatide is approximately 5 days, and therefore it allows a once-weekly subcutaneous injection. You can see the structure here. And coming back to the structure, chemically, tirzepatide is a synthetic linear peptide having 39 amino acids and has a structure very close to a GIP sequence. Tirzepatide, as I mentioned, is a man-made imbalance because there is a greater degree of engagement of tirzepatide with the GIP receptor agonist, corroborating an imbalanced mechanism. An imbalance towards GIP combined with distinct GLP-1 signaling accounts for the promising effect of this investigational agent. In other words, the structure of tirzepatide is similar to GIP, though it has some similarity to GLP-1, and the binding is also more for GIP, and the cyclic AMP activation is also more for GIP, and therefore it has a unique mechanism of action. And here you will see that in the L cells and the K cells, there is both GIP and GLP, and a combination of the two has very important actions. So then we come to the SURPASS study, which looked at tirzepatide versus semaglutide. Now, this was an open label 40-week phase 3 study. And as the investigators say, they randomly assigned 1879 patients into a 1:1:1:1 ratio. So one group got semaglutide 1 mg, second group got tirzepatide 5 mg, another group got 10 mg, and another group got 15 mg. At baseline, the mean A1C was 8.98, and the mean age was 57 years, and the weight was 94 kilos. And the primary endpoint was A1C reduction in these people with diabetes. Now, you will see that at one look, you will find that semaglutide and tirzepatide 5, 10, and 15 seem to lower A1C better, and tirzepatide 5, 10, and 15 seem to lower the weight also better. If you look at this slide, which shows the speed of reduction of glycosylated hemoglobin, remember this was only a 40-week study. Tirzepatide lowered the glycosylated hemoglobin faster and lower than semaglutide. It also reduces fasting serum glucose levels more rapidly and better. Tirzepatide, if you look at the body weight change, you will see that tirzepatide 5 mg, 10 mg, and 15 mg caused a more rapid and sustained reduction in body weight. And if you look at the percentage of people who met body weight targets, again, tirzepatide patients, a higher percentage with each dose, showing a dose response effect. Lipids, again, reduction was quite good with both the agents, but again, tirzepatide showing a little better triglycerides and, of course, LDL reduction. The side effects were similar in the tirzepatide and semaglutide groups. So you can see that tirzepatide and semaglutide both led to nausea and vomiting and diarrhea, which were mild to moderate intensity and transient. Therefore, if you see the primary endpoint of this 40-week study, which was a change in glycated hemoglobin level, you will see that 1 mg semaglutide versus 5 mg tirzepatide, the difference, the glucose lowering was better with tirzepatide, and the p-value was statistically significant at 0.02. But the 10 mg and 15 mg, it was even more significant, the glucose lowering efficacy. In fact, if you see the 15 mg dose, the A1C lowering was up to, the mean A1C lowering was minus 2.3. So therefore, the authors in the SURPASS study concluded that in people with type 2 diabetes, tirzepatide was non-inferior and superior to semaglutide with respect to the mean change in glycated hemoglobin level from baseline to 40 weeks. And better weight loss was also achieved with tirzepatide. There are some limitations of this trial. Firstly, the treatments could not be blinded because of differences in devices. Second is, the trial was only a very short trial, only 40 weeks trial, which allowed only 16 weeks at steady state. The higher dose of semaglutide, above 1 mg, were not available for comparators at the time of the trial. So I've looked at how GIP and GLP could be combined and how GIP-GLP receptor co-agonists like tirzepatide, by having a favorable effect on GIP alone, the GIP faction could prevent hypoglycemia by releasing glucagon. The GIP faction could augment the cerebral effects of GLP-1. And of course, the classical GLP-1 receptor signaling together could have benefits. And such a molecule, tirzepatide, was shown to lower glucose better than compared to semaglutide. And now let's look at what are the implications for the future. So you can see 3 molecules there, and there are many more coming: GLP-1, GIP, and glucagon. So having a post-receptor activation in different combination, you could get benefits. For example, GLP-1 binding to the receptor decreases glucagon, increases insulin, causes weight loss. GIP increases insulin, may be obesogenic because it causes lipid deposition, but it could increase glucagon during hypoglycemia and give an edge. Moreover, GIP potentiates the GLP-1 action at the brain, giving another advantage. And we are traditionally told that glucagon is hyperglycemic, but selective stimulation of the glucagon receptor to produce energy expenditure and weight loss, but not stimulating the diabetogenic pathway, may have effects. So GLP-1, GIP, and glucagon, stimulating their receptors in different proportions could be harnessed clinically. For example, a combination of all three would mean that glucose lowering would be an effect of GLP-1, weight loss may be an effect of GLP-1, increasing insulin may be a release of GIP, GLP-1 potentiation should be an effect of GIP, increasing glucagon during hypoglycemia may be an effect of GIP, and stimulating the glucagon receptor to cause weight loss may be an additional advantage. So what is the future of all this? Potentially, tirzepatide could replace pure GLP-1 receptors as therapy. Tirzepatide could be prescribed in combination with metformin and SGLT2. Remember, semaglutide injections cause weight loss of 15 kilos, mean weight loss, and 15%. And if you get more weight loss with tirzepatide, potentially it could be a good replacement of GLP-1 and be combined with metformin and SGLT2. Reduction of systolic BP, lipids, and AST/ALT have been shown, but you require outcomes of cardiovascular outcome and NASH-specific data, outcome data, which are needed. Now, another philosophical angle of all this is, with all these twin cretins and triple cretins, are we depending on drugs more than lifestyle modifications? And this trend is worth watching. Is it going to replace bariatric surgery? We'll have to see. Now, we know that this is emerging as a treatment for NAFLD, and are the metabolic and AST/ALT benefits driven by weight loss or not? In GLP-1, it is said that the cardiometabolic effects are largely driven by weight loss. But for GIP, GLP-1 combination, is this true? That needs to be studied. And what is the extent to which GLP-1, GIP receptor activations impact these functions? And also, if we were to use higher than 1 mg doses of semaglutide, how will tirzepatide compare? So these are the questions remaining at the end of the study. But meanwhile, let me share that it's an honor and pleasure to be invited to this meeting. And I thank once again Dr. Benny Neglur and Dr. Vijay Neglur for having given me an opportunity to join you virtually. Thank you so much.
Thank you, Dr. Unni. It was a wonderful talk. It's fantastic. Now, I have one question to you. We have the SURPASS 1, 2, 3, 4, and 5 trials. All of them could get the A1C below 7 in the 97% of the population. And you also have a weight loss of 12 kilograms. Such a massive weight loss and good glycemic control in a short period, as you mentioned, does it also translate into cardiovascular benefit?
Instinctively, I do feel that these benefits are likely to cause cardiovascular benefits. Of course, you require a trial to actually show it, but definitely I would, if you look at oral semaglutide and injection semaglutide clearly showed that there is a benefit, and therefore oral semaglutide, of course, the SOUL study is still in progress and we are one of the sites for the study. But at the same time, I'd like to add that tirzepatide and these molecules are likely to have cardiovascular outcome benefits, but again, it needs to be proven from a regulatory perspective. But I think that will also happen soon.
Yeah, once they come that, then I think the guidelines will be changed again. There'll be further change in the guidelines. One very practical question, when you give DPP-4 inhibitors, you increase both GLP, GIP. Such kinds of beneficial effects are not seen when you use DPP-4 inhibitor, even in the higher doses. Do you think that this is a different effect altogether when given by injectable route, that these molecules work differently rather than the endogenously produced GLP, GIP?
Yes, I completely agree. In fact, if you see the data, the GIP concentrations achieved with tirzepatide are more, and more than that, the CMP activation produced by tirzepatide is also higher. And therefore, I believe that at low doses of GIP, such as seen with DPP-4 inhibition, the levels of GIP may not be sufficient enough to augment the action of GLP-1 on the brain and cause weight loss. But at the same time, I also believe that DPP-4s have some degree of GIP elevation. The clinical implications of that might be studied.
That's great. Wonderful answers. I hand over back to chairpersons.
Thank you very much, sir. Thank you. Indeed, a wonderful presentation. A lot to look forward to in the forthcoming years. I now invite Dr. Pratiksha Patil to introduce the next speaker, please.
Thank you, Team Wodcon, and especially Benny ma'am for having me here today. I'm happy to introduce one of my well-known good friend as well, Dr. Purvi Chawla. As you know, she's a well-known face in many local and national conferences. She's also been an active core member for many conferences like Wodcon itself, plus Challenges in Diabetes, and a core team for RSSDI as well. She has been an active member for and sub-investigator for many national and global clinical trials conducted at Mumbai. She's currently practicing as consultant diabetologist and director of clinical research at Lina Diabetes Care and Mumbai Diabetic Research Center. Also as an honorary consultant at Bharti Nidhi Hospital, Juhu. So handing over to you.
Thank you.
Dr.
Thank
Purvi.
you so much, Pratiksha, for that warm introduction. And at the outset, let me offer my thanks and my salute to Dr. Benny ma'am and Dr. Neglu sir for making me a part of Team Wodcon and also for this cherished opportunity. I also have to share that our site is part of the SOUL trial as well as of Surpass 4. And our experience with tirzepatide has been excellent, except I remain concerned about the tolerability of all these newer molecules. So without further ado, it's always a very tall order to follow Dr. Dharini Krishnan's talk because he's outstanding, and to follow that, it's a tall order, but I'm going to try my best. I have a very simplistic presentation, straightforward one. It's a sponsored talk. So individualization of insulin therapy, choosing the right solution for your diverse patients. And this is a known or sponsored talk. So it's going to be their slides. So of course, the burden of diabetes, should we be worried about this during the current times? Of course.
Ma'am, sorry to interrupt you, but please put it on slideshow mode.
It is on slideshow mode.
No, ma'am. Yes, ma'am.
Okay, great. Okay, so the burden of diabetes, of course, we all are worried about it. The conundrum of how it is different in India and Asian countries, yes, we have a fair idea, but just to remind you all. And then in initiating insulin, the innovative 2-in-1 solution for total control of glycemia, and then a little bit of focus on the ARISE trial, the real world evidence study that was recently concluded. So with that, these are the latest figures from the IDF-10 Atlas. 10.5% people globally are suffering from diabetes today. It's higher in the urban area as compared to the rural, and higher in high-income countries than the low-income countries. But the worrying part is that the trend is only on the rise. Nowhere in the world are we able to reduce this trend or decrease it or change it to the reverse direction, right from 13% in Europe to a whooping 87% in the Middle East and North African countries. And somewhere in the middle at 68% projected rise in Southeast Asian countries, and India is well included in this. So yes, it's a startling phenomena when we see it like this, but I think this is what we all aim to improve in the coming years. Again, the diabetes burden in India from the IDF-10 Atlas, which was released in December 21. 1 of 12 adults have diabetes in India, and this number has changed again. It was 1 in 18 in the previous Atlas. previous version of the Atlas, and now it's 1 out of 12. And of course, 53% of these of our diabetes population does not even know that they have diabetes, which makes all the previous discussions that we've had since morning very, very relevant. And one of them was on the diabetes care scenario in India by Dr. Bansi Sabu, and he made very relevant points with respect to screening for diabetes. Again, we are so poor in our insulin use, even though we know that it's one of the most robust, effective agents for lowering glycemia, and we still delay the initiation of insulin, even if uncontrolled on oral agents. So as you can see, this is just a comparative graph of the HbA1c change when therapy is initiated. And you can see amongst all the agents, oral agents and the injectable GLP-1s, the robust efficacy is achieved with the different types of insulin as we prefer to use them, or as we select and appropriately use them in our patient population. So, well, now we move on to how is it really different in the Indian scenario, type 2 diabetes management. None of us can deny that Indians are exposed to a high carbohydrate diet. And again, since morning, I think there has been enough discussion on that. So these are some of the factors that really impact the glycemic control and the comorbid conditions of obesity, as well as other morbidities like hypertension and dyslipidemia. But these are the ground realities as well. So high carbohydrate diet leading to high postprandial glucose levels, and then patients uncontrolled on multiple oral agents, because there is a huge barrier to initiating insulin, both at the physician level as well as the patient level. And then the lack of simple or convenient options. So let's see how we can work around this. But once again, to belabor on that point, that high carbohydrate diet is really a driver of a lot of our glycemic issues or uncontrolled diabetes in India, and it's a common ground reality. And you can see that Indians, the eating pattern has evolved so much over the last few decades, and everybody will agree with me on this, that we have moved from our traditional eating and physical activity levels to a more urbanized, to a more Western kind of living. And every survey or every study has really shown us that the energy content from carbohydrates in our diet is extremely high. Almost 60 to 70% of the total intake is coming from carbohydrates, which is not encouraging at all. Whether it's urban India, rural India, east, west, north, south, central, everywhere we go in India, definitely a very, very high carbohydrate intake has been noted. And the START study also said the same with respect to the different regional influence in terms of carbohydrate intake. Now, taking you back to this classic graph or classic inference from the Monnier study, where, in the Caucasian population, we thought that there was higher contribution of PPG at lower HbA1c levels. And the same thing we see in the Asian population also. But we cannot simply ignore the postprandial glycemic contribution or influence in the total HbA1c that we see at the end of every 3 months, because even at the higher tertiles or higher quintiles of HbA1c groups, that means even in uncontrolled diabetes, there is a significant factor contributed from the postprandial glucose excursions. And so across the HbA1c quintiles, whether it's well-controlled patients at less than 5.7 to 7.1% HbA1c, or the highest group of 8.8 to 12.7% that was studied in this exercise, we find that postprandial glycemia remains an important concern. So can we take care of it with basal insulin? Because today guidelines, and yes, even the RSSDI and IDF guidelines do say that yes, there is a place for premix insulins, but we do want to initiate with basal insulin. So I'm not getting into that because that's not the objective of this talk. But initiating with basal insulin, does that serve for total control? If you see here, well, only 39.6% of the patients, Asian patients, are able to achieve their HbA1c target of less than 7% with basal insulin. However, in the non-Asian patients, it's a 47% that is able to reach, but with basal insulin. The point being that we are still not able to get more and more patients despite initiating insulin. So yes, basal insulin, is it suitable in case of high carb diet? Well, not so much. Does it offer direct control of postprandial glycemia? Well, again, not as much, but definitely lowering fasting plasma glucose helps. And is it suitable in case of delayed insulin therapy? Well, no, because we would have to intensify almost at the beginning itself. And does it offer convenience of insulin initiation with direct total control? Again, the answer is no. So with all these limitations of basal insulin, do we have any solutions for the same? And we seem to have a total control solution of 2-in-1, and let's look at that. So Idegas or Rhizodec, as the product is, it's a co-formulation, and the first one, which is it's a soluble co-formulation of short-acting as well as long-acting insulins, and truly an innovative product right from the time it was introduced to all of us. And this is the pharmacodynamic response curve and it's expressed as the glucose infusion rate. And you can see that as opposed to a pure basal insulin, you can see a very rapid onset of action right here. And there is a distinct peak. I won't call it a very sharp peak, but it's definitely a distinct peak, allowing for that postprandial glycemic control. And this comes from the aspart part of the Idegas. And then followed by a stable, more flatter curve of insulin action, which also lowers, which is responsible for lowering glycemia throughout the day. And this is the insulin degludec component, which keeps it at a stable level. So this, based on these pharmacodynamic responses of Idegas, it makes, and let's see how it can offer a 2-in-1 total control solution for our Indian patients. Now, well, as far as the clinical development program goes, this is the phase. This is just a visual summary of phase 3A and 3B programs. It's gone through intensive evaluation in different permutations and combinations of patient populations, duration of study, ethnic backgrounds, as well as starting it once a day or comparing it with the insulin glargine, or just with prandial insulin, or with another basal insulin, or with basal bolus therapies and whatnot. So it has been intensively studied, and now we have, before it got approved as for use in the clinic. And what do our guidelines world over say? Well, everybody endorses it. And also the RSSDI ESI clinical practice recommendations 2020 also endorse the use of once daily Idegas as a recommended choice of insulin initiation. Well, they also remind us that we need to avoid using insulin as a threat and definitely alleviate patient anxiety about insulin. And these are some of the key barriers to initiating insulin in the first place. So we need to work around them. And they also remind us that insulin therapy should be considered in all patients failing to achieve glycemic targets on 3 oral agents at least. Now, this is, I'm just going to go over some of the trials, important trials, and some important conclusions from them. So insulin initiation, this was evaluated in a 26-week open label trial in around 300 type 2 diabetes patients in Japan who were insulin naive, and they were randomized to receive either idagasp once daily or insulin glargine U100 once daily over and above the 2 or more OADs that were ongoing. And in these patients, what did we find? And this was, the study duration was 26 weeks. And at the end of 26 weeks, in the first left top graph, you can see that the HbA1c reduction was clearly better in the idagasp arm. Although the starting point was fairly similar, but this was a significant difference between the idagasp and the insulin glargine arm. So although it was minimal, it was significant difference in HbA1c lowering. As far as the fasting plasma glucose goes, well, the control was similar, or the lowering in fasting plasma glucose achieved at the end of the trial of 26 weeks. It was similar in both the arms and not any different. As far as the risk of hypoglycemia goes, well, there was a 27% reduction in confirmed hypoglycemic events in the idagasp arm as compared to insulin glargine. But the interesting phenomenon, this is the crux of using a co-formulation in our Indian patients, is the 9-point SMBG results. And that's displayed here in the left lower graph. And you can see that almost every, at the beginning of the study and at the end, the two arms behaved slightly differently. And at the end of the study, you can see that there is a difference in the post-meal rises with idagasp as compared to insulin glargine. And it's much lower. So the postprandial glucose is much lower in the idagasp arm as compared to insulin glargine. So this is an important, this is the proof of the matter, because this is why we want to use the co-formulation in our Asian patients, and this was proven in this study itself. Well, another study that looked at comparing idagasp versus the basal bolus therapy, because we know that probably basal bolus is the most efficient way of is probably one of the most efficient ways of controlling, or flexible ways of controlling glycemia in our patients. But again, it comes with a cost, it comes with a little bit of inconvenience, and it can be quite intensive. So patients with type 2 diabetes, around 532 patients were in this study, and they were, if they were uncontrolled on basal insulin, they were randomized into receiving idagasp once daily plus the oral agents, or they were randomized to receive insulin glargine, which was already going on, plus insulin aspart once daily, plus the oral agents going on. And the second, and this continued for a period of 26 weeks, and in the remaining 12 weeks till the end of 38-week period, they were intensified further, where idagasp was given either the dose was increased once daily, or it was even given twice daily in that arm. And the insulin glargine arm, the prandial insulins were increased from once daily to twice daily, or even thrice daily. And what did we find here? Well, in terms of HbA1c reduction, there was a 1.1% reduction in both arms. So HbA1c was similar, but the insulin requirement with idagasp was 12%, or significantly lesser with respect to idagasp as opposed to basal bolus therapy. In terms of nocturnal hypoglycemia, as you can see, there is a reduction of 45% with the use of idagasp. And of course, the power of a single solution, reduction in the number of insulin injections per day, 2 versus 1. So this was considered as an convenient options for patients who had no choice but to be on basal bolus therapy, even with type 2 diabetes. With that, I change gears and I'm just going to quickly go over the ARISE or the real world evidence study. It was a multi-center prospective non-interventional study investigating the clinical effectiveness of idagasp in those with type 2 diabetes in a real world setting. And ARISE was nothing but a rhizodec initiation and switch effectiveness study. And here is the study outline. So approximately 1,100 type 2 diabetes patients were either initiated or on idagasp or switched from other regimens to idagasp, and that was as per local practice. Countries participating were Malaysia, India, Saudi Arabia, Philippines, Australia, and South Africa. It was a non-interventional, multicentric, prospective primary data collection study, and the visit frequency was according to the local standard of care. All patients were adult type 2 diabetes patients diagnosed and treated with anti-hyperglycemic treatment other than idagasp, and the available HbA1c value was within the 12 weeks of study participation. So you can see, again, this was a 36-week study. And overall, and these are the global results, overall the entire study, they found that initiation with or switch to idagasp in the global cohort led to an HbA1c, a significant reduction in HbA1c at the end of the study duration of 1.4%. 49 milligram per DL lowering in fasting plasma glucose was also observed, which was statistically significant. In terms of hypoglycemia, there was significantly lower risk of hypoglycemic occurrence of lower hypoglycemic events. And in terms of resource utilization, so we are also looking at pharmacoeconomics as we are building our clinical study designs. And here they found that the outpatient visits were reduced by 61%. And what a boon this would have been in the COVID times. Again, the self-reported work days missed by the patients were less by 90%. I think these are important allied benefits, which we probably did not quantify in the previous times, but they are important pharmacoeconomic parameters to look at. As far as the Indian cohort goes, and that had a total of 185 patients, mean age of 58, more males than females, and body weight average was 70.8 kilograms, and a mean duration of diabetes 14 years, BMI 26.5, high fasting plasma glucose of 190 at baseline, and a high HbA1c of 9.8%. The reasons for switching were primarily to improve the glycemic control of the patient. And the other important benefits were looked at as fewer injections with idagasp as compared to basal bolus, flexibility in the dosing regimen, lowering the risk of hypoglycemia, and of course the fact that there was no reconstitution required, even though this was a co-formulation. It's a ready soluble injectable that we have today. 81 subjects out of the 185 were given idagasp once daily, and 104 received it twice daily. Now, if we compare the mean baseline HbA1c in the global cohort, it was 9.7. The Indian average was slightly higher at 9.8. But at the end of study, HbA1c was 8.3 and 8.2 in the Indian cohort. The mean change is definitely better in the Indian cohort, slightly better as compared to the global cohort. Again, as compared to, based on the baseline treatment ongoing, the patients fared the best in the basal only arm, or those who were on basal insulin. Well, they had the maximum response to idagasp, because suddenly now the postprandial glucose was also coming under better control. In terms of fasting plasma glucose, there's not much change in or difference between the global results as well as the Indian results. And in terms of hypoglycemic episodes, number of participants experiencing more than one hypoglycemic episode was significantly reduced, not only in the global cohort, but also specifically in the Indian one as well. And non-severe hypoglycemia as well as severe hypoglycemic episodes. And same is the case with the number of hypoglycemic episodes. That was the percentage of participants. And here is the number of non-severe and severe hypoglycemic episodes. They were also considerably or significantly reduced with idagasp as compared to other therapy. In terms of resource utilization and its outcomes, like I already told you, 61% reduction in the self-reported outpatient visits and 90% reduction in the work days missed. I think that's a significant achievement with using this co-formulation. And in ARISE, initiation or switch to idagasp led to a significant decrease in HbA1c and fasting plasma glucose, and also lower hypoglycemic events and lower resource utilization. So again, simplifying the therapy for our Indian patients, we can initiate with 10 units of idagasp once daily with the most carbohydrate heavy meal of the day as discerned by the physician in consultation with the patient. And for titration, there's a simple algorithm. If fasting plasma glucose is above target, then increase by 2. If it's at target, then maintain the dose. And if below, subtract 2 units from your total dose. But if you're using idagasp once daily, we know the titration based on fasting plasma glucose levels. If it's twice a day, then if you're using it at pre-breakfast, pre-lunch, and then dinner, then use the pre-dinner meal, the pre-dinner readings to titrate or modify the dose of idagasp given in the morning. And pre-dinner, if you're using it, that again will depend on the fasting plasma glucose or pre-breakfast readings itself. So with that, we also have very convenient devices to inject: FlexTouch disposable insulin pen, and then NoPen 4, which is a durable insulin pen. So with that, to summarize, idagasp, well, it's very suitable for high carb diet in India that we have seen. It offers total control, not just the fasting plasma glucose and HbA1c, but importantly, postprandial glycemia, which is an important contributor of uncontrolled diabetes in Asian countries, particularly India. It is also a very suitable option in case of delayed insulin therapy and offers a very simple and convenient option to our patients. With that, I thank you all for your patient hearing, and a big thank you to the Neglur team, respectable Neglur team, for involving me with this great initiative. Thank you so much.
Thank you very much, Purvi. Indeed, a very, very wonderful overview of the insulin whole agenda. And now, due to constraints of time, we will not be taking any questions, but we move forward to the next session. I thank all the chairpersons, Lily ma'am, Pratiksha, Ami, as well as the speakers, Dr. Dharini Krishnan sir. Thank you for making this session a truly memorable one. Thank you very much. We now move on to the next session, and to the session is technology. And I invite Ms. Shilpa Joshi. Shilpa Joshi ma'am needs no introduction. She is she's very well known all across the country. She's the director of Mumbai Dietetic and Health Center. She's a vice president of Indian Dietetic Association. She is an absolute sweetheart of a person, and I welcome her. She's also the scientific co-chairperson for Wodcon. Dr. Tejal Lathia is a consultant endocrinologist at Apollo Fortis Hospital, Navi Mumbai, and she is also a very dynamic speaker, and we'll be hearing her very soon. The third chairperson is me, and I now invite Shilpa ma'am to please conduct the session further. Ma'am, you're on mute, ma'am.
Good evening, everybody. For the next session, I would like to invite Dr. Jyotidev Kesavdev. Dr. Jyotidev Kesavdev is the chairman of Jyotidev's Diabetes and Research Center at Trivandrum, Kochi, and Attingel. He's editor-in-chief of International Journal of Diabetes and Technology, and he's the first author of Indian guidelines on vaccination, insulin pumps, and glucose monitoring. I invite Dr. Jyoti Dev to speak on new age insulin pumps, the reality of the closed loop.
New age.
Alex.
Thank you very much for those nice words of introduction. Thank you very much, Vijay Neglu sir and madam, for giving me this opportunity, for inviting me for this theme event. I am very much privileged. I know that only very few men are invited, and I am one among them. Thank you very much. So let me start sharing the screen. So I am given the task of discussing new age insulin pumps. And I'll be, of course, going through the history and discussing where we are exactly positioned right now and the future. So these are my disclosures. This is a news which has appeared very recently based on our publication. Women-centric approach. Yes, women-centric approach need to be encouraged for more efficient management of diabetes. And this aligns with the theme of the event. And this is irrespective of the type of diabetes. Yes, this has been the dream. This has been the dream ever since insulin has been discovered and executed for the management of diabetes. The parents were asking, the patients with diabetes, they were asking us, hey doctor, when will this delivery of insulin be fully automated? We didn't have an answer. We didn't have an answer for many decades, but currently we do have an answer. We are almost successful. We are successful in automating the delivery up to 80%. And the patients were obviously frustrated waiting for 100 years. And many patients in the last 5 to 6 years, they started creating their own algorithms. They started re-engineering the existing pumps. And this has been the we are not waiting movement all over the world. And in India, this is a celebrity. Again, the woman representing the first DIY artificial pancreas from India. And this has been a recent publication from Jaz Sethi, the celebrity dancer and the founder of Diabetes, known to everyone. Every diabetologist, physician, and endocrinologist knows him. And now even all the patients with type 1 diabetes are familiar with his name. And in this narrative, let me read out. I feel like I don't have to be obsessed with my disease. And this is a genuine feeling of relief and satisfaction. I sometimes even forget the fact that I have type 1 diabetes, and this is demonstrated. Look at the graph over there. This is before looping, when it is going up and down all the time with hypos and hyper. And this she is describing in detail in the narrative. And this is after the looping, when the glucose dynamics is looking like a flat line. Amazing, really exciting innovation. And she's using this with Omnipod and Dexcom, and this is a Riley link. And we tried to publish, I still remember when we were approaching the journals, many journals actually were not willing to publish this along with the patient, and that too DIY, because DIY is not approved. You eat yourself artificial pancreas. These are now used by more than 1,000 patients across the globe, not USFDA approved, not approved by any scientific organizations, but still, it has been a stupendous success of reaching more than, it is unbelievable, in many patients, more than 95 to 99% in range, and that you consistently. So we cannot ignore it. We cannot ignore it. And that is one of the reasons why this is the ADA and the EASD, a consensus report referring to our own publication from India. Yes, the scientific publications on technologies from India are also getting acknowledged by the international scientific community. So how can you create an artificial pancreas? How can you successfully close the loop? Of course, the recent terminology is AID, which stands for Automated Insulin Delivery Systems. You need a really faster acting insulin, faster than probably the currently available insulins. You need better reliable sensors. Of course, some of the sensors are now reliable, and you may probably need to consider hormones such as glucagon or pramlintide along with the insulin in the pump. But the component which is most essential and which is a deciding factor to decide on the success on the time in range and to eliminate the time below range will be the algorithm. Very, very confusing, sophisticated algorithms. This is JDR of long ago. This has been a publication long ago, and that has been a prediction at those times. The stages of automation in insulin pumps, starting with the first generation and then second, and the future will be the third gen automation. So the first gen, this is representing the VO insulin pump, which we started using in India in 2012. That is when the insulin, when the glucose is very low, when there is a hypo, the insulin delivery will stop. And that is threshold suspend mechanism. And then you have the hypoglycemia minimizer, the hypoglycemia minimizer. So this is representing 640G from Medtronic, which has been the most popular AID in India for more than 6 years. And this is how insulin will stop before the onset of an actual hypoglycemia. So these are the predictive systems. It will predict a low glucose at least 30 minutes ahead of time, and then it will stop the delivery of insulin. And then came the stage 4 of automation, that is the hybrid closed loop systems, where the basal is automated and you have the announced meals. So how will you define the stage 5 of automation? Because that is a dream, the fully closed loop systems. And that is when the meal, even the meal will be recognized by the system. You probably need to take a picture of your meal, and the system or your smartphone will recognize the carb, the fat, the protein content, and it will automatically count, and then it will deliver the bolus. The stage 6 of automation, I'm not sure whether it is required or not, whether it is really required or not, and that is when you'll be using multiple hormones in your pump. And this is how it has advanced. This is how the TIR has advanced. Earlier, it was only the hemoglobin A1C, but now we are more and more relying on the time in range. Since in the automated delivery systems, the overall objective is to expand the TIR and to minimize the time below range, especially during the nocturnal hours. And this has been phenomenal, starting from the threshold suspend, that is the LGS, low glucose suspend, to PLGS, HCL, to the most recent advanced hybrid closed loop systems, that is the AHCL. Yes, the pillar of support and success is the algorithm. And these algorithms can be the proportional integral derivative or the model predictive control or the fuzzy logic knowledge-based systems. And the third one, they're really very expensive. So how can you modulate, or how can you create a multi-variable AP? So just assume we are having an Apple Watch, and these are examples of a wearable sensor where we can not only sense exercise, but also can determine the type and intensity of a physical activity. You can detect the acute stress. You can detect a high heart rate or a low heart rate. You can determine not only the duration of the sleep, but also the time spent in deep sleep versus light sleep. So all the data can be gathered and provided to the control system to automate the delivery of it, along with, of course, the essential component. The most essential component will be definitely the continuous glucose monitoring systems. So this is a meta-analysis on whether you really require dual hormone systems or not. And this is a publication from Ahmed et al. He has compared, this is in a randomized crossover trial, the dual hormone with insulin and glucagon, the conventional insulin pump, and the third, the first one is single hormone, only with insulin. The second one is dual hormone. The third one is conventional insulin pump. So this has been the time in range, 62% with single hormone, 63% with dual hormone, and 51% with the conventional insulin. So obviously, dual hormones and single hormone is providing almost the same DIR in most of these studies. And even for a trouble-free or a hypoglycemia-free overnight sleep, the study has found that single hormone devices are sufficient. Probably it is also convenient, comfortable, and cost-effective. But still, there are multiple clinical trials where the bihormonal devices are also being even now tested. I will briefly go through them. So how do you compare a fully automated and hybrid closed-loop systems? Because even though you are having a completely closed-loop algorithm, still in the commercial market, we are only having either a hybrid or an advanced hybrid closed-loop system. The reason being, there is a delay in the absorption of the currently available faster acting or a ultra rapid acting insulin. Number two is a lag time in the sensors. The interstitial glucose versus the blood glucose or the capillary glucose variant. Because of these, even though you are using advanced systems, algorithms, it can result in a significant postprandial hypoglycemia and a late postprandial hypoglycemia. And that is why you are successful in reaching only 75 or 80% TIR. But remember, that TIR is exceeding the minimal recommended by the international scientific organizations of more than 70% TIR between 70 and 180 milligrams per deciliter. So these are the three popular advanced hybrid closed-loop systems globally available, of which only the Minimed 780G is available in India. So I will briefly go through in detail, of course, briefly in detail on 780G. So what is special about 780G? 780G has been launched in India in the January of 2022, and that is early this year. This is a system, the stage 4 of automation, which is capable of automatically changing the basal delivery of insulin once in every 5 minutes. So once in every 5 minutes, the basal delivery keeps on changing. And the bolus is also automated. So if in case the algorithm decides that a bolus need to be delivered, it is also capable of delivering a bolus up to every 5 minutes. And this is a comparison of HCl with sensor augmented pump PLGS, a TIR of 67.3 with PLGS versus 79.6 with 780G. And this is a snapshot from our own patient using an algorithm. So this is a 780G patient and we are remotely monitoring this patient. And look at the data. During the night when the patient is sleeping, it is automatically delivering the correction boluses, 0.2 units or 0.1 units. And on the right, you have the data on the time in range. At the click of a button in my mobile phone, I can remotely monitor the TIR, and that is phenomenal. And this shows the real advancement in technology. 99% TIR in a person with type 1 diabetes with the use of 780G with an advanced hybrid closed-loop algorithm. And this is basal IQ, of course, not available in India with a PLGS, and this is a T-Slim insulin pump, which is similar to the 640G in India. And this is a recent FDA approval of a T-Connect mobile app, which can be used along with the T-Slim X2 insulin pump. So it has got the ability to program or even cancel a bolus dose of an insulin from the convenience of your mobile phone. So everything is becoming not only automated, but all these remote monitoring and also delivering insulin. All these possibilities are going to be there with the mobile phone app. Not available in our country, another one, the patch pump from Omnipod. And this is the Omnipod 5 automated insulin delivery system, and that too, along with the Dexcom sensor. This is G5. And we are expecting the arrival of Accu-Check Solo micro pump in India very, very soon. And this is a long awaited launch in India of the first ever patch pump in our country. completely tubeless delivery, no strings attached. And it is expected that this will be connected with a sensor so that it can be automated. And this is a Netherlands discovery, the Intrida bihormonal pump tested in type 1 diabetes, 86.6% time in the closed loop at the bottom compared to 53.9 when it is in the manual mode. So when you're using two hormones, probably you are reaching a higher time in range in some of these studies. And the glucagon has always been a challenge to be used in these systems. And this is a study comparing desiglucagon with a freshly reconstituted human glucagon, and the mean TTD is almost the same. That means this innovation is successful with the use of desiglucagon. And this is Damiano, the original islet, comparing the two systems, insulin only with bihormonal, glucagon and insulin. 72% time in range with insulin only versus 79. So it is almost reaching 80 to 89% when you're using dual hormones. But another major change or another step ahead in technology, the Rocket AP automated algorithm. And this is tested with T-slim insulin pump. And that is when you are not announcing the meal. You are not announcing the meal. So the meals are not being announced and you are not delivering the bolus, and the system is recognizing the meal and quickly delivering a bolus insulin. And this is a TAR for the unannounced meals, 83% versus 53% when it is in the control IQ algorithm. How can I forget? How can I forget the Dana insulin pump? So Dana insulin pump historically has been the first insulin pump even before Medtronic launched Minimed in the United States. And this has been from South Korea, still very active with automated insulin delivery systems. And this is a recent study published in New England Journal of Medicine in 2022. And that is with CAM-APS FXAP. That is a closed-loop AAD algorithm. And this is also along with Dexcom G6 sensor. So Dexcom has been probably the most successful and reliable sensor been used with almost all these clinical trials with multiple insulin pumps. Eversense has been the only available implantable sensor, and this is the E3, the generation 3, with the longest life, almost up to 6 months. So one sensor which can last for all the seasons. And this is a recent FDA approval, and it requires a finger. So that is one challenge. This one requires a finger stick calibration. I would request all of you to go through this exhaustive review published from our center. And this is on do-it-yourself artificial pancreas. Why is it important? Look at this reference, and this is from the recent 2022 American Diabetes Association Clinical Practice Guidelines. And they were also referred to this original study from India. The reason being, there are thousands and thousands of patients currently adopting the do-it-yourself artificial pancreas. Since these are highly successful experiments, we cannot discourage them from using it. But you probably need to troubleshoot when there is an emergency. So a basic understanding of DIY, the open algorithms, the Android APS, the loop that is with Apple devices, all these are absolutely essential for every doctor practicing diabetes. And how do you justify the extra cost of all these new technologies? Of course, the DIY is relatively inexpensive but not approved by the current agencies, including the DCGI in India. It is not approved anywhere in the world. But how do you justify for the extra cost of these technologies? This is the estimated annual resource use and the cost of Minimed, approximately $8016. And this is for the conventional insulin pump or for the multiple daily injections used with intermittently scanned CGM, that is a flash glucose monitor, $3176. However, the higher treatment cost with Minimed 780G was partially offset by cost savings because it could avoid the diabetes-related complications and avoidance of lost workplace productivity. And this is the incremental gain of 1.95 quality adjusted life years with 780G compared to the conventional modalities of treating type 1 diabetes. Yes, of course, I am coming to the conclusion of my lecture. Yes, treating diabetes in women, it is different and it is difficult. You need to focus and you need to empower women with diabetes. And you need to have women-centric approach, which should be encouraged in every stage and in every type of diabetes. And I would like to conclude with this statement. Even if your patient is unaffordable, if the patient is eligible, always initiate a conversation on the use of technologies. Never ever deny the benefits of these technologies to those patients who are eligible and, of course, affordable, not only for the upfront cost. Remember, technology comes with a cost, including for the accessories. And this is a reminder for all of you to submit your original publications. And this is International Journal of Diabetes and Technologies, published by Walter Kluivers, to encourage original research in diabetes from our own country. Thank you. Thank you very much, my dear friends, for your patient hearing and for this opportunity.
Thank you very much. I now invite the next speaker. Chair, will you please do the honors? Dr. Tejal. Dr. Tejal. I don't think she's here. I have the privilege of introducing the next speaker, Dr. Manoj Chawla. He is a director and consultant diabetologist at Leena Diabetes Care Center in Mumbai. He is a consultant diabetologist at Raheja as well as the BSES Municipal General Hospital. He's been the organizing secretary of Diabetes India in 2022. He is an honorary visiting faculty at many places, has been awarded the RSSDI Fellowship for the year 2017 and Fellowship of Royal College of Physicians of Edinburgh in 2019. He's been a principal investigator for many trials and has been a technological task force member of RSSDI. He has many papers to his name and credit, and he is an associated author for the International Journal of Diabetes in Developing Country. Welcome, Dr. Manoj.
Thank you, Shefali, and evening, everyone. Let me start by sharing the screen. It's always a tough ask to speak after Jyoti, kind of work and the body of work that he has in technology. It's always inspiring. The task given to me today is to speak on the green and red flags in CGMs. Hopefully, yes. Is it seen in the full screen mode? Okay, great. So yes. Let me just start with a brief introduction on what is CGM. And by now we believe CGM, everyone is well versed that it's a method to track glucose levels through the day. Important for us to understand that during the CGM, it measures the interstitial fluid glucose and not the plasma glucose. And as you heard in Jyoti's conversation as well, that there will be a lag period which may differ based on the technology that we are using. Why do a CGM? Well, CGM provides visual feedback to help patients and clinicians understand the glucose variability better. We understand that patients having the same A1C could be having a completely different glucose profile. Especially beneficial for people who are not meeting their A1C goal, having frequent lows or suspected lows, want to reduce their A1C and get into the target without increasing the time below range or hypoglycemia, have widely variable blood sugar levels. What we in the past used to call as brittle diabetes, today we understand can be managed better with just seeing the profile. And of course, children and adolescents who are willing to use this device every day with or without the use of insulin pumps. Important here again to remember the provider's role in facilitating the CGM use. Now, we all have started advising and are using CGM, but we need to understand that it's our role to provide education to the user about what is CGM. The way you talk today about structured SMBG, and there is going to be this wonderful talk following mine on SMBG. The same way we need to understand about explaining patients about interpreting the data from CGM. So our role is to provide education, explain the accuracy or where the accuracy may be lacking, helping the patients analyze and interpret the data, and of course, guiding today on the selection of which CGM system. So our market is opening up as well. We have a few players and many more going to be entering in our field. What are the types of CGM? Well, basically the CGM is going to be two types, which is professional or largely blinded or retrospective CGM, which involves wearing the device provided by the healthcare provider. This may be for a week or maximum 2 weeks as of now. Patients return the equipment to the clinic and the data is downloaded and analyzed. And a personal real-time CGM, which is used by the patients themselves. This is something that we teach the patients to put it on themselves, see the sugar values, the movement throughout the day, regularly on either the reader or the smartphone apps as they are available. Further elaborate, professional CGM can be beneficial for patients who do not wish to pursue or who do not qualify. The professional CGM is for those who do not qualify for personal CGM. It allows the healthcare provider to obtain unbiased glucose patterns during typical everyday life. Professional CGM may be of benefit in adults with diabetes to detect nocturnal hypo, dawn phenomenon, the postprandial hyperglycemia, something which may be missed in your regular minimal SMBG testing. Professional CGM can also be useful as a teaching tool or for patients who are starting the journey as a person with diabetes or pre-diabetes to understand the various aspects of diet and lifestyle. And the professional CGM can be blinded or unblinded as well. It used to be only blinded, but today you have certain apps which allows them to see the data unblinded on the professional CGM as well. The personal CGM, on the other hand, are recommended for appropriate patients with type 1 or type 2 diabetes who are treated with intensive insulin therapy, not achieving glucose targets or experiencing problematic hypoglycemia. And also, this is for patients with pregnancy and diabetes today. The personal CGM systems are also available of two types. They may be the intermittently scanned systems or the genuine real-time CGM systems. The intermittent scanned CGM devices require the patients to scan their sensors to obtain the data. Personal real-time CGM devices continuously transmit the glucose data, and as we can see, there can be different ones, the Dexcoms, the Medtronics, and the Glunovos, which are again now available and launched in India. Most of these devices allow the users to share their data remotely with family members, caregivers, and clinicians as well as. And Jyoti was talking about how he can see the data for his patients on the 780 pump on the app on his phone as well. Two major differences between the real-time or the personal usage and the professional. In the real-time, it informs instant blood glucose reading and therefore can show the blood sugar readings up till about 350 and below 750. Loses out on data if not scanned for more than 8 hours. So most of the intermittent scanned ones, they require the scanning to be done, otherwise you lose the data. In the professional CGM systems, you need to, you don't see the data ideally throughout unless you're using one of these unvalidated apps. So you wait for 14 days or 7 days, depending on the service that you use, to see the profile, to see the trends, and then make changes. It doesn't help, doesn't give us the readings really above 350 or below 70, unlike the real time, which gives the complete data. The data is retained in the professional. It doesn't require you to scan. You do not lose the data usually. Now, some more green flags towards the CGM benefits. Well, it's more insight than just monitoring alone. Far more data than you can get through a glucose meter or an SMBG reading. It leads to more improved glycemic control. Gives continuous feedback on diet, exercise, insulin requirements. It helps the patient take those decisions, avoid severe hypers and hypos, and then leads to a tighter control. Fast proactive response. So the CGM systems take glucose readings every few minutes and allows you to set customizable thresholds and gives you alerts in terms of directions of how rapidly it's moving in either of the directions, up or down. Further benefits of a CGM, well, fewer finger sticks. So clearly, most of the newer CGM systems do not require calibration, and that's the larger benefit. And it should stick to that. It doesn't require the calibration, and hence leads to fewer finger sticks and fewer worries about the same. However, let's also understand some of the limitations here for the CGM devices. Sensor glucose reading and blood sugar readings may vary up to 20%. So there may be a difference up to that high tune. The CGM devices need calibration a minimum of twice a day to check the accuracy of your CGM using a standard blood glucose meter. And this I'm talking about the CGM devices and not the flash glucose monitoring, which is non-calibrated as of now. There could be interferences in the glucose readings. Various substances, including your high use of ascorbic acid, etc., can cause disturbances in these glucose values. The lag time may be up to 15 minutes, especially soon after meals when the glucose is changing rapidly. And of course, CGM is currently more expensive than the use of a glucose meter. Well, this is an overview of various CGM studies, a meta-analysis of multiple studies done, and they are in different population. Some of them have comparators against SMBG, some are randomized clinical trials, some are real-world studies and done in both type 2 and type 1 diabetes population, showing in most of the studies the impact on reduction in HbA1c by the use of CGM and also reduction of time spent in hypoglycemia, and most users talking about treatment satisfaction and leading to lesser hospitalization in our patients by use of CGM. Now, there can be a problem with the CGM data. And when we talk about limitations of this technology, let's understand that very often if you just download the data, you may see data in this format, which may be very confusing. How do you make sense of all this data that you may download? Continuous glucose data readings in the past could also be complex. Each color here denotes a different day. And when you see a data which is all over the place, you really don't know how to guide your patients about therapeutic interventions or lifestyle changes because it's all over the place. And which is where comes in the role of the AGP and the better understanding of this data. There are three important aspects to understand the CGM data. One is the kind of exposure that you're seeing in the data that you download. The variability, which speaks about the between day change, that is day-to-day change, day-to-day variability. And finally, the stability, which is more of the intraday movement. So three principles of interpreting the AGP and the CGM data, which allows you to individualize the therapy for the patients. Now, these are some of the observations that we've had from our own use of this technology. What really have we seen when we talk about the green flags? What are the green and red flags? Let's understand. So some of the green flags that I want to point out, the blood sugar data which is obtained during the period of sensor life does give a good insight to the patient on its lifestyle and choices of diet, exercise. The real-time data and the graphical trend of the sugar readings help in deciding the current and further treatment. Patients who use it find it very useful as they're able to understand the blood sugar movement and behavior after every event. So when they're especially using real-time CGM, the impact of meal, exercise, insulin delivery, they can very well appreciate the change in the sugar. Also, the patients are able to detect asymptomatic and nocturnal hypoglycemia, which was missed earlier in the infrequent SMBG reading. The notification alert helps to take action when sugar is going too high or too low. So some of these CGM devices clearly give you the direction and how rapidly things are changing. Patients who are not capable, you'll always have some patients who just refuse to do SMBG, are petrified of finger pricking and cannot and do not monitor at all. For them, again, CGMs are a boon. The pumps as well, as the previous talk clearly showed about, the artificial pancreatic systems are on the basis of pump used in accordance with the CGMs, which allows the sugars to be managed or the boluses and basals to be automated with the current algorithms. So let's also understand the red flags of the CGMs. Some of the CGM devices still need some finger pricks and calibration, and I think that's a big limitation today. In today's times, to still have calibration for devices is a big no-no. We have to move to devices which do not require finger prick calibration. The fact that all these sensors need to be attached to the body, well, you still have a lot of people who are extremely uncomfortable with that, do land up problems with skin irritation and sometimes the adhesive failure and the sensor coming off. Well, there are many patients where the sensors just do not have the data recorded even after it has shown activation, and we still don't know the reasons why. Every now and then you will have patients who come back downloading their data. This, of course, is for the professional CGM who just do not have any data recorded. Sometimes there is blood oozing or pain at the site of sensor insertion. And there is a warm-up time required when you initiate these, and very often that is 60 minutes or longer. So what have we really observed in our regular usage? Well, these are some of the problems that some of you may also have seen. That patient comes back, and as I said, it's frustrating because they put it on for 14 days and it comes back and it shows that the data was just not recorded. Now, of course, this is for the professional CGM because they don't get to see the data while they are using it. And then some of the reactions at the site, which patients may experience. And then again, this is for the personal CGM or the real-time CGM with the freestyle Libre. The reader is just not showing the data, even though everything in terms of sensor insertion seemed right. Here again, there is an example where the sensor is attached. Typically, it says to scan again after 2 minutes and confirm that the sensors come on. Of late, we've been observing a lot of times when it is asking us to wait for longer, 7 minutes to reassess. And at the end of that, again, we're seeing that the sensor was unable to record the glucose data. So these are some of the red flags with the current technologies that in spite of best efforts, we are not picking up the data and you have a sensor failure coming up. Quickly, let me take you through some of the cases where the usage clearly shows the advantages and some places where we need to be cautious in interpreting the data. So a 56-year-old male, HbA1c 7.6 on oral medications as well as BX insulin 20 units. Well, complaints of some occasional lows in the morning, has seen one reading which was 68, but the HbA1c constantly remains high and wants to get the HbA1c under control. The typical fasting and postprandial that the patient has been seeing is 135, but yet the A1C is 7.6. So you do the CGM and you look at the data, and all these are recent studies from our clinic setup. And you'll be able to appreciate here that this individual, if you see the fasting that he's talking about is close to 100, the postprandial, if he has his meal around 2 o'clock, the postprandial is 130, 140. But this patient is getting into hypoglycemic range even before the lunch period and as well in the early mornings. So this is a patient whose hypoglycemia was not identified much. It's only on the basis of the CGM that you are able to identify, and the multiple red zones are all in the time below range or hypoglycemic range. So this is an example where CGMs are extremely helpful, and then the medication is changed accordingly. Our second case again is somebody, 53-year-old male, diabetes for 4 years, A1C 8.6%, so not a well-controlled person, sedentary lifestyle, sugars in the 180 range. Again, on oral medications, has felt low but no hypoglycemia documented, concerned that the HbA1c is high but yet feels low. So you do a CGM, and here again you're identifying. Of course, the estimated A1C or the GMI should not be given much importance because it only reflects what you're seeing in that 2-week period. But also, you'll be able to appreciate the hypoglycemia, which is again seen through the nocturnal period, as well as the drips in the evening for this patient, something which was not getting picked up in the fasting and post-lunch. It all showed it to be the 170, 180 level. And here you can pick up the multiple episodes of hypoglycemia. Based on that, you talk about reducing the medication or adjusting the dosage. My third case study is for a type 1 individual, a female of 12 years who's at HbA1c of 11.8%, high sugars. She's on basal bolus therapy, also talks about variable sugars, especially during the menses, things going all over the place. You subject her to an CGM. Now, this is a real-time CGM, and that's why I put it up here to appreciate what happens. Now, when you see the AGP in the real-time CGM, and it would all seem that the patient is constantly high. However, an important point for me to point out is when you look at the AGP, you will not be able to appreciate if the patient has had occasional episodes of hypoglycemia, and hence it's important to see the individual day readings as well. So when you go into a different graph and you see, you'll appreciate that this patient has had an hypoglycemia going up to almost 50, 55 at about 1 o'clock in the night on a particular day. There was one particular day. Most of the other times the patient has been high. Also important when you are doing now CGMs to look at the sensor data percentage of capture, how often the patient is scanning, all of that improves the accuracy of the data that you're seeing. You see the AGP for this individual and you see that her sugars are all over the place. You see here, and at the AGP, as I was saying, you will not appreciate any hypoglycemia. But when you look at the individual day data, then you pick up that, yes, this patient has had an hypoglycemia. Also, when you see in the real-time data, the individual readings, on that one particular day, you're actually able to see the numbers. Now, this is something that you can't see in a professional CGM. You will not be able to see just when you look at the AGP. And I'm showing these slides because the usage of CGM increasing, all of us need to go beyond just looking at the AGP and look at the individual reports which are generated to actually appreciate what is happening to the sugars and analyze these numbers and help the patient also understand this data better and make changes. And of course, on the basis of this, the treatment was again adjusted. Finally, one last interesting case of an individual at an A1C of 8.1, again, sugars in the 160, 150 range, a homemaker female. She's again on insulin once a day along with OHAs. She has a constant fear of going into hypoglycemia at night. Now, this is a type 2 patient on insulin and OHA who's using the real-time CGM. And what's been happening, and if you see her, she's scanning 43 times a day. So it becomes a device, a fun thing that they keep scanning. Sometimes they overreact to what they see. Now, what's happening here is this patient has not had an hypoglycemia, but because post-meal in the night, her sugars would be in the 160 range. A little time later, they find when they're scanning that the sugar's coming down to 111, 108, and the arrow shows going down. A lot of people using real-time CGM now to seeing that arrow go down, especially in the night to 100, 110, and the arrow down because it's come down after that late meal, they start eating something or they start feeding themselves because of the fear of hypoglycemia. They are not going into hypoglycemia. And that is what we need to reassure them, again, based on their medications, that low arrow is because it's post-meal and it's going to come down. They don't need to react. And this lady was just reacting to that and pushing her sugars up every night. And that is why she was landing up with an A1C of 7.6, but she had no hypoglycemia. Finally, let me conclude, as I pointed out, the red and green facts, that CGM is important. These are some of our work and presentation. This, of course, is the Indian CGM guidelines, where we spoke about the need for CGM in every individual with type 1 and selectively in type 2 as well. This is one of our earlier papers which we presented, which was about the advanced glycemic care approach by identifying the diurnal glycemic patterns and A1C factorization using flash glucose monitoring. This was one of the first papers after FGM, professional FGM was available in India. This is my first paper on CGM, where I looked at the pattern of loss of glycemic control in Indian type 2 diabetes patients, and our studies found out a pattern different from the earlier Monnier study about how Indian patients behave. And this, of course, was the IPRO2 study, which validated the use of CGM in Indian patients many years back, with multiple centers collaborating to present this data. With that, let me stop here and remind that CGM is a wonderful tool, but as our usage of CGM is increasing, we also need to know about the limitations of this technology, the red flags, and the need for better interpretation. With that, I thank you for inviting me to Wodcon and hand it back to the chairs.
Thank you so much, Dr. Manoj. It was indeed a very elaborate overview of CGM, and it has made really our life very simple.
I learned the term from Jyoti, brief but detailed.
All in the details. Okay, it's indeed my privilege, my honor to invite the next speaker, none other than Dr. Benny Neglur, ma'am. And I'm at a loss of words because I really do not know how to introduce this charming, beautiful young lady. She is she's been the beauty, the brains, the backbone behind Wodcon conference, conceptualizing Wodcon for the women, where the women matter. She is a director of Dr. Neglur's Diabetes and Thyroid Specialty Center, and diabetologist at Jupiter Center. She's a fellow of American College of Endocrinology, Diabetes India, American College of Physicians, and Indian College of Physicians. She's been a teaching faculty at various institutes. She's the founder, president, and executive committee member of Association of Diabetic Educators. She is an editor. She has she's an editor for Awakening Diabetes newsletter, which is for patient education. She's been an author of several chapters and reputed textbooks of medicine and diabetes, has been a speaker at various regional and national conferences, a scientific chairperson for RSSDI Maharashtra and MedInspire. And it is my privilege and my honor to invite the most dynamic, elegant, and vibrant woman of Wodcon team, Dr. Dharini Krishnan, ma'am. Over to you, ma'am.
Thank you so much, Shefali. You have really, I think, overestimated me. But anyway, thank you so much.
Absolute words.
We all echo that, ma'am.
Thank you. Thank you so much. Just take it. Yeah, so we go back to simplicity now. You have seen how technology has revolutionized diabetes care, and the maximum revolution or changes have occurred in the monitoring and also in the pumps in diabetes care. So I'm going back to our good old SMBG, but I will be talking on SMBG with technology. And when you connect the simple meter to an app, you get what is known as connected glucose monitoring. And I'm sure most of the patients know how to do SMBG, so they don't have to be taught. And we also know that tight glycemic control prevents the progression of diabetes and also the complications. We have seen that in the DCCT and the UK PDS. And SMBG is endorsed by all guidelines as a monitoring tool, which is mandatory to be done for the patient. And SMBG empowers the people with diabetes, educates them, helps them to understand their sugars, and also brings about a behavioral change. And that is important. The behavioral change will have a great impact on the quality of life and metabolic control. It also helps the doctor or the healthcare team to assess the glycemia and optimize therapy. Besides using technology, it will prevent hypoglycemia and prevent hospitalization and also healthcare costs. So most of the bodies recommend SMBG more than 3 times a day, but it doesn't happen. And you can see the state of SMBG in many parts of the world. They may have been told to do 3 times, 4 times, 7 times, as in case of pregnancy and type 1 diabetes, but they may not even do once a day. And even after doing that, you see patients coming to our consulting room and they just said, today's sugar is 200 and 1 week back it was 150 and 3 weeks ago it was 120. So you don't understand anything and you don't know how to help the patient. It's exactly like the figure on the right, on the left-hand side of the face, totally disconnected. But if you structure the readings as on the right-hand side, maybe it will help people with diabetes use that information from their monitoring in a more meaningful way and will also modify their behavior, enhance their ability to self-adjust therapy, and help them decide when to seek assistance. So we need to structure the SMBG, and this is just example of what we do in our practice. So all of you know this, whether you do daily or not, we have to have pre-meal and post-meal. But despite 40 years of SMBG, why are we not able to connect the dots? Patients ask, what is a finger stick? What do the numbers mean? What do I do with them? When do I check? So they're not able to connect that data that they get from the glucose monitors to solutions and to action where they can change their doses and bring about good glycemic control. So can technology do this? Yes. So we can connect the glucometer. This is a one-touch VarioFlex glucose monitor with the ColorSure technology. And you can see that if it is connected via Bluetooth to an app on any Android phone, the app can be downloaded from the App Store or also from the website. If you can pair the two, and it's very easy to pair the two, you just follow the steps and write the number of the glucose monitor, which is on the back side of the glucose monitor. Then you can get all your readings automatically on the app. So this is a one-touch VarioFlex meter with a one-touch reveal app. And the app will give you everything automatically. You just saw the CGMS that Dr. Chawla showed you. This will be like a CGMS, and that too done automatically. The only difference is that you have to monitor. You have to do the finger prick and then get the reading on the glucose monitor. And this can be also shown to the healthcare practitioner who will have that Reveal app with him. And then he will recognize the pattern that is shown here, make specific changes, call up the patient and tell them how to monitor, how to make changes in their sugar. So it becomes like a closed loop. You heard of closed loop in the pumps, but this is a closed loop which is very, very simple and efficient. Even people who are not techno-savvy like myself can understand this. And I like what Dr. Jyoti Dev said. We should offer technology to the patient. Most of the time, we are not offering that to the patient. And if you offer technology to the patient, it can make a great change in diabetes practice. So these connected blood glucose monitoring tools, the glucometer and the app, can also be used for remote monitoring. So if the patient is outside India or outside the state or is not able to come for the clinic visits, he can just connect with the doctor. The doctor sees the app on his computer and he can make the changes and the patient can be controlled very well. That can happen also in the consulting room, as you can see here. Before the patient visits the doctor, he actually sees the app readings, and it is so well shown here with my arrow here. I'm seeing all the three colors. And then once the patient comes inside the consulting room, the healthcare practitioner can discuss, make changes, and make treatment recommendations, which gives optimum glycemic control. And here we can see it can be done online as well. And during the COVID era, all of us learned how to do online consultations. And this was very, very useful to bring about a glycemic control in the patient. And also in between the visits, the healthcare practitioner can look at the readings in his app and also use that data for many purposes, which I will just inform you. And even the healthcare practitioner, sorry. So that is the patient's app. This is with the patient, the One Touch Reveal app, and you can see multiple readings here on the right-hand side. And before the patient goes into hypoglycemia, so the blue color is hypoglycemia, the red color is hyperglycemia, and the green color is euglycemia or normoglycemia. So you can see here, the next reading is 63, and before that, the app is already alerting the doctor that, see, your sugars are trending downwards, and you just see that you correct that. So it changes the way your patients see their blood glucose results, and it helps them to manage their diabetes. It also draws a timeline of important blood glucose and activity events, highlighting when your patients have been repeatedly out of range. I think that's fantastic. And look at the figure, the app in the middle. So you can, at just a glance, find out how many times the patient was in hypo and how many times the patient was not controlled. The green tells you that the patient is in range. The sugars are in range. And this you can do at just a glance. We have been doing SMBG, and the patients have been writing these readings manually. But here they just do the blood glucose reading and see it on the app. And the beauty is that you can also get the time in range. So, which is the new parameter that all of us should know. The green color is the range. So you see 51% this patient is in range, 44% he's in hyperglycemia, and 5% he is in hypoglycemia. So you're also getting the time in range in this One Touch Variflex meter app. Besides that, you can also add an event. So you can manually add a blood glucose result, or you can log in an insulin dose, a rapid, long, mixed, NPH, others. You can keep track of food intake in grams of carbohydrates, and this is very, very essential for type 1 patients and also in pregnancy. And you can also report the activity. No activity, as you can see here, none, light, moderate, and intense. So once you put the event, that will guide you as to what you should do with the blood sugar readings. And this is very beautifully shown here. Here you can see a CGMS, just exactly like a CGMS. You see the time in range. The previous reading shows that the patient was 9% in range, but after he corrected and spoke to his healthcare practitioner, see the time in range increased even without visiting the doctor. So it helps remote consultation, it helps the patient to take action and not only to do the test. And in this graph, you can see the several times he was in hyperglycemia and also in hypoglycemia, just like a CGMS. And the doctor at the same time will also see the patterns as to what is happening to the patient's glucose, automatically detects over 30 patterns related to blood glucose results, and also insulin dosing and carbohydrate intake to help the patients uncover patterns that often go undetected. So they are simple, colorful reports. They reveal patterns to help your patient see a bigger picture and help you have more meaningful, engaging conversations during appointment. And this is what the doctor sees on his app. You see, the patient is asking a question and the doctor can either accept or decline. And he can see the data of a number of patients at the same time in the last 90 days of the data. And this is for single patient. So he can get all the data here in the last 90 days, especially seeing the times he was in hypo and the times he was in hypo. Now, before that, besides that, this is very important. He can do a quick subgroup analysis of his patients and generate ready to publish useful insights like never before, just at the click of a button. And today we talk of registry and research, and I think this will help us to do more studies in our patients of diabetes control. He can download the reports and also see the individual reports and also make copies and publish them. And this is what the doctor can see. This is an automatic logbook. When the patient doesn't have to do anything manually, and see how beautifully it is seen here. This patient is in hypoglycemia all throughout Friday and is in hyperglycemia only once. So if the practitioner sees this, he can make meaningful changes in his sugar and optimize his glucose control. And what is nice to see is that there are various colors. It's color coded. It is kind of a visual logbook for the patient where he just looks at the colors. He may not even have to look at the readings, and that will give a glance to where he is. And look at this, the doctor can also see the time in range, the green color, the time above range, and the time below range. Just at a glance, he can identify the problem and adjust the therapy. This is exactly like a CGMS at a glance. Just by doing SMBG at home, you see the patient and the doctor can identify the problem area and therapy can be adjusted, and he can learn how to adjust the therapy from his healthcare practitioner and make meaningful changes in his diabetes control. So can patient insights between visits and remote advice via text improve the glycemic control? This was a randomized control trial with type 1 and type 2 diabetes. And you can see here, he used a VarioFlex, one-touch VarioFlex meter with a one-touch Reveal app. And the doctor has also downloaded the Reveal app, and the doctor made changes after seeing this back to the app, and then the patient has made the changes in this. And this was done in 128 subjects for 24 weeks. And you can see a beautiful bar diagram on the right. The first one shows that the reduction in HbA1c from the baseline was much less in those who only did the meter readings without any text messages, whereas in those who took the meter and the app, with about 10 to 12 text messages, the HP reduction was higher, almost double. And that makes a meaningful change in practice. Use of a meter with color range indicators and a mobile diabetes management app improve the glycemic control and patient satisfaction in an unserved Hispanic population. This is another study, a randomized control crossover clinical study. When they use the one-touch meter with the app, they found that there was a 1% decrease in the A1C when they used both this after 12 weeks. There was a 10.4% increase in the number of the blood glucose values in range. And there was no increase in the number of hypoglycemia in the 12 weeks, which is nice to hear. So just to explain again, I'm showing you just one case, a 28-week pregnant lady. She's on basal insulin detamine and metformin. She was hospitalized for glucose control. Basal bolus therapy was started. At admission, her fasting was 149. Post-breakfast, it was 194. At discharge, it came down 81 and 148. She was put on the One Touch Reveal ecosystem where she contacted her healthcare practitioner who gave her advice and recommendation by which she could make changes in her insulin dosing. And you can see her, you can see the graph here. The patient has asthma actually. So this was the period of stress which caused the blood glucose to rise. And you can see clusters of hyperglycemia pre-meal and post-meal. The prandial glucose levels after breakfast and dinner were adjusted over email by the diabetic educator. And you can see that the blood glucose settled after a few days. So this is the benefit of connected glucose monitoring. I think it is one of the best methods. It is cheaper than doing CGMS. And it gives you real-time reading. It gives you time in range. And it actually teaches you, with the help of the healthcare practitioners, how to make changes in your sugars and bring about optimal control. So you become kind of educated, and that will decrease costs and also healthcare visits. So in summary, connected blood glucose monitoring with automated transfer to apps and online software, glucose data will be more easily accessible during appointments. And connected blood glucose monitorings improve the clinical outcomes. And we have just shown you 2 of the studies. We have clinical evidence now with One Touch, VarioFlex, and Reveal ecosystem to improve the clinical outcomes. It will tighten the feedback loops between data collection and action, expand the geographical access, and reduce the healthcare provider burden. Thank you. Thank you very much.
Thank you so much, ma'am, for that excellent talk. Sir, you want to add anything, sir? Vijay, sir?
Yeah, I think it's a wonderful talk. It's very easy technology we can adopt to see our patients in day-to-day practice, especially those who can't afford the CGM. They, of course, will be very useful. And here you're getting the actual blood sugar readings versus the CGM, which gives you interstitial fluid blood values. So, of course, there's also an extra value addition. The only problem is to prick every time to get the blood sugar. But then to get something better, you have to do something different. So therefore, I think this is definitely useful. I think for all a large number of doctors, this can be a useful technology.
I just have one question to ask Dr. Manoj. Is he here?
Manoj is there.
Manoj, you know, I'm also putting my patients on CGMS and they are doing real time. But I find that this SMBG and the CGMS readings, they have to scan that, are sometimes discordant and sometimes concordant. So why does this happen? Because the patients are so agitated, they are used to doing SMBG, and suddenly they are put on this Libre flash glucose monitoring, and then they say the readings are all wrong. And this is my experience with the patients. So can you please explain this?
One, of course, madam, is the lag, and the lag would differ at different times of the day. So if somebody is in a preprandial thing, you will usually not land up seeing much of a difference, again, based on the technology that is being used. And if somebody is checking, say, an hour after a meal or half an hour after a meal and they felt, then there will be a wider difference. And this could be more than even 20% at times. Also, typically, the nature of the patients is such that even if they went to different laboratories before the technology came in, they will prefer to go to the laboratory which gave them the reading which they were satisfied with. So it's always when the readings come higher or not to the satisfaction, the patients question that reading or the technology. So this is a genuine problem, and which is why in my conversation I said today that when we use CGM, it is our duty as a physician to explain to the patient which CGM to use, the limitations of this technology, and the means to understand. As I gave the example today, people are going crazy by just seeing the arrows and overreacting. Something that we had not anticipated earlier, but this is happening. So yes, there are limitations of the technology, and SMBG today still will be a gold standard. CGM only complements that. So does the HbA1c as compared to TIR. So I think all technologies are here to stay as long as we understand the strengths and limitations of each.
And also it's worse in pregnant ladies. Would you recommend CGMS in pregnant ladies? Because it's going too low.
So the low has to be taken with a pinch of salt, especially on day 1 and day 14. And I'm very clear with my patients using real time that do not react to day 1 and even day 13 to day 14. So if you see the trends and you see that the 12 days are different and day 1 and day 14 is showing completely different result, please discard those readings. In fact, the US FDA had only approved the 12 days use initially, and then they expanded to the 14-day use. So there are issues with that. Again, for pregnant females, where they are not on insulin and you just want to see the trends, a professional CGM is actually better than the real time. Real time works good only for those who are on intensive insulin and want to see. But again, where in doubt, especially for hypoglycemia, best to counter check with an SMBG done at that time.
Very much. Yes, thank you so much.
Thank you, madam.
Thank you, Manoj, and thank you, ma'am. This is a wonderful session in week, and we now move on to the next session, second innings. And to chair the session, I invite Dr. Kanchan. Dr. Kanchan is a consultant endocrinologist at Jupiter Hospital and Bethany Hospital in Thane, Mumbai. The second speaker is Purvi Chawla, we've just introduced, and Dr. Ami Sanghvi, who's the third chair. They both are very good friends of mine and scientific chairperson of Wodcon, and that says it all. They're both practicing diabetologists in Mumbai. So over to you. Kanchan, could you please introduce the first speaker?
I was on mute. Yeah. Good evening, everyone. I would like to invite Dr. Tejal Lathia. She's a very good friend, and to speak on the next topic on terrible tools managing hypo and hyperthyroidism in GDM. She's a consultant endocrinologist at Apollo, Fortis and Cloud9 Hospital. She's had major achievements in the last year, where she's been a co-author of Language Matters for People Living with Diabetes and also a co-designer for HEAL PCOS program. She's had a number of publications and reviewed in national journals. She's been invited as a speaker at various national forums. She's recently had 2 chapters written on bariatric surgery and Urja. She's also been a convener for the Endocrine Across Lifespan and Wellness and Women's Health. So welcome, Dr. Tejal. And we'll start with the first session.
Yeah, so I'll just share my slides. So specifically, hypo and hyperthyroidism in GDM will not be different than managing it in pregnancy per se. So, sorry, just one sec. I'll just quickly share my slides. So basically, I'll talk about managing hypo and hyperthyroidism in pregnancy. And though Dr. Benny greatly overestimates my ability to speak really fast, which I usually do, but it's extremely difficult to complete both hypo and hyperthyroidism in pregnancy at the same time. So what I've just done is that I put one slide to talk about hypothyroidism. I think this is something which is discussed very commonly in almost every conference that we have. And that is why in very short, this is the latest ATA, that is the American Thyroid Association 2017 guidelines for the management of hypothyroidism in pregnancy. So if the TSH in pregnancy is less than 0.1, then of course we will evaluate for hyperthyroidism. If the TSH is anything between 0.1 to 2.5, this is considered as normal and no further workup is required. Now, this 2.5 to 10 is a gray zone, and I would encourage the audience to not get confused. Or also, there is a lot of discussion going on this. In fact, just yesterday in our group, Dr. Kanchan will know, Dr. Usha Sriram, Dr. Gagan Priya, and all of us were also debating about the treatment of hypothyroidism in pregnancy. So a TSH between 2.5 to 10, and if the antibody status is positive, then what we do is we look at the upper limit of the lab. And if the TSH is between 2.5 to the upper limit of the lab, which is usually about 4.5, then we would consider treatment with levothyroxine. And what we mean by consider is that in those women who have recurrent pregnancy loss, are struggling with infertility, are undergoing assisted reproductive technology to get pregnant, in those women probably will err on the side of treatment. In women who are TPO antibody positive and the TSH is between the upper limit to 10, which is between usually 4 to 10, we would treat. If the TSH is between 2.5 to 10, but the antibody test is negative, then between 2.5 to the upper limit of the lab, which is usually 4, no treatment is recommended. Between about 4 to 10, treatment is usually recommended. So there's only one gray zone, which is this one, that in patients who have a TSH between 2.5 to 4 or 4.5, if they're antibody positive in particular situations, like undergoing ART, assisted reproductive technology aided pregnancies, recurrent pregnancy loss, infertility, we would consider treatment. In most other women who have spontaneous pregnancy, probably we will leave them alone and not treat them. So this is how I've summarized the management of hypothyroidism in pregnancy. And I will just quickly now go to hyperthyroidism in pregnancy. So what I've done is I've just taken the same woman and put her in different situations throughout the pregnancy, and I'll discuss how we manage her. So the first case is a 25-year-old woman who is pregnant for the first time. She's about 9 weeks pregnancy, and on routine TSH screening, her TSH was found to be 0.1. Now, whenever we see a woman with a TSH which doesn't look normal or is not within the normal range, we ask a few questions of the patient. So usually we look for a goiter. We ask for any family history of thyroid conditions. We ask them if there are any symptoms suggestive of thyrotoxicosis. We ask if they're on any medications, like steroids can suppress TSH, which can interfere with the TSH. We also look for any medications which the person has already been taken for thyroid disease. They could be taking levothyroxine, and because the dose is too much, the TSH is low. Or we ask if they've ever had a thyroid test in the past. Just one second. Can you close the door? Thank you. So what do you do when you have a TSH of 0.1? She's 9 weeks pregnant, and there is nothing that is positive in the history. She's never been screened for thyroid in the past, so you really don't know whether she had a thyroid problem. So what we probably do is check a T3 and a T4. It's as simple as that. Again, this is an area of great controversy, whether you do a total T3, T4, you do a free T3, free T4. But what most of us endocrinologists would do is probably get a total T3 and T4, because the total T3, T4 has a reliable relationship with the duration of the pregnancy, which I will elaborate on. Now, this is what her results look like. So she's 9 weeks pregnant. The T3 is 200, the T4 is 13, and the TSH is 0.1. So what do? This looks like classic hyperthyroidism. And if this was a non-pregnant woman or a man, then probably, yes, we would evaluate further for hyperthyroidism. We may make the person undergo a thyroid scan, maybe a sonography, to see what is happening. But what do we do in the pregnant women? Now, what we need to understand is that the hormones HCG, which is produced in large quantities in pregnancy, and TSH, have partial structural homology. That means they kind of resemble each other, and there's a partial overlap in their function. And what this HCG can actually do is stimulate the thyroid gland to a certain extent. Because of this, there's an increase in T3, T4 production and a drop in the TSH, which is the normal part of the pregnancy. So this is as the HCG rises. This is the peak of the HCG at about 10 weeks of pregnancy. This is the nadir of the TSH. The lowest TSH occurs around about 10 to 12 weeks of pregnancy, which is exactly where this woman is just going to be heading. So in pregnancy, one of the effects of the pregnancy is that there's an increase in total T4 as well as TBG, because estrogen stimulates the thyroxine binding globulin, and therefore there's more amount of TBG, so more amount of T4. There's also an increase in iodine demand and clearance under the influence of estrogen, and there's a reduction in TSH, which is based on the HCG. So as a result of this, what is actually probably a normal woman who does not have any thyroid problem, it looks like she has a thyroid problem during the pregnancy. As I already alluded to this, is there is a lot of controversy between free T4 measurement in pregnancy and total T3, T4. The thing is that as much as we would like to believe that free T4 is the better of the two tests, but the method that we use for free T4 estimation in daily practice in usual labs are by CLIA or RIA, which still have some amount of influence of albumin and the higher TBG. So free T4 done by the usual methods that we currently do in commercial labs is not good enough at the present time, unless we're doing it in a controlled trial setting where equilibrium dialysis or ultrafiltration or a tandem mass spectrometry is used. So therefore, if you ask me the question that in pregnancy, what would you use? Then I'd use total T3, T4 as compared to free T3, free T4. If we have the luxury of trimester-specific free T4 values, then we would use those. There is emerging data from our country for trimester-specific T4 values. So not going into too much detail. So how do you calculate whether this rise in the T3, T4 is appropriate for the pregnancy as well? So I don't really need you to remember all the complicated mathematics, but endocrinologists, we love our numbers. So usually what is recommended is you should add 5% to the upper limit of normal of the T3 and T4 for each week after week 7. So after week 7, week 9 is about 2 weeks. So that's about 10%. So if the upper limit of the T3, the T4 is 12, then now you will have to add 1.2. So the upper limit would become 13.2. So if you go back to the patient's report, this is what it looks like. If you add about 10% to the 180, you add a bit about 10% to the 12, then the upper limit of normal for both the T3 and T4, our values are almost at the upper limit of normal, and they haven't crossed the upper limit of normal. So this is probably just the influence of pregnancy on the T3 and T4. The TSH was 0.2, 0.1, and the lower limit for normal in the first trimester is 0.1, and we are happy with that. So the moral of the story is that in absence of any contributory history, this looks like a woman who has just the normal changes of pregnancy and does not really require any treatment. So the inference would be this is a normal thyroid function. Now let's make it a little bit more complicated. So it's a 25-year-old woman. She's primigravida. She still has 9 weeks gestation, but these are now her values. Her TSH is 0.05, total T3 is 220, total T4 is 14.5. And what do you do? Again, we ask for history, and all of the history is non-contributory. But yes, because the T3, T4 is higher now, I know that it's beyond the upper limit that I would expect for pregnancy. I go a little bit more into detail. I check for eye signs. Is there any proptosis? Is there any redness? Is there a stare? And what I find is that she has severe vomiting. She has dehydration. She's lost weight for about 3 kgs. She has anxiety. She has heat intolerance. Her pulse is 90 per minute. It's regular, and her blood pressure is normal. Now, what do I do? So this is a woman who is vomiting. She's lost weight, and the T3, T4, and TSH have gone up. So frequency of Graves' disease in pregnancy is low. It's about 0.2, but the frequency of gestational thyrotoxicosis, which is is much more common as compared to Graves' disease in pregnancy, is about 1 to 3%. Any pregnancy which produces extra HCG, as we remember, we talked about the effect of HCG on TSH. So if there's twins, if there's a hydatidiform mole, there's choriocarcinoma, all of which produce more than normal quantities of HCG, that also contributes to the gestational thyrotoxicosis. So it's important in pregnancy to differentiate, is this the Graves' disease in pregnancy, or is it simply gestational thyrotoxicosis? In this person, given the history of vomiting, dehydration, weight loss, it does look like it seems to be gestational thyrotoxicosis, and it is more common of the two conditions. Also, there wasn't any history prior to the pregnancy which suggests that this person had Graves' disease. So one of the things that we could do is do a TSH receptor antibody. A TSH receptor antibody is an expensive test, but this is one place where probably we could consider doing it. We treat the patient for the vomiting rehydration. We rehydrate her. Her pulse is not so much, so I consider beta blockers, but most of the time I would not give her any beta blockers. And probably I just look at the trend of the thyroid function. I'll do a close follow-up maybe every 2 to 4 weeks, and I'll see which way she's heading. At this time, because she's in week 9, and I'll talk about this a little later, I would prefer to avoid any kind of anti-thyroid drugs because she's in week 9 of pregnancy. Her pulse rate is not very high, and she's overall not very sick. So with just fluid rehydration, stopping the vomiting, she should be pretty okay. Now, what about this woman? So she's 25 years old, again, primary gravida, 9 weeks gestation. The T3, T4 are now even higher. So the T3 is 300, T4 is 19. This is definitely not the normal changes of pregnancy. The TSH is suppressed. She has a soft diffuse goiter. She has heat intolerance, anxiety, and tremor. There isn't any vomiting, but she has lost 1 kilo of weight. There's no eye signs, and there's no family history, any previous medication, or any thyroid disorder in the past. Now, what we usually would have done in this person if they were not pregnant is get a technetium scan, and we would have seen for the functionality of the thyroid gland. But because it's pregnancy, we cannot do any kind of technetium or radioactive iodine scan. We could do an ultrasonography, which would tell us if there's a multinodular goiter or there is a solitary nodule. Yes, and what we could do is do TSH receptor antibodies to confirm that it is hyperthyroidism. Now, this T3, T4 is quite high, and yes, definitely we should consider treatment. The reason being that very high T3 and T4 during pregnancy can lead to pregnancy loss, pregnancy-induced hypertension, prematurity, low birth weight, IUGR, even a stillbirth. It could precipitate a thyroid storm if the person has to go for an operative surgery or for an LSCS, and also could precipitate maternal congestive cardiac failure. Not only this, but the neonatal outcomes are if a woman has very high thyroid hormones during pregnancy, after delivery, the baby's TSH can be low, T3, T4 can be low, and it's a transient central hypothyroidism. There could be neurobehavioral problems like ADHD and seizure disorders in the newborn baby. So yes, it's important to treat. What is the dose that we usually would prefer? Maybe methimazole or PTU. 5 to 30 milligrams per day is the usual dose, 100 to 600 milligram in divided doses. However, what is very important is we need to know what are the risks associated with the use of anti-thyroid drugs in pregnancy. So all medicine is basically risk-benefit. If the benefit is greater than the risk, then you treat. If the risk is greater than the benefit, you don't treat. So previously it was considered that it was the methimazole which is responsible for congenital defects, and PTU largely does not cause any side effects. However, this study by Anderson et al. In 2013 first started this trend of identifying congenital anomalies also associated with PTU. And when they looked at the odds ratio of birth defects with PTU, it's 1.41. And the odds ratio for methimazole and carbimazole is 1.66. And if a woman has been exposed to both PTU as well as carbimazole during the pregnancy, the odds ratio are about 1.82. And if she has not been exposed to any kind of anti-thyroid drugs, then her risk is baseline. So PTU is not as innocuous as we thought it used to be, and we don't start all pregnant women with PTU, even if they have hyperthyroidism. So these are the different congenital defects that can be seen with carbimazole and PTU. The only difference between the two is that PTU does have slightly milder congenital defects, but they may require surgery in the future. So we're very aware of the birth defects caused by carbimazole and methimazole, which is aplasia cutis, choanal esophageal atresia, ventricular septal defects, and other things. But PTU can also cause a preauricular sinus, cyst or fistula, branchial sinus, cyst or fistula, and urinary system malformations. So what would I do in this particular pregnancy? Just 1 second. So in this particular patient, I would start PTU at the lowest dose and continue it till about 12 weeks of gestation. What I would also remember is that I need to maintain the T4 at the upper limit of normal. So we have to be very, very wary of over treating a pregnant woman with anti-thyroid drugs. At no point must we try to normalize the TSH or normalize the free T3, free T4 because, or the total T3, T4, because you will over treat this woman, and more of the drug will pass to the baby as well. And of course, we'll do a stepwise dose reduction. Most women do not require medications beyond 6 to 7 months of gestation. And block replace regimen is never to be used in pregnancy. The reason that we use PTU only till the first 3 months of gestation is because that PTU has been associated with liver dysfunction. It's the leading cause of drug-induced hepatotoxicity and liver transplant. And that is why PTU can only be given in the first 12 weeks of pregnancy. And then we switch back to methimazole or carbimazole. Now, there's just one small point, that the maximal sensitivity of the baby up to teratogens is between 6 to 10 weeks of pregnancy. And at this time, as far as possible, if we could possibly avoid any kind of medications, that would be best. So that is why we look at the T3, T4, we look at the patient's clinical symptoms, and if the clinical symptoms are manageable, between 6 to 10 weeks of pregnancy, if you could possibly avoid using PTU, then that would reduce the chances of getting any kind of birth defects. So most of the time we judge the patient individually. We look at how high the T3, T4 is, how bad the symptoms are, and then decide whether to treat or not to treat. And this is just more data which says that when is the maximum time that the side effects occur, and usually between about 5 to 10 weeks of pregnancy is where most of the congenital birth defects are seen. I think I'm almost out of time. So what about planning pregnancy? So in planning pregnancy, we shift the patient to PTU. We check for pregnancy as soon as the period is missed, and always reassess the continued need for any kind of antithyroid drug. So if the person is on a very small dose of PTU or methimazole, carbimazole, her thyroid function is well managed, then definitely you could consider the possibility of stopping the antithyroid drug completely and then allowing the woman to get pregnant. You check the TFT maybe every week, every 2 weeks, and after first trimester, we would use carbimazole and not PTU. We have to be careful about withdrawing therapy. And if the take-home message that I have first is for the hypothyroidism is that between 2.5 to 10, there is still controversy. If antibody is positive, between 2.5 to 4. If a woman has infertility, recurrent pregnancy loss, then we would consider treatment. Between 2.5 to 4, antibody negative, we would not consider treatment. Anything above 4 up to 10, then yes, we would treat. More than 10, of course, we would treat. Very important in pregnancy to differentiate between gestational thyrotoxicosis, physiological changes in thyroid function test as compared to real thyrotoxicosis requiring treatment. Choosing antithyroid medications for the treatment of Graves' disease in pregnancy is extremely important. PTU for the first 12 weeks, carbimazole after 12 weeks. Even in the first 12 weeks, if you could possibly avoid antithyroid drugs between weeks 6 and 10, this minimizes the risk of having any kind of congenital birth defects. As endocrinologists, we often talk about how low the risk is, but it's just one baby who's affected by aplasia cutis, one baby affected by choanal atresia, which I think is not permissible. Thank you so much.
Fantastic talk, Dr. Tejal, and thank you for even sticking to the time. I think that's of essence. Very, very well covered. The topic was really well tackled. So with that, we move on to the next talk. Again, a brilliant endocrinologist. I have the pleasure of introducing Dr. Anjali Bhatt, who is the founder of EndoClinic and practicing endocrinologist at Pune, Maharashtra. She's very passionate about patient care, research, academics, and community-based activities. After her MD in medicine from MGI of Medical Sciences, Wardha, she also trained in endocrinology from CMC Vellore and has done her diploma and MSc in endocrinology, former consultant at Chilaram's Diabetes Institute. Without much ado, let me have her start the talk. She's going to talk to us today about two very, very important aspects in women with diabetes, the aging partners of osteoporosis and sarcopenia.
Thank you, Dr. Purvi. It's always a pleasure to be amongst wonderful women led by Dr. Benny Neglur. Thank you, ma'am, for having me here. Thank you, sir, for having me here. I consider my slides and audio is okay.
Yes, and thank you for being in yellow.
Yes, sunshine yellow. We all are sunshine. So we are going to talk about the topic, the aging partners, osteoporosis and sarcopenia in women with diabetes. Before I go ahead, I want to highlight the key words in the topic. The first is aging. The second are osteoporosis and sarcopenia, which we look at as disease. Then we are talking about very important aspect of the population, that is women and those with diabetes. So there are so many aspects to be considered over here. Aging, osteoporosis, sarcopenia in women with diabetes. So that is how I wanted to design the talk. And I'll like to cover at what age do we start aging? By what age should we say that we are aged or we are aging? Does diabetes and gender make a difference? Sarcopenia and osteoporosis, how to clinically assess them, treat them, and monitor them. And then we'll summarize the talk. So let's look at all this aspect in form of a case, which we can correlate to our day-to-day practice. A 56-year-old lady, BMI of 28, sedentary lifestyle, known diabetes for 5 years on metformin and pioglitazone, 1000 milligrams and 15 milligrams, HbA1c 7.1. She had her menopause 5 years back and now presented with complaints of pain in lower back after a fall by accidentally jumping on her granddaughter's skating board, which was lying just below the basin, like it is always below my basin in my room. So this is my daughter's skating board for correlation. Now here the lady is 56-year-old. Is that an age where we should start worrying about aging? When it comes to specific reference to muscle and bone, it is the aging starts at birth or maybe before that. So if we have to care about someone at an elderly age for her bone and muscles, the things that we need to care start at birth or probably even before that. That means when the concerned person in his or her mother's womb, because the muscle mass growth development starts very early in life. What you gain in this period decides how you are going to be in the later time of your life. So the muscle mass and strength in later life not only reflects the rate of loss as you age, but also the peak attained in earlier life. So this is somewhere below 30 years of age, and then this will be somewhere around menopause, plus or minus 5-10 years, depends on the ethnicity and the time of menopause. So what you gain before 30 years will matter a lot during your middle age and the later age. So in the adulthood and youth, maximize muscle, because that is what will decide what you have when you age. In the middle age, we need to maintain what we have gained during the earlier time. And then as you age later, we need to reduce the loss. And all three are important. And the time that we need to start caring about rather than worrying about is as early as possible in the time zone of your life. So this slide is basically to delineate the difference that the correlation of birth weight and the muscle strength calculated by grip strength differs between men and women. You can see that the correlation is distinctly different. So gender matters a lot as long as the muscle and bone strength is concerned. With the same amount of birth weight, the effect that a man and a woman will have will differ because of the gender difference and the hormonal and biological reasons. Does diabetes make a difference? Does diabetes cause muscle and bone loss, or whether muscle loss and bone weaknesses will increase the chances of diabetes? So hyperglycemia is known to be associated with sarcopenia. The risk of sarcopenia is increased in patients with type 2 diabetes compared to normal population. At the same time, sarcopenia can be responsible for hyperglycemia because adults with sarcopenia are more likely to develop diabetes than those with good muscle strength. And the contributing factors have something like a common soil. Both insulin resistance and high glycated hemoglobin is associated with both sarcopenia as well as hyperglycemia. The baseline systemic inflammation, oxidative stress, and advanced glycation product contribute a lot to both loss of muscle and hyperglycemia. So this is not a linear relationship where you develop diabetes first and because of hyperglycemia you start developing sarcopenia. There are baseline chronic inflammatory and oxidative stresses which are responsible both for sarcopenia and hyperglycemia. And this is a very important information because just by treating one, the other is not going to get corrected. Just by treating hyperglycemia by oral or injectable anti-hyperglycemic agents may not probably make your muscles better. So you need to talk about the basics before that, or we need to tackle both of these disorders. As I said earlier, the effect is different in men and women, and why this slide is shown is an association of diabetes, duration, HbA1c, and cardiovascular disease with sarcopenia. So the dark black boxes are with sarcopenia and the gray boxes are without sarcopenia. Can you see the difference in sarcopenia being associated with the complications of diabetes? The difference is much higher in women compared to men. So the blue circled box is in men and the pink circle box is in women. So muscle loss is more worrisome in women than in men. So gender does matter a lot and we need to deal with women differently than men. Coming to clinical diagnosis and treatment and monitoring of sarcopenia, we all know that sarcopenia as a medical term means loss of muscle mass, but there has been a recent change in definition of sarcopenia where now the diagnosis of sarcopenia is done as probable, confirmed, or severe. And what probable sarcopenia means, a low muscle strength. Irrespective of the mass of the muscle, we need to suspect sarcopenia when there is a low muscle strength. And the clinical evaluation also will depend on evaluating the parameters that will suggest muscle strength, which becomes clinically easy. Then if there is a confirmed muscle quality and quantity loss, we call it confirmed. And when there is a low physical performance, we call it severe. So there is a recent change of talking about sarcopenia from low muscle strength overtaking the role of low muscle mass as a principal determinant. Low muscle mass, quality and quantity are more relevant in research settings. In clinical settings, what we are worried about is low muscle strength because that is the time when we can intervene to improve the outcomes. So there are multiple ways to deal with or to diagnose the sarcopenia. Case findings in the OPD, you can just do simple testings like chair raising testing or a short performance test of walking 400 meters or up and down for 5 times, and then see how much time it takes for the patient to complete the activity. If you want to go in details, you can use a muscle a grip strength machine, or you can use a DEXA, which is the gold standard for calculating the muscle mass. That is dual energy X-ray absorptiometry. Or we can have bioimpedances machines, which are very easily available and very commonly kept in the clinics. So whatever we do, we need to be actively finding the cases of sarcopenia by looking at low muscle strength rather than low muscle mass. And again, when it comes to men and women, look at the difference between strength. When grip strength less than 27 is considered sarcopenia in men, but in women it is less than 16. But when it comes to performances, whether it is chair stand or whether it is short performance or get speed, the time is not different in men and women. So even though we have lesser muscle strength in terms of grip, the time required for a certain activity should not be different for men and women. Women should not take more time to do the same activity. So the cutoffs of performance testing are not different, they are same. Whether you perform chair stand, get speed, 400-meter walk test, there are details of these tests available on the internet. I'm not going into details of how to perform each test, but these are very simple and can be done in simple OPD without any instrument, and sarcopenia can be detected. Rather than which test is better than the other one, in the same patient, if you use the same method, the serial findings will mean a lot, whether improvement or deterioration is happening in a given patient. Sarcopenia is not equivalent to lower weight or malnutrition. There are obese patients which can be sarcopenic. Their muscles can be lower strength and lower quality and mass. in spite of the patient having obese. So this in itself is a very long topic, but we are just iterating here that obese patients also might have sarcopenia. Anti-diabetes medications might be affecting the muscle mass, while sulfonylureas have some evidences showing that they can decrease the muscle mass. Most of other anti-diabetic agents we do not have clear evidences that they affect the muscle mass. Now, treatment of sarcopenia and type 2 diabetes mellitus might overlap. Calorie restriction and aerobic exercises that are known to be good for type 2 diabetes will have questions over muscle mass, but they will get balanced if you are also working on resistance training. So a good combination of aerobic exercises and resistance training. When calorie restriction we are doing, if we make sure that enough protein is supplemented, the bad effect of calorie restriction on sarcopenia can be very well tackled off. Coming to osteoporosis, again, operational definition. This is from a talk by Dr. Thomas Paul Sir, who is one of the very renowned speakers in bone health. And what the Vellore data says that every second woman above 50 years in India has osteoporosis. That's a huge prevalence. And even men, 1 in 5 do have osteoporosis in India from the South Indian data. So how do we define osteoporosis? Does osteoporosis equals to low bone density on X-ray DXA, or that is DEXA, and which will equal to treat with the medications that improve the bone mineral density? This is not the definition of low bone density or osteoporosis. What we are looking at is a low bone mass and microarchitectural deterioration of bone tissue. But what it means in our clinical practice is increased susceptibility to fractures, which will indicate us that the diagnostic pathway should start with assessing the fracture risk, which will include not only the bone mineral density, but also the risk of fall and the balancing capacity of the patient. So this all is going to correlate to preventing the fall and fracture using bone mineral density as a supporting tool. So this is not doing an DXA, looking at T-score below or less minus 2.5, and then treating with anti-resorptive or bone-forming agents, and then we are done. So when we assess the risk factors for fracture and fall, we look for some skeletal risk factors, which are first, previous fracture, which is the biggest risk factor for developing another fracture. Family history of fracture or osteoporosis. High bone turnover or secondary causes like endocrinological disorders, malabsorption disorders, medications that increase your bone turnover, and then supported by a low bone mineral density. And we are again reminded that we should not ignore the non-skeletal factors like sarcopenia that we have talked about, which will impair the balance and make the risk of fall higher. Poor eyesight, balance and hearing, and poor environmental condition. Like I said, my daughter's skating board is lying everywhere in the house, and if I'm always scared that my mother-in-law or my mother will put their foot on that and will have a fall. So the environmental conditions are also very important. A very important read for all those who are interested in treating bone, an ISBMR guideline which was just published last year by all the eminent speakers in bone and endocrinologists published. If it's a must read for all those who are treating bone. Now the pathway for evaluation and treatment, if there is a lady who has presented with osteoporotic fracture, osteoporotic sites in the body are vertebra, hip and wrist, which will include either humerus or radius. So if some lady presents with this, irrespective of anything else, she needs treatment for osteoporosis. If there is somebody who is younger, because age and gender will matter a lot here. If she is postmenopausal in women more than 60, mind well, in India, the menopause age is 45. So this figure might be much lower in India, but right now the guidelines say 60, and men more than 65. Or we are dealing with a younger man or a woman with relevant increase in the clinical risk score. Now, there is a controversy about which clinical score to use. Many experts believe that FRAX is good. There are Indian specific guidelines there. Dr. Thomas Paul, I heard from him that OSTA is a score, very simple, weight minus age into 0.2, or some other clinical risk scores. Like I remember my professor teaching me that if a lady has more than 3 teeth fall, then she has at a higher risk of developing osteoporosis. So whatever clinical score we are using, if the clinical score is higher in younger men and women, or younger men and women with a condition which increases the bone turnover, that is rheumatoid, malnutrition, diabetes, and steroid. In these, get the BMD done and treat if there is a high fall risk from the environmental factors and or low bone mineral density on an X-ray absorptiometry. By low bone density, we mean T-score below or equal to minus 2.5. Again, a very long pathway to talk. We can talk about this in a separate lecture. So FRAX, as I said, is an internet-based risk score, which you can go and find out. There is a link to the page over here. Before we start the specific treatment, it is important that we get hemogram creatinine, liver function, calcium, TSH, and vitamin D in every patient. Because if calcium is low, vitamin D is low, anti-resorptive therapies are not supposed to be started unless we correct calcium and vitamin D. If needed, we can also think of getting urine calcium, parathyroid hormone, urine or serum electrophoresis to rule out multiple myeloma, anti-TTG antibodies, and override DEXA suppression test to rule out Cushing syndrome. Coming to the treatment of osteoporosis, 3 most commonly used molecules: zoledronic acid, denosumab, and teriparatide. Zoledronic acid is once a year intravenous injection, costs somewhere around 2,000 to 5,000 depending on facility. Denosumab is a subcutaneous antibody given every 6 months, costs somewhere around 25,000 to 30,000 a year. And teriparatide, an osteoblastic agent. These two are agents which stop resorption of bone, while teriparatide is a molecule which increases the bone formation, is a molecule which is given every day as a subcutaneous injection, yearly costs somewhere around 50,000 to 60,000 rupees. Now, teriparatide for 2 years is always followed by an anti-resorptive agent, because unless the formed bone is stopped from getting resorbed, the treatment is not going to be effective. Now, which molecule to choose? There are multiple options. Again, from the talk of Dr. Amrish Mittal, who is considered as one of the very important speakers on bone. Prevalent, if the lady presents with a prevalent vertebral fracture, teriparatide has good data, followed by zoledronic acid, then denosumab, or if nothing of this is possible, alendronate. If there is a prevalent hip fracture, zoledronic acid takes over teriparatide or denosumab. And that is how we decide. If teriparatide and denosumab are not an option, zoledronic acid once a year is an excellent molecule to be used with eyes closed. After a vertebral fracture, it is suggested that the patient should not get discharged without a zoledronic acid injection, provided you have made sure that the patient has normal calcium, enough vitamin D. If not, give vitamin D and then give zoledronic acid, and the creatinine is normal. Now, coming to diabetes, in addition to the association studies that we have seen, there are some anti-diabetes medications that make the patient prone for developing osteoporosis. Pioglitazone tops the list, but there are some suggestions that others like SGLT2 inhibitors might be responsible. If possible, and the risk to benefit ratio favors, stop these molecules and give the molecules that are not associated with bone loss, but otherwise treat osteoporosis alongside the treatment of type 2 diabetes. Coming back to the case, the most important points are 54 might be a young age if we think of Caucasians, but in India, because the menopause comes early, we need to consider treating these women at an earlier stage. Sedentary lifestyle has to be changed to improve not only the bone formation, but also formation of muscles and improvement in the metabolic parameters like diabetes. Pioglitazone should have been avoided. After menopause, a routine BMD after 5 years or depending on the clinical risk score is indicated. And if there is a vertebral fracture, this lady needs treatment for osteoporosis. If you can get BMD done, well and good. Otherwise, it is important that she is treated with at least bisphosphonates, if possible with teriparatide or denosumab. And when we improve the bone, muscles, and the metabolic parameters, The skating board should not become an environmental factor, which is problematic. Coming to the summary of my talk, making together aging, osteoporosis, sarcopenia, women, and diabetes. What can we do? Good physical exercise, a balance of aerobic and strength training. Earlier we start in lifetime, it's better. Balanced nutrition with calorie restriction for diabetes, enough protein and antioxidants for reducing the oxidative stress and improvement in the muscle formation. Calcium and vitamin D go a long way, even more commonly should be prescribed than anti-resorptive or bone-forming agents. Active case finding for sarcopenia, because people who just feel tired, are not able to perform their activities, might actually be dealing with sarcopenia. So ask the patient to sit in the chair, get up and sit for 5 times. If she takes a long time, you can straight away say that probably she has sarcopenia and work over it. Appropriate treatment for osteoporosis must be done to prevent another fracture, or in non-prevalent fracture ladies, to prevent the first fracture after a fall. Avoid unfavorable treatments when you're dealing with patients with diabetes. So with that, I would thank you for having me here. And if there is time, I may be available for questions.
Thank you so much for that very, very fabulous overview on osteoporosis and sarcopenia and women with diabetes. With that, maybe we can have questions at the end of the session, and we'll just move on with the third talk right now.
Sure.
So thank you, Dr. Anjali. And now moving on to the last topic of this session, we have Dr. Alpana Suhani, who is a consultant diabetologist at SL Raheja Hospital, Mumbai, director of Diabetes Specialty Center in Mumbai, and her areas of special interest are GDM, diabetic foot, and pre-diabetes counseling. She's going to be talking on a very important topic of premature menopause. Can we get the happiness hormone back? I welcome you, Dr.
Alpana. Thank you, Ami. Thank you for the introduction. I'd like to go straight away into the talk as we are running late. First of all, definitely a big thank you to Benny ma'am and Negru sir for helping me to get this talk about premature menopause. Though, just give me a second while I just put it on a slideshow. Just give me 1 second, please. Yeah. So we will be talking about premature menopause and how to get the, can we get the happiness hormone back? Just a minute. Is the slide sharing happening?
It's on the first slide.
Yeah, it's on the first slide.
Just a minute. I'm not able to change it. Just give me a second.
Ma'am, click once on the screen, then try to move.
Yeah, fine. Thank you. So we'll get into this really quickly. This is just an overview of what the talk would be. Just a minute. Yeah. So the introduction of what is premature menopause. Premature menopause is basically defined as premature ovarian failure, which occurs before the age of 40 years. And any patients, just a minute, I'm having a little problem with my slides. Just a second. Can you see the slide clearly? Because I am getting a whole patch in front of my screen.
Clearly.
You can see it clearly? Okay, fine. So I'll just
start sharing again.
Yeah, fine. So the clinical features of premature menopause, it's associated with multiple syndromes, symptoms which are generally vasomotor, like hot flashes and night sweats. There are vaginal symptoms which could be either vaginal dryness or dyspareunia. There are urinary complaints in the form of frequency, urgency, repeated infections. And there are also sleep disturbances which are seen. The other symptoms could be headache, depression, anxiety, irritability, skin atrophy, and joint pains. Sometimes there is also lack of concentration, which is seen in women with premature menopause. The most predominant symptom which most patients enter our clinic with is the hot flushes which is seen, it can occur in up to 75% of the patients, and it tends to be more severe than what is seen in natural menopause. This is generally the cause with which the patients come to our clinic, and it is very unpredictable in its onset, and it is recurrent. So this has a detrimental effect on the woman's functional ability, but is not life-threatening by any standards. The investigations for premature menopause would be a FSH value and estradiol values. The FSH values are more than 40 mi per ml, and the estradiol levels are less than 20. Sometimes chromosomal studies are required to rule out certain syndromes. We also need to do antibody levels for thyroid and adrenal failures, that is the autoimmune variety. Blood sugar testing and X-ray of the pit gland to rule out a tumor. Blood calcium values and bone densitometry studies are needed as well. So what are the consequences of premature menopause? The consequences of premature menopause are either short-term or long-term. Short-term, we already spoke about in terms of hot flashes, night sweats, vaginal discomfort, and urgency and recurrent urination. There is also irritability, but it's the long-term consequences which are more devastating in the because of premature menopause, which include infertility, osteoporosis, and increased risk for premature death, cardiovascular diseases, and strokes if not treated well. So, how do we manage these patients with premature menopause? It depends entirely on, first of all, identifying the cause, and then we should institute the treatment based on what the cause is. It is always a good practice to recommend estrogen replacement therapy for women with a premature menopause. That is essentially what we are going to be talking about, is the role of the HRT. Is it applicable for everyone, or who are the right patients? There is a lot of hoo-ha which has been created about the bad role of HRT, but today I would like to clear up a little of the myths which are there about HRT, and hoping that we can offer this to more patients if they are correctly chosen. So the management of menopause, and we will be talking about HRT and the other complementary therapies. This slide is a little busy, but extremely well made, and it talks about how do we evaluate a patient with this primary ovarian failure. We need to find out first what are the causes, look at the symptoms, see if there is a presence of sexual dysfunction. Are there other osteoporotic risk factors and cardiovascular risk factors? Are there any psychological problems that the patient is also dealing with? And the presence of any other pre-existing medical conditions. In the investigations, a renal function test, a liver test, a bone densitometry with vitamin D levels, and a cardiovascular risk profile test in the form of HbA1c, a lipid profile, and a fasting blood sugar management. Before we go into HRT, I cannot emphasize the importance of lifestyle management in these patients, where if smoking is present, there should be cessation of smoking, regular exercise, try and maintain maximally ideal body weight. Even if the body weight does not change, at least improve the fitness levels of the patient, reduce the alcohol intake, manage the blood glucose values. Now, the MHT is one of the biggest parts of our talk, my talk today over here. And I would want to specify the importance of always discussing the benefits and the risks and individualizing the treatment depending on what the patient causes and what they feel like. Now, if there is a patient who HRT is completely contraindicated, are the patients who have estrogen-dependent cancers. So for them, hormone therapy is completely out of the question. But if they do have it, we can help them in the form of SSRIs or gabapentin and pregabalin and clonidine in the older women. But if there are no such contraindications, we need to decide what kind of HRT we will give. And over there, the deciding principle is whether the patient has been hysterectomized or no. So if the patient has had a hysterectomy and secondly to that has premature menopause, the hormone therapy will be in the form of estrogen only. But if the patient has not been hysterectomized, we again need to go into HRT development depending on whether contraception is needed or not. So if it is needed, we give such patients a combined OC pill, or they can be given a levonorgestrone intrauterine system, that is along with estradiol, that's a transdermal or an oral approach. Always make sure that the patient is given the HRT depending on what their personalized requirements are. We can also consider short-term, if you don't want to give oral HRT to the patient, we can give vaginal estrogen if there are urogenital symptoms persisting along with MHT. Also, short-term use of testosterone patches or creams for improvement in sexual function also work in premature menopause. Now, in the patients who don't require contraception, they can be given either a continuous combined hormone therapy or a cyclical combined hormone therapy. But always remember that all the patients who are there receiving a hormone therapy, it should be done with proper monitoring. It should be used up till the age of natural menopause, which is taken to be between 48 to 51. Regular BMD should be done, regular mammograms, regular pap smears, and a yearly TSH value requires to be done. Now, patients who have special issues such as breast cancer or a positive BRCA gene, if there is breast cancer history present, we do not give them hormonal therapy. But if it is not, and only a positive BRCA gene with no history of breast cancer, they can receive a short-term hormonal therapy. In Turner syndrome, it is not contraindicated. In patients with hypertension, it would be preferable to use transdermal hormone therapy as against the oral pills. In a history of a patient with who has a history of an embolism or thromboembolism, we would prefer to first go to a hematologist, make sure that there is a safety in using hormonal therapy, and only then start, or a transdermal therapy would be preferred. So a lot of people, many people know what to do, but few people actually do what they know. So that is very much applicable in the current scenario of hormone therapy. We need to make sure that when is medical intervention required, depending on the age of the patient in front of us. We also need to know what are the symptoms we need to be looking into. So it is very important. It is not that one pill fits all. Depending on what the patient has come to us and what are the symptoms, we decide about what kind of therapy is required. I cannot emphasize enough about the role of physical activity and health. It reduces the risk of other complications, it slows down premature aging, and it improves quality of life. I think physical activity and exercise is something which should be given and offered to each and every patient who walks into our clinics. Now, the menopausal hormone therapy, it is also known as HRT, and it covers various hormonal treatments that can reduce the menopausal symptoms. It is safe for most women in their 50s, or at least for the first 10 years after the onset of menopause. The added risk for blood clot, stroke, or breast cancer while taking hormonal therapy is small, and it's actually similar to that for the other risk factors, such as being overweight. So let us not just discount the giving of hormonal therapy for a patient because there might be a side effect. It is more important that we are able to identify the right type of therapy for the right type of patient. So what are the indications? It is either the relief of vasomotor or menopausal symptoms, or prevention of osteoporosis, or that of arteriosclerosis. The contraindications are definitely pregnancy, undiagnosed abnormal PV bleeding, breast disease, endometrial cancers, or active liver disease. Now, if you see the little cartoon in the side, it is actually the way the menopausal symptoms are treated. It's generally like a cocktail treatment where HRT plays a role, their lifestyle modifications make a role, the SERMs play a role, and there are sometimes even things like naturopathy and exercise and pranic healing, and all of those also sometimes help patients with severe menopausal symptoms. So what are we looking at? When do we give estrogen plus progesterone? If the uterus is intact, then treatment that combines estrogen and progesterone is the way to go. Progesterones could be the norethisterone, the medroxyprogesterone, the 1-dehydroprogesterone, or the micronized progesterone, and they're added on to the estradiol treatments. Now, the safety facts are pretty good for the estrogen and progesterone. It does not cause weight gain. The patients who have blood clot, the patches and gels can be used. that they have a higher tendency towards clotting disorders, they can use patches and gels. And if you're using tablets, there might be a doubling in the risk, but it is still very low, as in maybe maximum of 1 extra case per 1,000 women. In patients with breast cancer, there is an overall 1 in 8 women who will develop breast cancer during their lifetime. The added risk of breast cancer with hormonal therapy is small, and the risk rises the longer you take the hormonal therapy. So, and it decreases also once you stop. So every time, make sure that we know that we're customizing the treatment for our patients. Now, estrogen alone is suitable for women who've had a hysterectomy. The vaginal estrogen therapy is very useful for women who have localized symptoms like flashes. Estrogen plus SERMs, that is the selective estrogen receptor modulators, are now actually a very good combination for the treatment of menopause. They have anti-estrogen or estrogen-like effects that vary in different parts of the body. I will be talking more about SERMs as we go on. So this is to just bring it down as a capsule, what we have spoken as yet. So the approach to medical treatment for menopause would be treat the patient depending on whether the patient has been hysterectomized or no. If hysterectomy has been done, it is only estrogen, which is given from day 1 to 25. And in non-hysterectomized patient, a combination of direct progesterone with estrogen is given. So the different formulations which are used of estrogen and progesterone. I would definitely like to add these two, talk a little about these two studies, that what is the actual atherosclerotic risk with estrogen. 2 landmark trials occurred, that is the ELITE trial and the KEEPS trial. I'd like to talk a little more about the KEEPS trial, which is the Chronos Yearly Estrogen Prevention Study. What have we learned from this? It has very clearly shown that within 4 years, neither hormone therapy nor it does not affect beyond 4 years. It does not affect the rate of increase of the parietal intima thickness. But there is a trend for reduced accumulation in the coronary artery calcium deposition when conjugated estrogen is used. It also shows that using estradiol improved the mood of the patient, reduced the hot flashes, and improved the sleep and maintained the bone densitometry. Sexual functions also improved with the transdermal estradiol. In the ELITE study, it showed us that if it is given within at the right age, early in the menopausal period, up to 10 years, it does have a decrease in the cardiovascular risk for the patient when given at the right time, the use of estrogen. Now, what are the NAM guidelines? The NAMS is the North American Menopausal Society. They had very clear guidelines on hormonal therapy. It is appropriate for the treatment of vasomotor symptoms in women who are considered low risk for CVD and have no personal history of hormone-dependent cancers. It is the most effective treatment for hot flashes. It also supports a decreased cardiovascular morbidity and mortality when it is initiated in patients less than 60 and less than 10 years out of menopause. The goal is essentially to reduce the fear of hormone therapy and encourage individualized shared decision making. The International Menopausal Society also had similar things to talk, that they suggest that the progesterone component of the hormone therapy is more significant in any increase of breast cancer risk rather than estrogen. And moderate progesterones, natural progesterones, and SERMs, they optimize metabolic and breast effects. So they also suggest that hormonal therapy is a good way to go if you correctly choose your patients. Now, what are the pros and cons of HRT? The pros are the excellent symptom management. There's also a decrease in the incidence of osteoporosis, repeated UTIs, probably depression, and there is a good preservation of joint, teeth, and skin. The cons of using HRT may be that it doesn't help in a patient with chronic heart disease. It might increase the risk of stroke and thromboembolism. There is an increased rate of breast cancers if patients are not really chosen, increase in gallbladder disease, and increased chances of vaginal bleeding. So what are CAM therapies and what are their role in menopause? Basically, they're the other complementary and alternative medicines. Why do patients seek these therapies? Because a lot of inertia on the patient, on the physician side of using HRT even in the correct patients. We are talking about patients with premature menopause, and they could be as young as 30, less than 40, maybe even 35. And if the patient is a correct candidate for HRT and the doctor is scared of using it, the patients lose trust. They have beliefs, they hear half-baked data on the internet. They know that there are no side effects of this alternative therapy. It costs less and it's less invasive. So patients are more prone to use and switch to alternative medicines. There could be, I'm not going to be talking about the other procedure, but certain natural extracts today are having a very good role in management of premature menopause. The natural extracts include phytoestrogens, which are the phytosomes. Could be the soy, it could be red clover, it could be the black cohosh extracts, primrose oil, vitamin E, ginseng. All of them have a role to play. I will just talk about what is SERMs. They are the estrogen receptors. There are two types of estrogen receptors, the estrogen receptor alpha and the betas. The alpha are the ones which are seen in the uterus, breast, ovaries, and liver, and the beta are seen in the bone, endothelium, lung, and the CNS. Now, these selective receptors have differential actions at various sites. So, an ideal SERM is a SERM which will be used for applications of menopausal management that has no stimulatory action on the breast and uterus, and that would block the estrogenic action and act. It prevents any side effects on the vascular and central nervous system. So what exactly are these phytoestrogens? They're a group of plant chemicals which elicit an estrogen-like response. And these phytoestrogens, which exert their estrogenic effects, that is the antagonist action on the alpha cells, alpha receptors of estrogen, and the anti-estrogenic effect, that is an agonistic action on the beta estrogenic receptors. These phytoestrogens are described as natural SERMs. The most common one which we use is soy. It is used for peri and postmenopausal patients. It is found in a lot of our natural foods like soya beans, tofu, soy milk, and also in nuts like almonds and walnuts. It is also found in broccoli and certain berries. Few studies have been done, and we have a mixed response that whether the isoflavones actually make a difference in the management of the menopausal symptoms like hot flashes. The next one is the red clover. It's a member of the legume family. I would definitely like to talk a little about the black cohosh extract. It's an isopropyl alcohol extract, and it is endogenous to the eastern parts of USA and Canada. It has multiple levels of action, that it has estrogenic activities, it's a phytoserm, it's a serotonergic and a dopaminergic action. Lot of studies have been done, which are showing significant good clinical evidence in improving the climactic symptoms of premature menopause. There's an increase in HDL cholesterol, but no bad effects on the liver profile. There are also studies showing that the quality of life improvement is there when black cohosh extracts are used. It also shows that the risk of postmenopausal breast cancers, irrespective of the histological type and receptor status, there is a decreased incidence of this. There are certain adverse effects of the black cohosh extract, which could be either skin rash, pruritus, sometimes hepatic damage. There are contraindications like pregnancy, liver dysfunction, patients with vaginal bleeding, and hypersensitivity to these functions. So it does have a lot of advantages and should be considered in patients where HRT cannot be used. So what should we do after today? Should we or not use the HRTs? What we need to do today is to get past the misinformation and the hysteria and stop denying the potential benefits of HRT. It should be given to women who are symptomatic and have no major contraindication. There is good evidence from 50 years of observational studies and clinical trials suggesting that the benefits outweigh the risks when started early, that is within 10 years of menopause. To summarize, I would like to say that premature menopause is considerably higher in the Indian women As compared to their Western counterparts, nearly 5.5% of women in India reach menopause before reaching 40 years of age. There are certain states such as Andhra where it is as high as nearly 15% of the population. In Gujarat, it's as high as 6.5%, and in Rajasthan, nearly 6%. The rural women are at a greater risk, and it is time now that we start giving sufficient attention to the patients with premature menopause and give them the therapy which is required rather than neglecting the therapy. I will not, being a diabetes practitioner, I cannot close this talk without talking one slide about what is the relationship between early menopause and diabetes. The exact pathophysiological mechanism underlying the above association is not fully elucidated. The possible mechanism could be the lesser amount of estrogen safety which has been given to the pancreatic cells, and it leads to an increase in insulin resistance. Also, early menopause and primary ovarian failures increased associated with glucose intolerance, maybe because of metabolic consequences of body fat redistribution. That is, there's an increase in central obesity post early menopause, which leads to increase in insulin resistance. The menopause-related increase in steroid hormones may also lead to glucose intolerance. Also, the coexistence of risk factors like smoking, low physical activity, obesity, they are risk factors both for early menopause and diabetes. So this is all from a systemic review and a meta-analysis in the postmenopausal women, which is definitely showing an increased risk of developing type 2 diabetes in women with early menopause. However, there are a lot of conflicting data, but definitely enough data has been shown that necessitates further studies to look out for the above association between menopause and diabetes.
Sorry to interrupt. I think we have already.
This is the last slide. This is the last slide. Thank you so much. And I'm sorry for going ahead. Just a minute.
So thank you, Dr. Alpana, for such a wonderful presentation. We directly move on to our next session and hand over to Dr. Shefali for the next session.
Thank you for the wonderful session. Thank you, chairs. Thank you, speakers. We now move on to our last session of the day, the classic news session. And to chair the session, I invite Dr. Alpana Sowani, who's just been introduced. I also invite Dr. Sheetal, who is a consultant diabetologist from Mumbai, practicing at Diabetes Center in Mumbai. I also re-invite Dr. Tejal Lathia, who is a consultant endocrinologist at Apollo Fortis Hospital, Navi Mumbai. Over to you, chairs.
So thank you, Shefali. We'll be going into our first talk. I would first like to, it's my pleasure to introduce Dr. Mangesh Devaskar. He is the Honorary General Secretary of the National API, ICP, and the PRF. He's on the editorial board of various magazines like the JAPI, the Medicine Update, and the IJD. He's also a guest editor to Insulite Journal and the World Journal of Anemia. He has delivered more than 1,000 lectures at national and international conferences. He's an MRCP examiner for the Royal College of Physicians, UK. A very warm welcome to Dr. Devaskar.
Thank you for those kind words of introduction. And hello, everybody. I'm Dr. Mangesh Devaskar. And today's my talk would be focusing on incorporating the gender-specific lipid therapy guidelines. And this is Wodcon. Before I do that, thank you very much, the entire team Wodcon, especially Dr. Beni Neglur, Dr. Vijay Neglur, and the entire team Wodcon for giving me this beautiful opportunity. And what in next 15 minutes or so, I'll try and do is to cover some intrinsic aspects of gender-specific understanding about the dyslipidemias and what therapeutic change and awareness we all have to have whenever we are talking about managing, especially female gender, when it comes to the management of dyslipidemia. So in my today's talk, I'll try and give you some basics of dyslipidemia challenge, a bird's eye. What is the current guidance? I'll just touch upon it. And then I'll also try and make some points to understand some gender-specific evidences as far as the dyslipidemia and its management is concerned. And then, of course, finally, we'll have some carry-home messages. Now, friends, we all know that blood vessels, they provide battlegrounds for the cardiovascular events. And the main reason why we develop cardiovascular events is atherosclerosis. And one of the risk factors, the prominent risk factors of all the risk factors for atherosclerosis are dyslipidemias. So let's talk about dyslipidemias. When I was browsing through the literature and just wanted to understand what are those various interventions which can actually impact the cardiovascular outcomes when it comes to the HbA1c lowering or the LDL lowering by just 1 millimole or the diastolic and systolic blood pressure lowering by 4/2. And I have realized that just by mere lowering of LDL cholesterol by 1 millimole, that is around 39 milligrams per deciliter, you are able to reduce down nearly 4 events per 100 patients that you treat. So we also need more lipidologists and more sensitized lipidologists and the physicians to have a very, very specific approach to the dyslipidemia management. And why I say so, it's primarily because we have to understand that if you do the audit of the global deaths, we will see that ischemic heart disease and the strokes, they still contribute the highest numbers. And unfortunately, in the last decade and a half, the number has not changed much. And especially when the Indian subclass of the patients are concerned, you will realize that cardiovascular disease is still one of the prominent contributors for the mortality and morbidity. And there is a paradigm shift from the mortality related to just mere coronary artery disease to a very high risk atherosclerotic cardiovascular disease with a Southeast Asian population with an adjusted odds ratio of nearly 2.11. That means the risk is nearly double. And if you look at the population attributable risk factors associated with myocardial infarction or the cardiovascular event in the Indian subclass of the patient, and this is a data analysis from Interheart study, done by Salim Yusuf, where they analyzed nearly 17,500 patients, and they were almost 10% Indian patients analyzed. Would see that lipids, they contribute significantly. So dyslipidemias are the common parts of our practice, and primarily we treat secondary dyslipidemias. There are hardly 5% patients, those who have got either primary or the familial or genetic dyslipidemias. A concept which was kicked off by a beautiful invention by a Russian scientist, Nikolai Anishkov, where he fed egg yolks to the rabbits and found that it induced arteriosclerosis and atherosclerosis. And since then, we have walked a long distance. We have understood dyslipidemia better. We started understanding the various aspects of dyslipidemia. And we also have understood the various lipoproteins and their correlation to the morbidity and mortality. And what we have realized are that there are some good, the bad, the uglies of dyslipidemia as they are there on your screen. And if you really talk about the Indian dyslipidemia, there is a classic Indian dyslipidemia trial, little different than the Caucasian or the Western world. That is that in Indians, we do have got prominently a very low HDL levels. We have very high triglycerides, and also we have got high, small, dense LDL cholesterol and lipoprotein A levels, which are supposed to be highly atherogenic. And that's the exact thing that the guidelines, they say. We know that the first guidelines for the dyslipidemia management started as an adult treatment panel program of National Cholesterol Education Program, which is called as NCEP-ATP in way back 1988. And since then, since the last guidelines in 2019 released by the European Society of Cardiology and the European Association of Study of Atherosclerosis, and they have suggested to keep the target LDL range in the regular moderate risk patient to less than 100, in the high risk patient to less than 70, and in very high risk patients, the LDL targets needs to be less than 55. And that's how they have done it, by assessing the risk of atherosclerosis development over the period of 10 years. And the patients with very high risk of atherosclerosis, where you can use the risk scores, which are various risk scores which are available. You can use any one of them. But whenever there is an extreme risk or a very high risk, it is advisable to have LDL cholesterol less than 55. Now you'll ask me, why LDL only? Why there are no other lipoproteins or the dyslipidemia profiles which are addressed adequately? And the simple answer to this is this, that LDL cholesterol is a fairly well standardized estimation. It does not get affected by the external factors, including your diet and the day-to-day regular events happening. And most importantly, this has been one of the highest studied lipoprotein in majority of the cardiovascular event-driven trials. And you can clearly see that the data from Jupiter, now this is the data which was published in Lancet, but overall the meta-analysis which was published of nearly 18 trials in Lancet, including the Jupiter trial, they have found out that reduction of LDL cholesterol by 1 millimole, that is 39 milligram, causes the significant reduction in the major cardiovascular event, nearly 20 to 25%, but also causes the all-time mortality reduction and the all-time vascular death reduction. Now 20 to 21% may not hit you here, but what if I say that 1 in every 4 or 5 patient is benefited? And this is exactly what you can see on this chart, that the overall cumulative effect of the LDL reduction on the atherosclerosis. And you can see that LDL reduction by just 1 millimole will cause 22% risk reduction over the period of 5 years, 28% risk reduction over the period of 10 years, and 54% risk reduction over the period of 40 years. And if you do it by 2%, that is 2 millimoles per deciliter, then the risk reduction technically doubles. And what has been also proved that if you reduce LDL cholesterol by more than 50% from the existent level, the benefits are nearly 60%. So the events, they go down significantly, and the numbers needed to treat also significantly drop down. And you need to just treat 26 patients when you are trying to get down LDL cholesterol by 50% or more to get 1 cardiovascular risk reduction. So what are the gadgets, the armamentariums that we have to treat the raised LDL cholesterol? First, of course, is the therapeutic lifestyle change. And then to that, depending on the risk attribution, you need to add statin as the primary drugs of therapy. So HMG-CoA reductase, part of the therapy, needs to be added. And then depending on the response or the intolerance to the statins, the other therapies to be added. But the latest European guidelines suggest that whenever the patient has got a high risk for development of atherosclerotic cardiovascular disease, or the patient has a high risk for developing a cardiovascular event, it is recommended that only high intensity statins need to be used. And look at the class of evidence and the level of recommendation that you can see. These are different statins which are available, but 2 different statin, I would say, mechanism of actions. And also you can see that rosuvastatin and pravastatin are the only hydrophilic statins, where the rest of the other statin groups are lipophilic. Now, importance is this, that they are extremely rapidly effective. And not only that, both of these statins are metabolized in liver and kidneys. So especially in the renally compromised patients, you can still continue giving patient either rosuvastatin or pravastatin. Now, what do you understand by a high intensity, moderate intensity, and a low intensity statin? High intensity statin, that means that the daily dose is able to reduce down the LDL cholesterol by nearly 50% or more. The statins are atorvastatin in a dose of 40 to 80 milligrams and rosuvastatin in a dose of 20 to 40 milligrams. They become high intensity statins. Simvastatin was also studied in this, but it was found that simvastatin of 80 milligrams and above, they tend to cause a lot of statin-induced myopathy in the patients. So simvastatin was was revised from the high intensity statin group to the moderate intensity statin group, where in the moderate intensity statin therapy, you will see that the LDL reduction happens by around 30 to 50%, whereas the low intensity statin will cause LDL reduction by less than 30%. The moderate intensity statins are the Atroa, Rozua, Simua, Prava in the regular practical dosages. This was a beautiful study which was published by Shashank. This was ICMR INDIAB study, and they studied and they looked at the prevalence of dyslipidemia in both urban and rural Indian population. And what they found out that apart from the typical Indian dyslipidemia phenotype, almost 10% of the adults had all the three lipid abnormalities, that is high cholesterol with high triglycerides, with low HDL, and with high small dense LDL cholesterol and lipoprotein A levels. And rosuvastatin in Jupiter trial has shown that it has an ability to impact the levels of all these three challenges, and it causes the reduction of the myocardial infarction, the stroke, the unstable angina, or the need for the revascularization, or the cardiovascular death by nearly 44%, and the number needed to treat to get benefit was just 25, and the total mortality also reduces by 20%. So this is overall risk benefits of use of rosuvastatin, and this is again the Jupiter trial PM Redker's, Paul Redker's data, which actually told us that it is important to induce the probably high to moderate intensity statin depending on the risk factors. Last 5 minutes or so, I'll try and talk to you about the gender specific therapy needs and are there any differences. So my first question when I started preparing for this talk was that, do we really have some gender specific dyslipidemia management guidelines? And I have realized that the answer is clear no. There are no specific guidelines by any society till today, including the American Heart Association, American Cardiology Society, European Society of Cardiology, or even the Lipid Association of India. So the second question was, do we really need them? Probably yes. And why I say so is basically because this Chinese study, which was published by Wong et al. In 2020, 2 years ago, has shown that there are clear-cut gender and the age-specific differences in the dyslipidemia pattern of men and women. You can see that, as the age advances, probably the risk of dyslipidemia increases in women. No matter, it could be overall dyslipidemia, it could be the overall hypertriglyceridemia, it could be overall total cholesterol, or it could be overall LDL cholesterol. And also what is significant, and it is different from men and women, is this, that the prevalence of low HDL is very, very high in men, and also it stays high in men, whereas the prevalence of low HDL is little lower in women. This probably is basically because of the effects of the estrogen, and we all know about it. That estrogen, especially in the young fertile age group, has got a tendency to cause high HDL levels. It will reduce down the triglycerides and the LDL cholesterol, and it will also cause reduction in the free fatty acid levels by reducing down the insulin resistance. And the estrogen acts through two different receptors, estrogen receptor alpha and beta. Alpha primarily offers cardiovascular protection. Beta will cause vasodilation and neovascularization. And same thing in pregnancy, probably there is a high amount of lipogenesis, and this is thanks to the progesterone effect rather than an estrogen effect, and that causes rise in the free fatty acid levels, including the lipoprotein little a, and also will cause rise in the insulin resistance. Overall, the dyslipidemia pattern disturbs, but remember that postpartum, the total cholesterol, the triglycerides will start settling down within 24 hours of delivery, whereas LDL cholesterol and lipoprotein little a will stay high up to around 5 to 6 weeks postpartum. And in women, those who have got a tendency to develop preeclampsia, really this dyslipidemia profile takes a little longer time to settle down and come back to the pre-pregnant or non-pregnant state. Multiple trials, whether it is a primary prevention trials or the secondary prevention trials, they included women population and they analyzed. See, like primary prevention, like Jupiter had a women population of nearly 38%. All had lipid lowering trial had almost 49% women. And also in the secondary prevention arm also, there were women included. And these are the details where they looked at all the effective statin therapies. And what they realized is this, that women respond beautifully well to rosuvastatin and simvastatin than other statins in comparison to Prava and other statins. That was shown in Jupiter trial. Women are more likely to develop statin-induced rhabdomyolysis, and especially this was highly seen with a little higher dose of simvastatin. Gender-specific impact could be primarily explained through the transporter polymorphism on statin pharmacokinetics. I'm not going into the details about it, but remember that estrogen-induced water and sodium retention, increase in the volume for lipophilic drugs, higher protein binding of globulins, the higher CYP3, so metabolism, lower BMI, lower clearance definitely affect the dyslipidemia outcomes in women. And there are also a few more important epistles that I would like to give, that in women, probably HDL cholesterol and non-HDL cholesterol may better predict the cardiovascular mortality and morbidity in comparison to LDL cholesterol targets. So we need to also take in consideration the levels of HDL cholesterol and non-HDL cholesterol in women in comparison to the men. Really increased hypertriglyceridemia appear to be independent risk factor, especially in women. And this is the meta-analysis of all these trials, which included women as a gender population. In large, you will see that even with the high LDL cholesterol level, as the women achieve menopause, they develop atherosclerotic cardiovascular disease and the risk increases. And that is the reason why it is also suggested that the cutoff for the HDL cholesterol for women should be more than 70 rather than as it is in men, which is usually 60. And women also have been shown to respond to phenofibrates or fibrates better than in men. And this is very, very important to note. And in the menopausal women and the post-menopausal phase, you need to be extremely watchful. But then there was a beautiful exploration, whether then, if at all the estrogen progesterone plays a role, then whether hormone replacement therapy plays a role in offering a cardiovascular risk reduction. Probably the answer was no. So purely hormone replacement therapy did not work as far as the dyslipidemia and the mortality is concerned. But if you use the statins plus hormone replacement therapy, they have been found to be extremely effective. So whenever you are treating the patients, especially women in the postmenopausal phase with dyslipidemia and with hormonal challenge, it is always advisable to use both hormone replacement therapy and statins in combinations. There are a few questions on the horizon that in future, whether the guidelines, especially for the women, will change when you talk about the management LDL targets, or will consider non-HDL and HDL cholesterol as well in women alone. Will the combination therapy with statins and fibrates, because it has been shown that fibrates are more effective in women than in men. And are there going to be the dedicated gender trials to incorporate large percentage of women to have a genuine outcome data? These are a few new agents which are coming on the horizon for the management of dyslipidemia and especially LDLs, the ACAT, the CETP inhibitors. We are going to have the drugs which will decrease the ApoB synthesis, and also we'll have the drugs which will offer you the phytosterol reduction. I know it's time to stop. So quickly, let me tell you that for the management of dyslipidemia overall, irrespective of the gender, statins and especially high intensity statin are pivotal. In the patients, those who still do not reach the LDL goal with the maximum tolerated dose of statin, the second best add-on is estimab, which is recommended. And in the patients, those who do not respond to this therapy, these are the patients who are likely to be benefited with probably the PCSK9 new sensations. So these are all my practical approach to the management of dyslipidemia. Finally, this is my last slide, where you have got LDL as a target. And if the LDL is not in target, the drug of choice has to be statin. If triglycerides are not in target, the drug of choice has to be fibrates plus statins. And especially if the triglycerides more than 500, then it has to be fibrate along with statins. If you want to manage low HDL, then the best drug to use in statin is rosuvastatin, because that is the only drug which can cause a rise in the HDL. And then, of course, you can add fibrates or nuts or probably sometimes the niacin group of the drugs. And to manage inflammation, naturally rosuvastatin is best. When all are abnormal, probably you need to deal with these patients differently. So thank you very much for your kind attention. I'll end up my talk because we have celebrated recently on 8th of March, the World's Women's Day. So I'll end up my talk by saying a few words about appreciation of women, that be very proud of what you have achieved. There is something so special about women who dominates our world. It contains certain grace, strength, intelligence, fearlessness, and the nerve to be strong, which all of you are. If you want to, it is always said that if you want to ask something, probably ask a man. But if you want something to be done, always ask a woman. There are no limits what women can accomplish. So thank you for being there in our lives to make our lives more lovable and livable. Thank you very much. I'll stop sharing my screen here. I'll be happy to address and answer any questions. If at all I am not confused all of you anymore. Thank you very much.
Thank you very much. Wonderful insights on lipid. I ask Dr. Sheetal to introduce the next speaker, please.
Am I audible? Yes. It's a great pleasure to introduce our next speaker, Dr. Tejas Shah. He's a practicing diabetologist for 23 years. He's a diabetologist and director at Aiva Diabetes Care Center in Mumbai and honorary diabetologist at Raheja Hospital. He's a founder and president of the United Diabetes Forum, is a visiting teaching faculty for fellowship in diabetology at Dr. D.Y. Patil Medical College. He has been a speaker at various national conferences like CID, RSSDI, IdeaCon, Diabetes India, DIACON, IdeaCon, etc. He's been an organizer and scientific committee and faculty of CID since its inception. I welcome Dr. Tejas Shah. His topic for today is the new norm, HbA1c and fasting sugar. Do we need postprandial sugar testing at all?
Thank you.
What do you say?
Thank you very much, Sheetal, for the introduction. A big thank you to Dr. Benny, Madam, Vijay sir, and kudos to the entire girl gang for excellent conference and the excellent event organized today. I'll just start. Yeah. So thank you for giving me this topic today. What we are going to discuss today is the importance of postprandial blood sugars. Basically, since the time of that we've been talking about diabetes, we have been treating diabetes. Focus has always been, especially in the Western countries, on fasting sugar, on HbA1c as being the targets for glycemic control. More or less the clinical trials that were done in the past also were always talking about the correlation of fasting sugar and HbA1c. The trials like UKPDS and DCCT also initially talked about the reduction of A1C and the importance of to prevent glycemic control. And for the patients who are not under control or not achieving the target A1C in spite of being on a good fasting sugar were then subjected to control the postprandial sugars. So for years, when we are following the Western literature, the importance of postprandial control was a bit forgotten. But in the last few years, with newer trials, with newer data, and the importance of postprandial sugars, which has now come up due to various drugs also, we now know that it is an important aspect of glycemic triad, which we need to control, which we need to reach in order to make our patients reach the desired goal of glycemic control. So this is the outline of the talk, where I'm going to talk about initially the importance of achieving glycemic control, the association of postprandial sugars and A1C, some of the mortality and morbidity data associated with postprandial hyperglycemia, and summarizing the few tips on management aspect. So we know that the prevalence and epidemiology of diabetes has been increasing in the last 2 decades or so. We have more than 500 million diabetics all over the world, with almost 40% of the population of diabetes coming from two countries, like namely India and China in Asian continent. It itself tells us how the numbers have increased in the last few years. And when we talk about Asian population particularly, we have to understand that we are predominantly talking about countries where it's a carbohydrate rich country, where the importance of, again, postprandial sugars is much more as compared to the Western population. The need to achieve glycemic control is known to all of us. If you look at the data, almost with the prevalence being almost 9 to 10%, we know that diabetics are almost fourfold more likely to have an increased risk of myocardial infarction, almost eightfold higher risk to die from first myocardial infarction. It is the leading cause of blindness. It forms almost 33% of the cases of blindness is due to diabetes. The most common cause of amputation in terms of disease after accident, and almost the most common cause of end-stage renal disease is diabetes. So our goal primarily to control our patients is to prevent these micro and macrovascular complications over a period of time. When you look at the data from long-term studies, we always give a reference for UKPDS because it was the largest, at one point, it was the largest trial done on type 2 diabetic patients, newly diagnosed type 2 diabetic patients subjected to intensive and conventional control. And what it achieved in the 10 years of UKPDS, it showed that by controlling our patients better or by intensive control, you could prevent the progression or you could reduce the incidence of microvascular complications. However, at the end of 10 years, the figures on macrovascular complications were not absolutely significant or not very high. But when these patients were followed up after 10 years in the UKPDS long-term data, it clearly showed that the benefit of early glycemic control, the benefit of controlling our patients better, gives a benefit in the long term too. And there was almost a 13% risk of all-cause mortality, almost a 15% risk reduction of myocardial infarction, and almost 10% risk reduction of any diabetes-related endpoints, which tells us that we need to control our patients better from the very beginning, and the earlier you control, the better it is. Similar data from DCCT trial, which showed even a 1% reduction in HbA1c goes a long way in terms of reduction of incidence of retinopathy, nephropathy, and neuropathy. The study done in type 1 diabetic patients clearly showed the benefit of almost 50% reduction of retinopathy progression in those patients who are intensively controlled as compared to those who are conventionally controlled. If you look at the leading cause of death in patients with diabetes, cardiovascular disease itself forms the highest is the major contributor. 65% of diabetic patients die from cardiovascular cause, be it ischemic, be it cardiomyopathy, or any cause of coronary artery diseases. Therefore, it tells us the importance again that we need to control our patients mainly better, not in the later half, but in the first initial part of their diabetes, and right from the very beginning. The pathogenesis of diabetes is such that it's a progressive disease, we know, and that's how we need to understand the importance of postprandial blood sugars. Whenever a patient gets diagnosed with diabetes, much prior to that, he passes through the stage of insulin resistance, where there is a continuously increased secretion of insulin due to the compensatory mechanism. The body tries to secrete more and more insulin in order to compensate for the resistance, following which, after a certain period of time, the beta cell fatigue starts setting in. There is a drop in the insulin levels, there is a drop in the beta cell function starts deteriorating, and that is the time when frank diabetes starts appearing. So when we talk about the initial years or in the stage of pre-diabetes or impaired glucose tolerance, when the fasting sugar has not yet risen, but it is the postprandial sugars which actually starts rising much before, and it almost happens 4 to 7 years prior to patient gets maybe diagnosed with diabetes. So when we talk, and by the time a patient gets diagnosed with diabetes, by the time his hepatic glucose production is more, but his insulin secretion fails to compensate this, by that time his postprandial sugars as well as fasting sugars are at a relatively high level, with the insulin resistance being always there. So the earliest effect in type 2 diabetes, what we know, is postprandial hyperglycemia. Postprandial hyperglycemia usually presents almost 4 to 7 years before the fasting hyperglycemia becomes evident, and therefore it needs to be treated, it needs to be targeted at a much earlier level. So despite optimal treatment, what we have drugs, primarily if you talk about insulins, if you talk about the basal insulins, if you talk about the other drugs in the past, if you talk about metformin per se, which was mainly working on the decreasing the hepatic glucose output or improving the insulin resistance, overall the targets were to achieve the near normal or fasting blood glucose in the controlled level. However, the extra glycemic excursions that used to happen with the postprandial period are something which were not targeted enough, which were not controlled enough. Now let us look at some of the data which directly correlates our postprandial blood sugars with HbA1c and its association. This is an interesting study done in 2007 by Monier. It mainly looked at the progression of diabetes. It mainly looked at the contribution of blood sugar of fasting and postprandial sugars and to the increasing blood sugar levels. Here they tried to group patients in different categories, tried to group patients depending on their HbA1c from 6.5 to 7, 7 to 8, 8 to 9, and more than 9. Patients were put on 24-hour CGM and their blood glucose profiles were recorded. It was mainly to find out that what is the order of blood sugar rise or what is the order of blood sugar deterioration that happens in these individuals depending on their HbA1c and what contributes more. Blood sugar profiles were mainly assessed on 3 different periods. The daytime periods or the diurnal period was assessed, which was representing the postprandial peaks. The fasting or the nocturnal period was at the night time or the nocturnal period, which was the fasting period. And there was a morning dawn phenomena period, which was in the morning between 6 to 10 or 7 to 10 in the morning. What was seen here was that in the maximum rise that used in the age group in the HbA1c between 6.5 to 7.5 or between 6.5 to 8, it was the postprandial or the diurnal time of blood sugar which started rising first, and that showed the maximum abnormality. While the nocturnal or the fasting period was the one which started rising the last, and the morning period or the dawn phenomena was the intermediate one which started rising second. So what it tells us is, or what it informs us is that until the HbA1c starts rising almost above 8%, it is the fasting hypoglycemia does not contribute much, it does not rise much. But between 6.5 to 8, it is the postprandial component which actually starts increasing much more and therefore contributes to the early defect that happens in patients with type 2 diabetes. Monier also showed in his data the contribution of fasting and postprandial. This was a study done in European population mainly, and it looked at the contribution of fasting and postprandial to HbA1c. For a A1c less than 7.3, almost 70% of the contribution came from postprandial sugars, while as the HbA1c starts rising above 7.5 and 8 and above, gradually the contribution of fasting sugar starts taking place more. So to achieve the desired glycemic goal, to reach the desired glycemic goal of A1c, we need to target the postprandial sugars once the patient's HbA1c is less than 8 is what this data against told us. This is a smaller study done with 175 people with normal glucose tolerance, IGT, as well as type 2 diabetes, defining the relationship between HbA1c fasting and postprandial. Again, showing that in the early stages of prediabetes and diabetes, the deleterious effect of imbalance between impaired insulin secretion and insulin resistance were more apparent in the postprandial state than as compared to the fasting state. So the postprandial state started rising much more in the initial period, up to A1C of almost 6.5 to 7, rather than the fasting sugar, which contributed more. This is again a meta-analysis done from 11 studies looking at the contribution of fasting postprandial with A1C. Almost 7 studies out of these 11 studies showed a higher correlation of postprandial blood sugar to HbA1c as compared to fasting. Here the coefficient of index or the coefficient of ratio between PPG and A1c was almost 0.68 as compared to 0.61 done with the fasting and HbA1c, clearly showing a bigger contribution of PPG for a better HbA1c. Yes, attaining HbA1c below 7 is difficult. We need to understand that. The DCCT and UKPD did demonstrate that 1% reduction is important to reduce the complications. The post-meal glucose often is not suitable or not available for safe adjustments of fasting versus the postprandial medications, and therefore postprandial hypoglycemia is an independent contributor to diabetic complications, and we need to treat it separately. Now, if you look at the physiology of a human being also, and the kind of food pattern that we have, we need to understand that we have 3 different phases of digestion. The postprandial period is actually the period from ingestion of meal to up to 4 hours, where the oligo and disaccharides are converted to monosaccharides with the help of the alpha glucosidase enzymes. From 4 hours to 10 hours comes the post-absorptive period, where these monosaccharides are absorbed, and then comes actually the fasting period after almost 12 hours of your meal. So if a person is eating, say, 3 meals in a day, almost more than 80% of the time, or more than 12 hours of the day, are actually spent in the postprandial period rather than the fasting period. And therefore, which tells us that these spikes are something which we need to control. This is an interesting study again done, where it compared patients who failed to reach the desired target A1C of less than 7 and versus those who reached the target A1C of less than 7, and compared their SMBG profiles. What was shown is that those patients who were in the A1C less than 7, here the fasting sugar was identical in both the groups, but those patients who did not achieve the A1C had a much more higher spikes of postprandial sugars, or diurnal blood glucose fluctuated much higher. The postprandial peaks were much higher in this group of population as compared to the other group. This is again a study done with around 160 individuals, trying again to look at the contribution of PPG and fasting in well-controlled patients. Here, 64% of the patients here achieved the fasting target of less than 100 when their A1C was less than 7. But for those patients who achieved the postprandial of less than 40, almost 94% of the patients could achieve the target A1C of less than 7. So decrease in PPG actually accounted for nearly twice as much for decrease in HbA1c as much as the decrease in fasting blood sugar, is what this study showed. Now, for years, this debate and this controversy came up whether postprandial blood sugar is an independent contributor to cardiovascular disease and mortality. This came up primarily because there were a number of studies which showed the correlation between postprandial sugars and cardiovascular mortality. If you look at the data from DECODE study, it's a study with 15,000 men newly diagnosed or not previously diagnosed with diabetes, subjected to OGTT, and it looked mainly at the contribution of fasting and PP to cardiovascular mortality. Again, here in this study, the 2 hours PPG level done following a 75 glucose test showed an increased CV death rate as compared to fasting glucose levels. The other studies, like the diabetes intervention study done with around 1100 men, again showed that PPG and not fasting showed increased risk of myocardial infarction and mortality. The companion postprandial hyperglycemia study showed a reduction of PPG and not fasting, again associated with reduction in carotid intima thickness. There was Chicago Heart Association follow-up data with 12,000 men, which showed again the increased risk of CVD mortality with higher PPG. So there are various theories, there are various contributing factors related to postprandial hyperglycemia, which could be playing a role mainly to increase the risk of cardiovascular disease. There are abnormalities seen related to blood coagulation, decreased fibrinolysis, there is free fatty acid decrease, there is increasing insulin resistance, there is a decreased clearance of low density lipoproteins, which happens when the hyperglycemia postprandially is high. The basic defect that happens is mainly the endothelial dysfunction. As we know that endothelial dysfunction is the seat of atherosclerosis. This is from where the inflammatory markers and the endothelial dysfunction contribute, and thereby there is a further increase in inflammatory cytokines. There is the expression of the adhesion molecules. The endothelial release per se really causes decrease of nitric oxide synthesis. The vasodilatation decreases. And in totality, all these factors contribute to increased vascular damage, which is also known as the vascular theory, where there is an increased generation of atherosclerotic plaques, there is increased atheroma formation, and more chances of a thrombus and myocardial infarction, mainly related to the postprandial hyperglycemia. The oxidative stress component related to, again, hyperglycemia or postprandial hyperglycemia is something which directly contributes to coronary artery disease. There is increased advanced glycation end products which are seen. There is a lipotoxicity and insulin resistance, increased inflammation. All these factors together contribute to increase formation of coronary plaques and increase chances of heart diseases. The association between macrovascular disease and PPG is what we have spoken. There was always a theory that microvascular complications are directly more related to fasting sugar. This was a study to show that the contribution of PPG to retinopathy, a study done in around 140 Japanese patients, where they were assessed over a period of time on admission and then followed up for a period of 5 years, which showed that the increased incidence of retinopathy, and it was more closely or more directly associated to the postprandial blood sugars, and it contributed more directly to increasing A1C as compared to the fasting blood sugars. When we talk about our country specifically, we know that we are a carbohydrate-rich country. People consume food mainly high in carbs. If you look at the data from STAR study done by Dr. Joshi and group, carbohydrate constitutes almost 64% of the total energy from diet, and PPG of 62.5% of diabetic population in this study was above the target range, in spite of being on all medications and in spite of being from established diabetic care centers all across India. If you look at the glycemic response and compare the glycemic response of Asian Indians versus Caucasians again with the same kind of food, it clearly shows us that the glycemic response that we have is different and more for typically certain foods as compared to the Caucasian population, which again tells us why we are more prone to have a higher postprandial component. So higher the plasma glucose with which a patient goes to bed as a result of postprandial hyperglycemia, higher is the fasting. Similarly, higher the fasting hyperglycemia in the morning, higher would be these postprandial spikes, and therefore the methodologies, the targets that we use, that primarily should be targeted to both fasting as well as postprandial sugars. But unless we achieve the reduction of postprandial sugars, it is difficult to reach the desired HbA1c in spite of reaching a good fasting level. Dietary therapy with low glycemic index foods are beneficial mainly. We have various drugs and medications now available to us, which we can use judiciously, mainly to target the post-meal blood glucose levels. Pharmacotherapy in the form of alpha-glucosidase inhibitors, in form of GLP agonists, which have shown great promise for postprandial blood sugars. DPP-4 inhibitors work very well on the postprandial blood sugars. Of course, metformin and short-acting sulfonylureas like glinides are there, which can also be used mainly to target these postprandial blood sugars and can be used in combination to achieve the desired control. So to summarize, postprandial hyperglycemia is a detrimental factor mainly in the evolution of diabetes-related complications. There are numerous studies which have established the role of PPG in the development of atherosclerosis. Isolated postprandial hyperglycemia in the face of normal PPG and HbA1c even increases the risk of cardiovascular death by twofold. And guidelines recommend OHAs as well as rapid-acting analogs to be considered, and GLPs to control our PPG better. Thank you very much for the hearing.
Thank you, Dr. Tejas, for your wonderful insights.
Thank you.
Thank you so much, Dr. Tejas. Thank you, Dr. Chi. I now invite to introduce the next speaker, please. Dr. Tejas. Dr. Krishnan, could you please introduce the next speaker?
Sure. I introduce the next speaker, Dr. Meenal Mohit. She's a consultant and head department of endocrinology at Manipal Hospital in Jaipur. She's a director of Sashakta Thyroid Endocrine Diabetes Center. She has many international and national publications to her credit. She's a gold medalist in University of Rajasthan. And she has won various awards, including the M. Chenna Reddy Award and Jaipur Chapter Award. Her topic for today is diabetes management and different cancer therapies. Over to you, Dr. Meenal.
Thank you so much. And thank you for inviting me here, Dr. Beni ma'am and Dr. Vijay sir. Very, very good evening to all of you. First of all, a very happy Holi to all of you. As you all can see my splashed face, the color has not yet gone. So please bear with my red face. So the topic that has been given to me is diabetes management in different cancer therapies. Something new probably to discuss today evening. The diabetes management in different cancer therapies. First of all, let's try to understand the collaboration of diabetes and cancers. The epidemic of diabetes as we all understand, the mostly undiagnosed, with a high risk of almost 1 in every second person or 1 in every third women having there now?
Yes, ma'am.
Okay. So as I was talking, we are talking about diabetes and cancer, and the collaboration of diabetes and cancer we are trying to understand. So the topic is cancer and diabetes. Let's understand the connection first. It's not moving. Okay. So as I was saying, almost 8 to 18% of the cancer patients also have diabetes. Now, the particular type of cancers which are at higher probability or at higher risk in type of diabetes are such: type 1 diabetes, which is at higher risk of cervical cancer and stomach cancers. Type 2 diabetes is at a higher risk of breast cancers in women, endometrial cancers, pancreatic cancers, liver, kidney, and colon. One line here, one word here, that type 2 diabetes is probably protective against the prostate cancer. So what is the exact relationship? The relationship begins from hyperglycemia, hyperinsulinemia, and of course the growth promoting effects of the insulin-like growth factor 1. So what are the major risk factors in diabetes that may influence the cancer risks? Hyperglycemia, of course, hyperinsulinemia and insulin resistance. There is insulin receptor overexpression, and of course there is fetal insulin receptor also playing its role. Other risk factors that may be included are obesity, hyperglycemia, elevated fatty acids, oxidative stress, and a state of chronic inflammation. Now, what we have studied from the various literature and meta-analysis, though there is not much of the data to analyze, but one of the papers which I could find was showing, and we have our own clinical experience also as all the references from the onco ward, the HbA1c level at the end of 12 months or at the end of 24 months shows some rise, except for the gastric surgery, except for the gastric cancers or the cancers requiring a gastric surgery. This is probably because, of course, the lumen of the gastric size is reduced, so the food absorption is reduced, and so there is reduction in HbA1c. But if we take out this particular cohort of CA, stomach, and the gastric surgeries, most of the cancer patients with diabetes actually face a rise in HbA1c at the end of 1 year or at the end of 2nd year. High blood sugars, of course, in case of all the diseases, not only in cancers, cause increased stay and increased cost. There is higher infection rates, but specifically in cancer patients, there is shorter remission period, increased morbidity and mortality, there is decreased immune function, and there is decreased QALY. So what is the role that hyperglycemia is actually playing? There is a sort of glucose addiction. There are certain tumors that actually thrive on glucose. There is increased energy requirement by the certain tumor growths, and that increased energy requirement is fulfilled by increased glycolysis, and increased glucose supply serves the purpose and actually serves tumor growth. So if we can control good glycemic control, or if we can offer a good glycemic control to our patients, probably we can also limit the tumor growth. Now, what is the challenge? What are the different challenges that we are facing in our onco ward managements? There is difference in BMI, first of all. The BMI difference results maybe probably because of the underlying type of cancer, the type of cancer treatment that is being offered. Then there is significant change in the glycemic control, which is necessitated by the diabetes therapy. There is difference in the cancer type, cancer staging, and cancer treatment across all studies. The population sometimes is being given a hormonal therapy that worsens the glycemic control. At times, you will find that there is a rise in the fasting blood glucose mode because of the rise in insulin resistance. Then there are chemotherapy drug regimes requiring steroids at times. So these steroids, antiemetics, or hormonal therapies, they actually disrupt your entire glycemic plan. So what are the variations we come across? We come across this type and stage and severity of cancer which differs. The cancer treatment differs right from chemo, endo or radiotherapy or even surgeries. Then there are competing comorbidities like obesity and cardiovascular diseases. We tend to pay less attention probably to the potential co-founders or the confounding factors like the diabetes duration, the treatment history of the diabetes, what HbA1c the patient presented with at the time of treatment of cancer when it started, and what are the supportive treatment that is being offered. There are inconsistencies in various study inclusion and exclusion patterns. We are at times dealing with missing data, and we are using, there is no control group when we are dealing with cancer group. So the comorbid diabetes and cancer is a fatal, almost a difficult outcome, I should say, not fatal always, but it has a poor outcome, and there happens to be, this outcome is translated into higher mortality. So hyperglycemia, what is the cause of hyperglycemia? Most commonly, you will find that the patients are poorly adhering to your anti-diabetic treatment. At times, either they cease to take the anti-diabetic medicines or they decrease the dose of the anti-diabetic medications. Our cancer physicians, our onco physicians may also be playing a role here. They pay little attention to the glycemic control. Then there is poor self-management by the patient themselves because now they have another chronic condition to take care of. And as a result, the care towards diabetes is decreased. And we have a lack of integrated care approach and competing care priorities. So what is the solution? Probably we need to have more competing care priorities to be established, like diabetes to be given equal weightage when we are giving care to the cancer patients. And we should be able to differentiate between the modifiable and the non-modifiable factors that are needed for the cancer management as well as the diabetes management. So when we talk of diabetes management in cancer patients or in cancer therapies, the treatment for diabetes, when we talk of, always begins with food. So when we are deciding the food or the nutrition for our diabetic patients suffering with cancer, we must think of nutritional goals now, a combined approach. For diabetes, we have to maintain a blood glucose control, we have to maintain the lipid profile, we have to maintain the blood pressure. So the metabolic profile has to be maintained. Then we have to slow down the complications also. We need to address the individual nutritional needs because it's always tailor-made. And then, of course, the palatability always counts because now with cancer, the charm or the fear of mortality is always raised, though we may deny it, but we all know that once the diagnosis of cancer is made, patient and the families tend to forget or overlook the importance of good glycemic control. So looking at the cancer goals, we must try to maintain and achieve sufficient energy stores. We have to maintain the muscle mass, the lean body mass. We also have to maximize the immune system. We have to slow down the side effects of the drugs because sometimes the cancer therapies are also causing similar side effects, especially the GI intolerance. We have to address again the individual nutritional needs and of course the palatability of the food. So when we talk of carbohydrates, here we are not talking of very low carb intake. We have to maintain an optimal carbohydrate intake so that sufficient energy intake can be maintained. But we have to at the same time focus on carbohydrates which are more complex rather than the simple other refined carbohydrates. So we can choose more often from the fruits, vegetables, whole grains, beans and legumes, and the natural sugars. One big challenge comes here is that most of the oncologists refuse to take raw food. So raw food, especially including fruits and vegetables and salads, are usually taken out when we are managing diabetes in our onco patients. So still we have to choose from some solution that we have to offer them whole grains, beans and legumes, and we have to cut down on the refined food, the white products, the simple sugars, cakes and candies that has to be removed at least for sure. When we talk of proteins, yes, we have to give them sufficient amount of proteins because they're already in a catabolic state or a cachexic state. So proteins being the building blocks of our bodies, they build up the immune system. We have to keep the protein intake sufficient, and we have to focus that the kidneys are not involved, so the renal challenges are less. So we can keep 2/3 of the protein sources from the vegetable sources and 1/3 of the protein from the animal sources. So proteins being the immune system, building block system. Fats, again, we all know that fats are essential in diet, but at the same time, they have their own set of challenges, increasing the cardiovascular risks and also increasing the cancer risks. So we have to cut down the saturated fats, encourage the unsaturated fats, do away with the trans fats. From the unsaturated fats, we can offer the monounsaturated as well as the omega-3 polyunsaturated fats. Alcohol is a big no. We can come down to moderation, but better it would be that we can counsel our patients against alcohol intake. So how does the diabetic management or the anti-diabetic therapies influence the cancer? That is very interesting to understand that metformin, one of the most favorite molecule that we all are using day in and day out as almost the first line therapy for diabetes management, also has been the favorite amongst the oncologists, as it has been found to show a reduction in the breast cancer cell lines. Also, it has been shown to decrease the prostate cancer cell lines. Metformin has been having a significant effect to inhibit the cell proliferation, colony formation, and causes a partial cell cycle arrest. So, though we do not have enough evidence as of now, but it has several literature is coming up which is supporting the use of metformin in breast cancers especially. It has improved the cancer prognosis, and it is associated with higher pathological complete response among the early stage breast cancer patients. Another drug which initially was found to be associated with CA bladder rather, that is a thiazolidinediones, the molecule which was significantly disputed, has been shown to have important anti-cancer activities, inhibiting growth and inducing apoptosis and cell differentiation. So PPAR is currently being considered as one of the potential targets for both chemo prevention cancer therapies. This is based on several preclinical studies. There have been certain clinical trials with rosiglitazone, which have really shown no increase in the risk of cancer. As I was talking, that initially this was a disputed molecule and it was thought to be withdrawn because of the CA bladder incidences were increased. Insulin secretagogues. Now, sulfonylureas are probably one of the very neutral molecules, but they have been shown to get associated with increased cancer risk. Though we do not have a direct evidence that the secretagogues, that is the sulfonylureas, do increase the risk of cancers, but it has been shown that because of their increased insulin secretion from the pancreas, they do increase the tumor growth, because insulin, as suppose one of the molecules, endogenous insulin, which is, if present in the state of hyperinsulinemia, promotes tumor growth, tumor cell growth. But we do not have any definite evidence in favor of sulfonylureas that they do cause, they do help in oncogenesis. Neither do we have another comparator group which says that if the group is not on sulfonylureas, probably the cancer chances are less. So these are the molecules which are most neutral, I believe, so far. Incretin-based therapies, again, the liraglutide was disputed in terms of medullary thyroid cancer, especially the MTCs in animals, but none of the human studies supported it so far. Still, we do not use this molecule in a patient with MTC or with a family history of MTC or MEN syndrome. Insulins and other insulin analogs, though the glargine was again recently in controversy because of its risk of cancers, but it has also been done away with. Exogenous insulin has not been found to be associated with any cancer increase so far. So cancer and diabetes prevention, both the arms need to be taken care of. When I talk of cancer and diabetes prevention, the gold standard remains just the same: a very good lifestyle, maintain a healthy body weight, ideal body weight, try achieving the weight loss, at least 7% of the body weight can be targeted to be lost so that we can be at our ideal body weight. And the method and the formula remains just the same: a good diet and a regular physical activity. The recommendations are remaining just the same, that is 30 minutes of physical activity every day, at least 5 days a week. So the strategies for weight loss, we should always have a healthy diet, cut down your portion size, and keep yourself physically active. To conclude, diabetes is an epidemic and it continues. There are strong correlations between diabetes and cancer. We must control blood sugar to give a euglycemic status to all our onco patients who are already fighting cancer. So the gap exists because of the educational gap, and we do need more national standards and more education probably, that diabetes, even in the face of cancer, is not that the priority is not undermined. It is still stands, and we still need to give a good metabolic control to all our patients. So what are the unanswered questions so far in diabetes and cancer care? The most importantly, we are still not sure that whether the diabetes complications are greater in people with diabetes who receive cancer treatment, or they're just the same as a patient who's not on cancer treatment. Are there seriously some potential complications or potential outcomes because of the treatment interaction between the chemotherapy and the diabetes therapy? So what are the well laid down treatment and care pathways? Most of the patients receiving steroids because of the chemo regimes, should they always be on insulin? Can we send back the patient home on OHAs? So we do not have actually an algorithm set for our cancer patients. There are more than 50 varieties of malignancies that today we are dealing with. So we are really not sure as to the standard protocols and what really will happen to the HbA1c levels and the diabetes complications once the steroids are given, short-term pulse therapies, or the cytotoxic drugs are given, or the anti-emetic regimes are given. So we still need to answer these questions over a period of time. More researches, more studies, maybe more protocol-led studies are required, and we can really follow up our onco patients and the diabetic patients to answer these questions, and maybe we can come up with better answers next conference. Thank you, ma'am, again. Dr. Beni, ma'am, Dr. Vijay, the entire Wodcon team, please thank you so much for allowing me here.
Thank you, Dr. Meenal. That was a wonderful presentation. I now invite our next speaker, Dr. Ami Sangvi. Her topic for today is Vildagliptin, Continuing the Legacy in Diabetes. Dr. Rami is a consultant diabetologist and co-director of Sangvi Eye and Diabetes Care Center in Mumbai. She's a consultant diabetologist at Nama Hospital in Mumbai. She's a lecturer for CPS and diabetology. She has been a member of the organizing committee of CID since its inception, and also Women and Diabetes. She has been a speaker and faculty at various national conferences and also published a chapter in RSSDI textbook of diabetes. I welcome Dr. Rami to move ahead.
So I think I'm one of the last batsmen for the day. Thank you all for patiently waiting through. And at the outset, I would like to thank Dr. Beni ma'am and Dr. Vijay sir for making me a part of the core committee of Wodcon and such a wonderful conference. Thank you, Dr. Sheetal, for the kind introduction. And thank you, Novartis, for giving me an opportunity for talking on Vildagliptin, continuing the legacy in diabetes. So DPP-4 inhibitors have been with us for more than a decade now, and they have been an important part of our day-to-day prescription. We all are prescribing them day in and day out. They have not only proved their efficacy in terms of the glycemic control, less side effect profiles, but also it's backed with a lot of science and a lot of data. We had a talk on a DPP-4 inhibitor by my dear friend Shifali in the early part of the day. I'm going to be discussing more about Vildagliptin. And before we go on to discussing about Vildagliptin, let's understand a little about evolution of DPP-4 inhibitors. So DPP-4 inhibitors have had a long journey, but a journey which has been worthwhile. The incretin term was coined first in the year 1930, and from then it's been a fruitful journey in terms of invention of DPP-4 inhibitors, hitting the market and taking over in the good glycemic control in our patients with type 2 diabetes, and now with so many DPP-4 inhibitors available and the generics also. So Novartis was the first in developing the gliptins, and when we try to connect these dots, we understand that Novartis has had a lot of role to play to get gliptins to us to prescribe to our patients with type 2 diabetes. Now, Novartis was honored with the invitation to name the new class. So the stem for all DPP-4 inhibitors for type 2 diabetes was given as gliptin. And it's interesting, how vildagliptin got its name. So it actually, Mr. Edwin Wilhor was the scientist who was attached to Novartis, one of the pioneers to invent vildagliptin. And the word "will" comes from his name. DAP comes from dipeptidyl aminopeptidase. GLI is the WHO suffix for anti-diabetic agents involved in glucose and insulin, and TIN is an enzyme inhibitor. So this is how the word has been put together, and we have vildagliptin to use for all of us. Now, we have a lot of gliptins or DPP-4 inhibitors available to us, but are they all similar? There are certain differences in the structures, the inhibitor types, the timelines, the metabolism, and the renal excretion. So, we have to use some of them with a lot of cautiousness when prescribing to our patients with renal or hepatic disorders. But if we look at the patent priority date, it establishes the fact that Novartis was the pioneer in terms of getting gliptins to us. So let's understand this gliptin by Novartis, vildagliptin, a little better. Vildagliptin has been backed by a lot of science, a lot of data, but we will be going through some important trials which establishes the fact that vildagliptin can be the right choice of treatment of DPP-4 inhibitor in our patients with type 2 diabetes. So one of the trials was EDGE trial, which is the largest prospective real-world study to assess the use of vildagliptin versus the other OADs after metformin failure. Another trial, the initial trial, which has a lot of data from India to a large Asian real-world evidence on vildagliptin in drug-naive type 2 diabetes patients. And verified trial, which, as we all know, this changed the whole outlook towards our patients, especially with lower A1C. So, but it assesses whether early initiation of treatment with the combination of oral anti-diabetic agents with complementary mechanism of action can increase the durability of the glycemic control compared with metformin monotherapy, followed by a stepwise addition of OADs. So let's understand in brief about each of these trials. Coming to EDGE, which evaluated the effectiveness of diabetes control with vildagliptin and vildagliptin metformin. So it was an observational multi-center study where, around 27 countries across the globe were taken into account, and around 2957 centers were enrolled. More than 45,000 people were enrolled in this study, and the patients were on monotherapy, were prescribed as a vildagliptin as an add-on OAD by the physicians based on the patient's need, and were assigned to one of the two cohorts. So what was the cohort? So after the monotherapy failure, either the patient was added a vildagliptin as an add-on or a vildagliptin metformin fixed dose, and then compared to the dual therapy OADs. Initially, they evaluated the demography, the HbA1c, the weight, and type 2 diabetes. And after a period of 12 months or a year, they were again evaluated for A1c, weight, the type 2 diabetes medications the patients were on, and if the patients had any adverse events or serious side effects. Now, when they evaluated a trial, look at the Indian subgroup. What they saw was that even if, in our patients, there were around 472 centers from our country where 11,052 people were enrolled. Our patients had a higher baseline A1C. Highest number of patients were from our country. What they saw was that vildagliptin offers a significant A1C reduction in our class of patients as compared to the other patients globally. So we had a reduction of around 1.44% versus 1.11% globally. Now we all know, and there has been a lot of data on the fact that Asian and we Indians respond to incretin-based therapy a little better as compared to our counterparts. We respond to DPP-4 inhibitors a little better than the Caucasian population. And this was again endorsed by the results from the ED study. Coming to another trial, which was from the Asian patients, the initial combination therapy with vildagliptin plus metformin in a naive type 2 diabetes patient in real life. So this was a real world study from Asian patients where patients were started on vildagliptin with metformin and who were drug naive. So we had around 532 patients they had in this study, which was a real world setting, and 200 from India. In fact, I think Dr. Manoj Chawla was one of the investigators for this trial. Now, here what they had done was initial combination therapy with vildagliptin plus metformin in drug-naive patients with type 2 diabetes was used. So around 532 patients were enrolled with an A1C of more than 8%. At the baseline, they studied their assessments were done, and then the patients were looked at after 12 weeks and after 24 weeks. So it was the parameters they assessed was A1C, fasting blood sugar, PP blood sugar, the body weight, the medications, and the patients were looked for any adverse reactions or any hypoglycemic events. Now, something to note here was that 200 patients enrolled in this study were from India who had a confirmed diagnosis of type 2 diabetes, and they had a documented A1C of more than 8% as compared to 7.5% from other countries. And what were the results from the initial trial? So when we look at the A1C from baseline at week 12 and week 24, both showed a significant reduction in A1C in the patients who were put on the vildagliptin metformin. From the baseline A1C of 9.3, it came down by 1.6% at the end of 12 weeks. And at the end of 24 weeks, it was around 1.9%. And this reduction in A1C was seen across all the age groups. So patients who were below 65 years of age also showed a good reduction, and patients who were above, the elderly class of patients who were above 65 years of age, even they showed a reduction of 1.4% at the end of 12 weeks and 1.8% at the end of 24 weeks. Now, what they found out was that 40% of the patients achieved the glycemic target with almost zero adverse events. So if you look at the end of 12 weeks, 27% reached the glycemic target of having the A1C of less than 7%, and 40% of the patients reached their glycemic target at the end of 24 weeks. So this definitely is beneficial for us because it's a real world data, a lot of patients from our country. This was Asian population with type 2 diabetes associated with poor glycemic control and presence of multiple CV risk factors. And the good part was that there was no adverse events or deaths reported during the study. Now, when we look at the reduction in the fasting plasma glucose and the postprandial plasma glucose from the baseline, if you look at the fasting glucose from 183, it came down by 41 milligram per deciliter. And by the end of 24 weeks, it was 50 milligram per deciliter. Even in the postprandial blood glucose, there was a reduction by 68 milligram per deciliter and up to 81 milligram per deciliter by the end of 24 weeks. So here is a molecule with less side effects, which shows reduction in both fasting and postprandial blood glucose and a reduction in A1C, and this has been proved by real world data. So that is why initial trial is important, because it's real world data. 67% of the patients enrolled were from India. 100% of the patients were drug naive. Almost equal distribution between males and females.
Patients with high risk CV risk were also involved, but no CV events were reported. And patients of both the categories of less than 65% and more than 65 years and more than 65 years were also enrolled in this study. Now coming to one of the most important study of vildagliptin, the VERIFY trial, and we all know that it changed the outlook, the way we treat our patients with type 2 diabetes, even with lower A1Cs. And I can say that after the results of VERIFY trial, even I have started using the combination in patients who come in even with a A1C of around 6.5 to 7.5. So VERIFY was a multinational, multi-ethnic study where 34 countries across the globe with 254 centers were involved. Around 2,000 people were enrolled in this study. And what did VERIFY show? They had primary outcome results and that secondary outcome results. So after the run-in period with metformin, the patients were randomized to either period 1 or where they used a combination of metformin with vildagliptin or randomized to a group of metformin and placebo. Now, as a primary outcome, what they were trying to look at is that do those patients with type 2 diabetes benefit from having a combined therapy at the beginning of their pharmacological treatment. And what did they look as treatment to time to failure was defined as an A1C of more than 7%, which was confirmed at 2 consecutive visits 3 months apart. And what did they find as a result? So the result was really, reassuring that they said that early combination treatment significantly reduced the relative risk of time to initial treatment failure by 53% versus the monotherapy. So it was much less with the combination therapy as compared to monotherapy. And this was also with a hazard ratio of 0.47, which was significant. Again, they saw that 50% of the patients failed in the metformin monotherapy group at 1.5 years as compared to 4.75 years in the early combination therapy group. So patients who are on the early combination could sustain the glycemic control for around 5 years on being on that combination, where the monotherapy group showed a failure at around 1.5 years. So again, reassuring the fact that this has a sustained result, does not show any secondary failure of OHA. When we started on metformin monotherapy, Indian data showed that Indian patients tend to fail earlier with monotherapy at around 1.5 years versus the global VERIFY population, which was around 3 years. Again, putting to us that we start a combination therapy right in the beginning of the treatment for getting good results and less complications in our patients with type 2 diabetes. What was the secondary outcome results the patients were looked at? So patients who stayed on combination therapy and patients who could not stay on combination therapy and they were moved to insulin, which was a period 3. Now, again, the failure was defined as 7.0, A1C going above 7, confirmed at 2 consecutive visits 3 months apart. And what they tried to look at in the secondary failure was that do these patients with type 2 diabetes benefit more from having the combined therapy at the beginning of their pharmacological treatment compared to a sequential additive strategy. So what do these secondary outcome results tell us? And again, they saw that an early combination treatment strategy significantly reduced the relative risk of time to second treatment failure by 58% versus the initial monotherapy. So again, it reassured the fact that incidence of second failure was also reduced with a combination therapy with a hazard ratio of 0.42%, which was significant. So again,
your time is up. Please wrap up.
Just give me 2 minutes, last slides. So early combination treatment halved the risk of time to initial treatment failure versus monotherapy strategy. The median time to initial failure was 1.5 years in the initial monotherapy compared to 5 years in the early combination strategy. And when all patients were receiving combination therapy, the risk for time to second treatment failure reduced by 58%, and both the approaches were were safe and well tolerated. Just the last slide, that with so many generics in the market, why Novartis vildagliptin? Because it was one of the first gliptin to be discovered, only imported vildagliptin available in the Indian market, experience and trust of more than 11 years with us, more than 200 clinical studies done, data to support it, around 34 million patient years exposure, and around 1.5 million patients annually on this molecule in India. Thank you very much. Thank you all for your patient hearing.
Thank you so much, Dr. Ami.
Thank you so much. It was indeed a wonderful talk, and I request Dr. Alpana to please introduce the next chair to the next speaker.
Our next speaker is Dr. Seema Bagri. She's an honorary diabetologist at the Thana Healthcare Hospital and Indian Red Cross Society. She's the director of Dr. Bagri's Diabetes Care Center and Bagri Diagnostic Center. She has been a special investigator for the X-RISE study and the STAR study on penigliptin. She has regular articles on awareness on diabetes and is published on a monthly basis. And she's a regular diabetes education and awareness programs which were conducted on NDTV. A warm welcome, Dr. Seema.
Thank you, Alpana, for the kind introduction. Before I start my topic, this is the last topic of the day. And before I start my topic, I would like to thank Benny ma'am and Vijay Neglu sir for giving me this opportunity to talk on this prestigious Wodcon conference. So without wasting much time, I would like to start my topic as clinical application of remogliflozin-based combination in type 2 diabetes management. Now, after the DPP-4 inhibitor, let us have a talk about the SGLT2 inhibitors, among which we are going to talk about remogliflozin, which is the most affording SGLT2 inhibitors in the market. The remogliflozin came in the market when the SGLT2 inhibitors were very expensive and it was out of reach for every Indian patient. So let us begin with the journey of remogliflozin with relevant and rational combination. Remogliflozin came in the market in May 2019. After the success of remogliflozin, then came the combination in September 2019 as remogliflozin with metformin. Then came era with the remogliflozin with vildagliptin, that is DPP-4 and SGLT2 inhibitors. And then July 21, the remogliflozin with linagliptin, and the last and the most important, in October 21, the Remo, Vilda, and Metformin, that is a triple drug combination in Indian market. Now let us have the discussion on SGLT2 based regime, which have received immense interest in type 2 diabetic management. Evidence of benefits of metformin SGLT2 inhibitors available over 104 weeks. We'll have the two trials. Now, the combination therapy with an SGLT2 inhibitor as an initial treatment for type 2 diabetic patient in a systematic review and meta-analysis. There were 4 RCTs and number of patients included were 3,749, which was studied over a period of 26 weeks. So metformin and SGLT2 inhibitors versus metformin as a monotherapy and SGLT2 as in monotherapy, where we found that versus metformin, when it was used, there was a greater reduction in HbA1c in the tune of 0.55% and greater reduction in the weight with 2 kg. And the relative risk of genital infection was 2.2 versus SGLT2 inhibitors as in monotherapy. It showed a greater reduction in HbA1c of 0.59 and a greater reduction in weight as 0.5 kg. And the genital infection ratio was very less, 0.69. But the ratio of diarrhea was 2.23. And the long-term efficacy of